Jonathan Steinberg, State Representative from the town of Westport, 136th District. Here with my co-chair, Senator Anwar, and our esteemed ranking members, all members of this committee, the hardest working committee in the Connecticut legislature. We have another public hearing today with an interesting grouping of very interesting bills, which I'm sure will get some interesting testimony. So we have over 100 people to speak today, and we're going to stick as well as we can to the 3-minute limit. At roughly 3 minutes, you will be advised that your time is effectively up, and we will ask you to conclude expeditiously at that moment. We have, as we usually do, a number of elected officials that we will handle first. We give the first hour to them. I think there are only maybe 6 or 7, in which case there's a chance at least we'll get that all accomplished within the first hour. So I will turn it over to my esteemed co-chair, Senator Anwar, for any opening remarks.
Thank you, Mr. Chair. Just wanted to welcome everybody in the committee who's here and everyone who is going to join us. We value the public perspective and opinions and your thoughts. So looking forward to listening in closely and making sure that our bills get better with your insight and your input. Thank you, Mr. Chair.
Thank you, Senator. Good morning, Senator Wong.
Thank you, Mr. Chair. Eager to get started and want to acknowledge that it's another busy day at the General Assembly Zoom world. So there may be other meetings that colleagues will be going into, but I'm eager to get started. Thank you very much.
Thank you, Senator. Yes, it's rare indeed that we only have one thing to do at a time this time of year. Senator Summers, good morning.
Good morning, everyone. I'm eager to get started. We have a lot of interesting bills on the agenda today. Again, I just want to reiterate, if you see a legislator with either their name up or their face up or they disappear for a while, they probably are hopping into another. We have a big transportation hearing today. So please, if you're watching, do not see it as a sign of disrespect. It is not meant to be. We are all bouncing between multiple meetings at the same time. Thank you.
I don't know about you, but I think my brain is getting rewired from being in at least 2 meetings at any given time. Probably not in a healthy way. I see 2 Representative Pettits. Either one, good morning.
Good morning, Mr. Chair. Struggling with my internet here was struggling with internet. I think I'm on now, so I will get rid of my phone, and you only have to deal with one of me, sir.
I was getting a little concerned there. I know we're ahead in the state in genetic research. I hadn't thought that cloning had gotten to that level quite yet. I see Representative Zupkis has her hand raised. Good morning.
Good morning. Thank you, Mr. Chair. I too will be in a couple of meetings. However, for some reason, I cannot get my camera on. So I apologize in advance. When I ask questions, I'll continue to try to work on it, but I'm here. Thank you.
Yeah, I wouldn't advise kicking the computer, but sometimes rebooting works. If there are no other questions or comments at this hour, I believe we will get started. And first up on the list today is Representative Christine Conley, followed by Charlize Walcott. Good morning, Representative. Is the representative in the House? You can see we're off to a flying start. We will come back to the representative if she's able to connect. So why don't we go to Charlize Walcott from the Division of Criminal Justice, State Attorney's Office. Good morning.
Good morning. Thank you for having me. Senator Anwar, Representative Steinberg, Ranking Members Wong and Pettit, and distinguished members of the Public Health Committee. My name is Charlize Walcott. I am the State's Attorney for the Hartford Judicial District, and on behalf of the Division of Criminal Justice, I thank you for allowing me this opportunity to testify on HB 5278. The division is committed to the proper and thorough collection of evidence in sexual assault investigations. In 2020, the Chief State's Attorney requested I chair the Commission on the Standardization on the Collection of Evidence in Sexual Assault Investigations. Through the Commission, we address issues surrounding the collection of evidence in sexual assault cases. And the Commission is made up of professionals from the medical, legal, scientific, law enforcement, and victim advocacy fields. While the division takes no position on the bill, clarification is needed to preserve a patient's right to choose and prevent an unintended benefit to violent offenders. The inclusion of specific language that subsection C includes the collection of evidence of sexual assault based on information to believe that the patient was sexually assaulted or abused provides the needed clarification, and it is our request that the language be included. The presence of forensic evidence is often critical in the investigation and prosecution of sexual assault. With that, I am happy to answer any questions that the committee may have, and thank you again for having me here.
Thank you. Could you just elaborate a little further as to specifically what you mean by clarification in the section that you referred to?
Yes, sir. So right now, under subsection B, section C, it indicates that in the case of an unconscious patient, the intimate examination is required. If the examination is required for diagnostic purposes, it could be allowed. That language, the way it is, it's a bit ambiguous, and we're asking that it clearly and specifically include the collection of sexual assault examination kits for a patient who may present to a hospital unconscious. Oftentimes, violent sexual assaults include violence, and if a patient were to present to the medical facility unconscious, we do want to be able to preserve that patient's right to choose whether to proceed with a complaint by collecting, by performing an examination.
Thank you. And you've provided us with the language for clarification?
Yes, sir.
Thank you very much. I see Representative Gilchrist had a question. No longer?
Nope, your question cleared it up. Thank you so much. Thank you, Ms. Walcott.
Thank you, Representative Gilchrist.
Well, we seem to have covered it all. There are no further questions. Thank you for joining us early this morning, and we wish you a good rest of the day.
Thank you.
Next up, we have Mairead Painter from the State Long-Term Care Ombudsman's Office, followed by Representative Farrar. Good morning.
Morning. Morning. Good morning, Senator Abrams, Representative Steinberg, Senator Summers, Senator Wang, Representative Pettit, and distinguished members of the Public Health Committee. My name is Mairead Painter, and I'm the State Long-Term Care Ombudsman. Thank you for the opportunity to provide you this testimony today. I'll be testifying on SB 254, an act requiring long-term care facility residents to undergo a criminal history and sexual offender registry search. I appreciate the desire to protect residents in nursing homes. However, I'm not currently able to support this bill, although it is well intended. The mission of the Long-Term Care Ombudsman Program is to support the well-being of residents, safety, and their rights in long-term care settings. I understand where the concerns come from and why people want to see parameters put in place to better safeguard residents living in our skilled nursing homes. I worked in nursing homes over 20 years ago, and part of what I did was processing and screening applications for admission. As part of this process, we would use the Sexual Offender Criminal History Database and other publicly available judicial websites. Every nursing home currently has the right to look an individual up on these public lists and portals. Every nursing home has the right to review all information related to the admission, referral, and decide whether the facility can appropriately care for this individual. When they agree to accept the individual, they are agreeing to appropriately care and provide services to meet their individual needs and goals. As we have seen census in our nursing facilities drop, we have seen corporations make decisions on the ability to fill these beds and not the overall ability to care for each resident appropriately and safeguard everyone in the facility. I absolutely do not believe that this is a question related to knowing and having access to information about a resident's history. The facilities where we have had the greatest concerns knew the history of the residents. They made a business decision to accept them without providing the necessary staff, care, and services to protect both these individuals and safeguard everyone within the facility. I want to be clear that it's not the majority of our skilled nursing facilities in our state. This is a business decision that individual companies or facilities have made. Most skilled nursing facilities screen proposed applications and make appropriate decisions about their ability to care for individuals who are applying. When making that decision, we must look at all of the needs an individual may have, including their ability to return to the least restrictive environment and appropriate discharge planning. Many nursing home facilities do this very well. However, we continue to see a portion of our facilities in the state put their ability to profit over this necessary care. I agree we need more accountability related to the acceptance of an admission to a skilled nursing facility. When a resident is accepted, there is a requirement in place to ensure that the skilled facility can provide appropriate care to meet their needs. These rules are further expanded by the CMS Mega Rule, which was a 3-phase approach reforming the requirements of long-term care facilities.
Excuse me, Ms. Painter, but your time is almost up. If you please summarize. Thank you.
Absolutely. This began in 2016 and continued into 2019. The tragic cases we heard about are not related to individual disclosures. They're regarding the choices that the long-term care facilities made. I believe that change is necessary, and I'd be happy to participate in any information or questions that is necessary to move something forward. Thank you.
All right, thank you for your testimony. This is our attempt to remedy a situation as you described. Is this adequate or appropriate? Are there other things you would have us do to assure that every facility conforms to, an effective standard?
Where I think there are gaps is in the notification of someone being in the home. So I think where it comes to the ability to screen for and appropriately provide for that anyone who has served their time, depending on what the scope is and what the requirements are by law, that they register, that if someone is in a nursing home, that they be required to be on the registry, that nursing home's address should go on as the person's address. And that's where, in a couple of cases, we did see gaps. I believe, and we can get more information on it, that if someone is a short-term rehab resident, that it's not their permanent address, so they don't have to list that as residency. And so that's where I think there's gaps. That's where I think there's concerns, and ensuring that as a customer, if I'm choosing to live in that nursing home, that I'm informed of who is living there with me, and I can make the choice, so that if a company or a provider decides to make a change in their business model and who they're going to provide to, I have as the customer have the right to make a decision to be there or not. And I think that we need to put the controls there as the individual or the family members.
Let me just ask before I turn it over to Representative Gilchrist. What about enforcement? You're more boots on the ground than most of us in understanding how things actually operate. Even if we were to make these changes, do we have an effective enforcement mechanism?
Well, as far as enforcement goes, we have the Department of Public Health. They go out and they survey these facilities. We do highlight issues and concerns to the department when they come up. If we hear of something not going well, but I think if there was a requirement to list individuals in the building who were either registered sex offenders or whatever that requirement is, that they should follow that, and that could be something that's looked at on survey.
Yeah, I think inclusion on survey is exactly what I was referring to make sure it's on that list. Representative Gilchrist.
Once again, Mr. Chair, the questions I had got answered. Thank you so much. Thank you, Ms. Painter.
Representative, I'll stop asking questions so you'll get a chance. Thank you, Mareska, as always, for not only your testimony today, but for the work you do. Incredibly important to us. It is our intention to close this loophole as effectively as we can. And we appreciate your ongoing engagement to make sure we get it right.
Thank you very much. Have a good day.
You too. Next up, unless Representative Conley is here, is Representative Farrar, followed by Representative Gupel. Good morning, Representative.
Good morning, Chairman. Nice to see you. Hello to you and our co-chair Abrams and the vice chairs, ranking members, and all the distinguished members. I'm thrilled to be here today and testifying in support of what is House Bill 5272, an act concerning menstrual products. I'm grateful for the leadership of the committee to introduce this bill, and it's one that can immediately make the difference in the lives of over half of Connecticut residents, because over half of our residents are or have been menstruators. And unfortunately, for far too long, menstruators often choose between food, a roof over their head, their education, and simply access to menstrual products. Unfortunately, periods do not stop during the pandemic, and neither have the barriers for many individuals to these products. I would like to say that due to the timing of this hearing today, many students who are leading this effort are actually unable to participate because they are in school. And given their leadership, I would like to share their voices with you. Joy Wren, who's from Wilton High School, she asks us, when was the last time you had to pay for toilet paper in a restroom? On most accounts, never. Imagine inserting a quarter into a machine that only gives you a single usage of toilet paper. If you don't have any coins with you, you're forced to find some way to deal. And Chanel Thorpe, a student at my own local Conard High School in the 20th District, shares, high school certainly isn't easy, and having to worry about where you'll find a pad should not be a monthly struggle. This legislation promotes the fight against the stigma that society has brought upon us and brings together hundreds of individuals with unique stories and backgrounds. To Chanel, House Bill 5272, it gives an opportunity to young individuals who menstruate to build their confidence and alleviate the stress with having a period. These two students are not only leading the way, but they're expecting us as legislators to act, not just for them in schools, but for students at our public universities and menstruators in shelters and prisons. This is because 1 in 4 teens have missed class due to lack of menstrual products, 1 in 10 college students lack access to products, and 1 in 4 menstruators simply struggle to afford the products. There's not just this economic strain that you've heard of, but there are also, for your committee's interest, severe health consequences without access. I hope our state can learn from the overwhelming bipartisan support of this legislation in states across the country, most recently Utah. There's actually 7 other states, including Alabama and Florida and Massachusetts, who also have legislation proposed for this year. And this piece of legislation before you, it's crucial to break down this period poverty barrier that just perpetuates shame and stigma and fear surrounding this simple biological function of life. I hope that you'll agree that all menstruators in our state deserve better. I thank you for this opportunity and I urge passage. Thank you, Chairman.
Thank you, Representative, for your testimony. I'm going to play Senator Anwar's game and hope that Representative Gilchrist asks my question, because I know that she's eager to ask a question of you. Representative Gilchrist.
Thank you, Mr. Chair, and thank you, Representative Farrar, for being here and for all of your advocacy on this important issue. We know that young women, young menstruators are menstruating earlier and earlier, in particular, Black individuals in our state. And so I believe the language as currently written speaks only to middle and high school. Was that the intent of the legislation?
Thanks, Representative Gilchrist, for that question. I would recommend to the committee to include elementary. We can know from all the information out there, as you noted, that the average age for students to get their period is between 10 and 15, but we do know that for certain children, they can have their first period as young as 8. And this is why, again, when I mention other states, actually in Utah, their unanimous support was for elementary, middle, and high school.
Fantastic. Thank you. Thank you, Mr. Chair.
Thanks, Representative.
Thank you, Representative. No, that wasn't my question. I'm going to try Representative Berger Travalo, see if we get it.
All right, let's see if we think alike. Thank you very much, Mr. Chair. And thank you, Representative, for being here and for representing on such a strong and important issue. You mentioned the severe health consequences of not having access to menstrual products. Can you elaborate on that?
Yes, certainly. I am not a medical professional. I certainly know those folks can go into greater detail, but I can say that from all of the research out there around the effects of not having menstrual products or having to use menstrual products beyond their use, there can be a range of issues from fungal infections to UTIs to even cervical cancer. And one of the things that is also a effect, unfortunately, of kind of a lack of products and also overuse of products beyond their time of use is really the mental health effects associated with the anxiety and stress of either not having products or being concerned about the products that you're using. And, this is something that can affect not only, again, a lack of focus in school or at work, but particularly concerns around, just being able to get through the day. And this is the thing that we hear from students, especially who honestly, are continuing to share their experience of just not feeling comfortable, in school while they have their period. And, that in and of itself should be a concern to us, not just for our students, but ensuring that, they have access to this can resolve that kind of physical long-term effects, but also that stress they might be feeling without the product.
I think those of us who are menstruators can all relate to that anxiety we feel when we don't have access and the panic that sets in, particularly when we're young. So I appreciate that you explained that, especially to those of us on this call who are not menstruators. So thank you for describing that and for all of your work.
Thanks, Representative.
Thank you, Representative. Yes, there's enough stress, particularly in high school or even junior high school, without these kind of access issues. Create one less thing to worry about. Next up is Representative Zupkis, followed by Representative Elliott.
Thank you, Mr. Chair. And again, Representative, I apologize. My camera is not being recognized on my computer, so I apologize for that. I remember this bill, I believe it was last year, wasn't it, that it came up. And there were a group of young ladies from, I don't exactly remember where, I think somewhere in Fairfield County, and this was kind of their charge. Are they still involved?
Representative Zupkis, thanks for your question. First off, I would just note the bill last came up actually in 2020, and it didn't move forward because of your session being cut short. And you are right that there was a group of incredible young women who were fighting for this. And one of the individuals I mentioned actually in my testimony, Joy Wren, was one of them from Wilton High School. And she's still very actively involved. And we've also heard from students, from so many different communities, Wethersfield, Bethel, as I shared in West Hartford. I know there's further testimony from communities such as Hamden. So we're really hearing from students everywhere that have taken this on in their own schools to make change, but they want to make sure that all students across the state have access.
Right. So yeah, 21, all these years, 20, these years run together, but thank you. I really thought that was great because I think it is so great for people in different communities to get involved in other communities and to get to meet other folks, maybe people from Fairfield County that, meet people in the cities. And so I thought that was really a great idea. And I thought it was also great that they would take it on as a charge to fundraise for it and understand that whole aspect of it also. My second and last question is are you looking, and these folks looking to have the state supply all of these menstrual products into schools, into bathrooms, or are you looking for this group just to be able to go out and fundraise and go in and meet the ladies in all these other communities and build relationships?
Representative Zupkis, such a great question. So the bill as a whole would cover our school restrooms, public universities, shelters, and prisons. And one of the elements to the bill does note the ability for any of these institutions to accept donations, because we know many of them already are. As you noted, not just in schools, but we've heard from shelters, for instance, that are already receiving donations, and there's no reason that they can't. But one of the things we've also heard and have learned from other states is that, there's no amount of donations, unfortunately, for covering this in a way that all school bathrooms really have access, and that, again, that it's implemented in an equitable way to cover all of our state. So what we've seen from other states who have passed this, and again, we could be the 14th to do so, is that there's been this approach to allow the acceptance of donations, and then that there is a certain amount of state funding that schools particularly could access if they are unable to provide these products themselves.
And this is my last question, I promise. Do you know the amount of funding you're looking for from the state?
Sure. Yeah. So based on kind of the calculations of usage and our schools, there would be a potential upfront cost of dispensers, since some schools may need to install new dispensers based on their current dispensers. So that could be a couple $100,000 for those dispensers. And then for the ongoing cost of product, again, based on what we know are donated products out there and what we know schools might be requesting, it would likely be approximately $1.4 million.
Okay, thank you.
Thank you, Representative Zupkis.
Thank you, Representative. And now Representative Elliott.
Thank you, Representative/Chairman Steinberg. Representative, for a quick question for you. What is the scope of this bill in that how many bathrooms on campuses or in prisons are we going to be requiring these products? Is there a minimum base, or is it based on population that's normally on location? Could you just explain a little bit?
Sure. So in schools, so elementary, middle, and high school, the goal here is for all bathrooms to have access to these products. But the legislation for public universities actually just indicates the products be available for access in one location on campus, that students can go and pick up products. And then for our shelters and prisons, the legislation specifies, again, being able to have one location and to be able to request access without stigma. I would say, Representative Elliott, we have heard from our universities, both the Connecticut State University system and UConn, that they perceive this as something very easily done and something in many ways they're already doing. And what was encouraging to hear from them is that I think they're willing to kind of go above and beyond what might be required in this legislation.
And you may have mentioned this, and maybe I missed it. I heard 1.4 million. Do you know what the ongoing year-over-year costs are?
Yeah, good question. I think what we're anticipating is based on, again, what we've seen in other states, it'd be approximately a similar cost year to year. But what we might see is that schools themselves, again, might take on some of those costs in their budget and not need the state funding over time. Because as you can imagine, the intent here is to ensure that these products might be ordered just like toilet paper or paper towels are. So what we imagine is that there could be that ongoing yearly cost, but over time it could be reduced based on schools incorporating this into some of their own budgets and then based on donations.
And then this last question is maybe a bit nebulous, but do you get a sense of what some of the pushback is on this topic and what some of the counter arguments are to having these products be provided? And I only say that as somebody who heard the argument of, if we have toilet paper in a bathroom, why don't we have menstrual products? And to me, it was that simple. But do you have a sense of what some of the counter arguments are to this?
I think one of the things that we've heard, from a range of conversations with schools was why can't students just go to the nurse's office? And because many nurses' office do offer these products for free for students. And there's a few things I think students have just said to us time and time again, is that requiring them to take time away from their classes to go to the nurse's office is a barrier. Often, dependent on how your school functions, you might have to request a note to go to the nurse's office. Again, greater barrier and stigma. And for students, if you think about it, in any after-school activities, there's no access to the nurse's office. And so we're really, creating a greater barrier there.
That's it for me. Thank you.
Thank you, Representative. Next up is Senator Haskell, followed by Representative Linehan.
Thank you so much, Mr. Chair. And Representative Farrar, you read my mind. I was just going to ask, first of all, thank you for leading on this bill and for speaking on behalf of so many students in my district and elsewhere across the state who are championing this reform. I was going to mention that a superintendent had reached out to me asking, why can't students simply go to the nurse? And I think you answered that so perfectly in your last answer. I just want to tack on one more question, if it's okay, and that's another superintendent reached out saying, we haven't seen any empirical data that this is a problem in Connecticut. And I just want to give you an opportunity to respond to that. I personally have heard from a lot of students that it's a problem, but you likely know more about what the data has shown here in Connecticut than I do.
Yeah, Senator Haskell, thank you for that. And thank you for highlighting the students in your district. I think for so many of us, not just on this, but on other issues, we're catching up with them. This is another one of those issues that, we're kind of catching up to where they're at and have been requesting our action. So to your point around kind of empirical evidence, there, have been studies just as recent as the last year during COVID that a quarter of students have said they've struggled to afford period products. And, when you kind of look at that closely, you can't help but recognize that, in all of our school districts, we have a range of need, some school districts more than others. But, when you look at the affordability issue, there's no doubt that in all of our schools, there are students that would be struggling to afford these products. And we have certainly heard, as you noted from students in your own district, of students who in their own schools, have expressed these barriers that I mentioned around not being able to get products at the nurse's office, having friends who cannot access products and are, struggling to stay in school. So we are hearing that directly from students, but we can, again, look to the research that's been done even in the past year about a true quarter of our students being indicating that they're struggling to afford the product.
Thank you so much, Representative, for that thoughtful answer and for your leadership on this critically important topic. Mr. Chair, thank you for the time.
Thank you, Senator. Next up is Representative Linehan, followed by Representative Claritas DiTrio.
Thank you, Mr. Chairman. Good morning, Representative. Thank you so much for being here and for advocating for this legislation. You did touch on some of the things that I wanted to point out. So this might be less of a question and more of a statement of support. We did pass this bill out of the committee that I chair, the Children's Committee, a few years ago. Unfortunately, it didn't get across the finish line. So I just want to make sure that some points were actually in this version of the bill. First, I want to thank you for pointing out that elementary schools needed to be included. That was a big point for me when we had it in our committee. And one of the reasons for that is beyond the fact that periods are starting earlier, we know that. I just want to point out for other people that not all districts have 6 to 8 middle schools. And in my district in Cheshire, we have a junior high and it goes 7th and 8th grade. So that was really important to me. And you did touch upon the problem with only holding menstrual products in the nurse's office, but I just wanted to check with you. Is there a language that strictly prohibits only keeping these products in the nurse's office?
There is not, Representative Linehan. It wouldn't preclude schools from still having them there, but it does say that they need to have them in all of the restrooms.
Okay, good. So it says that you can have them in nurse's office, but you must have them in the restrooms.
It doesn't state in the language, it doesn't reference what the nurse's office can or can't do. So again, it wouldn't preclude them from making that decision, but it is clear where they need to be, which is in all of the restrooms.
That's wonderful. Thank you. Because that was one of my biggest concerns, especially when we're talking about, I mean, you touched on mental health, and you know that that is of extreme importance to me, especially when we're talking about adolescent girls. Just sometimes the fear of having to and ask to go to the nurse is too much for some of these girls. Making it accessible in the bathrooms is extremely, extremely important. So we seem to all be on the same page. I want to thank you very, very much for your advocacy and your leadership and for putting this forward. So thank you.
Thanks, Representative.
Thank you, Representative, for your hard work on this previously, which has clearly informed the bill that we have before us. Last up is Representative Claire DeStitria. She has a cat, so keep it away from the dog.
Thank you, Mr. Chair. A couple questions. I'm looking at the language right now. So just to clarify, all boards of ed, middle and high school, have to have the products available in every single bathroom, girls and boys?
Good question, Representative, and thank you for that. So the way the language is currently written is, yes, that is how it's currently written. And as was noted earlier, is that the request for the language would be also to include elementary.
Okay, and so yes to boys as well?
Yes.
Okay, and then locker rooms that have bathrooms in there, they'll be in there as well?
Yes.
And then the nurse's office, it usually has a bathroom, so then it'll be in the nurse's office because that's a bathroom.
Yes.
And then what was my other question? And then higher ed. So higher ed, universities only have to have it in one bathroom in the entire university?
Good question. It's not a bathroom, it's one location. And so what we're hearing, especially from our community colleges and Connecticut State University system, is they might have the product in one location on campus where students are able to go and pick up the product at their, a time that works for them and just associated with their range of student needs. But what we have found is that UConn actually is already, again, providing product in one location that students know they can pick up. And UConn is actually starting to pilot having the dispensers in the restrooms.
Okay, and the reason, if you can give me an explanation why we'll have them in the boys' bathroom as well?
Yeah, sure. When you kind of look at this issue, not just here in Connecticut, but across the country and the world, we do want to ensure that there's access to period supplies for everyone that needs them, including those who don't identify as girls.
Okay, thank you very much, Representative. Thank you, Mr. Chair.
Thank you, Representative. We have one more question from Representative Tavros.
Thank you so much, Mr. Chairman, and thank you, Representative Farrar, for your leadership on this. I am thinking of all the young women, especially. I'm glad that this is addressing the younger girls specifically because, as women know, and that's why it's so important that women serve, that when we first get our periods, it's not very regular. And so beyond not being able to afford it, I think it's critically important that you have access anywhere and everywhere so that you don't have to be embarrassed that this has happened. And also, we do sometimes have inconsistent education around our periods, so it's another positive. So that's my comment. But my question is, you sort of touched on this, but I just wanted to make sure that I'm understanding. Are these going to be available for victims, survivors of domestic violence in the domestic violence shelters? Because I think that that's, whether you call it a pink tax or however you want to phrase it, that is a significant barrier for some women.
Thanks, Representative, for your comment as well. I think the more that we talk about our periods, right, the more all of this is more normalized. To the question about domestic violence shelters, In the language currently that you have before you, I do have concerns, and I think you'll hear this from the Connecticut Coalition Against Domestic Violence, that it's not as explicit as we would suggest it be to be inclusive of our domestic violence shelters. I think right now the language references grantees of the Department of Housing, which would more reference our homeless shelters. So we would request the committee add the language of our domestic violence shelters. They're on the front lines. Just last year, I was just kind of looking this up, nearly 3,000 victims were housed in Connecticut for domestic violence services. And as you noted, no one should be left seeking menstrual products as they're seeking safety.
Yeah, that's a huge challenge for a lot of women. And often they're coming out of situations where they have to move so quickly. They may not have time to grab what they have, or they may have control, in which case, what they have may have been controlled as well. So thank you so much for bringing that to the forefront. We appreciate it.
Thanks, Representative.
Representative, let's keep on coming. We have Representative Parker has a question.
Thank you, Mr. Chair. Thank you, Representative Farrar, for your leadership on this. I asked a lot of questions, so just wondering if you can leave us with a reminder, because I think you mentioned this before, about where the other states or where some other states are at, and help us get the context for where Connecticut needs to catch up, or why we might feel comfortable doing this based on our neighbors or other places across the country. Thanks.
Thanks, Representative. And to the chairman's note before, and Representative Linehan, I note, Connecticut, we have tried to do this for several years prior, and I do hope this is the year, because there are 13 other states that have passed the legislation. And it's really been done, which is really refreshing in a bipartisan way. Most recently in Utah, there was unanimous support for this legislation. And right now, there's actually 7 other states around us, Massachusetts, but elsewhere in the country, Alabama and Florida, who have legislation proposed. And all of this, I think, is just, again, taking the leadership of the students in many ways that we're learning from, to ensure that this is just a normal part of all of our lives and that we have access to these products. So thank you for the question.
Thanks, Representative.
Wait, there's more. Here is Senator Anwar.
Thank you, Mr. Chair. I have my camera off as I'm driving over to the Capitol right now, but I wanted to thank you, Representative Farrar, for your leadership. And I also wanted to mention that Senator Abraham, who's the chair of this committee, along with Senator Kasser, were very passionate about this issue, where they brought it to the Children's Committee and then it passed through the committee, but never crossed the finish line. And I know you and all the others were working on this. So this work and this bill is much more comprehensive, and it's also again pushing this important need that is critical there. I just want to mention that last time I was also a co-sponsor of the bill when Senator Abrams, Senator Kasser had pushed that forward. And in one of my towns, there were people who started writing these quote unquote town Facebook newsletters about what a waste of money it is. And it was, sadly, it was young women, but it turned out it was a partisan issue. And to me, it was just like, wait, we are trying to, this is not a partisan issue. Can you help explain to some of the people who feel that this change or the cost is not worth it? Because to me, we as a society have restricted support on physiologic needs of women. And this is a physiology, and that is something that is a part of how human body works. And now we are trying to make it difficult for one gender, and to the point that sometimes the strongest opponents, at least what I saw in one of my towns, were the women who were against this entire policy. So I just wanted to share those thoughts, and if you can empower us with more information on education so that we can educate people who feel otherwise. Thank you.
Thank you, Senator. And I appreciate your indication of, again, how much we've wanted to bring this forward and have success with this bill previously. And I do hope this is the year. I appreciate your comments and asking around how do we talk about this in a way that we really get everyone on board. And I think, as some of my colleagues asked earlier and commented earlier, unfortunately, this has become an issue that we don't talk about enough. We don't talk about our periods, our menstrual health. And unfortunately, that means that it's often a point of secrecy and shame for so many menstruators. And if anything, I hope that us talking about it more, and again, our students are talking about it and they're asking us, why is this not a normal part of my life at school? And I think those are the voices when I speak with people about they're hesitant to change. I really encourage them to talk to the students in their lives, to listen to the students in their lives, because they're the ones who are pointing out that our world has just not caught up to how they want to be living, not just in school, but in the world as a whole. So that's kind of where I would encourage you, Senator, and so many of us to really listen again to the youth in our lives who are really asking us, why is the world still set up this way? And why can I not simply access the products that I need for my biology?
Thank you so much. Thank you, Mr. Chair.
Representative Farrar, you seem to be the witness of the moment. We have Senator Summers.
Thanks. Thanks, Senator.
Good morning, and thank you. I know we have a lot of bills to get through today, so we spent a lot of time on this particular topic. I just would like to share, I have a 12-year-old daughter, and in her school, there is no shame, there is no stigma, people don't feel the need to talk about their biological happenings, and I'm concerned. I mean, I understand access is an issue for some, and I think that's something that we need to address. I'm concerned on the funding. I do not want to put another mandate on our school systems that are already struggling with their the money that they receive from the state. So how would you suggest, if this bill moves forward, that we can guarantee that the burden of this cost, in depending on how many bathrooms a school has, does not fall to the school districts where it could perhaps inhibit the ability to hire another teacher or to provide another function or service? How do we make sure as a legislature that doesn't happen? I'm really concerned about mandating another thing for our schools that many of them struggle each year with budgets locally, to ensure that we do have access for individuals who need it, but that we're not overburdening our schools. I think that maybe there's a balance in the fact that we require schools to have them readily available, but when we start mandating that it has to be in every single bathroom, I think that's where some of us have a little bit more of a hesitation. So could you speak to that at all?
Yeah, Senator, I'd be happy to. And I appreciate your question, because trust me, we want this to work for our schools. We want it to work for our students. We want parents to feel secure, as you noted, to know that their students, as they're at school, have access to these products. And one of the things I think I've heard, and I think you may hear later today, from our superintendents, CIAC, and the school nurses, all who are supportive, is that they view this as something that they want to do, that they know that, again, that students are asking them to do, and that they see that this can happen based on what's happened in other states with some form of state support. So I definitely see this as something that, to truly implement in an equitable way, does require a certain level of state support. But again, it doesn't preclude any entity, including our schools, to accepting donations, which many of them do already.
Okay, but that still doesn't answer my question. Maybe it's, that's something that you can't answer. If we're going to mandate this on schools, and they can fundraise, it still doesn't answer the question on how do we ensure that it doesn't become another added cost as part of their budget, that they then maybe not be able to do something else because of it. I see the need, and I see the idea that we want to make these products readily available. I also see what could happen if these are put in a middle school boys' bathroom, and what the teachers are telling me they think will happen with the products. So I'm trying to find a balance and make sure that we're not, again, mandating something for our school districts to have to follow and take on as the cost, where I think that we could maybe look at other ways to provide these products in the schools without them having to add this to their school budget. If we pass this, we should be paying for it. So that's just some thoughts that I've had. I've heard school districts that are supportive, but they don't want this added to their minimum budget requirement at all. So just food for thought. Thank you for your answers.
Yeah, and Senator, as I shared, in other states that have provided funding, the point of that, as you noted, is not to put the burden on the school districts, but to ensure in their implementation that they have the funding to do that.
Well, Representative, we could let you go, but let me ask a question. You heard Representative Elliott make the comparison between these products and availability of toilet paper. To me, that sort of illustrates the point that this is something that's part of regular hygiene that simply must be available for those who need it when they need it. And I know that we grossly underpay our teachers, but would you say that the cost of these products are equivalent to what we pay a teacher with benefits? Is that really a fair comparison?
Thank you, Representative Steinberg. It is not a comparison. Actually, one of the things that's been learned in having these products available as states have passed this legislation is, again, in usage, it's way lower usage than the toilet paper or paper towels usage might be in any of these restrooms. And the cost is really minimal per student when you think about the number of students who are menstruating and their usage.
Thank you. I see Senator Summers' hand is still up. Is that a question for the second time?
Yes, thank you for your indulgence for the second time. And I was not saying that they were going to cost a teacher, but I remember last year when we heard this bill, I think it was Representative Claritas Dietra that had done some numbers, and her school district had come back saying that if they had to provide these products in every single bathroom throughout the district, it was equivalent to a teaching position. So that's why I asked the question. I don't know what they're equivalent to. I could have that wrong, but that's what I remember. Maybe she can clarify that or not. So I'm just trying to put it in perspective what the cost would be, or is it, a programming? All my intention here is, if this moves forward, I want to make sure if the state is going to mandate this, that the state covers the cost, because I don't want to put it on the back of the school districts that are already struggling and trying to fight for every dollar. So that's my point. Thank you.
Thank you, Representative, for that clarification. Senator, excuse me. Representative Farrar, thank you for taking the brunt up. Just before I see Representative Carpino's hand is up.
Thank you, sir. I was hoping my question got asked. I just want to talk about the finances. You're just over $1 million number. I want to understand really how you came to that number. Is that to support every female, or I think you used the term menstruating, so every individual who is in need of a feminine hygiene product for their complete needs? Is that a percentage of when they are in the school? I'm really trying to just understand your number, because unlike others who spoke before me, I don't believe that this is a partisan issue. I think this is an issue that just needs to be aired out.
Thanks, Representative. I'm happy to share a little bit, and then I'd be happy to follow up with you a little bit in regards to the math formulas associated with this. Because as you said, the funding number is based on looking at the schools across our state, the anticipated number of restrooms, the anticipated number of menstruators, and again, the usage per month per menstruator, and how that usage would again, be utilizing those products during their time in school. So it's based on, again, the research that's been done in other states who have already implemented this. And I'd be happy to share a little more detail with you, even following up from this hearing, about how that number was arrived at and some of the, again, the math behind it.
Thank you. I would just appreciate the formula, and it's a very specific question. Are we taking the total number of individuals who need to utilize this product and accounting for their average, and as everyone who's ever needed them, there really is an average, but there isn't a typical number. Are we trying to provide for their total need, or are we trying to provide for their school-based need? And so I'm just looking for a basic calculation. If you could share that with me, I would, after today, I would appreciate that so I better understand.
Absolutely, Representative, happy to.
Great idea, Representative. So we all know what we're talking about. Representative Farrar, it looks as if you're about to set the record for most questions asked by one committee of a witness. We have Representative McCartney.
Yes, thank you very much, Mr. Chair, and welcome, Representative Farrar. I'll be very brief. As I looked at the bill, I noticed that the date for implementation is effective July 2022. And so my question to you is, you can understand for the schools, it is a mandate and they do need time for preparation. Would this just be for the menstrual products themselves, or does it also, would that date say to the boards of ed that they have to have the disposable machines ready in place as well? Because I think that will be very difficult to implement with that short amount of time. Can you just comment on that?
Yeah, it's a great question. And I would say personally, and I'm sure you might hear this from other testifiers today, very open to what the date of implementation might need to be or should be for this, because we want it to work. We want it to work for our schools to ensure, as you noted, that they can get the dispensers they might need for updating purposes and to have access to the product.
Okay, thank you, Mr. Chair. Thank you.
Okay, I believe that's it, Representative. Thank you for your testimony today. Obviously, you've answered a lot of our questions, and we look forward to making sure that we have the language precise and we know how much we're talking about to actually implement this program. Seeing finally no further questions, I will thank you, and we will move on next to Representative Gupta, and I understand Representative Conley has returned, so she will be after Representative Gupta. Good morning.
Good morning, my esteemed colleagues and chairs. I'm just muting myself on my other committee meeting. So thank you so much, my esteemed colleagues, chairs and co-chairs of the public health and ranking members. I want to thank you very much for taking the time to raise the issue of HB 5303, the continuing medical education requirements concerning endometriosis and cultural competency, and the creation of a plan for the endometriosis data and bioreciprocity program. One area which I'd like to bring your attention to, which I believe is very well associated with this particular bill, is the pain management which takes place during gynecological procedures and the need for transparency and disclosure of pain management during that process. Fairly recently, I had a constituent bring this to my attention. And interestingly, they had a procedure which they found to be extremely painful. And during my discussions with other colleagues and other friends, more and more I've heard from people that there's a lack of transparency, that the procedure will be painful, both from a pre-standpoint, leading up to the procedure, during the procedure, and then post-operative. Some of the procedures that are lacking in any pain management from a gynecological standpoint is pap smears, coloscopy, the IUD placement and removal, uterine cysts and uterine polyps. And for some women who are experiencing the challenges of being able to conceive, the painful, both mental and physical pain that they experience through those procedures. Some of the things that we will hear during gynecological procedures you'll experience some tenderness. It will be uncomfortable. You'll feel a slight pinch. There might be some pressure. And after the procedure, you might want to take a little Tylenol or Ensted for it, or use a heating pad. Some of the feedback I've received from some women is more of the pain has been severe, excruciating. I've heard of women vomiting after procedures, passing out, generally extreme pain. And there is the full gamut, but I believe it's time that we need to address pain management with any gynecological procedure, and that women should have the option of the many available procedures for pain management, the oral options. They have the lidocaine, NSAIDs, inhalation, analgesias, and local applications of benzocaine. Some of our other countries, such as the United Kingdom, does administer some of these before some of these general procedures. So I'm asking the Public Health Committee to please consider this within your consideration of HB 5303. Thank you so much.
Thank you, Representative. This is a new one on me. Basically, there is no requirement to inform a patient that they may be feeling pain and that they have a right to access appropriate medication. So that there's really no rule about that currently.
Thank you very much. My understanding, again, is that when you go back to what is available within your patient bill of rights and what you do receive when you sign on to a practice, there is a clause typically in it that relates to pain management. But typically when you go in for a procedure, you're not pulling out your patient bill of rights, and neither is the practice or the patient bring it to their attention saying you have, mentioned that there is the option of pain management and discussion of pain management. So I believe what is happening within the context of gynecological procedures with women is there is a implicit bias that there is no pain in the uterine wall, the cervix, and therefore no pain management is necessary for some of these procedures. Ultimately, what I'm concerned with is the fact that a lot of women and young women who are having these procedures and experience this tremendous amount of pain are then going to not trust their professionals that should be guiding them through future procedures that are ultimately necessary for them. And they ultimately might not seek out procedures that could be life-saving.
Thank you for that. I see we have a number of questions. We've got an active group this morning. Representative Gilchrist, followed by Representative Berger-Travallo.
Thank you, Mr. Chair, and thank you, Representative Goupil, for bringing this to our attention. In doing the endometriosis work, what we heard about was this concept of the normalization of female pain, and I think this ties in directly to that. In an ideal world, what would you like to see happen? What would be the policy?
So having heard from a number of constituents who are concerned about this moving forward for the future, I think you need both at the onset of making an appointment for a procedure, some indication that there could be a level of pain associated with it. So should you prepare? Should you be taking an NSAID before that? If there's concern about blood flow, are there other pain management procedures that can be employed pre-procedure? Right before the procedure, a number of women, and I myself have experienced it, I've gone in to have a cyst removed, and or to determine whether cyst needs to be removed. And it seems as though it is viable to remove it at that particular appointment, and they go ahead and remove it without any pain management. For myself, it was extremely excruciating. So again, I hadn't thought much about it until other people started bringing this up, and I said, no, it actually has happened to me as well. So right before the procedure, there should be a pause, a discussion of what kind of pain management needs to be in place. And then obviously post-op, again, going back to the fact that a lot of women leave these procedures in extreme pain, and nothing is recommended to alleviate the pain other than maybe taking Advil or a heating pad. Most procedures, if you look to some other procedures that people have, you're typically advised that you're going to need to have somebody drive you home from a procedure, even that you might be not competent to drive.
Thank you so much. Thank you, Mr. Chair.
Thank you, Representative. Next up, Representative Berger-Chavallo, followed by Representative Tavros.
Thank you very much, Mr. Chair. My question was actually answered through Representative Gilchrist's question, but thank you very much, Representative Goupil. I will simply comment that in my experience, and very recent experience actually, in an attempt to have an IUD inserted to manage menopausal symptoms, that was the only suggestion that the practice that I very much trust and I have all of my faith in this practice, but this is what was recommended to me. There was absolutely no information given to me about what kind of pain I would be experiencing, and in fact, it was minimized by the doctor who suggested this. I began going into shock after an unsuccessful attempt at inserting this IUD. And afterwards, it was suggested that I could have a prescription for pain medication that I would take a few hours before. So my concern too is that perhaps if we're talking about in the moment procedures, that may not be enough time. So I do very much appreciate this. And the last piece of this is, in speaking to my my doctor afterwards, she said she herself thinks that for her own practice, and again, this is a doctor that I trust tremendously, when women have already delivered children, there is this assumption that their ability to withstand pain is greater than with others. So this is actually something that may be happening even more with women my age, women who have already delivered children, particularly if they delivered without pain meds. So that's kind of my perspective, and with the conversation with my practitioner, I do very much appreciate that you're bringing this to light. Thank you.
Thank you very much, Representative.
Next up, Representative Tavros.
Thank you, Chairman, and thank you, Representative Goupil, for bringing this up. Also, in my experience, this is similar situation happened to me, but with a different procedure, and it was an in-office procedure that I was not really warned about ahead of time, and then had to turn to Dr. Google after the fact because I was experiencing so much pain, and thought, oh, well, they would have told me if, I needed to take, Advil or, that sort of thing. So my question to you is, why do you think doctors and or nurses aren't providing this information? Because I can tell you from when I went online, it was an ablation procedure, gynecological procedure, and there certainly were hundreds, if not thousands, of women saying, "Oh yeah, that happened to me when they did the biopsy," or "Oh yeah, that happened to me when this happened." So I just am curious why, perhaps women aren't being informed.
And I'm by no means, and it's not my field of expertise. So what I can say from the amount of research I've been trying to do to find out why we have not moved forward, there was the 1953 Kinsey report, which I will quote that all the clinical and experimental data show that the surface of the cervix is the most completely insensitive part of the female genitalia anatomy. And we seem to have not moved on from that concept of that there is pain receptors. And I know there has been a number of studies to isolate different areas of the female genitalia to determine where the pain receptors are, in fact. But whether or not that has been adopted fully by the gynecological medical field, I'm not sure. And I have found a number of reports that have been done that I'm happy to share with the Public Health Committee on pain management, comprehensive reviews of it, pain management associated with the assertion of the uterine contraceptives and why it's not happening and what really should be happening.
Thank you so much. This has been really enlightening because it's one of those things where until women start talking about it with each other, sometimes you don't necessarily know and you think you're the only one, or, so this is critically important. Thank you so much.
Absolutely. Thank you so much, Representative.
Thank you, Representative, for your testimony, and we will take into consideration suggestion for including this in our existing legislation. Seeing no further questions, I want to thank you. With apologies to Representative Conley, we have blown through our first hour. We will go quickly to a member of the public, Joyce Liao from Yale College Democrats, followed by Representative Conley.
Good morning, everyone. My name is Joyce Liao, and I'm an undergraduate student at Yale. So as a college student, I've been caught unaware by my period multiple times. Sometimes I'd be really lucky and just have like a pad or a tampon that was just stashed in my backpack. Other times I'd have to use like a folded up toilet paper and like use that as a provisional pad before I could find a friend or run home to grab a pad because I was scared that I'd leak through my pants. In high school, students miss more of their class since like sometimes they'd have to run to the nurse's office, wait in line, and then ask for a menstrual product, and then go back to the bathroom, which takes up so much time. And now that I'm in college, menstrual products are limited to me by both access. It takes a really long time for me to walk to the nearest CVS to grab one, and sometimes they're really costly, and college students might not be able to afford them. So lack of access to menstrual products takes much more and has much further implications than just bleeding through your pants. So in a 2018 UBI Kotex survey that was conducted with YouGov, it was found that 1 in 5 low-income women report that they've missed work or other commitments such as school because of a lack of access to menstrual products. For low-income students, they might not be able to afford menstrual products, and providing these products at school allows them to attend school while they're menstruating. And then generally, by providing menstrual products in bathrooms, students would miss less class time and wouldn't have to go through the embarrassment of asking a nurse for a menstrual product. And then there's another section of this bill that requires correctional staff at your correctional facility to provide menstrual products. And I think that is absolutely necessary. Testimony from another inmate that I've read who served a 6.5-year sentence at your correctional facility said that each week her and her cellmate received only 5 menstrual products to share in between them. In a month, they would have received 20 menstrual pads total, and that means that they each have 10 to use for their menstrual cycle, which is absolutely not enough, as a light period uses about 15, and a much heavier period would probably use around 25 to 30. The inmate said that when she asked for another menstrual pad, she was often rejected and ridiculed for her request. What I'm saying is that people should never be ridiculed or humiliated for a natural bodily phenomenon. They should never have to miss school or work because of something that they have no control over. And that's why I'm urging you all to pass this bill, just to protect the rights of menstruators across Connecticut. Thank you.
Thank you for a very personal perspective in a variety of contexts. Representative Parker.
Just really briefly wanted to thank you for taking the time to I actually had the chance to come speak with some of the Yale College Dems last night, and as a Yale graduate, I'm very proud of the advocacy that you and your colleagues and classmates are doing. So thanks for being here and sharing that perspective with us.
Thank you, Representative. As another Yale graduate, I will thank you as well. Seeing no other Yale graduates with a need to speak, thank you for your testimony today. We will move to Representative Conley, followed by Lucy Nolan. Good morning, Representative.
Good morning, Representative Stasham. I appreciate you taking me. I'm sorry I missed my first call, but my morning meeting did run a little late. I'm here to testify about 2 bills today, HB 5278, an act concerning unauthorized intimate exams on a patient under deep sedation and anesthesia, as well as 5272, an act concerning menstrual products. Both bills have been before this committee for several years. And we have made progress on both bills over the years. An act concerning intimate exams has made a lot of progress since COVID. We have expanded this to intimate exams on men and women, rectal, pelvic, and prostate exams. We feel very strongly, a large group of us, that all examinations should be consented to by students, examinations that are not necessary for medical procedures. As more and more of the hospitals are changing their consent, it's showing that the public agrees with this procedure, agrees with informed consent on student procedures happening to adults. And as more and more hospitals across our state are requiring the specific informed consent, they're learning that the fears that people would not consent to these procedures are unfounded. People are consenting, but people who don't want the procedures are having the ability to say no thank you and are not getting unconsented procedures while they're under anesthesia. Second bill I'd like to talk about is an act concerning menstrual products. Students in my town have relayed and testified before this good committee last time we were open to the public, and noted that they did an exam themselves. It took 15 minutes out of classroom time to get from one of the further classrooms, wait in line at the nurse's office, get a product, use the restroom, and then go back to class. So having products accessible to our students is important so that they're learning algebra and English and science and not waiting in line at the nurse's office for a normal bodily function. But I hope that this committee moves both bills forward. Thank you.
Thank you, Representative, and for your advocacy, particularly on behalf of the intimate exams issue. Could you just answer for me, why is it you think that the hospitals have been in any way resistant to the idea of requiring such notification if they are effectively complying with the law as is?
So I think we have two issues going on. We have our larger hospitals who have been, as time has gone on, and they've seen more and more states doing this. We're up to 19 states that currently.
Representative Changa, if you could mute yourself, thank you. Thank you. Okay. Sorry about that, Representative.
That's okay. 19 states currently require the specific informed consent for exams under anesthesia. And at the first, when we started talking about this, this was a new thing, and sometimes new things cause anxiety. But as more and more of our larger hospitals are doing this and changing their consents, they're realizing that the students are still being allowed to participate and do their exams. The second issue I want to talk about is we do have residents who traveling residents who might not be at our larger learning hospitals. And it's important to have a statewide law so that way all residents and all exams at all of our hospitals are being done in the same way, not just our two large learning institutions doing it one way and others maybe not realizing that the science has changed and that it's important that we have the informed consent.
Thank you for that. Appreciate the insight, and we appreciate you were taking the time to testify in what clearly is already a busy day for you. Thank you very much. I see no further questions, so enjoy the rest of your day. Next up, we have Lucy Nolan, followed by the last of our public officials, Senator Baroni. Good morning, Lucy.
Good morning. Good morning, Senator Anwar, Representative Steinberg, Senator Wong, Senator Summers, and Representative Pettit, members of the committee. My name's Lucy Nolan. I am the Director of Policy and Public Relations at the Connecticut Alliance to End Sexual Violence. We are the state's leading voice to end sexual violence and a coalition of our 9 community-based sexual assault crisis service centers. I have testimony for 3 bills today. I will be mostly speaking on one, but I did want to mention SB 254, an act requiring long-term care facility residents to undergo a criminal history and sexual offender registry search. And we just want to say that while we know that the registry does serve a purpose in some settings, we want to be very clear that this is not going to be something that protects people, that the long care facilities will really have to always make sure that they're always on the lookout for sexual violators, and that we really applaud that looking into long-term care to make sure that they're safe places. My testimony has a lot more about that and about the recidivism rate and things like that. But the other is an act, HB 5261, an act concerning access to reproductive health care. we just want to make sure that for victims of sexual violence, it is critical that they have access to abortion. And one way to do that is to allow qualified advanced practice clinicians to be able to do aspiration abortions. And so we fully support that legislation. And finally, I want to testify on HB 5278, an act prohibiting the unauthorized intimate examination on a patient who is under deep anesthesia or unconscious. We just heard from Representative Conley, who's done some fabulous work on this bill, and what it's about. And what we want to say is that we're not legislating any standards. What the only standard we're legislating is that patients need to be asked if something is going to be done with their body for teaching purposes. And we know from studies that 90% of patients will say yes if they're asked, but they want to be asked. And if they're not asked, they feel that it could be akin to battery. And I think it's one of the things that Representative Farrar talked about is about the world hasn't caught up in some places. And I think this is one of the places that the world needs to catch up. That when we go in to have a doctor's appointment and there's a resident there, they ask us if they can come in. That's the same. What we're saying is we're asking if the resident can come in or the trainee can come in and place their digits in our body. And I think that that's a critical piece that is not difficult to get signed authorization for, especially now that we have electronic medical records that people can sign right then and there. And you'll find testimony later from a doctor who talks about how quickly and easily these questions are asked and answered.
Excuse me, Ms. Nolan, your time is almost up. If you please.
Okay, thank you. I just want to say we fully support this, but it is also critical for victims of sexual violence who carry the violence with them in their bodies, and people may not think that if they're if they're unconscious, it doesn't matter, but it does. Their body, there's a famous book, Body Keeps the Score, and it does. And so it's critical that people are asked about before having these intimate exams. Thank you.
Thank you. With regard to access to abortion, do we have an access issue in the state in which we would need to expand those who could provide the service?
You know, I think that there's a sense that Connecticut is good with reproductive rights, but there are, I think that there are becoming limited number of doctors who are able to do some of these procedures. It's also people are used to going to their ACP to get their medical care, and that they want to be able to have that continuity of medical care. So I think that, yes, there is, and there could be, particularly as as we're finding more and more of these rights are being taken away, that we have to make sure that access is available.
Thank you. Representative Gilchrist has a question.
Thank you, Mr. Chair. Thank you, Lucy, for being here and for your testimony on these three important bills. I want to follow up on 5278, the intimate exam legislation. We heard earlier that there might need to be changes made to the language to ensure that when someone is getting a sexual assault forensic exam, they are still asked if they want that exam. Could you speak to that piece and what might need to be fixed in the language?
Sure. I do not feel that the language needs to be fixed at all because, first of all, I'm not sure that it would be germane to the bill because the common law really states that evidence collection is not medical, is not medical, and so it doesn't fall under sort of the exceptions to the informed consent rule. But also Connecticut has statute, and in our technical guidelines on doing sexual assault kits, it's clear, and the statute is clear, that there has to be consent to get a sexual assault kit done by either the patient or by their legal representative. And regardless of how they present at the hospital, that evidence cannot be collected until they have permission. And I think particularly for this kind of examination, somebody has been sexually violated, in a worse way, and then to have somebody come in and decide that it's better for them to do this when in fact it may not be. And many people do not decide to report the crime for a number of reasons. And so that you can see sort of the unintended consequences, that the crime gets reported and goes to court, and here's the person who the victim is being forced to go further with something that they're not mentally prepared to do. Also, I just think we have to be very careful. We don't want to change the law to say that for the sake of evidence that we can not get consent for the exam. And finally, I just want to say there are other ways to get the information that you need to do without consent right away. If somebody is unconscious, is you can look at bruises, that doctors can write those things down. They have 5 days after the actual event to collect the evidence, internally. So it isn't as something that has to happen right away.
Okay, thank you. So you think as is, current law stands that someone would need to consent to the sexual assault exam kit, and the bill that's being heard today, because a sexual exam kit is not a medical procedure, it isn't impacted in this legislation?
Correct.
Okay, thank you. Thank you, Mr. Chair.
Thank you, Representative, and thank you again for your testimony today. Greatly appreciated. We will look at the language very carefully to make sure we get it right. Seeing no other questions, we will move on next to Senator Maroney. I've been wondering who's going to be the next James Bond. I thought it was going to be a woman, but it's clear that the next is indeed our own Senator Maroney. Welcome, Senator.
Thank you, Chairman Steinberg. Co-chairs Anwar and Steinberg, ranking members Fong, Summit, and Pettit, and distinguished members of the Public Health Committee. My name is James Maroney, not Bond, and I represent the 14th Senate District, which includes Milford, Orange, West Haven, and Woodbridge. I'm here today to testify in favor of HB 5260, an act establishing a rare disease council. With the chair's permission, I would like to yield the remainder of my time to my constituent and friend, Dominic Cotton.
Thank you, Senator. Dom, welcome.
Good morning, Chairman Steinberg. Let's make sure we're on. I'm here obviously to testify in support of HB 5260, a bill to create a rare disease advisory council, a permanent council. As many of you may know, rare disease encompasses about 7,000 different rare disease, which have up to about 200,000 or less people, and we're approximately 1/10 of the population. And obviously that doesn't include the people that are directly affected, such as family members. I know my son has a rare metabolic disorder that was diagnosed on the newborn screenings. Unfortunately, at the current time, and as is 12 years ago, there was limited information that was available to us on his disorder. Basically, we were called up and told that we had to feed our son every 3 hours without really giving us a reason why we needed to feed him every 3 hours. Both my wife and I are in the medical field. So obviously, we complained virulently about the whole situation. And come to find out that he has SCAD, where he basically doesn't process fat. And when you're a newborn, your body can't break down fat. When it runs out of energy, it starts breaking down muscle. And the biggest muscle that you have when you're a child is your heart. So he was obviously clear that if he wasn't fed on a regular basis, that he could die. So we were quite lucky. We found Deb Gould, who started Fatty Oxidation Disorders group, who's really was kind of like our savior during the initial years in helping us to get involved with Birth to Three and several other groups. I think the biggest takeaway from that one specific situation, obviously, we've had multiple situations to deal with my son. is that there are no direct links in DPH to newborn screenings and the things that they're testing for. So the main thing that I'm looking for in helping this Rare Disease Advisory Council is obviously to bring awareness and to get information available. I know I've been involved with this for the past 7 years.
Excuse me,
And,
Mr. Cotton, your time is almost up. If you could please summarize. Thank you.
Sure. And so we've come to address some of the issues in this bill that people usually disagree with. I know DPH has some issues that they brought up in their testimony. If anybody'd like to ask me about those, we have some specific answers for that. Thank you.
Thank you, Dominic, for all the work you've done over the past 7 years. And we understand your passion to help those with rare diseases and see that we have a permanent presence looking out for their interests. I see Representative Pettit has a question.
Thank you, Mr. Chair. Thank you, Mr. Cotton. I just wonder for the viewing audience and members of the committee, if you could, you mentioned information and education. Are there other concrete results you would like to have come forth from having a permanent rare disease, the Rare Disease Disorders Council? What benefits will accrue to patients, families, and the state in general?
Sure. I wanted to highlight, obviously, education, because that's one of the most important things. My son currently is in school right at the moment. He has a 504 plan to address his medical needs. Again, along those lines, his first day of school, he ended up hospitalized because the school system failed to follow his 504 plan, mainly because I don't think that they really understood his disorder. I think in the long runs, there's other people are going to be testifying. There's people that have issues with health insurance and being able to cover like needed supplies. I know my son doesn't need specialized medical formulas in order to keep him out of the house. I mean, out of the hospital. But I think the thing to look at in the wider perspective is if we provide some of these things, we can stave off people ending up going into the hospital and causing, great amounts of money towards the state. I mean, pediatric care for rare disease accounts for 40% of all cost of care for the whole pediatric population. So I think it's finding ways to be able to avoid having people go into the hospital. It's helping them to be able to find their way to a diagnosis, simplifying some of those processes. I know there's experts, geneticists that can give you more information with regards to that. But there's a simpler way to be able to do this, and that's what we're really trying to get towards with having the Rare Disease Advisory Council.
Thank you, Mr. Cotton, for your hard work, and thank you, Senator Maroney, for yielding your time. All set, Mr. Chair.
Thank you, Representative. I see we have a number of further questions. I'm not sure whether they're for the Senator or for Mr. Cotton. First up is Representative Kennedy, followed by Representative Terciak.
Thank you, Mr. Chairman, and I just want to direct my comment to Mr. Cotton. Good morning, Dominic. I don't see you on my screen. I lost you. Oh, there you are. Good morning, and thank you for coming before us. I know you've been working very, very hard on this issue, and it's hopeful that finally this Rare Disease Advisory Committee will finally move to that finish line that you've been wanting to for so long. You did answer my questions. Representative Pettit asked about your son, Michael. And I hope that the schools will help you and have better understanding of that 504 plan. That's just key. And so I again want to just thank you for your testimony and all your hard work, and I look forward to supporting this bill. And I just want to also say to you, Mr. Chairman, if I could, congratulations to Michael on his youth volunteer award that was awarded to him last week.
Thank you. Thank you very much.
Thank you, Mr. Chairman.
Thank you, Representative. Thank you for noting that distinction. Next up is Representative Terciak, followed by Senator Kushner.
Thank you very much. Thanks for coming to tell us about this important bill, Mr. Godden. You mentioned that you had answers to some specific DPH questions or comments from their testimony. I'd be many of us would be interested in hearing that, please, if you could. Thank you.
Thank you, Representative Terziak. As part of working on this bill, I always believe you have to answer your critics whenever you try to come towards this. And I know in past situations when we had a rare disease task force, part of the complications of getting it up and running was that it was originally supposed to be housed in Department of Public Health, and they were supposed to provide a forum to have that. And it had to go through several iterations because I think they were concerned about costs as well as being able to provide a person to be able to accommodate some of the secretarial or note-taking situations. I know I was on a phone call with them as well as DSS probably about a couple of months ago. And we highlighted the very need for this program. And I come to look in their testimony today, and I understand that the new commissioner is new, and this the people that we talked to was a deputy commissioner at the time, and they might have overstated the initial needs for the first year. Really, what we want to be able to do is get this up and running by October, be able to meet. We have several people that have offered venues, including several hospitals, Jackson Labs. So the venue isn't a question. We have written into the bill to be able to raise money to be able to pay for services. Obviously, we figure that those would be very limited, as it would be somebody to record the event. I think DPH, because of the magnitude of the issues with our community, kind of went ahead and was looking 5 years into the future, whereas we're looking specifically at this year to be able to start making recommendations. And obviously, there is a clear need for awareness materials, but we were looking to be able to provide some of those things. And I believe it would be limited, very limited in the first year. And look, I know my son just raised $1,800 for the Alzheimer's Association. I doubt that we would have any specific issues with raising some amount of money in order to be able to provide for those services. But obviously, the first meeting would have to be brought up by Department of Public Health as we're housed with them. So, like I said, I know it's a non-budget year, so I don't want to clog up the system with having to go to another committee. That's why we were offering this, so that we can make sure that this gets passed.
Thank you very much. I'm all set, Mr. Chairman. Thank you.
Thank you, Representative. Representative McCarty.
Yes, thank you very much, Mr. Chair, and welcome, Dominic. It's good to see you.
It's good to see you, too.
Thank you. Could you just comment for a moment? I was looking through the bill proposal at the makeup of the advisory council, and I'm just wondering, because you mentioned an issue that you had with your son, do you feel that the membership is complete, or do you see room? And I was very pleased to see someone who's actually experiencing a rare disease will be part of council. That's excellent. But are there any gaps in the appointments?
So I believe there's 15 appointments, and two points to that. One was we're a little bit unusual in the nomination process because obviously we're having the chairs and the ranking members of public health be able to appoint people, because we felt that it was be expeditious due to previous experiences. I think the current breakdown of the committee is probably about a third patient representatives, a third doctors and other hospital representatives. Obviously, you have the people that are necessary, like Department of Insurance, Department of Public Health, and Department of Social Services. So I feel it's a good breakdown. I think one of the things that we're looking towards is being collaborative. And so where DPH might have some concerns that they don't have people that have the necessary knowledge on the subject matter, we're creating that opportunity to be able to collaborate and give them that information. So having it, obviously, this is from a patient's perspective, but in the larger picture, you know, we're looking at opportunities to bring specialties to Connecticut. Obviously, we have Alexon Pharmaceuticals, Jackson Labs involved with this, the Hospital Association. So really, we want to also, there's an opportunity to bring business. And, you know, I know that this is a big part that will help not only our rare disease community, but also Connecticut itself.
Great. Thank you, Mr. Chair.
Thank you, Representative. And again, thank you, Dom, for all your hard work on this. And we are very pleased to have this bill before us this year.
Thank you.
Before I let you go, I see Senator Wong has raised his hand.
Hi, Dom. Thank you very, very much. Thank you, Mr. Chair. Thank you very much for your great work. And I just want to take a moment and echo the sentiment of so many of my colleagues in their exchanges with you. But I just want to also acknowledge all the wonderful parents who have fought and advocated for their loved ones on this important issue. So thanks, Dom. You're omnipresent.
Thank you very much.
And, it makes a difference. Much appreciated.
I appreciate it.
Thank you, Senator. All right, I don't see any further questions. Thank Senator Maroney and Mr. Cotton for your testimony today. We next have Jennifer Gaines, followed by Renee Mason-Craig.
Hello, good morning, co-chairs and committee members. I'm proud to be here today to testify in support of House Bill 5272, an act concerning menstrual products. So thank you for this opportunity. My name is Jennifer Gaines, and I'm the program director for the Alliance for Period Supplies, a national network of more than 120 independently operated organizations that collect, warehouse, and distribute millions of period supplies every year in their local communities, helping to serve individuals, children, and families who struggle to afford basic material necessities. The Alliance for Period Supplies is headquartered here in New Haven, Connecticut, and our allied partner in the state is the Diaper Bank of Connecticut. At the Alliance for Period Supplies, we work to end period poverty in the United States. Half of the population menstruates, yet 1 in 4 people struggle to purchase period supplies due to lack of income. This is period poverty. We strongly believe that no student should miss school, no adult should miss work, and no person should miss out on daily life simply because they are unable to afford the material basic necessities that we all require to thrive. This legislation focuses on increasing access to period products and ensuring equitable access to education for all students. In a national study, nearly 1/3 of students who menstruate report missing school due to a lack of period products. Even when menstrual products are available in a school's nurse's office, students must go there and ask for a basic necessity that should be as freely available as toilet paper is. This also means they lose time in classroom compared to their non-menstruating peers. This bill reflects a growing bipartisan effort we are seeing across the country. 13 states and the District of Columbia have passed legislation to provide free period products in schools. And just last week, Utah unanimously passed a bill, thereby becoming the 14th state to recognize that basic necessities matter. Currently, 16 additional states, including Connecticut, are considering bills that will put period products in schools. Students are calling for policy reform, and they are demanding that period products be recognized as a basic human necessity. We at the Alliance for Period Supplies know that funding is vital to the equitable implementation of this legislation. Only 3 states have passed bills with the funding necessary to ensure that school districts with limited resources can equitably provide all students with the period supplies they need. In states that have not included funding with their bills, our member basic necessity banks have heard and seen that the products aren't being made available to students most in need. So we look forward to working with Representative Farrar and the stakeholders to make sure that legislation gets done equitably. So thank you for allowing me to testify today in support of this initiative that will make a difference in the lives of people who menstruate in our state of Connecticut.
Thank you for your testimony today. Very much on point and appreciated. I don't see any questions. So again, thank you for your testimony. Next up is Renee Mason-Craig, followed by June Vendetti.
Good morning, Public Health Committee. Thank you, co-chairs, vice chairs, and members of the committee for having me today. My name is Rodney Mason-Craig. I reside in the 72nd District of Waterbury, and I am here to support HB 5272, an act concerning menstrual products. I not only am an advocate for menstrual equity, I am an owner and founder of a nonprofit organization here in Waterbury, Connecticut, Helping Hands with Open Hearts, where since 2017, we have not only advocated for menstrual equity, but provided menstrual products to school-age children, people homeless in the homeless shelters, just kind of anybody in Waterbury who needed menstrual products. So I support this bill because getting a period isn't a choice. It's just gonna happen. It's biology. These products are not luxury items. These products are necessities. I just want to thank Jennifer and the Alliance for Period Supplies and all the statistics that you just brought about this necessary issue. Unlike Senator Summers' daughter, where she said that this isn't an issue at her school, that's not the case for the girls in the schools where I am from. This is a big problem, and we have been working very hard to address it. So I also want to thank Representative Ferrari for campaigning for this, and everyone who, all the representatives that were campaigning for this and asking questions. I think you guys are phenomenal, and I want to work together to get this done for Connecticut. I also want to highlight that just the embarrassment that can come when you're out and you get your period. This isn't just for the schoolgirls. This is for people like myself. I was just out this weekend and I got my period. I had no products. I have the means to step into a store and go buy something. Everyone doesn't. So putting products in public places, schools and universities, shelters, correctional facilities, that's the right thing to do. More access is going to alleviate a lot of health issues that we are seeing and that can be related to using menstrual products for too long or not having enough supply. Thank you guys for your time.
Thank you for your testimony. That was really very helpful and very directed. We appreciate it. I don't see any questions, so we appreciate it. We will move on next to June Vendetti, followed by Andrea Sanchez.
Good morning, Public Healthcare Committee members. I'm here to testify against HR 5261. When I look at the word reproductive in the title of this bill, I ask what exactly is being reproduced in this bill. All I see is the taking away of human life in the most brutal and barbaric way possible. Without any anesthesia, the baby's limbs are torn from its body in a painfully horrific way. What if you were being torn limb by limb without any anesthesia? How would you feel? I thought the practice of barbarism ended a long time ago, but since abortion became legal on that fateful day in January of 1973, over 60 million lives have been snuffed out because of selfishness or immaturity, or because one of the partners is forcing the other one to abort the life growing inside the mother. Then there's the issue of selling baby body parts. How gruesome, How could we, as a civilized society, even allow such evil to take place? These are the sins that cry out to heaven for vengeance. Everything that we're going through right now is a direct result of our sinfulness, our arrogance, and our disobedience to God. It is unconscionable to call abortion reproductive health care. Quite the contrary, it's the killing of human life, which goes against the fifth commandment, thou shalt not kill. It's time to end this brutality. It's gone on for far too long. It's time for women to take a step back, to examine their conscience, to see how demoralized and desensitized they've become. When Roe v. Wade became legal, the first words out of my mouth were, no woman would ever kill her own flesh and blood. Boy, was I wrong. But I was much younger then, and I thought everyone thought like me. How I wish they had. Perhaps we would not be talking about abortion today. Life is too short, very short, for those whose lives have been terminated before being given a chance to live. Thank you very much.
Thank you for sharing your personal beliefs. Next up is Andrea Sanchez, followed by Elise Coutua. Is Andrea here? Okay, I missed a notification. She's not available. Next up is Elise Coutua, followed by Colleen Quinn.
Hi, good morning. Can you see me?
We're good to go.
All right. All right. Good morning, Chairman Stenberg and committee members. My name is Dr. Elise Coutua, and I'm the Associate Director for Single Cell at the Jackson Laboratory. I'm here today because I am a molecular biologist and scientific researcher, and I work specifically on endometriosis. As the driver of a clinical and biological research program, I do study endometriosis at the molecular level to better understand this disease and in order to identify better diagnostics and treatments. Today, I'd like to support HB 5303 for the act of creating a plan for an endometriosis data and biorepository program. So endometriosis affects 1 out of 10 female-born individuals in the state of Connecticut. This is 6.5 million individuals in the US and more than 200 million worldwide, independent of sociocultural status or race. Endometriosis is a prevalent disease that causes debilitating symptoms for patients. It is a burden that not only affects individuals, but the family, the healthcare system, and all society, with an economic impact greater than $20 billion per year in the US only. And yet, despite this huge prevalence and associated burden, endometriosis as a disease remains largely not understood. As a result, there's a diagnostic delay of 7 years on average after the first symptoms, and this disease is often misdiagnosed or missed altogether. So diagnostic tools and effective treatments are dramatically needed for patients suffering endometriosis. Endometriosis is a complex and highly heterogeneous disease, and our lack of fundamental understanding of its biology is why we don't have proper treatment options, or why we don't understand the condition that fosters its initiation, progression, and recurrence. So we need more investigation. We can obtain proper and accurate understanding of endometriosis by creating a collection of clinical data and biospecimens for the state of Connecticut through combining surgical and clinical with biological sample information. We also need to have sufficient power for extensive and representative data sets of all patients, all background, and all communities affected by the disease. This will allow us to disseminate information and raise awareness towards improving our understanding of endometriosis in an unbiased way. This plan will be informed by the successful foundational partnership that is already in place between the Jackson Laboratory and the Yukon Health Center, which includes pioneer single-cell study of endometriosis patients. Yukon Health is a center of excellence in minimally invasive gynecology surgery and an endometriosis reference center. And the Jackson Lab stands as an expert research institution for the study of human diseases using advanced molecular biotechnologies. The creation of a plan for an endometriosis data and biorepository program for the state of Connecticut will provide us researchers and clinicians with the tools we need to affect real progress in the fight against endometriosis. I'd like to thank the committee for the opportunity to testify in favor of HB 5303, and we'll be happy to answer any questions.
Thank you very much for all the work you do. We are also proud to have Jackson Laboratory in the state of Connecticut and all of its groundbreaking work. Your insights into this challenging topic, as you say, it's not well understood, is extremely valuable to us. I see we have some questions. Representative Gilchrist, followed by Representative Pettit, and I will add that Representative Gilchrist will be taking over for me shortly.
Thank you, Mr. Chair, and thank you so much, Dr. Courtois. It has been a pleasure working with you on the endometriosis working group, and I thank you for your testimony. Just wondering if you could share what is the current way that individuals are diagnosed for endometriosis?
So at this point, the final diagnostic relies on surgery. So it's laparoscopic invasive surgery to actually identify the presence of lesions. That is the gold standard for a diagnostic of this disease. We can use imaging in some cases for to identify like big lesions in the ovary, for example, but this doesn't apply to all patients. So invasive surgery is the final way to actually diagnose this disease. There is no other tools to do it.
Thank you, and that is very invasive. So it would be fantastic if we can move the needle and find some other ways to diagnose endometriosis. My second and final question, based on your experience, the rate at which individuals experience endometriosis, do you find that with other comparable diseases, there's this type of lack of research and information, or is it seemingly unique to this disease?
So there is definitely a huge lack of information and understanding that basically will drive a better diagnostic. And this is very specific to endometriosis or gynecological diseases, because this is a field that is heavily underfunded for research. We basically don't have the tools yet to have a proper understanding and proper diagnostic, just because in particular gynecological diseases are not well funded at the research side.
Thank you, Doctor. Thank you, Mr. Chair.
You're in charge now.
All right, sounds good. Switching gears, then next we have a question from Representative Pettit. Go right ahead.
Thank you, Madam Chair. Thank you, Dr. Seems like it should be Courtois. For myself and for the general public, I'm not completely sure what this adds beyond what, say, Jackson can do in working with UConn, Yale, or other facilities in terms of attempting to obtain, what is the benefit that you see? And has Jackson done this with other disease processes in Maine or Connecticut or elsewhere in terms of trying to create a partnership to increase research and knowledge? And I'm kind of broad, but I'd just like to hear your perspective from Jackson's point of view.
So first, I'd like to say that Jax already collaborates with UConn. So it is very important to have this partnership where you actually bring specialties and expertise of biological research with clinical research. I think it is important to actually establish a very unbiased and overview of all patients that are affected by this disease. In addition to the difficulty to diagnose, there is also a lot of bias that are affecting different communities. So by creating a biorepository that encompasses all those different things, like the heterogeneity in the clinical presentation, the biological heterogeneity for us to understand, but also collects data from all the communities, but are some very often left undiagnosed because of different bias, that will be basically creating the foundational for like advanced research. That will be also, the goal is to really do something at the state level, starting first with the partnership between Yukon and JAX, but expanding it for the whole Connecticut to make really like a resource of foundational work that will support the future research and will put the Connecticut state in a competitive place for advancing research in this field. So it's double. We have to cover all the population, but at the same time, we have to partner to make it powerful enough so it's sufficient for sustaining research.
So the Department of Public Health would retain the phenotypic information, name, age, presentation, symptoms, etc., and Jackson and or Yukon would have data concerning, say, the DNA or the pathology specimens, or would that be the divide? The DPH would more be in charge of the phenotypic, and Jackson and Yukon would be in charge of the scientific end of it?
So this is still a plan that is ongoing. We actually will collaborate with the DPH to form this plan and to actually establish all the different roles into this biorepository project that will need to be finalized and concreted. But we could think about like a shared role for the different institutions, not yet finalized.
Thank you, Doctor. Thank you, Madam Chair.
Thank you.
Thank you, Dr. Pettit, and thank you, Dr. Courtois. We don't have any additional questions. Thank you again for being here and for your testimony.
Thank you.
All right, next we are going to hear from number 16, Polly Moran. Polly, are you with us? All right, I'll come back if you do get on. I'm gonna move to number 17, Jessica Quinter.
Hi, can you hear me?
Yes, I can. Go right ahead.
Okay, great. Good morning, distinguished members of the Public Health Committee. My name is Jessica Quinter and I'm a resident of New Haven. I'm testifying today in support of raised House Bill 5261, an act increasing access to reproductive health care. I'm a second-year student at Yale Law School, a student director of the School's Reproductive Rights and Justice Project Clinic, as well as a student director of the Haven Medical Legal Partnership and a student fellow with the Solomon Center for Health Law and Policy. But most importantly, I'm a person who can become pregnant, who may need abortion care, and who is counting on my state to protect my human right to determine my own reproductive future. And I should say the views I express today are my own and do not represent the institutional views of Yale Law School, if any. At a time of proliferating threats to our reproductive rights, it's important for Connecticut to do all it can to expand access to abortion. HB 5261 is an important move in that direction. And allowing qualified advanced practice clinicians to provide aspiration abortion, Connecticut will be catching up to the more than a dozen states that already do so, including states as nearby as our Northeast neighbors and as far away as Alaska, which just became the most recent addition to that list this past November. Laws artificially limiting who may provide abortions are medically unnecessary and only serve to restrict access to healthcare. To be sure, Connecticut has been a leader in promoting the equality of its citizens, but abortion access in the Constitution state is far from perfect, particularly for communities that already face systemic barriers to care. Expanding the pool of procedural abortion providers with the passage of HB 5261 is a common sense, concrete step Connecticut can take to address this. Moreover, as the members of this committee are surely well aware, the fate of Roe v. Wade hangs in the balance. It remains to be seen whether come June, federal protections are eliminated outright or severely undermined. But what's certain is that states hostile to reproductive autonomy will do all they can to make abortion a practical impossibility within their borders. Connecticut can play a crucial role in making normal, needed reproductive health care more accessible for people across the country. In closing, I strongly support this bill with the recommended language changes provided by the medical professionals and advocates that best reflect modern medical practices. And I urge the committee and Connecticut lawmakers to vote favorably and take immediate action to expand access to abortion care and improve the health and safety of people in our state. Thanks very much for your time, and I would welcome any questions.
Thank you, Ms. Quinter. And we do. Senator Haskell, go right ahead.
Thank you so much, Madam Chair, and Jess, good to see you today. Thank you so much for your testimony. You mentioned very briefly that this reform has the potential to impact some communities more than others, that some communities disproportionately lack access. And I wanted to just give you an opportunity to expand on that and talk about why this bill might be especially important for perhaps New Haven, where I believe you said you live, or perhaps other neighborhoods around Connecticut.
Yeah, absolutely. Thank you for the opportunity, Senator Haskell. Certainly, we're privileged in Connecticut to have a number of abortion providing facilities across the state, but that number has been dwindling. And for folks who face economic barriers to care, transportation issues, things of that nature, it can be really hard to find an appointment. Even at some of our larger providers, the wait time can be several weeks for an abortion. And not only will this just expand access in general, but it will make it easier for folks to obtain abortion care from their usual provider, whether that be a nurse practitioner, a physician assistant, or other APC. And so, which is important for just comfortability and continuance of care and things of that nature. So I think that this would allow folks who already face a lot of obstacles to accessing care due to things like finding time with finding childcare, if they have abnormal shift work and things of that nature, to really just open up appointment availability and make this accessible across the state.
Wonderful. Well, thank you so much for your time and for your testimony today. And thank you, Madam Chair.
Thank you, Senator Haskell. Thank you again, Ms. Quinter. Have a great afternoon.
Thanks so much.
Next, we'll hear from number 18, Angela Mareska.
Hello. Dear Senator Anwar, Representative Steinberg, Gilchrist, and distinguished members of the Public Health Committee. Thank you so much for having me here today and giving me the opportunity to share my experience. My name's Angela Mareska. I'm from East Haven, Connecticut, and I'm a physician assistant at Planned Parenthood of Southern New England, PPSNE. I am testifying in support of raised House Bill 5261, an act increasing access to reproductive health care. This bill addresses a critical public health need, expanding abortion access in our state by eliminating barriers to essential, time-sensitive health care and modernizing our abortion regulations in line with advancements in medical practice. I have been involved in providing health care since 1985, when I began working in one of New Haven's first abortion clinics, Women's Health Services. I was so inspired by this experience that I became a physician assistant. I spent over 24 years providing reproductive health care in New York City. I have returned to Connecticut and have continued to provide the work that I'm committed to at Planned Parenthood of Southern New England for over 7 years. And as a medical abortion provider, I feel privileged to be able to provide women the abortion care they need. Abortion, including medication and aspiration abortion, is one of the safest medical procedures in the United States. Almost 90% of abortions occur under 13 weeks gestation. Providers like myself can be trained to provide first trimester aspiration abortions at the same level of safety as physicians. In fact, they have been performing aspiration abortions with clinically equivalent patient outcomes, very safe and satisfied in other states. It's time for Connecticut to catch up to the 14 states who permit advanced practice clinicians to perform procedural abortion, including New York, New Jersey, and Massachusetts. In Connecticut, advanced practice clinicians also provide a wide range of reproductive health procedures that are similar to or more complex than procedural abortion, including IUD insertions, endometrial biopsies, and colposcopies. I have patients who come to me within their first trimester who have chosen to terminate their pregnancy with a vacuum aspiration procedure. They come early enough with ample time to have this procedure done. It is quite common for women to have to wait 2 weeks for an appointment because there are not enough abortion providers here in Connecticut. Meanwhile, I and so many other advanced practice clinicians are willing to learn and will be able to provide this service, and we're prevented from doing that. I strongly support raised HB 5261. I urge the committee and Connecticut lawmakers to vote favorably and take immediate action to expand access to abortion care and improve the health and safety of people in our state, This is a matter of public health, as no one should face delays to time-sensitive essential abortion care due to medically unnecessary barriers. Thank you for your time.
Thank you, Ms. Mareska, for your testimony today. We do have a question. Representative Pettit, go right ahead.
Thank you, Madam Chair. Thank you, Mrs. Mareska. In my previous practice, I worked with PAs and APRNs, but that we didn't do procedures. Can you just educate me and the public? Are PAs currently allowed to do gynecologic procedures or first trimester abortions, and is that part of your current clinical training at this point?
So PAs throughout the state do many procedures, I don't know if you know, but there are we have a lot of surgical PAs and just PAs in general. In terms of OBGYN, we do many procedures. Right now, the only procedure in the first trimester abortion is a medical abortion. The vacuum aspiration procedure is actually quite simple procedure and is very similar to some of the stuff that we already do. Right now, we haven't been trained on them. We want to be trained and we want to learn and we want to perform them. We're just not allowed to right now.
Well, maybe perhaps outside your area, from your organizations, do you know whether or not that the PAs would require a certain education and a review of scope of practice to be able to go forward with this procedure? Do you know what the procedure or policy would be?
Sure. So Planned Parenthood has very specific procedures about training clinicians. And in fact, it's actually quite a large scope because Planned Parenthood is part of the Planned Parenthood Federation, and there are standards of practice throughout the country. And the training is standardized in every single state for all kinds of procedures. So there's a very rigorous training, both from a didactic, we have to really watch videos and we have to be observed. I mean, it's a lot of training. Usually it takes a while to be trained. When I first came on, I had to learn IUD insertions, biopsies. I don't do colposcopies, but colposcopies take months of training. So, but Planned Parenthood is really great about really training clinicians the right way. In fact, I've been a PA since '91, and I have to say, Planned Parenthood is one of the best organizations I've ever worked with in terms of the support and learning from the physicians and other people I work with. So yes, there would be very specific training.
Do you have you mentioned something about the weight? Do you have any idea, and I know it's probably a number I wouldn't be aware of in practice, how many providers of abortions currently practice in the state of Connecticut? Maybe I could ask someone from Planned Parenthood if they testify.
I would defer that to probably the people who are speaking in next. There's a CEO coming, a lot of people coming, but remember there's medical abortions and there's the basically the vacuum aspiration abortion. There's two separate procedures. We can do the medical abortions, which is considered a procedure in a sense. And the only ones who can perform are MDs. So that I would defer to other people who will speak how many. I do know that there's not enough.
Would you just explain for the non-clinical people what a medical abortion would entail? What the type you said that you now participate in?
Sure. A medical abortion is basically there's medications that are used, two medications specifically. One medication is mifepristone, which is a medication that stops the pregnancy from growing, basically. And then there's another medication, misoprostol, that causes cramping of the uterus to expel the pregnancy. People come to Planned Parenthood. We do a large amount of medical abortions. And the PAs and nurse practitioners and midwives, we go through a rigorous training. We need to do ultrasounds, all kinds of follow-up. But yeah, that's basically it.
All right, I appreciate your testimony and thank you for all the hard work I suspect you've done over the past couple of years. Thank you. Thank you, Madam Chair.
Thank you, Representative Pettit. I have a follow-up question based on this line of discussion. To your knowledge, are there PAs, are your colleague PAs in other states who work at Planned Parenthood performing aspiration abortions?
Yes. Yes. And in states, yeah, there's many states. Yeah. Yeah. It's just a little little glitch in the law here. Yeah, there's 14 states, I believe, altogether. And yes, definitely.
Thank you.
And we want to be part of them.
Yeah. Thank you for your testimony. I don't see any other questions. Have a great afternoon.
Thank you, you too.
Next, we're going to go back to 16 to Polly Moran.
Hello, thank you, everyone. Thank you, Representative Gilchrist, Senator Anwar, Representative Steinberg, and all the members of the Public Health Committee. My PA colleague said so much of what I was going to say, but I will add my 2 cents, so hopefully it can be quick, but very happy to answer any questions. I too am someone who has seen our profession evolve over the past 30 years. I've been a nurse midwife in Hartford for 30 years now and working exclusively with reproductive health, OB, and vulvar vaginal disorders. So and I think, Dr. Pettit and Dr. Anwar can also talk about this, but within the scope of health care, we are going with ongoing education all the time. So we are, over the course of the years, we have learned new equipment, new technology, new procedures as healthcare changes. We do, as nurse midwives, we place LARCs, which are long-active contraception. So that might be an implant in the arm. That might be one of the 5 IUDs that exist. I do vulvar biopsies. We repair third-degree tears when the rectal muscle is partially torn with birth. We manage postpartum hemorrhage and evacuate uteruses. We do endometrial biopsies. I did not leave midwifery school with all of that. And over the course of the years, I have had ongoing education, some of it being certified, some workshops, some as we do ongoing education every year to meet the state standards of our statutes. We know that the aspiration abortion is not only would be great for ongoing care for our patients, but also for ongoing care for our patients that are seeking abortion care, but also for our patients who are post-miscarriage care. So that is another aspect that would allow us to maintain consistency of care when people have had miscarriages, but yet there's still some tissue or clots that might interfere with their, setting themselves up for some types of infections like hemorrhage or infection. So the same procedure could be used to basically clean up the uterine and cavity and make sure that they are not at risk for further complications. As was stated, 14 states already allow this for the advanced practice clinicians. This is not a new change in a statute to Dr. Pettit's question. It's not out of scope of practice. Many things as we have moved forward have been added, and we frankly have never had to come before a legislative committee to get that approval. So it's a little infuriating, only because like colposcopies, ultrasound certificates now, part of our professional responsibility is to stay on top of the newest research and to learn new techniques to better care for our patients. Too often, I think that the whole issue around abortion, despite it being a constitutional right, is politicized. And so this becomes a separate statute when really it just is part of our everyday care that we should be providing to people.
Excuse me, Ms. Moran, your time is almost up. If you could please summarize.
Okay, thank you so much. Just to reiterate, in my professional life, I've seen so many changes to my own practice. We have acquired new skills along the way. This would just be one of many. I think it's an extremely important one to have as we see other restrictions towards access to abortion happening in other states. I will be very happy to continue care to my patients that need this in order to meet their needs wherever they may be. Thank you all so much for your allowing us to present. And if anyone has any questions, I'd be happy to entertain them.
Thank you so much, Ms. Moran, for being here today. Good to see you. We do have a question. Dr. Pettit, go right ahead.
Thank you, Madam Chair. Thank you, Mrs. Moran, for your testimony. No, I don't think anyone on this committee expects us to make decisions in terms of scope. Typically, review of practice issues go to DPH and then come to us with DPH's blessing or without their blessing. As I understood your testimony, it sounds like nurse midwives perform many things that seem that they would be able to perform first trimester abortions well. So you're saying that for nurse midwives, that is currently within your usual scope of practice?
Well, we don't do it because of the controversy and because of the statute. So I think this is why this is coming up, because we hope to modernize with the raised House Bill 5261. We hope to modernize the language around what is our scope of practice, but we do not, I don't know of any, I did throw it out to our affiliate to see if anybody was using aspiration as a way of a partial miscarriage. And I don't see that we are. Everyone felt like it was still a legal issue, and therefore hopefully this will clarify with this legislation so that that will no longer be something that we can't offer our patients when they're in that situation. To your question.
Go ahead. No, all said. Thank you for that response, and thank you, Madam Chair.
Thank you, Dr. Pettit. We have a question. Senator Anwar, go right ahead.
Thank you, Madam Chair. Thank you, Ms. Moran, for your testimony. I heard the term that you are looking to modernize the procedure. Tell me, how are you going to modernize through this legislation? I want to make sure I may have missed something.
Not modernize the procedure, modernize the statute to better reflect what we can do, and to, I think both in language, there's some issues with language, making it a little bit less binary, along with other elements of what 5261 could, if passed, would bring to the table. So it wouldn't be modernizing the procedure. It would certainly be giving us another tool to better do consistency of care and better care for our patients.
Okay, so it's not modernizing the procedure. It is just trying to give a level of access, different level of access, and just because you feel that increasing the access is part of the modernization, it's not the skill that is getting modernized. I want to clarify, because the word modernize can give a perception that we are going to improve the procedure in some respects.
No,
but it's
nothing to do with the
that.
procedure itself, but just into the access and equity of our patients' ability to continue care with us, their primary care provider, in terms of reproductive health procedures, so that they can stay with us, we can carry through and accompany them through those decisions that they're making.
Thank you so much. And Ms. Moran, what can go wrong with the procedure?
What can go wrong? You could have some bleeding. You could have a uterus that might get perforated, or in less medical terms, get a hole through the infection. You could have a tissue left behind that might create a further need for another type of procedure, or a repetition of that. But once again, those are not risks that we are unaware of, or that we don't also take into account when we insert IUDs or do endometrial biopsies. So I feel very similar to that, once trained and getting the skills necessary, that those are already things that we think about whenever we are entering the uterine cavity. So in that way, it would not be extremely different.
And when I listen to some of the potential risks, there's a theoretical risk of perforation, retained fetal products, and bleeding and infection. All of them, if not identified and managed, can they lead to disastrous outcomes?
I mean, yes, theoretically they could, but that is why we provide consistent cares to manage those any type of complications too. We always work in a
And-
team fashion, so it's not as if we're, you know, we are always have our backup physicians available if need be. Many of things like the infection or the retained tissue, those are usually something that are seen as a, you know, not immediate situation. So once again, providing integral, complete, comprehensive care, we want to minimize those possibilities, but we also are not saying go out and go forth. It's obviously we're doing follow-up with our patients to make sure that they've come through the procedure well and that they have no complications.
No, I just want to make sure that there, and could you tell me how is the training that you get different from the American College of OBGYN recommendations?
Well, we haven't gotten the training yet, so I can't actually comment on that, but there are institutions that are doing that already, and they are the very similar modules for this particular procedure. There's already organizations that have modules and training sessions.
Okay, so some of the modules that are there, who has created those and who oversees that?
I mean, I think there's a whole literature that we could certainly supply for all of you if you want to look at that. I think that others who are on the educational part may be able to address that better. But I think just like physicians, we also do we can sign up for workshops, we can get certified. Oftentimes, you know, I'm just thinking about colposcopy since we're not doing the aspiration abortions yet. Oftentimes there'll be, you know, a few days prior to say the national conference or, you know, with the college, where they'll have a workshop. So you are there for, you know, 16 hours or X amount of hours doing a full integrated workshop directed at a certain skill acquirement. So I suppose that would be one way to do that.
So
we can certainly
I may
look
have
to
missed
some
that.
of the
So,
other, oh, sorry.
yeah, no. So you said that in the backup, you have a physician that you would reach out to when there is a concern that something has gone wrong.
Certainly. Yep. That's how I think all of us work as a team approach anyway.
So within your organization, is it a physician-led team that's managing this?
Midwives can have their own practices, so not always. I happen to work for a physician, but there would be others that have their contractual relationship, just like people have contractual relations. You are a primary care, and so you have the person that you use for your orthopedics people. You know, once again, it's a team-based approach. So when it is out of our scope of care, or you know, if someone needs a C-section, even though you are a midwifery run program, you would obviously not do the C-section. So the contract would be step in and do that. So same thing, you would say, you know, I'm concerned that, you know, there are products of conception. I think maybe she needs a D&E, and then that would be then our physician backup would be the person that we would have do that.
And I think Dr. Pettit had already alluded to the fact that it's the DPH which will decide the scope of the practice component, and less so than this body. But I wanted to make sure that we as collectively can understand the issue. With respect to the issue, can you tell me any insight into the waiting period for somebody who's seeking an abortion in our state?
Yeah, I mean, I think it's different because frankly, as you well know, being a doctor, that oftentimes there's issues around who is in your network, and do you have public insurance? Do you have private insurance? So I think that it really makes a huge difference. I can say that, say for, it can sometimes be a week or two to get somebody in for a surgical abortion, at least in my in our area in Hartford, less so for medical abortion. So I can bring somebody in. It's a 2-day thing where they come in and get an ultrasound, and then they can take the Mifeprex. But then they do return 2 weeks later also for a repeat ultrasound to address some of the issues that you had pointed out with possible complications. Same with the bleeding, the retained products, and the infection are also possible for medical abortion. So we always do a 2-week follow-up for an ultrasound, which I suspect we would have a very similar protocol once we're able to do the aspiration abortion. So people are educated to the possible complications. But, I think part of this effort is one, myself as a person who likes to follow my patients throughout their, every step of their care, this gives me another tool to use in order to be able to follow them and allow me to take care of them rather than having to use the backup physician for this at this level. But the second thing I think too is as abortion access is being tightened in other parts of the country, will we see, hopefully as we move forward and expand access, will we see an uptick? And we know that the medical community is aging in terms of abortion. A lot of the doctors that are doing abortions in the state are we're not old, but we're more mature age. So there is a concern that there won't be enough practitioners in the near future. So part of this is an effort as we see more and more advanced practice clinicians starting to move into, when we're looking at numbers, that is growing, and some of the OB/GYN numbers are falling. So it's a way to also address a future possible shortage. I think Connecticut has a much better ability to accommodate our patients, but it's not perfect.
Let me, you alluded to something that's very important. Thank you for bringing that up. Many of the OB/GYN that I know that have left our state, they have left because the malpractice insurance and the lack of insurance reform for physicians is so poor that you're better off not practicing OB/GYN in the state of Connecticut. And then that's the reason that many hospitals have stopped providing that service. Are the malpractice insurance for the midwife at the same level as the OB/GYN doctors?
It is rising, but it is not, we do not pay the type of rates that OB/GYNs pay. Oftentimes, for those of us that work with a OB/GYN, we are in an umbrella kind of situation where the practice is insured. And so we have our own, I'm even forgetting the terminology, but like it will follow us. What is it called when you go elsewhere and it follows you in case case happens? I can't remember what it's called. So, but we are usually kind of like, we as She Medical, my practice, we are all in it together. But we do not pay the rates. Some of the other midwives around the state that are in independent practice, they can talk about how, yes, in fact, that is a huge part of what they have to pay for overhead.
Right. Thank you. And I'm probably going in a tangent, so I'll stop here. The issue is that we go back to my patients. They're going to kill me. Right. No, but because we have not addressed the malpractice disaster that we in our state of Connecticut have allowed. So every OB/GYN and slowly more doctors are going to leave, and then we'll hear statements like, well, we don't have mature doctors in the state anymore. We have too mature doctors in the community. And that's why we need to have the scope of everybody change.
I will come testify on that bill, Dr. Anwar. When you write it, I will testify.
Okay, it'll be an insurance. Thank you so much, Madam Chair. Thank you for indulging me.
Thank you, Senator Anwar. And Polly, I don't want to hold you up too much longer, but I do have two quick questions. One is, do nurse midwives deliver babies?
Mommies deliver their babies.
Oh, I'm sorry. Do you help deliver?
We call it catching babies.
Okay.
But yeah, nurse midwives catch babies.
And it's my understanding that delivery is actually a much more complicated procedure than aspiration abortion. Is that your understanding?
Absolutely. I mean, really, aspiration abortion is a very, very, very safe procedure. And once again, I would say that it's very much in line with what we already do as an office procedure in the office in terms of even, I mean, the actual skill of introducing something into the uterus. So it's super safe. Terminations are something that, you know, between the medical abortion and the aspiration abortion, we can do very early, and it minimizes the risks.
Wonderful, thank you. And do your colleague nurse midwives in other states perform aspiration abortion currently?
They do. They do. And ACOG and ACNM, our college, also support that, that we can and should.
Great. Thank you for your testimony and your time. And thanks for catching those babies.
All right. Bye. Thank you all. Have a nice day.
You too. Next, we will hear from number 19, Cindy Prizio. Go right ahead.
Good morning to the chairs, vice chairs, ranking members, and all esteemed members of public health. My name is Cindy Prizio. I'm executive director of One Standard of Justice, a civil advocacy rights organization. We've submitted our written testimony yesterday. I'm going to read an accompanying statement that I feel complements our written testimony. And we advocate for people, not crime. What I would be remiss if I don't say, out of everything I've heard this morning, I must state for the record, there is no useful purpose, certainly not in the name of public safety, for a registry for anyone. And so there's no scientific evidence, no scholarly evidence. It's a false sense of security and is a public shaming tool. So let me go to my testimony now. I'm here to talk to oppose Senate Bill 254. Such a simple and logical response, yet very challenging to convey or convince anyone of, is that no amount of protection will stop every single sexual assault. It's as if we're all only ever one crime away from a new proposed law. Now this law that will potentially prevent necessary health care for the masses of people on the registry who don't and will not reoffend, who may need inpatient care in the future and already have a very difficult time finding it, will be denied it. As the population of people on the registry is increasingly aging, so too must the idea that they're all going to reoffend when one does. Can it be imagined that we will deny masses of people healthcare? When are we going to stop believing that another new law is going to stop all crime? It's not prevention with evidence-based research. It's a quick fix until the next something occurs. This is anecdotal. Aged people on the registry with failing health, registrants needing full-time care due to a sudden catastrophic health condition, as well as some having severe chronic mental health conditions, were the most difficult to find placements for, many of which have no family. Far more die from not receiving proper care compared to the number who reoffend against someone in a nursing home. In 15 years of seeking placement for persons with sexual crimes as both a treatment provider and reentry coordinator, the parole officers and myself found more people on the registry of all ages dead from not finding available healthcare placement necessary for their survival.
Excuse me, Ms. Prizio, your time is almost up. If you please summarize. Thank you.
Yep, I've got just a few sentences left. They died from homelessness, unsupervised prescription drug use, accidental overdose, lack of necessary prescribed medication and treatment, homicide, and suicide. I can remember just about all of their names. Of those approximately 30 registrants we were able to secure placement for, none committed a new crime. I don't talk about this often. It's painful. It's too frustrating to know that educated career politicians, let alone the public, seem to have no clue or care of consequences that do not affect them. And from OSJ, we appreciate the public pressure legislators are under when an incident happens But as my friend and colleague has shared, this is an example where we have to draw the line. These are emotionally fraught situations, but I'm here to present evidence-based solutions. And we offer one standard of justice is members, volunteers, and resources to create an evidence-based bill.
Thank you, Ms.
Thank
Prezio.
you.
Thank you. We do have a question. Senator Anwar, go right ahead.
Thank you so much, Madam Chair. There you are. Ms. Prezio, thank you for your testimony, and we have spoken in the past as well. This bill is based on, in my district in East Windsor, a nurse was assaulted by a patient, sexually assaulted by a patient. And this nurse just came to work to take care of patients. And had we known, even though some of the people in the administration knew because this patient was out of state. And
yes, I know the story.
Yeah, but so who are in the vicinity for a case caused harm to be able to have a protection, have a peer with them, or have a safety net to protect them, just so that they are able to do their job. And your testimony suggests that no, that nurse should not know, and it's okay for them to be in that danger.
If we created a bill, Senator Anwar, every time there was an isolated instance, we're already overbilled, overpopulated, quite frankly. And so we're just saying that that's not going to be for the greater good of everyone. I'm not saying you don't look at nursing homes and that's and staff, but I'm just saying that somebody's, whether they're on the registry or not, is not the answer. These could be back in the days before there was even a registry. People have been grandfathered in for 30 years. There is no risk to reoffend beyond 15 to 17 years. I've included desistance data. So quite frankly, rather than writing a good law that understands that the vast majority of people will never go on to reoffend, it's just for a very small fraction of the fraction. And so, yeah, I think it's bad policy. I've had grown men. I mean, look, I'm an older citizen, right? I'm getting there. And I've had grown men from the state of Connecticut call me who need senior citizens housing and cry on the phone, who are fearful of where are they going. And I know one, this gentleman went to look at a home, a senior citizen's home, and he did all his homework. It should have been a place where he was accepted. And instead, the administrator at the nursing home outed him in a very bad public shaming way. And he cried. And we have it's almost like hate crimes, quite frankly. But yeah, people age out. And so I think there is a lot of sex happening at senior citizens' residences, but it's just part of the environment. I had another gentleman. I mean, typically we age out. And if you look at the registry, these are people who offended in their early 20s and as 50-year-olds are still on the registry. So the registry captures people who urinate on trees, who have consensual teenage relationships, or do more heinous offenses. And quite frankly, everyone deserves and is to redemption and a second chance. And my community is sort of one and done. They do one mistake, and the vast majority will never, ever reoffend again. So I don't know. I looked up the information about Windsor, and I didn't see any follow-up, in terms of what happened. How did a Massachusetts man, a 50-year-old, get into that home? I don't know.
I think this is what this bill is going to do. When that person is going to get to a Connecticut home, there would be a background check, and he would potentially still be able to get there, but there would be some safety net and information that would be shared with the personnel taking care of him. And that's probably in other words, it's not a denial, but it's also risk assessment. And it's important for anybody who is working, taking care of patients to know what may be at stake. So I know you're looking at it from another angle, but we have to protect the workers taking care of those patients in the middle of the night. And sometimes because of the ratios of the nursing staff and the other healthcare staff in nursing homes is so poor that you're basically leaving them in some of these environments and in an endangered fashion. And I think that having a risk assessment for somebody is just fair, because in some cases that is their home. And we need to make sure that there are some safety nets around that. So that's at least how I see this. And again, I'm looking at it from the case and also the concerns that the staff have after this incident in the community. I'll stop here, Madam Chair.
The language of the bill, though, denies people outright. And then they have to go through a petition process. And quite frankly, how many sensationalized cases along different classes of crimes are there? I really think while you're looking at it, I'm looking at from a broader view than you are. And I just think that you are going to harm more people than you are going to help. And that while this is not something that can be fixed the way you're fixing it, I think it's well-intentioned but misguided. And I don't know. I don't know why we're continuing to create bills that sensationalize rather than really address what the issues are. And again, I'm happy to sit at any table if invited to look for logical solutions, but this is not it. We're already an underserved community. And, you know, I heard something recently, and this is indicative of my entire community. All human beings are deserving of hope. And yet we suck this group dry, and we suck them dry oftentimes without evidence, without data, and just by virtue of they made a mistake and their lives are irreparable for 50 years or so. I mean, it is a crime.
Yeah.
Continue my
Thank you, Ms. Prezio.
Because I think I just will make one little comment. The data that you're looking for on the other end means that there will be X number of nursing staff that have to be assaulted, sexually abused, to be able to get to data that you're looking for. I don't think I'm in favor of creating that database to prove a point. But thank you, Madam Chair, and I know others have
Senator, may I ask you what the data is?
Ms. Prezio, we do have another question. Senator Haskell, go right ahead.
My senator, save me.
Hi, Cindy. Good to see you. And
hey,
thanks
Will, how are you?
I'm okay. Thanks for your testimony and for your advocacy on what is such a hard issue. You know, one thing that I've learned from our conversations is that we tend to think of sex offenses or someone's placement on the sex registry as being a binary. They are or they aren't. And that may be how the system currently works. But you mentioned earlier that there's really a wide variety of crimes that could land somebody on that list. And I just wanted to see if you might be willing to go into a little bit more detail. I think we're all pretty familiar with the crimes of a heinous nature that would land an individual on that registry. Do you want to, could you talk about some crimes that might surprise us that end up on that, you know, land somebody on that registry?
Well, in years past, we're starting to make some headway, but not enough. Like a 14-year-old who was housed with DCF and may have experienced sexual trauma himself. Maybe he did the behavior with his little cousin, right? And so it could be, so there we have people who are victimized, hurting other people, right? It could be a 14-year-old who shimmied on a bed with his little brother maybe he spooned him, maybe, you know, so it may have been some sexual gyration, but nothing else. And that child ends up in prison for 6 years. And on the registry, it could be, I've got a lot of falsely accused and people that were forced to take plea deals because it was the difference between 1 or 2 years in prison versus 8 to 12 years. It could be somebody like my son, who was a 20-year-old, who with a 14-year-old girl. But, you know, the courts don't allow, it was his girlfriend. In fact, it was his first girlfriend. And so we do a lot of, I've got one of my members was pregnant when she was 14 and they arrested her boyfriend who was older and he ended up on the list. And instead it really hurt her because she lost financial support and she lost emotional support. And recently I met a woman who was 14 years old and she chased a 24-year-old man. And she ended up marrying him. She chased him. They were married 45 years before he passed and 5 children. And in the past, we would have arrested him and their lives would have turned out very differently. The falsely accused, they have so much shame and so much anger and bitterness. And I have this vision in my head, Will, that we're creating unsafe communities because I see the person, the homeless person, disheveled, pushing the grocery cart with the plastic bag with all his belongings in it, talking to himself, because we're really not dealing with the issues. We're dealing
Understood.
with, okay.
Yeah, thank you so much, Cindy, for that testimony. It's such a hard issue. I've learned a lot in listening today, and I'm sure we'll continue to hear testimony. I very much trust the intention of the chairs that the intent of this legislation is to create opportunities for all folks to age safely in the state of Connecticut and for healthcare workers to be safe. But I think you raise really important points about distinguishing between denial and access to information. So I'm sure as a committee will continue to dig into that. And thank you so much.
Thank you, Senator Haskell.
Thank you, Senator Haskell. Ms. Prezio, you did mention recidivism rates, and I just want to caution us all. According to the U.S. Department of Justice, it's really hard to determine recidivism rates for sexual crimes for a variety of reasons. One being that oftentimes what they're looking at is rearrest data, but we know that as a largely unreported crime, it'd be hard to determine the recidivism. And so the numbers I'm finding vary with 5 years out, 10 years out, 15 years out. And so just wanted to push back quite a bit actually on the information you threw out there about recidivism rates being, I don't know what you said, something about either non-existent or incredibly low, because I just don't think we have that exact data.
Representative Gilchrist, I must answer that. In my written testimony, R. Carl Hansen, who is a world-renowned researcher and the co-founder of the Static 99, which is the most widely used risk assessment tool. If you look at his paper from 2018 and his webinar, he came into the state twice with Senator Gary Winfield and myself in January and June of 2021. And every 5 years, offense-free in the community, a person with a sexual assault conviction, his risk is cut in half. So if the vast majority of these people are already low risk, that means I may be a higher risk than they are. And that's the reason that even the highest risk offenders living offense-free in the community, 15 to 17 years, are no more risk than I am. So I would have to ask you to read the data and then let's have a follow-up conversation.
Well, I'll certainly look at that report as well, but I will reiterate that I'm also looking at quite a bit of data on my own. Thank you, Ms.
Well,
President.
I mean, Senator Winfield would be happy to talk to you about it as well. So I encourage every member of this committee. Sexual offense is one that it's nuanced and you must take a deeper dive to just think you know more than you may know is you're creating deadly consequences for a community that is sucked dry of hopelessness. We're getting it wrong, senators and representatives. Thank you so much.
Thank you for your time today. Next, we'll go on to number 20, Dr. Charles Wyra.
Yes, thank you, Representative Gilchrist. Just double checking, can everybody hear me? Okay.
Yes, we can. Go right ahead.
So thank you for the opportunity to talk, distinguished members of the Public Health Committee. Thank you especially as well to Representative Pettit and Representative Parker, who have offered wisdom and guidance over the course of the past year as we have tried to move this forward. I appreciate the opportunity to offer oral testimony regarding House Bill 5273, establishing a statewide stroke registry. I am a resident of Madison, Connecticut, work in the Yale Department of Emergency Medicine and also for the stroke program. I have multiple national volunteer positions working to improve stroke care, and I'm also the past volunteer chair of the Connecticut Legislative Stroke Task Force. As many of you know, nationally in Connecticut, stroke is a leading cause of death and disability, cited to be the 4th leading cause of death in Connecticut. I fully support the creation of a stroke registry to monitor, track, and analyze data for Connecticut, which will improve outcomes. The creation of such a registry was a past recommendation of our Legislative Stroke Task Force. And in partnering with stroke leaders across the state, we hope to pass a strike-all amended version of this bill, which is attached to my written testimony. Having a state registry will do the following. First, it will improve stroke care for all citizens in Connecticut across the spectrum of stroke care, from EMS activation through the rehabilitation stage, by providing data to inform quality improvement initiatives. Second, it will identify state-level geographical disparities in stroke care, which will provide the necessary knowledge for implementing improvements. Third, it will provide the necessary data to inform targeted educational interventions to reduce the known racial, ethnic, and economic health disparities that exist nationally and within our state in stroke care. And then finally, it will make us comparable to our peer neighboring states. Massachusetts, New Jersey, New York, and Rhode Island are all states that have had established stroke registries. In mentioning the amended bill that is attached to my written testimony, I ask you to consider this. The language has been, I call to your attention, modified to include the following. Number 1, giving the Department of Health the option of which data platform to utilize. Number 2, providing the Department of Health the necessary 1.5 full-time employees to operate a statewide registry. And this is a model that's been implemented by other states that operate registries. And then number 3, removing language that enacts penalties or other punitive measures for hospitals not meeting state registry requirements. I again thank you for the opportunity to comment on this bill and for your attention to this requested amendment, and I'm happy to answer any questions.
Thank you, Dr. Wyra. We do have a question. Representative Michael Parker, go right ahead. Oh, John Michael, we can't hear you, even though you are unmuted.
How about now?
Yes, go right ahead.
Thank you, Madam Chair. Thanks, Dr. Weir, for being here, and as a constituent for taking the time to help me understand this issue over these last couple of weeks. I have just a couple of questions. The first one is, can you sort of help orient us all to the state of sort of data collection and sharing and understanding as it exists currently among some hospitals in the state of Connecticut, and why this registry is important to get us all the way? So sort of like, where are we now and what's the gap that this is trying to cover?
So thank you for that question. So currently there's nationally, first for background information, there's nationally promulgated guidelines for stroke centers that they have to maintain stroke registries for their individual sites to track outcomes, and then, obviously incorporated into quality improvement initiatives so as to optimize care for patients in the entire system of care. currently, per my knowledge, there is no existing statewide registry. And this has been true for quite some time. There is data that comes to Connecticut from other sources like the CDC, but what this bill will enable us to do is that the hospitals, and I believe that there's 22 that are already collecting data as a part of being certified centers, it will enable them to send their data to the Department of Public Health, by which it will be centrally pooled, and then we will have the opportunity to analyze it and look for the disparities that I've mentioned that likely exist, and then identify interventions that we can kind of improve care across the state.
Thank you for sharing that. So my understanding is that although there are some hospitals that are currently collecting this data and sharing it effectively, maybe even specifically through the Yale system, what you're trying to do is ensure that all of the stroke care in the state is up to that level. Is that a fair interpretation?
Yes, and not only up to that level, but there are great opportunities that can come from looking at our data. And I just call for one example. The DOH, I think a year or two before the pandemic started, was presenting at a regional stroke conference and presented data on a key metric of door to CAT scan time. And as we all know, time is brain for stroke. We need rapid identification by CAT scan to establish that the stroke etiology, and then rapid time to interventions as well. But in this published report by the DOH for door to CAT scan time, Connecticut actually ranked worse among all New England states, and in comparison to New York and New Jersey as well. We do have, for background information as well, we do have for several years now, since the Legislative Stroke Task Force, we do have a state advisory council, which has participation from the vast majority of Connecticut hospitals. And there's a great interest on the part of this advisory council to get more granular data so as to inform changes that we can not only make in our own systems, but at a statewide level as well. So there is great interest certainly to utilize a registry in many ways that will optimize care for citizens of Connecticut.
Thanks, Dr. Brewer. I have one other question that I'll get out of the way and let Dr. Pettit, who's an expert here, ask questions of you. But I just want to call attention to my colleagues. As you mentioned, that you folks have some language for a substitute from the language that's currently in place. And I appreciate you and your team developing that. I wanted to just see if you could speak to 2 points that you're hoping to change in that from the bill that is currently in front of us. I understand one piece is that currently the language is overly punitive in terms of trying to bring hospitals to the table. I was wondering if you could speak to your experience on that and why you suggested change there. And also sort of given some other testimony that we've received, I believe from the Connecticut Hospital Association, you folks are really underlining an importance around what I understand are the stroke achievement measures. Can you just speak to those 2 points, why you don't think there needs to be a punitive element of the bill and why it's important to articulate those stroke achievement measures in terms of the data that's being collected specifically?
Sure, happy to. So first for the punitive measures, all of us, working at hospitals, we kind of oppose this. Number two, we don't think that is the necessary item to result in the change that we want. A past example is a prior bill that we passed, I think 4 years ago, in the recognition of stroke centers. And really what helped to mobilize and motivate uncertified stroke hospitals at that point in time was the DOH giving a list on their website and to EMS agencies of the certified centers in the hospital. And with just that language, we grew the number of certified hospitals by 7 or 8 at the time. And many of us from our Stroke Advisory Council believe that just if the DOH does a similar thing and lists the stroke centers that are in compliance with reporting data to the DOH, that should be enough of a necessary carrot to really get great participation in this. In terms of the quality measures, or kind of what has been talked about, and that is utilizing, kind of the core stroke center quality measures that are promulgated by advocacy organizations, and many of them are quality measures for a reason, because they result in improved outcomes for stroke patients. And just for example, some of them are as follows: dysphagia screening, which is a nurse or clinician screening test to see if there's aspiration. I can offer personal testimony that I've had patients who have indeed aspirated. So this is something that can prevent further morbidity in a stroke patient's admission. Venous thrombosis prophylaxis is very important, not only for stroke patients, but for all hospitalized patients, because the stasis of being in bed or bedbound can result in blood clots that can potentially be life-threatening. Considering thrombolysis for all eligible patients is another quality measure of importance, which is critically important, because that's as many of you know, the first potential intervention to treat an acute ischemic stroke where there's a clot in the brain, administering this clotbuster medicine. And another sample quality measure is starting the appropriate what's called antithrombotic medications, which basically affect the platelet cascade of clotting to prevent further secondary larger strokes in patients. And so all of these quality measures have evidence-based. We hope that as time evolves, that we can track further data. Like I alluded to, there are published disparities in care in terms of EMS utilization, access to the clotbuster medication. We hope to look at these things as well. In the past, there's been DOH publications, one in 2011, that Black men had higher stroke mortality rates than white men when age adjusted. And then going back about a decade, there was a publication and a brochure that addressed stroke mortality rates in Black women that at that time was the highest of any demographic in the state. And so there's many opportunities of further things that we can look at to take a deeper dive to then identify targeted interventions to improve care across the state.
Thanks for sharing that. So you folks just want to make sure that those specific measures are articulated in the bill itself. I appreciate you walking through the details of that. Thanks for the indulgence.
Yes, thank you.
Thank you, Representative. Thank you, Dr. Wyra. We do have a question. Representative Pettit, go right ahead.
Thank you, Madam Chair. I'll be very quick. Thank you, Dr. Wyra, for your testimony. Representative Parker, your answer to this question answered most of my questions. I would just suggest to our members that I think this bill has the potential to have the greatest impact over the next 5 years on the health of people in the state of Connecticut. Perhaps this and the lead initiative that should go forward this year will have a major impact. So I hope we can come to agreement on the potential for the 1.5 FTEs that DPH would require to have this move forward. And I'll hold any other questions. I see that Mr. Williams is on the list, and hopefully he'll hang in because he's about 56 people from now. So thank you very much for your testimony.
Thank you, Representative Pettit.
Thank you, Representative. And thank you, Dr. Wyra. My apologies for pronouncing it wrong.
Oh, sorry.
Now I'm going to turn it over to Senator Anwar.
Thank you, Madam Chair. And our next speaker is Sally Grossman, followed by Ashley White. Ms. Grossman.
Hi, thank you. My name is Sally Grossman. I'm from Windsor. I am providing testimony in favor of Raised House Bill 5621, an act increasing access to reproductive health care. Across this country, we've seen unnecessary burdens placed on not only abortion care providers, but those who wish to access abortion services that serve no medical purpose other than to delay or deny pregnant people basic health care. I would like to see Connecticut become a leader in this country regarding expanding access to abortion care. Legality is not the only barrier facing those who wish to have an abortion. Even in a state like Connecticut that has codified Roe v. Wade, there are still limitations on the ability to access abortion care. For several years, I've been a clinic escort at an abortion care provider in Hartford. I've seen firsthand the barriers facing Connecticut residents like transportation, childcare, appointment availability, just to name a few. As someone who has had abortions, I know the importance of being able to access time-sensitive care. When I had an abortion to terminate a non-viable pregnancy 8 years ago, I had to wait weeks for the only doctor in my OBGYN's office who performed abortions to have availability. This put me at the very end of my first trimester, and the appointment I got was the day before my son's first birthday. So this was obviously far from ideal. Limitations on abortion access that are not medically necessary should be eliminated. Current state law allowing only physicians to perform procedural abortions is outdated, as 14 states allow advanced practice clinicians to perform procedural abortions. Connecticut should update its laws to align with current medical practices and be a leader when it comes to accessing abortion care. I urge the committee to vote in favor of HB 5621, taking the language recommendations for medical professionals and advocates. Thank you.
Thank you so much for your testimony. We appreciate you coming in and waiting and giving us your thoughts. Seeing no questions or comments, we'll move on to the next person on our list, which is Ashley Whites, followed by Amanda Skinner. So Ashley Whites.
Thank you, Mr. Chair, members of the committee. My name is Ashley Bates. I am a victim advocate and trauma-informed care consultant in Salt Lake City, Utah. I'm here today to speak to HB 5278 about non-consensual intimate exams on patients in healthcare settings. In 2007, I went to an ER here in Salt Lake for uncontrolled nausea and vomiting. Lots of labs and imaging did not yield many answers. I have the note here from the encounter, and the physician says, I've been seeing this 23-year-old woman in the emergency department. I had anticipated she would be discharged. However, she persists in having tachycardia and appearing quite nauseated. I treated the patient additionally with a medication. I had held off of another more sedating medication, expecting her to be able to drive home. But at this point, since it was not the case, I gave her that sedating medication. She has had some improvement in her nausea. She is quite somnolent. I was very, very asleep. He continues, also there are symptoms. It is unclear the exact cause. I performed a pelvic exam. I know that we never had a conversation about this pelvic exam or why this physician thought that he needed to do it. And I know that I never consented because I woke up in stirrups screaming. As a survivor of sexual abuse and assault, the experience was as confusing as it was traumatizing. It was not until 2019, when similar legislation was introduced in Utah, that I finally realized that it had felt like a violation because it had been one. My experience has impacted the way that I seek and receive medical care. I have gone without necessary care because I've learned through experience that at my most vulnerable, I can't trust that my autonomy will be honored. My non-consensual exam was a product of the way that that clinician learned. No one ever has any reason to stop doing what they don't consider to be wrong or harmful. There are many professional association guidelines about informed consent and laws in 20 states, but we know that this is still happening. We as patients are saying, please just ask. The risk of asking is so much less than the risk of causing lasting harm. Repeated student exams for learning purposes are not patient care, and patients have every right to consent to be a part of learning. In no other profession does society tolerate the practice of routinely instructing learners to penetrate people without their knowledge or explicitly informed consent. I've submitted written testimony refuting arguments that come up commonly against prohibiting the practice and appreciate you reviewing it. In just a few ways, I honestly don't feel like this bill goes far enough. But I also know that any measure of progress is still progress. This bill, if moved forward and passed, will help patients and providers in Connecticut and elsewhere. And I appreciate your consideration and votes in support of HB 5278. Thank you.
Thank you so much for your testimony, and hope the weather is better where you are. And seeing no questions or comments, we will move on to the next person on our list, which is Amanda Skinner, followed by Alexis Charles. So Amanda Skinner.
Senator Anwar, Representative Steinberg, and honorable members of the Public Health Committee, my name is Amanda Skinner, President and CEO of Planned Parenthood of Southern New England, testifying in strong support of HB 5261, an act increasing access to reproductive health care. As the state's largest provider of sexual and reproductive health care, including abortion, to over 65,000 patients at 14 health centers, patient safety is of paramount importance to us, and we believe all people should have access to quality, affordable health care as a basic human right. We understand that abortion is healthcare. Many of our patients face barriers to accessing time-sensitive abortion care due to a lack of transportation, childcare, time off work, or lack of healthcare coverage. Our state's outdated law presents an additional and medically unnecessary barrier by preventing qualified advanced practice clinicians, or APCs, like nurse practitioners, certified nurse midwives, and physician assistants from providing aspiration abortion. Currently, patients face an average wait of over 2 weeks to get an abortion appointment for a procedural abortion. Patients in Connecticut deserve accessible care and to obtain this care from the healthcare provider they trust and who knows them best. For our patients who receive abortion care, 93% of those patients have a first trimester medication or aspiration abortion, meaning the vast majority of patients could be seen by APCs for their abortion care if our law was updated. I am a nurse midwife myself and spent 10 years in clinical practice in Waterbury, Connecticut. I provided at that time a wide range of reproductive healthcare procedures similar to or more complex than procedural abortions, such as IUD insertion, endometrial biopsy, and colposcopy. Abortion is one of the safest medical procedures in the United States. And just as APCs are trained to provide other procedures, research and years of data make clear that APCs can be trained to provide aspiration abortion at the same level of safety and quality as physicians. The General Assembly took bold and courageous action in 1990 to codify the protections of Roe v. Wade into state statute, and we're so grateful. And we know that legal protections alone are not enough to ensure access for every person who needs abortion care. The healthcare landscape has changed in the past 30 years, and it's time to take action again. Updating our law to allow APCs to provide medication and aspiration abortion does not change the law or regulations that govern scope of practice in our state, nor does it change the other mechanisms that ensure that all healthcare providers practice in a manner that is safe. The Institute of Medicine defines high-quality healthcare as care that is safe, timely, patient-centered, effective, efficient, and equitable. By this definition, enabling APCs to provide medication abortion and aspiration abortion procedures will improve the quality of care for the people of Connecticut. Planned Parenthood strongly supports raised HB 5261 with recommended language changes that will best reflect current medical practice and standard of care. Abortion access for millions of people across the country hangs in the balance. We urge the committee and Connecticut lawmakers to vote for this bill to take immediate action and expand access to abortion care for people in our state. Connecticut can catch up to the 14 states who permit APCs to perform procedural abortion, including New York, New Jersey, Massachusetts, Vermont, New Hampshire, and Maine. This is a matter of public health and of health justice, as no one should face delays to time-sensitive essential abortion care due to medically unnecessary barriers. Thank you for your time and consideration.
Thank you, Ms. Skinner. You timed it perfectly well, just like a few seconds before 3 minutes. Thank you for waiting today. Good. And then you were very clear and concise and timely. Is it possible if you can, my perception is with what's going on in the rest of the country, we will see women coming from other parts of the country to come to Connecticut, which may be a safer haven at this point. Have you seen that trend at this point yet?
We have seen that start to happen now. Right now, the most significant restriction is in the state of Texas, and that is where currently abortion is unavailable to anybody who is more than 6 weeks pregnant. But we have already seen patients come to us from Texas to access safe, high-quality abortion care. One of the things that we know about Connecticut is that one of the things we have is a procedural abortion health centers in close proximity to where we have an airport. And that is one of the things that makes care more accessible for people who do need to travel. It is a tragedy and a travesty that that's necessary, but that is going to be the case in the United States, most likely following the Supreme Court decision.
And the sense of urgency that you're sharing is based on this anticipated increased needs based with the changes in various parts of the country.
That is part of the urgency, Senator Anwar, and that's an excellent question. But as I said, already patients face a more than 2 week wait for procedural abortion care. And of course, I think we can all agree, as you know, you are a physician, I am a nurse and a nurse midwife. As healthcare providers, what we want is patient to have agency over their decisions. And that means that we offer our patients the option to decide what is the most appropriate procedure for them, as long as it is clinically and medically appropriate for them. And so patients may choose medication abortion or procedural abortion if they're in the first trimester. So for patients choosing procedural abortion, they already have to wait, and 2 weeks is too long of a wait when we're talking about the first trimester of pregnancy. I can also share, just as an example, One of the things that we know is only 14% of OBGYNs in the United States currently provide abortion care, while over 97% of them have said that they have patients coming to them asking for abortion care. So we know that there are constraints on care even from the physician community just currently. And we know that provision of training for abortion in medical programs is actually reducing, as Polly Moran referenced earlier in her testimony. So these constraints already exist currently. And again, in my opinion, 2 weeks is too long of a wait.
Thank you so much. I see Representative Gilchrist has a question or a comment.
Thank you, Mr. Chair. Hi, Ms. Skinner. So good to see you.
Hi.
You referenced a number of procedures that are similar or more complex to procedural abortion. Could you talk about how individuals are trained to provide those procedures?
Absolutely. So I can certainly speak from my own experience. As I said, I'm a nurse midwife, and I was in practice in Waterbury for 10 years. I was in 2 different private practices. And in my case, for example, for colposcopy, I went to a training program. I was trained to provide colposcopies, and then I began providing them in my clinical practice as part of my scope of practice. And for people who aren't familiar with colposcopy, it is a medical procedure where you examine, and if the examination indicates it, then you may biopsy the cervix, and what you're looking for is the possibility of cervical cancer. In the case of endometrial biopsy and the placement of intrauterine devices for contraception, I was trained in my clinical practice. So I was trained to do endometrial biopsy after I had graduated from midwifery school while I was in clinical practice, in the course of clinical practice. And I was trained by my colleagues in my practice.
Great. And then a follow-up to that, if passed, how do you envision the training for procedural abortion rolling out at Planned Parenthoods here in the state for advanced practitioners?
Yeah, absolutely. So first, if you would indulge me for just a moment, I would like to note that, for folks who aren't familiar with advanced practice clinicians, we are talking about people who are healthcare professionals. They are licensed by the state. They are certified by national organizations. And like other healthcare professionals, they're held to standards of ethic and practice, and they're held to those standards through the same kinds of mechanisms all healthcare professionals are held to. In the case of training for Planned Parenthood, what I would say is that we would ensure a training program for our providers that is based in the best research and that would be entirely centered on ensuring the safety and dignity of our patients. Thankfully, we can look to our national office. We have very rigorous medical standards and guidelines, and we can look to other institutions like the University of California at San Francisco that have developed programs. UCSF developed something called the TEACH program, which is a comprehensive training program for early abortion care that is directed to advanced practice clinicians and to other healthcare providers who may not be trained, for example, primary care physicians.
Great, thank you. And my final question, if the chair will indulge me, is since Planned Parenthood, this gives us such a good view, since 14 other states have passed this, and Planned Parenthood, I would assume, is in all 14 of those states. Maybe I'm incorrect, but
yes.
Okay,
Yes.
Great. Have there been any safety concerns in the other states where advanced practitioners can do procedural abortion?
There have not, actually. There is excellent research from the state of California where they examined 11,487 aspiration abortions, looking for safety, quality of outcomes when comparing nurse practitioners, nurse midwives, and physician assistant performed aspirations to physician performed aspirations. And their conclusions from that research were that abortion complications were clinically equivalent between newly trained nurse practitioners, CNMs, and PAs, and physicians, supporting the adoption of policies that allow providers to perform these early aspirations and to expand access to care. And it is my assumption, though I could be wrong about this, that this is part of the information that led to the American College of Obstetricians and Gynecologists Committee on Healthcare for Underserved Women and the Abortion Access and Training Expert Work Group at ACOG, putting out recommendations the following year in 2014, calling for the repeal of legislation that creates barriers to abortion access, including requirements that only physicians may provide abortion care.
Thank you so much. Thank you, Mr. Chair.
Thank you so much, Representative Gilchrist. Before I have Dr. Pettit ask questions, I understand that the legislation in California also was expecting a certain level of training to go into the process. Is that correct?
Honestly, Senator Anwar, I haven't reread the California legislation.
Okay.
What I do know is that sort of going back to what I said about Connecticut regulations and requirements and scope of practice guidelines, that our expectation is that we are talking about healthcare professionals here. There are extensive mechanisms to ensure that healthcare professionals are properly trained, credentialed in the services that they provide, and to held accountable to providing the highest quality care. And certainly at Planned Parenthood, the paramount thing for us, I cannot say this strongly enough, is the dignity, safety, and quality of care that we provide to our patients. Nothing is more important to us.
Thank you for that. But just because there's going to be some training that is going to be expected, and that's going to be the understanding, at least that's what the California legislation did touch on. And I think while there's safety studies are there, it's important to look at the depth of the safety studies, because in many of the safety studies, there were physicians who were part of that team that were overseeing the procedure. Mm-hmm. So I'm afraid that in future, there'll be a medical students who are going to come out and say, hey, because I, as a medical student, while I was working on a procedure with this, somebody was helping me out, I'm safe as well. So I want to be able to do many of these procedures too. Just because there was somebody else standing there working with them at that time doesn't make them the main person doing the procedure. So you have to tease out the studies a little bit. I'm not saying the study that you're quoting has that, but it's worthy to keep that in mind.
Yes. We do also have 14 states where this is the current practice to look to for the safety and outcome of those states, and where they may have, as you're citing, California may have cited that, whether it's in their regulations or their statute, but we do have 14 other states to look at outcomes, and what we know is that outcomes are equivalent.
Good, thank you. Representative Pettit, thank you.
Thank you, Mr. Chair. Thank you, Mrs. Skinner. A number of people have asked, and I don't know if you have access to the data as to, do we have any idea what the number of abortion providers are currently practicing in the state of Connecticut?
I don't think we could possibly know that, Representative Pettit. And the reason is that most people don't put on their website or hang a shingle that says that they provide abortion care. As I said, what we do know is that nationally, 97% of obstetrician gynecologists have said that they are asked about abortion care, but only 14% of them actually provide abortion care. At Planned Parenthood, we know that we are the primary provider of abortion care in the state, doing approximately 90% of the first trimester abortion procedures in the state.
Wow. And a number of people have used the 2-week example. Is that 2 weeks an estimate, or is it possible that depending on what part of the state you're in, you could call and get an appointment tomorrow or on Monday, or is it pretty much 2 weeks across the board in terms of wait times?
That's an average for Planned Parenthood of Southern New England, and is the primary provider of abortion care in the state for first trimester abortions. I feel pretty confident that average across our health centers is an appropriate approximation of the state wait, again, since we are the primary provider of these services. I think another, data point that I would cite is, just as an example, is that in the month of February, we typically run approximately 23 procedural and surgical procedural abortion being first trimester aspiration abortion, surgical being, for example, D&Es, clinics per month. Those are sessions in our health centers, and 7 of those, so 7 of 23, almost a third of them, we actually weren't able to provide to our patients because we didn't have physician coverage. That was in the month of February. That's just one example. It's just one data point, but I think it's a good example of the constraint on access to care that we are seeing currently.
Thank you. And finally, to sort of avoid confusion for the general public and members of the committee, as I understand it, and you can correct me, not my area of expertise, PAs, APRNs, nurse midwives right now are legally able to provide the medication-induced abortions. There's no issue with that, correct?
Currently, they are able to do that through an attorney general's opinion, whereas the language of our law, obviously it's our position that the language of the law governing that, governing the provision of abortion should be changed to reflect specifically what we know is appropriate, safe, current clinical practice.
Sure. And the next part of it is now the procedural abortions, which range from sort of the first trimester suction abortion versus something that requires B&C or something more invasive. From your understanding, that would require some form So would be potentially allowed for people would require some review of scope of practice by DPH, which is typically where those decisions have been made. Is that your understanding?
My understanding is that that has been requested. I believe it is clear, and I believe the professional organizations of those three healthcare professions feel strongly that it is clearly within their scope of practice. As a nurse midwife myself, again, I feel very confident that it is within the current scope of practice of nurse midwives in the state.
Okay. Thank you. I appreciate your answers to the question. Thank you, Madam
Thank you.
Chair. Or thank you, Mr. Chair.
Thank you.
Thank you so much, Dr. Representative Pettit. I wanted to thank you for your testimony. Seeing no other questions or comments, we will move on to the next person, which is now Carolyn Bennett, followed by Alexis Charles.
Thank you very much.
Members of the Public Health Committee, my name is Carolyn Bennett, and I am testifying in strong opposition to HB 5261. I'm opposed to Section 1 because it is simply unscientific. I'm opposed to Section 2 because it is wrong and unnecessary. The title of this bill states that its purpose is to increase access to reproductive health care. But abortion is not health care. Abortion is a tragedy, and increasing access to it is not good for anyone. The idea of a woman having a right to abortion ignores the fact that she is not the only person involved. I'm here today in honor of my grandmother. Over 65 years ago, she was 19 years old, living across the continent from her family in a lumberjack camp with her husband. When she found out she was pregnant, everyone around her advised her to abort the baby. It was not a good time. They couldn't afford it. She was too young. But because my grandmother is brave, stubborn, and very independent, she refused to bow to the pressure and gave birth to my mom in a Canadian village in the middle of winter. This story illustrates the fallacy of the supposed right to abortion. My mom was there, alive, through that whole story, just in various sizes. One could argue that at 12 weeks of development, she couldn't survive outside the womb and thus wasn't really a person until after she was born. That argument falls apart when you consider how long a 1-year-old child could survive on her own, or a 3-year-old. The child is still entirely dependent on the adults in her life for her survival. The only difference is whether or not she is visible to the outside world. I would note that with the development of technology, an unborn child can now be easily visible to the outside world as well, if we choose to look. I would like to close with a quote from Dr. Mildred Jefferson. She became the first Black female doctor from Harvard University, the first woman to intern at Boston City Hospital, the first female surgeon at the Boston University Medical Center, the first woman admitted to the Boston Surgical Society, and a renowned professor of surgery at Boston University Medical School. She said, "I became a physician in order to help save lives. I am at once a physician, a citizen, and a woman, and I am not willing to stand aside and allow the concept of expendable human lives to turn this great land of ours into just another exclusive reservation where only the perfect, the privileged, and the planned have the right to live."
Excuse me, Ms.
So,
Bennett, your time is
50,
almost up.
50.
If you could please summarize, thank you.
I'm all done, thank you.
Thank you, Ms. Bennett, for your testimony. You were just within 3 seconds of finishing in perfect time. So thank you for taking the time to speak to us and then share your perspective. Thank you. We appreciate that. Seeing no questions or comments, we'll move on to the next person, which is Alexis Charles, followed by Dr. Diana James.
Hi, committee members. I'm Alexis Charles. I'm the Director of Student Services Committee here at the Undergraduate Student Government at the UConn Stores campus. And I'm speaking in support of Bill HB 5272, which is an act to raise concern concerning menstrual products. The issue with menstruation equity here in the state is built upon the idea of an individualized responsibility and socializing menstruating people to expect less. Here at the Stores campus, my committee and the subcommittee under my committee, Sexual Health and Education, which is staff of my two lovely classmates, Michaela Dawkins and Dana Torto, couldn't be here, are the sole providers of free menstrual products here to the undergraduate students here at the university. The precedent that we have set for menstruation in the state has left a burden on those who menstruate. With over 19,000 students at our beautiful Source campus, half of which menstruate, my committee of 6 paid staff, 15 USG senators who work for free, along with 6 non-committee senators who are UConn students who also work for free, are not the answer to the access of free menstrual products at our university. The burden of responsibility should not be on student organizations, because menstrual products and free menstrual products is not about redefining laws or assessing student needs. This is a basic human right of dignity and decency. Honestly, menstrual hygiene products are something that most people don't want to think about, they don't want to talk about, they don't want to have it in their face. Yet it is in the face of mentioning people's daily lives. Faculty and staff, along with students, should not have to be burdened with wondering how they may provide for themselves in such timely matters. This current model forces menstruating people to take the burden into their own hands to provide for themselves menstruating products. Though some students may be in the position to go to CVS and buy menstruating products for themselves, a lot of students are not. And we have to consider the fact that most menstruating people, especially if you are a BIPOC person, you start menstruating around the age of 9. And it is hard for a 9-year-old to be able to go into a store and purchase their own pads, tampons, or menstrual cups. And it's much harder to do that when you are already bleeding, already menstruating in a way that not only are you unable to walk without being noticed and clearly bleeding, but when you're a child, that type of embarrassment is not only detrimental to your education, but it's detrimental to your social life. You feel embarrassed. You feel as though this is your responsibility, and it is not. We do not ask people to bring their own toilet paper to the bathroom. So we should stop asking menstruating students and menstruating people to bring their own tampons to the bathroom. Thank you.
Thank you so much, Ms. Charles. Thank you for articulating your position very well, and also helping us as a committee hear your voice and your views, which is very critical, because sometimes people say there is no issue, there is no problem, and you're coming up and speaking about the reality for students is really helpful. Seeing no comments or questions, we will move on to the next person, which is Dr. Diana James, followed by Amy Brown. Dr. James, I see you're a radiologist right off the bat with some of this things in the back.
My background.
Yes.
I am. Just a few pictures in case you get tired of looking at me, you can look behind me. Find the breast cancer. Anyway, so good afternoon, Senator Awar, Representative Steinberg, Senator Wong, Senator Summers, Representative Pettit, as well as Madam Chair Gilchrist. My name is Diana James. I am a radiologist practicing in the state with a specialty in breast imaging. I would like to offer brief comments on Senate Bill 249, an act of implementing the recommendations of the Breast Health and Breast Cancer Awareness Working Group. This working group was created last session as a result of Section 14 of Public Act 2135. I was fortunate to participate in and as well as present data on breast cancer that I will briefly, I promise, discuss here. Breast cancer affects 1 in 8 women over the course of their lifetime. Unfortunately, it's very common. In 2018, which is the most recent year, we have data from the CDC. Breast cancer was the most common cancer affecting women in the United States. And we know that Connecticut is typically either in the top 5 in incidence or well within the top 10. So it's unfortunately a problem in our state. Breast cancer disproportionately affects minority women in terms of mortality. That's another problem. Although the incidence of the disease is typically lower in Black women, for example, the death rate is about 40% greater than white women. And the issues include earlier onset of the disease, so women less than 40 years, women between ages 40 and 49, decreased participation in regular screening programs is a problem, and longer time intervals when abnormalities are detected. The working group actually heard about multiple examples from these issues from residents throughout the state. Mammography has reduced mortality, which is death from the disease, by 30 to 40% since its implementation in the late 1980s. Tomosynthesis has further increased cancer detection by 40% and helps to reduce false positive rates for these exams, which helps to minimize patient anxiety. Early detection of the disease will not only save lives, but will also minimize overall treatment costs to our healthcare system. Senate Bill 249 will expand the breast and cervical cancer early detection and treatment referral program. It will prioritize screenings of women of color and minorities, as well as encourage the use of tomosynthesis. I believe these policy changes make sense. I am also hopeful that funding this program can be increased so that more women can be screened each year. A little over 4,000 women are screened annually under this program currently. If we make these changes and Senate Bill 249, this will hopefully expand that access. Thank you very much for your time and consideration.
Thank you so much for your testimony. I have a few questions, but I'll first start with my colleague, Senator Moore, followed by Representative Gilchrist. Senator Moore.
Good afternoon. Thank you for the work on the work group. I have a question regarding sufficient funding for screening for women who may not fit into an insured category. Did you hear anything in the way of funding for those people for mammograms or clinical breast exams?
So we did hear about programs throughout the state. There's a program at Hartford Hospital that definitely takes uninsured patients. And Hartford Hospital also runs a mammo van. A similar program is down in New Haven through the Yale community. These vans go out to the community, to churches, other sites to kind of increase overall access to care for screening mammograms. And often they receive funding through grants, through state funding. So there are some small programs in the states, but the consensus from the working group is that these could absolutely be expanded.
So at one time there was, I run a nonprofit for 20 years for breast and cervical cancer program and had state funding and funding from other grants to help women get mammograms, served over 20,000 women over a course of time. And at that time, and I'm no longer doing that, but at that time, I found that access was a problem for women, that there was a mobile van at Stanford at one time, it's gone away. There was a mobile van that would travel from Stanford all the way up to Bridgeport. We no longer have access to that. And I think I would just question, is there access for women? I mean, if you're running a program from 9 to 5 and people are working and can't get there, did you see access as being a problem?
The current situation, absolutely, access is a problem. I mean, I think there are definitely programs in the state that could be expanded to increase that access, but you raise a really important point. There's absolutely issues with access. The other issue that we also discussed, which isn't on the docket today, if I'm aware, but there are places where people could get a mammogram, but they don't accept Medicaid insurance, for example. Those are real issues in the state of Connecticut that are limiting access to women from getting these screening tests. And we know that they're so important. So you raise a great point.
So, and I also know that at one point that the American Cancer Society did not recommend clinical breast exams. I don't know if that's changed. Has that changed?
I think the clinical breast exam by the provider is still recommended. It was more the self breast exam. I think the data is slightly controversial on that if it's done. So I think that one of the important things that we were discussing in the work group is just education and the importance of education in younger women in middle school, women in high school, college. And this would be a topic, teaching them how to do a self breast exam correctly, because I think the problem in the past has been they're not necessarily doing it correctly. And then you might increase your false positive rate. So the education piece is absolutely very important. And the working group realizes that as well. It's a great point.
So at one point I taught breast self-exam, and I had lay health advisors teaching women and witness role models, breast cancer survivors, going out talking about their story and their journey on cancer. What I found for our organization, which is the only African-American led and operated breast cancer organization in the state, and the first organization in the state to have a patient navigator, is funding for those organizations that are on the ground that could reach those people. We were always beat out by the larger hospital, but I don't see the outreach any longer. And I still get calls today from people that I don't see the outreach that we did taking place any longer, where people would actually could go to a church, could go to an organization and have someone come out and talk about breast cancer. And I think that's a void. My final question is, funding through the Connecticut Breast and Cervical Cancer Program, do you know if there's sufficient funding there to meet the needs?
I think Representative Gilchrist could probably help me out on this topic. Is that the answer to that question? But no, I don't think there is sufficient funds currently. And to your point about reaching out through churches, I want to say I think the pandemic has been a problem, in terms of preventing patients from coming in for their regular screenings, and also decreasing those really important networking opportunities through churches, through schools, and information. So I think we need to really step back and look at what's worked in the past and then make a pathway going forward. But Representative Gilchrist, please help me with some of this.
Thank you, Dr. James. I appreciate the work that you've done here with this group. I appreciate it. Thank you.
Thank you.
Thank you, Senator Moore. And then Representative Gilchrist, go ahead. You'll probably be able to answer it and then ask your question too.
Yes, thank you, Mr. Chair. And thank you, Dr. James, for participating on the work group and bringing such invaluable information.
Yes, I was wondering if I could
speak. Senator Somers. Oh, good. Oh, we can. Sorry, got distracted. I learned quite a bit, so much by getting to participate on this group. So to answer the question, I think we could use this legislation to expand outreach efforts. I mean, this is what this original program was created to do. And so to your question, Senator Moore, no, there's not enough funds. I believe there's waiting lists at this point in time to be able to get the mammograms. And what we learned, and you probably already know this from your work, but what really opened my eyes is that Black women present earlier. So they present in their 30s with breast cancer. And so I think we just need to do a tremendous amount of education and outreach to communities so that women are getting these exams when they need them and not too late. Because the other stat then that really kind of connected it for me was that there's a 40% greater mortality in Black women with breast cancer. And so the point of this working group, as established by the Connecticut General Assembly, was to target those hard to reach populations, in particular young people and women of color. And so I think we should designate additional funds to this program to ensure that we can reach more people.
And so what's disheartening to me is that I started my program in 1996. I replicated a project out of Little Rock, Arkansas, during a replication project of research. What's disheartening to me that I started something in 1996 and here we are in 2022 addressing the same problem, right? That you don't see things change. And I think we have to stay hard on and stay on top of not just in Connecticut, but nationally, stay on top of this because there is a disparity among Black women. And I mentioned that I heard the doctor say, more white women will be diagnosed, but more Black women die. Later stage diagnosis, access to care, how they're treated in the hospitals, how they're treated at the front door when they come in for programs, how they're turned away based on how they look, the biases, all have impact, right? I want to say, Dr. James, I went 2 years without a mammogram because of COVID. I panicked when it was time for me to go, but I knew I needed to go, and I did it. But that time between getting the mammogram and getting my results, I was like, oh my gosh. It's not as though a mammogram is going to protect me or save me, but at least I would know very early on if I had a problem, if there was something wrong. So I want to support this as much as I can, and I want to thank you all for the work that you've done. Thank you, Mr. Chair.
Thank you, Senator Moore. I'll just add one quick perspective, and I'll have Representative Gilchrist continue with her question. We know that if we pick the cancer early, we are going to not only save that life, but the cost of healthcare for, God forbid, a metastatic breast cancer. And these preventive initiatives pay for themselves multifold. That's where it says prevention is better than cure. So that's where the money, frankly, is the public health cost, besides the human cost. The prevention is going to pay for itself right off the bat. So Representative Gilchrist.
Thank you. Yeah, I was going to say, and maybe Senator Moore is probably aware of, we heard from a group called Sisters Journey, and they specifically do outreach into the Black community. But what they shared with us is that they don't have enough funding. So I think it would be really interesting to look at this program through the Department of Public Health to see if there can be a way to provide funding to these localized organizations who are doing the outreach but need support.
So I just want to say, so Sister's Journey is, there's this thing in the Black church that somebody starts a church and then somebody says, I can do this too, and they start another church. Sister's Journey is a spinoff of the Witness Project that I was involved in '95. And they have never received funding from the state of Connecticut to do the work that they're doing. And they're the only Black-led organization on the ground doing that work. What's wrong with that picture when you talk about mortality and morbidity? So thank you. I hope we can do something this time.
Thank you, Mr. Chair. Thank you, Dr. James.
Thank you, everybody.
Actually, I do have a question I did not ask you earlier. Could you tell us what tomosynthesis is for benefit of everyone? And then also the next question I'll follow after that.
Oh, absolutely. So, colloquially, we say it's a 3D mammogram. So it's essentially, it's the same to the patient. It looks the same as a mammogram. You're taking an X-ray, but we actually get little tiny slices through the breast. So for example, a woman with dense breast tissue, we can see all the dense layers in between. So we can find smaller cancers, and that's been proven. And tomosynthesis actually finds more invasive cancers. So there's a lot of clinical debate about, oh, is DCIS real disease? I don't want to muddy the waters, but tomosynthesis specifically finds small invasive breast cancers. It is a more expensive technology, but as I said, the dollars again, as you said, actually the dollars again go to prevention. So we know that if you can find a breast cancer less than 1 centimeter in size, more often than not, that patient does not need chemotherapy. They can be treated with surgery and radiation alone, which is a huge cost savings and a significant benefit to the patient who does not have to go through chemotherapy. So.
And Dr. James, if this bill passes, amongst other things, this will make the tomosynthesis a standard of care, if you will, for breast prevention and identification. Is that fair?
That is fair, and I think that's important. I mean, I think it is a significant improvement over the previous technology. We've kind of gone through improvements over the years, but it's a 40% increase in cancer detection. That's been proven in the US literature, the Canadian literature, as well as the European literature. It was published in JAMA back in 2013. It's a tried and true technology. The literature is well established by multi-center trial, randomized clinical trials now at this point. So I think it's a reasonable expectation in the state of Connecticut that is the benchmark in terms of technology for screening mammogram.
And right now there are insurances which are not allowing this to happen.
Yes.
Thank you. It's just that's why this bill is so important. When we as a state say that this is going to be the standard of care, that would give us the ammunition, if you will, to be able to say, why are we allowing all women, and especially minority women too, not get the standard of care? And have the disease that is preventable, identifiable, and treatable to spread. And in 2022, we are having this conversation, and sometimes you just can't stop but say, are we really in still 2022? Just like Senator Moore said, that we are having the same conversation 25, 30 years later. Thank you, Dr. James, for your testimony, and thank you for the work that you do.
Thank you, Senator Awar. Thank you.
And the next person on our list is Amy Brown, followed by Olivia Rinkus. Ms. Brown.
Thank you, Chairman Steinberg, Chairman Anwar, members of the Public Health Committee. My name is Amy Brown, and I'm currently a practicing gynecologic oncologist with Hartford Healthcare. And I thank you for the opportunity to speak today in support of HB 5278. I would like to state without equivocation that Hartford Healthcare and the gynecologic community in general wholeheartedly support the basic concept of this bill, that patients should always be given the opportunity to consent to or decline any medical procedure or examination. ACOG, the American College of Obstetricians and Gynecologists, also supports the concept of informed consent for pelvic examination. As a surgeon, oncologist, and clinical researcher, informed consent discussions with my patients are integral to the care I provide on a daily basis. However, as a physician educator, the imperative of the current generation of physicians to train the next generation must not be forgotten. Without the ability to learn from both practice and where practice is not feasible from observation, how will the physicians of the future learn the critical skills necessary to safely care for patients? If trainees cannot learn these critical exam skills in training, we will be faced in the future with physicians who have potentially limited competence in independent practice. I have specific concerns about two areas in this bill where I believe the proper balance of patient safety and trainee education has not been achieved. First, I would like to address Section 1C1E. For the majority of gynecologic procedures, where the pelvic exam is integral to the procedure itself, the ability of patients to request exclusion of trainees from even observing the exam seems both illogical and detrimental to education. For a trainee to wait in the hall until the initial exam is performed, only to return to the OR to assist in the surgical procedure itself, where the same anatomy will be exposed, is not logical. Additionally, during the exam in the operating room, there are multiple other staff members present: the attending surgeon, the anesthesiologist, the scrub nurse, the circulating nurse, and often nursing students and anesthesia residents. The surgical trainee would never be in a situation to be unsupervised with a patient under anesthesia, so there would be no chance for a trainee to perform an exam unwitnessed on a patient who had not consented. There is also significant educational benefit to allowing trainees to observe exams, even in the cases where patients do not consent to having an exam actually performed by a trainee. With the relaxation of the pelvic floor muscles during anesthesia, the ability to visualize both normal and pathologic anatomy is increased. In an operative environment, teaching can also be performed using more specialized medical terms that the trainee should be learning, but which would be out of place in an ambulatory setting. I would urge the committee to consider rephrasing this section so that while patients can decline to consent for an exam performed by a trainee, they cannot mandate that the trainee be excluded from observing the exam. Second, I would like to address Section 1C1B, requiring
Excuse
bold
me,
type-
Dr. Brown, but your time is almost up. If you could summarize, thank you.
Sure. Yes, the section of the bold type and the 18-point font, my concern is that would draw undue attention to this segment of the consent and would not be consistent with the relative risks of the surgical risks versus the risk of the pelvic exam. I would support this being rephrased that it has to be included in the informed consent, but request removal of the bold type and font requirements.
Thank you so much, Dr. Brown, for your testimony. Anything else you wanted to just say?
I mean, only that the idea and the concept of this bill, I think these similar bills have been passed in multiple states, and I think essentially all gynecologists would support this as a concept. I think it's really just those two fine points of the observation and the sort of semantics of the documentation of the informed consent.
One of the things I wanted to clarify, because this bill has come almost every year for the past few years, and some of the proponents have shared the traumatic experience some patients have had who were sedated or who were not enough sedated or who were under anesthesia, who felt assaulted, if you will. And that's why it was a very emotional issue and it impacted them deeply. And that's why this bill is there for being their voice. Have you heard of those experiences, and can you explain to me how do we address the issues that those individuals have had?
Yeah, I certainly, have had patients who are survivors of sexual assault where the exam in and of itself can be quite traumatizing. And that's why I think, patients should have the right to refuse a trainee to perform that exam. I think documentation of that is also very critical. I think it's a little different in the gynecologic world. I don't think anyone would argue at this point that you should have a pelvic exam when you're under anesthesia for your gallbladder. But when you're under anesthesia for a gynecologic procedure, the exam really is part and parcel of the procedure. So short of allowing patients to refuse to have a trainee in the operating room at all, it just medically is not logical to refuse to have them present in the operating room during the exam, because that would essentially have the potential to exclude trainees, which as this bill is phrased, includes not only students, but also residents and fellows who are full physicians, to exclude them from the operating room for any procedure where the patient does not want a trainee involved. In the number of teaching hospitals in the state of Connecticut, if there's not a trainee in the operating room, the procedure essentially can't be performed because these hospitals do not have the support staff, the PAs, the nurse practitioners. You can't perform a surgery independently. You really do need an assistant. And in a teaching hospital, that is a trainee by definition. And I think explaining, all the patients I've had, when you explain this to them, that nothing is going to be done that they haven't consented to, and that you as their attending are going to be present and in charge and involved, the vast majority of patients then are accepting of it. I think it's a bigger issue in the ambulatory side, but this bill doesn't cover that, and patients there are awake and can verbally decline an exam in the moment.
Thank you for putting this from another angle and looking at this. I just wanted to make sure you have a written testimony with some of your recommendation. Yes. That was okay. Thank you.
Yeah, I wasn't sure I was going to be able to make it today. I'm in my car, as you can tell. I apologize.
Well, thank you so much for your testimony. We appreciate it. And seeing no other questions or comments, I will move on to the next person on our list, which is Olivia Rinkis, followed by Kelly Huber.
Thank you. And thank you to the Public Health Committee for the opportunity to testify. I'm testifying on a couple bills today. First, I wanted to testify in favor of HB 5272, an act concerning menstrual products. These are necessary items. Speaking as someone who has had the inconvenience of being without a product when I needed it, I can't imagine being in like a place or a position where I'm unable to access these items on my own. Many advocates have already spoken to the importance of making these, making these items accessible in schools, which is absolutely important. In addition to the accessibility issue, there's also the destigmatization of menstruation and the importance of health education, which will have a huge impact on youth. I'd also like to add my voice to those stressing the importance of making these products available in correctional facilities as well as homeless shelters, as the menstruation process is not a choice. To speak to the concerns about mandates, these items are no different from any other basic hygiene item in a bathroom. I would also like to testify in favor of HB 5261, an act increasing access to reproductive health care, because healthcare is a human right. And finally, I'd like to testify in opposition to Senate Bill 254, an act requiring long-term care facility residents to undergo a criminal history and sexual offender registry search. While I can understand the need to keep the staff safe, this bill is just a way of punishing those convicted of a crime beyond the end of their lawful sentence. A criminal record should not be used to deny someone housing or employment, or in this case, to deny someone necessary long-term or rehabilitative care. So yeah, I am testifying in opposition to this bill, and thank you again for the opportunity to testify.
Thank you so much for your testimony, and thank you for being concise and to the point and sharing your perspective on multiple bills. You got so much done in a short time. So appreciative of that. Seeing no questions or comments, we will move on to the next person on our list, which is Kelly Huber. Ms. Huber.
Thank you, Senator Anwar. To the members of the committee and the General Assembly, I thank you for the opportunity to testify in support of HB 5261, an act increasing access to reproductive health care. My name is Kelly Huber. I'm a proud native and current returning resident of Simsbury, where I have just returned with my husband after graduating from law school. Most milestones that I've reached in adulthood are a direct result of the abortion that I received when I was in my final year of study at the University of Connecticut in 2014. When I knew that I was facing major transitions so quickly, I knew at the same time that I was not ready to be a parent. A friend immediately recommended UConn Student Health Services, and I received clear, judgment-free guidance on what my options were. The supportive team of nurse practitioners helped me find security and comfort in my decision to terminate my pregnancy. And with the office's help, I made an appointment at the Hartford Women's Gyne Center. During my procedure, I encountered several physician's assistants, nurse practitioners, and other physicians in the practice. While on my exam table, I realized each of these providers had the same common goal, ensuring that I had a safe and comfortable abortion experience. This goal continued after my procedure when my team of providers worked together to secure a birth control implant quickly after my appointment and within my insurance limitations. Looking back, I could only find trivial differences between the providers at my appointments, not because of apathy, but because each provider within their conduct had earned my trust through every step of my experience. Those appointments at the Hartford Women's Gyne Center and UConn Student Health Services were how I got to where I am today. This medication abortion was the catalyst to completing my bachelor's degree, landing my first job, and earning my law degree. When I think about who provided me with the care that I needed at that time, not just in medication dosages, but answering my questions with scientifically supported realities and respecting my decisions, I don't think about whether I was in Storrs or Hartford, or who was or was not in a lab coat. When working with other abortion advocates on the state and national level over the years, my story has struck out for its relative ease, and for that, I have the outstanding team of medical professionals to thank from both offices for this unique quality. In our current climate, where politically radicalized federal courts threaten to overturn decades of precedent, state legislatures have an exigent responsibility to step in and protect their citizens' fundamental rights to privacy and abortion care. Connecticut has been synonymous with progress on the national stage since the days of Griswold, yet gatekeeping who can and cannot provide abortion care with antiquated laws goes directly against this reputation. State legislatures must stand up for all of their constituents, affirm and protect the rights to abortion care, and then create policies that make exercising that care actually accessible. Patients in the Nutmeg State are fortunate to be surrounded by leading hospitals and healthcare providers, but limiting abortion care to a select class of providers is only going to hurt patients in the long run. I respectfully urge members of the committee and the Assembly to support HB 5261 and respond to the current desecration of fundamental rights to privacy in our country with expanded access to constitutionally protected healthcare in Connecticut. Thank you very much for your time.
Thank you so much for your testimony. And seeing no other questions or comments, we'll move on to the next person on our list, Kristen Hickey, followed by Leslie Bennett.
Hello, my name is Kristen Hickey, and I'm a nurse and a stroke coordinator of the Central Region of Hartford Healthcare for the last 17 years. And I'm also a member of the State of Connecticut Stroke Advisory Council. I'm a resident of Wolcott, Connecticut, and I work every day to improve stroke care to my patients. I'd like to thank the Public Health Committee for hearing my testimony today on House Bill 5273, an act establishing a statewide stroke registry. Stroke is currently the leading cause of disability in 2020, with almost 1,500 Connecticut residents dying from a stroke. During a stroke, approximately 2 million brain neurons die per minute, so rapid coordinated treatment during a stroke is critical in improving patient outcomes. In Connecticut, we can do a better job at identifying stroke patients, rapidly screening them with advanced testing, and then providing them the best and most updated treatment in order to improve their outcomes. The statewide stroke registry is needed as we evaluate the care delivered to the patients, the financial impact stroke has on healthcare costs, and the discrepancies in care that are given to various underserved communities, cities, and towns. A statewide stroke registry is a repository of de-identified data and will help the Department of Public Health, as well as the State of Connecticut Stroke Advisory Council, evaluate the stroke care delivered throughout Connecticut and identify the potential discrepancies in care delivered to the stroke patients. Data will then drive the performance improvement initiatives that are needed in Connecticut so every resident will have access to high quality stroke care. We cannot improve the care provided to stroke patients until we identify the areas that are most in need. Concentrating resources to those areas by providing mentoring, education, and feedback will benefit everyone in Connecticut and will be a priority of the State of Connecticut Advisory Council. Currently, Connecticut's practice is behind many of our neighboring states like Rhode Island, New York, and Massachusetts, who already have a database and a process in place for evaluating stroke care. This bill will be a much needed step to ensure care to stroke patients in Connecticut is current and delivered to the standard all residents deserve. Stroke registries exist in 27 of the 30 existing hospitals. So having access to the aggregated data will help identify initiatives to improve stroke care in Connecticut. I'd like to thank you for raising this bill, but some of the language as it is currently written is not what our team had endorsed or requested. The way it is written, it includes financial penalties for those in hospitals that do not participate, and it also includes specific database that should be used. Our team does not support or endorse financial penalties on any of the hospitals that do not participate, and we do not endorse only one data platform for the deposit of the data. I've attached some redrafted language in my written testimony as well. I thank you very much for your time hearing my testimony, and I look forward to working with all of you in the future to improve stroke care for our patients in Connecticut. Is there any questions?
Thank you so much for your testimony. Very helpful, and appreciate your insight, and thank you for the work that you're doing. And I know many of us in this committee would agree with what you're saying, and I agree with you about some of the language modification aspect as well. So seeing no comments or questions, we will move on to the next person, which is Leslie Bennett, followed by Kelly Peretti. Leslie Bennett.
Good afternoon. Thank you, Chairman Anwar, Chairman Steinberg, and the ranking members of the committee, Representative Pettit, Senator Summers, and Senator Wang, for the opportunity to testify in favor of House Bill 5260. This is a bill that's my name is Leslie Bennett, and I should clarify that I am a resident of Stamford and was the primary caregiver to a daughter, Kelly, who was born with a metabolic disorder. And for the last 25 years, I've been advocating for patients, mostly children with rare disorders, on a state and national level. Currently, I'm also the volunteer Nord State Ambassador for the Connecticut Rare Action Network. On a more personal note, Representative Steinberg, our community would like to sincerely thank you for all the work you did on this bill. And we'd also like to thank Representative Pettit for all his advice and help, and all the wonderful members of the CGA who've been working with us on this. We enjoy support from both sides, both committee, both caucuses, the Republican and Democrat, and we sincerely appreciate it. Our biggest problem is that state lawmakers, health policy experts, and even state agencies often struggle to understand the needs of our community, and we feel that a Rare Disease Advisory Council will allow patients and their advocates to actually the opportunity to partner with agencies such as the Department of Public Health and Social Services, and to directly interact with state leaders in order to educate the state. And this includes healthcare providers, agencies, our hospital systems about the needs of rare disease patients, and to make formal policy recommendations about our community. Since we believe an RDAC should be housed in the Department of Public Health, you have my testimony on the reason for this committee. I'd like to address some of the commissioner's testimony, the points she made. I understand Commissioner Juhani is new, but her department, we took the liberty of going to them first to talk to them about this. And quite honestly, I think the testimony I found a little bit hurtful, but I think it also illustrates to us the problem that we have with the state agency. They say that the Department of Public Health isn't the right entity to host this council of proposed magnitude. I have that feeling that deals with the 7,000 rare diseases. We're not asking them to list every 7,000, all of the diseases. We're just asking for a link on their website to NIH with information on all rare diseases. I mean, it's a simple link, but it would help physicians in our state understand our population a little bit better. They say that the suggested focus would best be achieved without interference from the department's competing priorities. I have no idea what they mean by this, unless they're referring to the defunct Genetics Council, Advisory Council that they had probably 10, 15 years ago, or the current Connecticut Genetics and Newborn Screening Advisory Council, which all states are supposed to have for their newborn screening program, but this has not been open to consumers and members of the public since for a year and a half. So I'm not even sure it's in existence right now.
Excuse me, Miss Bennett, your time is almost up. If you would please summarize. Thank you.
Thank you. We don't think that that will interfere with the any of the programs that DPH is offering. They also say they have no expertise in rare diseases. However, they do. We've had the newborn screening program for over 50 years, and DPH lists acquired disorders such as babiosis, dengue fever on their site. So we need their expertise on this council. And I think it would be a huge loss not to have them. Their budgetary concerns, we've already addressed. The council will fund itself. The only possible expense would be for part-time aid for the first meeting, only because the council can't seek funds and everything else from right now because we're not in session. Thank you.
Thank you so much, Ms. Bennett. I see my co-chair, Representative Steinberg, has a question.
Thank you, Mr. Chair, and thank you so much, Leslie, for your testimony, even more importantly, your work to bring us to this point. Yeah, I think we do have to be careful about independent fundraising and staying within the limits of the law.
I do.
Yeah, so we'll work on that part. But yes, the points you made with regard to DPH's testimony, we will have further conversations with them. I think the way in which you have narrowed the ask, if you will, to simple things like links on the website, and that helps. I also know that they're concerned about staffing such a group as the Public Health Committee is as well. But these are things hopefully we'll be able to work out.
Yeah, and there are questions about surveillance. We don't have CPD or ICD coding in order to even do that. So this is way premature. And the council will actually seek a grant if that's what they decide to do. But during the first year, it's pretty much set up. So we don't envision a huge problem for them. And as far as housing goes, we already have commitments from Jackson Labs and Yale to host us when we go back to meeting in person. So I
That's
just
like a good deal.
Yeah, I think we've been worked on a lot of this. And we did approach them about this before we even had the bill introduced. So.
Well, if you have it in your testimony, if you could perhaps via email just reiterate with these points so that it will aid our conversation when we talk to DPH further.
I'll send you an email about the points. Thank you.
Thank you, Mr. Co-Chair. Dr. Pettit.
Thank you, Mr. Chairman. Thank you, Leslie. A quick question on a number of people from different organizations, businesses have approached me. And so the general question is whether you think the group would have any concerns about perhaps changing the mix of people on the council. Some people have suggested that a little bit more expertise might be needed. I have no amendment in hand nor specific plans, but do you think the group would be amenable to any changes in the makeup of the advisory group if that was put forward?
We had talked about this long before. You had wanted to keep the number down. So we stuck with the number of 15. Yes, it could have been expanded quite a bit, and we could have asked for more expertise. The problem is we sat down and talked to everybody, and we thought we got a pretty good mix. And we figured that if the committee needed, they could reach out. Last time when we had the task force, for instance, there were a number of doctors on it, and their schedules are just so busy, they can't make it all the time. So we were figuring if the committee could reach out to a physician, instead of during the meeting, they could reach out, get expertise, or have them come testify. You know, it's up to you, but we were trying to keep it as minimal as possible, so it wouldn't get too large and unwieldy. I know I've been approached by other people. We did this with a coalition of 50 representatives from industry, hospitals, academic institutions, everybody we could think of, caregivers, and we tried to include as many of them as we possibly could.
Oh, I appreciate that and appreciate those comments, and we'll see where it goes and how many other people reach out. So thank you for all your consistent and hard work on this issue.
Thank you very much.
Thank you, Dr. Pettit. So Ms. Bennett, I wanted to just follow up on a couple of questions. I had a chance to try and get the history of why in the past, when something like this was working or was initiated, why did it not move forward? And I think this was the pre-Zoom era. It was a logistical challenge to get too many people in this at the same time in the same place. I know while you have a place to house this, I think Zoom has its blessings where you do need some of these people who are dealing with these rare diseases and can give you the specific area, because there are some of the diseases that would need the clinician's insight in more depth. So I'm just going to leave you with that thought. Yeah,
we do. That's why we had asked that one of the people on the committee be a geneticist. There's only 2 in the state really to do this. They're practicing, and they know where all the people are that they could reach out to for a lot of these, the input on a lot of this. So the committee can reach out to these physicians and have them Zoom in or come in for a meeting and get their input. So that's always a discussion. We can also have subgroups and everything else. That's for the committee to decide how they want to set it up. One of the constraints was the number of people and making it too large. And they wanted the group of advocates who all got together wanted to make sure the patient voice was heard. So that's why they insisted on having 5 of the members be patients or patient representatives of some sort.
I think the time is always right, but this time is very, very right, because you actually have the capacity to coordinate the people now much better than what we did a few years ago.
Yes,
but
that's
also
definitely true.
The opportunity for diagnostic tests and therapies have exponentially improved every single year, so which is quite fascinating. So,
well, that's another thing we'd like to see up on the DPH side is just modernized genetic testing. The genetic testing they have up there is limited, and it's just expanding like crazy, and people are asking for information. We have physicians asking for it, we have patients asking for it, and one of the first places they go to get reliable information is the DPH website, and it's just not there.
So one of the ways we can do this, and I'll close after this for my part of the conversation, one of the ways we can approach this is this committee, when it's formed, you start to send the recommendations to the Public Health Committee, and we will be your partners on trying to see what your recommendations are and collaborate with the Department of Public Health on some of these things.
One of the things we were thinking of doing is like the newborn screening had gotten a grant from HRSA, I think it was, to update the website. We could possibly do something like that too once the committee is up and functioning to help support it, because I know one of their big things is the website and maintaining it, and we could probably get a grant to do that, make sure the information's there.
Perfect. Thank you so much for your testimony. Seeing no other comments or questions, we'll move to the next person.
Thank you.
The next person on our list is Catherine Villetta, followed by Kelly Parody. Catherine.
Hi, dear Senator Anwar, Representative Steinberg, and distinguished members of the Public Health Committee. My name is Catherine Villetta, and I am a Bridgeport resident. I am a community organizer and advocate within the reproductive health and immigrant rights community, and I am testifying in support of House Bill 5261, an act increasing access to reproductive health care. Nearly 1 in 4 people have abortions in their lifetime, and Connecticut can be a leader alongside the 14 other states who permit APCs to provide aspiration abortion. I really want to emphasize that this would allow Connecticut patients to obtain this care from the health provider they trust in their community and who knows them best. The same provider they see for their routine wellness exams, their STI testing, or their vaccinations, and will result in greater access to care for communities that already face significant systematic, economic, and logical barriers to such care. The timing of this bill could not come at a more crucial time with the increase of extreme abortion bans across several states, and with the Supreme Court considering a case this summer which could overturn or undermine Roe v. Wade. If the Supreme Court does overturn Roe, access to abortion care will become even more challenging, and states like Connecticut can and should play a critical role in expanding access to reproductive health care, including abortion, for patients in our state, as well as those who will be forced to travel to get care, by removing medically unnecessary and unjust barriers that prevent qualified clinicians from providing procedural abortion in our state. Abortion is healthcare, and healthcare is a human right. And this is a matter of public health, as no one should face delays or to time-sensitive essential abortion and reproductive health care due to medically unnecessary barriers. I strongly support HB 5261 with recommended language from providers as well as advocates to best reflect current medical practice and standard of care, and I hope that you all vote favorably. Thank you for your time and consideration.
Thank you so much for your comments. And saying no questions or comments, we will move on to the next person on our list, which is Kelly Peretti, and followed by Anissa Reed.
Can you guys hear me and see me okay?
Yes.
Perfect.
Very well.
Good afternoon, ladies and gentlemen. My name is Kelly Parody. I come to you wearing two separate hats. First off, as a student, I'm a full-time student at Central Connecticut State University. I'm also the chair of the External Affairs Committee on our campus. Thank you for allowing me to share my testimony with you all today in support of House Bill 5272, an act concerning menstrual products. This topic is important to me on multiple levels as it pertains to affordability and health. Specifically, on campus, it boils down to affordability and health. As a university and Connecticut State school system, we've worked hard to make college affordable. We have done this with free community college efforts, scholarships, grants, financial aid, CARES Act, and continuous work through open educational resources. Additionally, we have talked thoroughly about food and housing insecurity. Period products fall into this category, as a majority of our campuses have open food pantries across the campus as well as other assets. Putting period products in our laboratory facilities is just the next step in affordability and ensuring our students can pay attention to their coursework and be successful on their college campuses. Next, I come to you on a more personal note. As it pertains to the portion of the bill that speaks to the correctional facility. I'm the sister of a former inmate at your correctional facility. And speaking with her about the period products and period issues on there, she informed me that a lot of the different things they were required rather, to sometimes choose between period health and their health and safety or food. That is a decision that no woman or no individual who is menstruating should have to choose. They were forced to potentially use socks, other items, use their period. I'm sorry. They were forced to use either socks, use their tampons and pads more than once. This is a safety issue, both health as well as for depression issues. No woman, no menstruating person should have to choose between food and whether or not they should be choosing for their health. On behalf of both of those, I urge our lawmakers to support this bill in order to support our menstruating community, for the health of all, for the affordability of all. Thank you and have a nice day.
Thank you so much for your testimony. Truly appreciate your thoughts and words. Seeing no questions or comments, we'll move on to the next person, Anissa Reed, followed by Jan Kurtzman. Ms. Reed.
Great, thank you. Good afternoon, Chair Abrams-Daughtry, Chair Steinberg, and members of the Public Health Committee. My name is Anissa Reed, and I am the State Policy Manager for the Eastern Region at the National Organization for Rare Disorders, or NORD for short. I'm honored to testify today in support of House Bill 5260, legislation creating a Rare Disease Advisory Council, or RDAC for short, in Connecticut. NORD represents the 1 in 10 Connecticut residents who are living with a rare disease. We're grateful for this committee's support and for being champions for the rare disease community. Patients with rare diseases face unique challenges every day. A Rare Disease Advisory Council will give rare disease patients a unified voice in Connecticut state government and provide a forum for the rare disease community across the state to analyze their needs and make recommendations to the governor, the legislature, and state departments on how to improve public policies to better support the Connecticut rare disease community. Any condition that affects fewer than 200,000 Americans is considered rare. Overall, as was mentioned, there are more than 7,000 known rare diseases affecting 25 to 30 million Americans across a broad spectrum of medical conditions. Many patients with a rare disease endure a lengthy diagnostic odyssey and struggle to obtain an accurate diagnosis and access to medical specialists with knowledge of their condition, or are forced to battle for fair insurance coverage of their treatment and care. In addition, it can be difficult for state lawmakers to have an in-depth understanding of the rare disease community's needs due to the small patient populations and the variety of rare diseases. This lack of awareness often contributes to the obstacles faced by rare disease patients and their loved ones. And RDAC is an important tool that can help fill that gap. RDAC members typically include a variety of rare disease stakeholders, and the council may conduct surveys to better understand common challenges rare disease patients or caregivers face, consult with experts to improve access to quality healthcare, or compile resources related to rare diseases. In creating this council, Connecticut would be joining 20 other states that have already enacted similar legislation, in support of their rare disease community and proven that it's an effective way to ensure better government engagement and action on issues of importance to the rare disease community. Once again, thank you for adding House Bill 5260 to this agenda and for championing these efforts. I urge the members of this committee to swiftly pass it out of this committee. Thank you.
Thank you so much, Ms. Reed, for your testimony, and thank you for the work you're doing. Seeing no comments or questions, we will move on to the next person on our list. This is Jan Kritzman, followed by Kathy Flaherty. Jan,
can you
go ahead.
This is Jan. Okay.
Yeah, we can
greetings.
hear you, but we cannot see you. It's up to you.
Okay,
if
well,
you want next to the mic, there's a next to the mic sign. There is also a
right
camera.
here.
You can click on that.
I got it.
Microphone.
And then
Okay. No, it's just speakers.
no, just speakers.
We don't have a camera here.
Okay. Well, anyway, I think all you have to do is hear me. Seeing me, really,
Yes.
it's not that important. Okay. I'd like to wish everybody a belated, happy International Women's Day one day late. And I would like to celebrate by passing any and all breast cancer legislation. For example, I'm here to speak in favor of Senate Bill 249. My name is Jan Kritzman. I live in Newington. I'm a 9.5-year breast cancer survivor, and I support any breast cancer legislation in Connecticut that provides what I call the earliest possible early detection of breast cancer. I'm supporting SB 249, which will add some new and important requirements to Section 19A-266 of the Connecticut statute from 2014. There is no prevention of breast cancer. There's no vaccine. There's no warp speed. The only tool in the toolbox we have to provide long-term survival is education, complete and thorough testing, and early detection. I have a few additions that I'd like to make to this bill as follows. Even a 3D mammogram, also known as tomosynthesis, is sometimes not sufficient enough to find a small, early-stage, non-palpable breast cancer if a woman has heterogeneously or extremely dense breast tissue. Dense tissue shows up on a mammogram as a whitish snowfall, and a small, very small cancerous lesion is like trying to find a snowflake in a snowstorm. Sometimes it can't be seen even on a 3D mammogram. Density affects about 40% of women. It's an essential follow-up ultrasound, essential, or even an MRI must be done to get a different contrast. And a small cancerous lesion is much easier to detect. Ultrasound and MRI should be added to the language in Senate Bill 249. In 2010, a law in Connecticut was passed to mandate medical providers notify women of their density and urge them to follow up with an ultrasound or an MRI. Connecticut was the first state in the nation with such a law, which became the gold standard model legislation for 38 other states. You, the legislators in Connecticut at that time, and you still are my heroes. This notification law, thanks to the legislative efforts of the late Nancy M. Capello, PhD of Woodbury, saved my life. She was the founder of areyoudence.org. Please Google this website if you ever have the opportunity. Also, diagnostic testing by a mammogram, ultrasound, or MRI should be included in Senate Bill 249. If a questionable finding appears on a screening mammogram, a woman gets a call back. This is for diagnostic testing and must never be a financial barrier. Furthermore, I'd like to lower the age of screening, especially for cervical cancer, to age 18, and raise the age, especially for breast cancer screening, to unlimited. The most important addition I suggest is that breast cancer awareness and breast self-exam be taught in the Connecticut public school system from grades 6 to 12. Presently, it's not included in the state of Connecticut sex education curriculum. At about age 12, girls become women, their bodies change, and they develop breasts. I think this is an excellent time to instruct them about breast self-exam with question and answers from a qualified educator and inquire.
Excuse me, Ms.
Ask them
Kurtzman,
to acquire.
your time is almost up. If you would please summarize, thank you.
And inquire if possible about their family history. By the way, this same goes for school-age young men. Testicular cancer strikes in the late teens and early 20s. Education and awareness should also be provided for them in the classroom. The cost of adding breast cancer, cervical cancer, and testicular cancer awareness to the Connecticut sex and health education curriculum would be minimal, and the potential of saving lives priceless.
Thank you so much, Ms. Kurtzman. Congratulations on being a survivor, but also being a voice to raise awareness and in trying to save more lives. And I think with your testimony and the work we're trying to do, and maybe after we sit down with some of the proponents and look at the language opportunities that you've given us, we may be able to have many more women like you who would be able to identify the disease early and be able to give back to the community. So thank you for your testimony and thank you for the work you're doing.
May I make one more comment, Senator?
Yes, please go ahead.
And a short comment. In minority communities, breast cancer often strikes women at a much younger age than Caucasian women. And it's often detected at a late stage, and it's often the type called triple negative, which is extremely difficult to treat. Outreach must be made to this community. Access must be had for this community. Transportation should never be a problem for testing or for treatment for this community.
Thank you so much. I listened to your testimony. Everything that you're saying is medically accurate from my understanding as well. So I truly appreciate your work and your words. And seeing no other comments or questions, we will move on to the next person on the list, which is Kathy Flaherty, followed by Barry Walters. Ms. Flaherty.
Good afternoon, Senator Anwar. I don't know why my video isn't coming up. I got the message to be promoted to panelist while I was testifying in Judiciary Committee, so you may not be able to see me today, but rest assured I've been here. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project. We are a legal services agency that provides legal services to people who are eligible for mental health services from DEMAS. I'm here to testify on two bills. One, HB 5272 concerning menstrual products. I do believe, it is something that affects half the population for 40 years. It's a basic need, and this committee should advance that bill. However, I'm here in very strong opposition to SB 254 because I'm not sure that it will really provide the safety that I know it is the goal of the Public Health Committee to provide not only to residents of nursing homes, but also the staff who work there. You have my written testimony, you have the written testimony of other people, and the biggest concern is, given all the work that we have done in this state in recognizing some of the inherent problems of our criminal legal system and all the collateral consequences that come from having a criminal conviction, being on the registry in and of itself is not necessarily evidence of present danger to others. And when we're talking about people who are seeking admission to a nursing home, they are people who, by virtue of either their physical health condition and or their mental health condition, need a nursing home level of care. And if that screening is going to result in a denial of admission, my question to the members of this committee is, what happens to that person next? We know that 60 West was established in Rocky Hill as sort of the nursing home of last resort. We at CLRP know of people who were denied admission to 60 West because of their being on the registry. So does that mean that we leave people out on the street? Does it mean that we leave people in Department of Correction that is unable to meet their medical needs? I'm not sure what the plan is. And that's really what I'd ask you to consider, is the unintended effects if you were to pass that bill. So I'd encourage you not to. I'm happy to answer any questions.
Thank you so much for your testimony. I see Dr. Pettit has raised his hand, so we will have Dr. Pettit go and then I'll follow up as well. Go ahead, Dr. Pettit.
Thank you, Mr. Chair. Thank you, Kathy, for your very reasoned testimony. Looking at it from the other point of view, do we need to do, as a legislature, other things to remove people from the registry when they're no longer at significant potential for harm? Is that part of the issue? And the follow-up beyond that is, are there things that we should do in the nursing homes to increase safety in this area, or do you think we're covered with current statutes and regulations? Thank you.
I really appreciate that question, Representative Pettit, and I will tell you that I am actually not the attorney at CLRP who has been doing a lot of work on sex offender registry issues. That's Attorney Sally Zanger from our office, so I certainly would like to consult with her before giving a more detailed answer. But what I can tell you is that people have literally been working for years on trying to revise the registry and make sure that it's a truly risk-based, more personalized assessment of people who need to be there, especially for a lot of people who the members of this committee may or may not realize. There were a number of people who were grandfathered onto that registry, so had done crimes, committed crimes, found guilty of crimes before the registry even existed, may have been put on it originally for 10 years and then at some point for some reason got switched over to a lifetime registry. And there are a number of people who, did something once, never did it again, yet really literally have this, whatever letter you choose for it, but have that scarlet letter attached to them. So I do think a big part of this has to be a reevaluation of the registry, which obviously I guess would be Judiciary Committee, not this one. And I know there was a second part of your question and I'm just not recalling it.
If there's anything else along the lines of this bill that we should do in terms of safety at skilled nursing type facilities.
Well, I think every worker deserves to have a safe workplace. And I think part of the challenges that we face when we're dealing with institutional settings is how do we make sure that the needs of the people who are coming into them are properly understood so that we have people being placed in the proper setting that meets their needs, but is also the least restrictive, most integrated setting to meet those needs. And, I would certainly think it's important to bring all the stakeholders to the table, both the people who work in these places on the front lines, people who are residents, their family members, administrators, advocates. There may be a place where this discussion needs to go. I just don't think this bill is it.
Thank you. Thank you, Mr. Chair.
Thank you, Dr. Pettit. I'll just make a quick little comment to your comments, Kathy. Massachusetts has a bill which actually has created gradations, and between the various bills that have been out there, that looks at a person who may be an offender but now is from a stroke or any other illnesses is bedbound and is not necessarily able to move, and we may not control that individual's mind, but we may be able to recognize that they are not even able to move, so their risk profile would not be as high as a person who has been active and physically able to harm somebody. And that's where they have tried to create gradations, which has been a way to identify. But what's happening is that the other states have similar laws, but they're actually sending the patients over to us. And I feel that our workers need to be aware. And yes, we may not want to deny, but we want to do a risk assessment. We do not want to deny a worker the safety and information of what they're going to be what situation they're going to be walking into. And that's their right. And we need to protect that, but identify ways to be able to look at it. So there may be an opportunity, but I appreciate your testimony. And
thank you. I appreciate it.
No other comments or questions. We will move on to the next person on our list, which is Barry Walters, followed by Kathleen Lutz. Barry Walters, Mr. Walters.
Chairman Anwar, Chairman Steinberg, Vice Chair Gilchrist, ranking members, and distinguished members of the Public Health Committee, thank you for the opportunity to submit testimony in support of HB 5190, an act concerning testing of human immunodeficiency virus. My name is Barry Walters, and I reside in West Hartford. As a matter of record, I am Director of Prevention Services at APNH, A Place to Nourish Your Health, formerly known as AIDS Project New Haven, and I am a person living with HIV. In my work and in my life experience, I am witness to the stigma, hesitation, and fear associated with HIV. While HIV is no longer the death sentence it once was, for many, it still carries a heavy weight that prevents individuals from testing, access to education and prevention, and to culturally competent care. My belief is that HB 5190 will increase access to HIV testing, prevention, and care. I have submitted written testimony and would like to address some of the objections that I have been presented in discussions around this bill. The ask burden to healthcare providers. I understand inserting one more thing into the limited time spent with a patient or client is an issue. I do not believe there is an equal comparison to the burden carried by those persons living with HIV. Stigma and the daily reminder of your mortality is a heavy burden to bear, as is the burden to our healthcare system and cost to local, state, and federal governments. At an average of $420,000 lifetime treatment costs per person, the cost burden is immense and should not be overlooked. There is no comparison. Fear of asking the question. HIV should not be any different than any other illness. A reluctance to make an ask for HIV screening because a provider is fearful of how the patient will take it only feeds the stigma around HIV testing, prevention, and treatment. This bill will hopefully assist in addressing stigma by asking all persons, regardless of presumed risk. Please remember, an individual will not always confide in a healthcare provider why they may be at risk. Universal routine HIV testing treats everyone equally. Education is needed. This is a true statement. Education inside the healthcare profession and outside is very important. The AIDS Education Training Center has offered to provide educational programming for providers to increase their knowledge base and perhaps make the ask more simple and more comfortable. In addition, a toolkit is already in development at DPH and is modeled after toolkits already in use in New York and Florida. Education is vital to delivery of HIV services. Insurance does not cover HIV testing. In fact, it does. Under the ACA, most new health insurance plans must cover certain recommended preventative services, including HIV testing, for everyone aged 15 to 65 and other ages at increased risk without additional cost sharing, such as copays and deductibles.
Excuse me, Ms. Walters, your time is almost up. If
Thank
please
you.
Summarize. Thank you.
Covered by insurance. Emergency rooms are a busy place. Unfortunately, many who arrive in the ED are individuals without insurance or underinsured and are utilizing the ED for primary care purposes. Even one case of HIV that is not identified in the ED is too many. The reasons that an individual has arrived at the ED for their care should not preclude them from quality, culturally competent, and equitable health care. That includes HIV testing when that individual is able to consent. I have a couple other arguments here, but for the sake of time, I'm going to skip those. I support HB 5190 and routine testing in medical care settings, including emergency departments, and urge you, the Public Health Committee, to vote favorably and move this bill to the GA. Routine HIV testing is an important tool that can help the epidemic after all of these years, end the epidemic after all of these years. Thank you.
Thank you so much for your testimony, Mr. Walters. Appreciate your insight, and we as a committee truly agree with you, and that's why we have this bill forward as well. I see Representative Gilchrist has a question or a comment.
Thank you, Mr. Chair. Hi, Mr. Walters. So good to see you today. Thank you for your advocacy and work on this important legislation. Just wondering if you could briefly walk us through what the policy actually does. What would the routine screening look like?
Routine screening, it basically makes it so that our healthcare providers would make the ask of a question. It doesn't mandate that a person take the test. It has it so that they make that ask. And the hope is that we can increase the number of tests, identify HIV infections, and treat them before they become advanced. In Connecticut, some 28% by 2019 numbers are what we call late testers. Late testers are those individuals who are testing HIV positive, and then within 3 months of that original test, also have a diagnosis of AIDS. Once you reach that point, the health outcomes do diminish somewhat. And there's also a much higher chance that there have been other infections because it has been so late in their diagnosis. With earlier detection of HIV, the health outcomes are much better. They're also preventative, in which that individual, once they go into treatment, they're going to become undetectable. And as some may know, once you have become HIV positive undetectable, the odds of passing the virus to another person sexually is very low, almost zero.
Thank you. And just one follow-up. What would you say in your experience, why are there so many late, why does it take folks a long time to get tested? What are some of the barriers?
Well, it could be just access to care. In many cases, that's what it boils down to. And whether it's the lack of healthcare coverage or diminished healthcare coverage, or if they're in places where they just don't feel comfortable in getting that test. There's also some cultures here around the world where discussion around HIV is just not, you don't do it. And it can prevent, that cultural influence can prevent access to care. So there's a number of things that can play into that. The major one is just the wait. They're not feeling comfortable with going to a provider.
Great. And so my background, I trained healthcare providers to screen for intimate partner violence. And there was this thinking that by asking the question and opening the door, you were giving folks an opportunity to get resources and referrals. And so it's somewhat similar in my mind, because by at least asking the question, it's normalizing the discussion and potentially linking folks sooner, like you said, than later. Sorry.
Absolutely. And that's one of the areas. Stigma is a huge barrier. And I should have just mentioned that. But stigma, prevents so much from happening in the HIV world. And by addressing that and asking everybody, you are actually chipping away at that stigma, in my opinion. And that's what we have found in our work. So it does address stigma, this kind of routine testing does. In addition, I think that, by making it available to everybody, it removes the judgment call that a provider, whether they mean to or not, sometimes make. They may not know the risk, or they may assume a risk, or they may not assume it at all. And so unfortunately, the ask doesn't get made. In my particular case, my doctor knew I was a gay man. He knew that it was standard in his practice that all of the doctors asked those that might be at higher risk. He asked me in a routine visit, it was a physical, if I wanted to add on the HIV test. I'm like, whatever, go ahead. And, I got a call back saying, Mr. Walters, your test is positive. Can you come in? So, for me, I was fortunate enough to have somebody, he knew what my risks are. But if we don't know the risks, we're not discussing the risks, then those questions don't get asked in the first place. And, to what you're saying, this opens the door to evaluate that risk. And not for nothing, it also is for risk for all sexual health. It's for SUDS, substance use disorder, because we know that HIV is not passed only sexually. It can be passed by the sharing of needles. So, and also mental health. It can raise red flags in mental health. So there's a broad spectrum here where it could open up the conversation. And yes, it does add time, but that time versus a person's overriding or overall health, I struggle to find the comparison, and we're trying to treat the whole person. So, thank you.
Thank you. Thank you, Mr. Chair.
Thank you so much. And I think, Mr. Walters, you touched on this very well, is that where HIV is now, it's become preventable, it's treatable, and you can actually prevent the spread of it as well. And identification becomes the entire reduction in the cost of healthcare if we can prevent it early enough. And this bill just does that, is it helps prevent this. And when you have the prevention, you're able to actually subsequently reduce the spread risk, because all of the treatments are now available and accessible in our society. So, Dr. Pettit.
Thank you, Mr. Chair. Thank you, Mr. Walters, for your testimony. First question is, if I recall correctly, the CDC guidelines are to offer the test once and consider people's risk factors in life versus this requiring at each ER visit or interaction with someone over the age of 30. Why such an aggressive approach compared to the current CDC recommendations?
Well, there's a couple of reasons. One is just the reality. The reality is that people are engaged in behaviors that may have some applied risk, far more than just once in their lives. And I think that's applicable to most people, whether we want to admit it or not. So it's more aggressive because we're recognizing that people, they have sex. There are people that are using needles. There's a need out there, and it doesn't end just after one test and a lifetime. So that lifetime, what is it? Is it 20 or is it 60? So, it's addressing that what I think is a gap. And I'm sorry, the other part of your question was?
No, just that it differs. I mean, most physicians in practice are going to take into account people's risk factors and be more likely to offer someone who has 2 or 3 risk factors versus a 14-year-old who they believe has none, if they're getting the whole story. Let me move on to the emergency room. This seems complicated because certainly in my practice, I had a number of frequent flyers, meaning people who ended up in emergency rooms 40 weeks of the year. So they could potentially be offered this test multiple times and get tested multiple times. That's an issue only for a tiny percent of the population. But the bigger issue I see is taking the test. If it's not a rapid test, and if it's not, then trying to follow up with patients. It's a big, devastating diagnosis to people. So to put it in the hands of an emergency room, a busy emergency room, to then try to reach out and provide services, I think creates an issue. I think it works better in your primary care office versus an emergency room. What do you say about this? Sort of, you got a call and you got to come in to see your doc. If you're in an emergency room, hopefully it doesn't get lost. Then someone has to reach out to you, say, you sprained your ankle last week and you're HIV positive. Where do the emergency rooms go from there in terms of handling it on a practical basis?
Yeah, absolutely. Thank you. That's actually a very good question, and I appreciate it. DPH actually tried something a few years back where they engaged 6 hospital emergency departments and tried to get them to employ some HIV testing. And it was found to be very difficult. I know there's pretty much only one of those hospitals now that is still trying it. And in their particular case, they passed the responsibility of tracking the patient down to their HIV services department. So rather than them taking that job on and expending the resources, they gave it to the people who do it for a living and know how to do it. And in addition to that, there are tons of agencies in Connecticut, even here in Connecticut, my own APNH, Apex and Danbury, AFL and New London. There's a number of them that can help connect the patient to the services that they need. It's what they do every single day. And When I say services, I'm talking about connect them to medical care. I'm talking about medical case management. I'm talking about, in some cases, housing. I'm talking about food. I'm talking about a lot of different areas in which these agencies either do or have access, direct access to. So that shouldn't be a barrier. We have the resources available. They do it every day. It's just a matter of creating the system where that hospital ED or hospital is working more closely. And most of them already do. You know, we have a great relationship at APNH with Yale. And I know that Danbury, Apex, has a great relationship with Danbury Hospital. So I know that those relationships already exist. So it's just a matter of formalizing them and making them work.
And finally, having read most of the testimony on this bill, the State Medical Society offers a compromise. You may not have seen it yet, where they say, what about the possibility of offering it on an intake form? You come in and you can check a box and say, yeah, I want an HIV test, and then have something posted in the waiting room saying we offer HIV testing. Have other states done that? Has that been an effective mechanism to get to the same goal?
Well, I am aware that the Medical Society has proposed that. I have spoken to them a couple times, and you know, my rebuttal to them was, why can't medical assistants ask this question and make it part of the screening that already takes place before the provider walks into the room? I actually see no issue with that. Part of the toolkit to address the other part of that toolkit that they've actually seen, the New York ones, includes signs where you can post it right in the lobby and say, we do HIV testing. And so those are very, very, in my mind, I don't want to use the word acceptable, but you know, they're very viable, I guess I would say.
Thank you for your answers, and that's it. Thanks, Mr. Chair.
Thank you.
Thank you so much. What we'll do is before Representative Tavros comes in, I will hand over the chairperson responsibility to the Representative Gilchrist. She will be managing the meeting. I will be in another meeting and I'll be back, but I'll be listening in. Go ahead, Representative Tavros.
Thank you so much, Mr. Chairman. And I think we're all doing double and triple duty this week in meetings. So we're listening as best we can. Thank you so much, Mr. Walters, for being here today. I hope you didn't log off yet, because I do have a question for you. I wanted to say that, you know, as a for instance, when we go to our OBGYN appointments, we're screened for domestic violence. And it was interesting. I remember the first time that I got screened for that, I was kind of surprised, and I sort of made a joke, which I shouldn't have. And you know, the nurse pointed to where there were little tear-off sheets about getting, you know, who to call. In my case, it would have been Interval House. And she said, well, look how many people maybe didn't tell me, but tore off the sheet. And so I guess what I'm wondering is, you know, what are other states doing around this? Because that was sort of referenced, but I just kind of want to be clear on that. And while I understand, you know, what the CDC is saying, I do think that even the doctors on the call might agree that patients don't always tell the whole truth and nothing but the truth, especially when it comes to their sex life, and especially married couples and people who aren't married. And, you know, that's the nature of human beings, right? So what are other states doing? And I because this does seem to me like it would be a good idea, regardless of known risk factors. It's the unknown risk factors, I think, that concern me more.
Absolutely. And what I can speak to directly is the New York law, which was actually brought up back in 2010. And then it took a year for them to implement it in 2011. And they have seen an increase. They saw almost immediately an increase in the number of tests conducted. They did a lot of surveys and had a lot of reports that people were being asked. They reported they were being asked. And I'm sure that those surveys were probably not as scientific as they could have been. But we know that they implemented it in New York. We have spoken with them a bit about what did they do right and what did they do wrong type of thing. And it's worked there. Another state is Florida, where they actually, it's automatic in Florida. So they don't give you the option to opt out, to say, no, thank you, I don't want to test. It's just included. And they too saw, obviously, a dramatic increase in the number of tests and in the seropositivity rate. That is those new identifications, new HIV illnesses identified. They, which, at first I would expect that possibly there would be a bump in that number, but the hope is that it would drop off very quickly as more people are getting tested. Now, as far as, talking about what people will or will not confide in their providers, I work at a community-based organization. We see those individuals that come in to test because they don't want to go to their provider. No offense to the providers on here. They want to keep it under wraps. They want to keep what their risk factors, they want to keep that minimized, as to who knows. And so they come to us. So we know for a fact that it's out there. And it's this bill, when you start talking about routine testing, it's hopefully will catch some of those individuals that are reluctant.
I think that this points out something that I think those of us who have lived through the 80s and the 90s, we have memory of what it was like when it first, when first we're detecting. And I think that it's a valuable reminder that this isn't just one community that gets this one disease, that this is a disease that can affect many cross demographics. And that's why it's valuable to put this forward and to ask people, because you just never know, who's going to be caught. And like you said, you catch it early, it's treatable. And obviously, you're able to live longer, you're able to live healthier, all of those things. So thank you so much for your testimony today.
You're welcome. And just to touch on that, heterosexual Black women are seeing some of the spiking rates right now. So, you're absolutely correct. It isn't just a gay disease. It isn't just people who use injection drugs disease. This is something that affects a wide variety of individuals and communities. Thank you.
Thank you, Mr. Walters, and thank you, Representative DeGraw. I think that is all for today. Thank you for being here, for testifying.
Thank you.
Next, we will hear from number 39, Kathleen Lutz.
Hi, good afternoon. My name is Kat Lutz, and I'm here to testify on behalf of House Bill 5260, an act establishing a rare disease council. So I work at the Jackson Laboratory. I'm the senior director for the In Vivo Pharmacology and Drug Efficacy Testing Center, as well as the senior director for the Rare and Orphan Disease Center. Wanted to take a minute just to underscore something that was mentioned about therapeutics for rare diseases and how fast they're advancing. I want to make sure that the folks on this call know that that is in fact more true than it's ever been. I work with a number of biotechnology companies, a number of major pharmaceutical companies, and the advances in genomic medicine and genetic medicine are more so now than they've ever been. It's a very exciting time, I think, to be a part, and very promising in terms of individuals and families who have rare diseases, that there are possibilities that have not been there before in terms of therapeutic strategies on the other end. I do also want to touch on another role that I have at the Jackson Laboratory, and that is really working with individuals who are newly diagnosed. And newly diagnosed families with rare diseases often have a very similar story, one that is a little disheartening, and one that I think that this council can help address. And that is with their diagnostic odyssey and their education in terms of having their diagnosis in place. Oftentimes, the signs are missed. Developmental milestones are seen as maybe delays in their patient in their patient populations. and the information that pediatricians have in order to have individual families and patients access to exome sequencing, for example, and quicker diagnostics is just imperative. The quicker we have a diagnosis, the more then we can understand even how to treat individuals from an occupational therapy as well as a dietary standpoint. So with that all being said, there's a number of pieces of information here. Not all that I can touch on today, but wanted to make sure that I was here to testify today to offer my full support for the rare disease community and all of the things that this council can provide, which I think are exceptionally important. Thank you for your time.
Thank you, Ms. Lutz, for your time and your testimony. I don't see any questions, so we're going to move on to number 41, David Leeds.
Hello, good afternoon. So thank you, Chairs Steinberg and Anwar, and the ranking members and all the esteemed members of the Public Health Committee for the opportunity to testify in support of the proposed House Bill 5260, an act establishing a rare disease advisory council. My name is David Leeds. I'm a resident of Avon, Connecticut, and I am a patient with a rare disease called hereditary angioedema with normal C1 inhibitor. Hereditary angioedema, or HAE, affects approximately 1 in 50,000 people. HAE with normal C1 inhibitor is the rarest form of this disease and is estimated to affect as few as 1 in a million. The symptoms of HAE present as episodes. We refer to them as HAE attacks. It's swelling in the body. For me, the attacks cause swelling in my face, my lips, and my tongue, and the attacks have the potential to restrict my airway, which can be fatal. The Rare Disease Advisory Council will help the CGA and state agencies understand issues that come with living with a rare disease. Today, I'd like to highlight just one aspect of life that is more difficult with a rare disease: getting treatment at a hospital. It's a place that as a rare disease patient, I don't feel safe, and I spend a fair amount of time in them. A few years ago, I was a patient at Dempsey Hospital at UConn in the ICU. I had a conversation with a resident who was overseeing my care. The interaction really brings the experience of being in the hospital with rare disease into focus. The resident came into my room and asked if I worked in a medical field. And I replied, no, I work in commercial insurance. This answer surprised her. She said, you know so much about your condition and all of the medications, like how each one works, and a great deal about the pathophysiology of your disease. My answer to her was, I have to. I have to know everything about my disease and my treatments because you and the doctors treating me here don't. And she thought about the response and admitted that I was right. I was the first patient she had ever met or treated with hereditary angioedema. I'd like to encourage the committee to please pass 5260 to create the Rare Disease Advisory Council. It will provide Connecticut's rare disease patients and their caregivers with the ability to educate and raise awareness to the CGA, state agencies, and the public about common life activities, such as getting treatment in the hospital, that are more difficult, scarier, and burdensome to rare disease patients. So thank you for your time and consideration of the matter, and I'd be happy to take any questions.
Thank you, Mr. Leeds, for being here and for your testimony. We do have some hands raised. Representative Tavros, go right ahead.
Thank you so much, Chairwoman. Thank you for being here today, Dave. I appreciate so much because I know what you and your family often go through with this. I've heard today from some of my colleagues concerns over the patient voice versus the expert voice being a doctor, but I think that part of what you just said illustrates that maybe that's not always the case because, can you explain a little bit more about just how rare your disease is and why you are the expert on that?
I can. So, and hereditary angioedema is interesting. We actually have a very strong patient community. And I know a number of other patients, even in Connecticut, with the disease. So the types of the disease, there's type 1 and type 2 are the most common forms. And they typically say type 1 is 85% of the people, type 2 is 15% of the people. And then there's the people with HAE with normal C1, which is the bucket I fall into. And with the basic math, that's no percent. It's such a small number. And I recently had a conversation with a doctor, and there's one test that they run. And there's one lab in the country that can run the test. And over the course of the years they've done the test, they've only ever tested 300 people. So hereditary angioedema with normal C1 is very rare. It's not very well understood, even under the doctors who are the experts in this condition. It is in the version I have is actually more diagnosed with women. They originally thought it was an estrogen based. They've come to learn that that really isn't true, but they have also identified, I think they're up to 6 or 7 different genetic causes for HAE normal. So there's a whole bunch of different causes that all present symptoms that match the disease of hereditary angioedema. The type 1 and type 2, the more common forms of the rare disease, they know exactly which gene is defective. They know it's the SERPING1 gene. HAE normal, they're up to 6 or 7, and they continue to identify more and more every day. And those 6 or 7 only represent maybe 10% of the people who have been diagnosed with HAE with normal C1. So it is very rare in spots, although hereditary angioedema is less rare than the form I have.
I can certainly understand why you and the other folks that we've heard today testify, on behalf of this initiative, why you feel that it's necessary, because I can't imagine something scarier. We all go to the hospital expecting the doctors to be our experts. And for you, that just unfortunately isn't the case. If you had to go to any hospital anywhere in the country, what are the chances that you would have, someone who knew about your illness?
And I think it'd be small. And at least as a rare patient, there's 7,000 rare diseases. I don't expect an ER doctor to know anything about mine versus necessarily any other. The bigger concern, I think, is one where there's an opportunity for education, not only to the hospitals, but also to policymakers and decision makers, is that you kind of go to the ER and you don't want a doctor to say, oh, I've never heard of that. But as a rare disease patient, I would almost rather hear the doctor say, oh, I'm not really sure. Is there someone I can talk to? Is there someone, who is your specialist? Can I reach out to them? And I think a lot of times and I don't think it's out of malice or anything else. ER doctor, right? They're busy. They're dealing with emergencies. They're dealing with traumas. I was in the ER one time and there was a carbon monoxide poisoning in an apartment building in New Britain. I got dropped to the bottom of the line. I mean, stuff happens. But there is often a case where I can give them the name of my specialist, but they won't reach out. They won't ask the questions. And I don't know, I think you had mentioned with another panel, another speaker earlier, the Google doctor. Do they think I'm coming in and right? I'm the patient. I can't possibly know more than the doctor. But we're rare, we have to. And if it's not me, my wife, who's my caregiver, or if it's a child with a rare disease, it's their parent. Or even if it's an adult with a rare disease, it still might be their parent who is still providing their care. We know because we have to, and I would rather a doctor or someone come to me and say, that's a rare disease, I'm not as familiar with it. Who can I call? Give me the name of your, and at least HAE doctors, they will pick up the phone for anyone calling them about their patient's care. And I would assume the same is true with all of these other rare diseases that we don't expect the world to understand because they can't. But we need there to be understanding that this is the reality for rare disease patients, and we need some way to support that.
Thank you so much for your testimony today.
You're welcome.
Thank you, Representative. Next, we have a question from Representative Berger-Jaballo.
Thank you so much, Madam Chair. And thank you so much, Mr. Leeds, for being here and for sharing your personal experience. We often hear about how the high cost of medicines is such a huge barrier for rare disease. Is that something that you can speak on personally and more broadly?
I can. So, and it's interesting about treatment. So I kind of think of myself, I'm one of the lucky rare disease patients, if that's possible. Of the 7,000 rare diseases, only about 10% have treatments. Hereditary angioedema is one of those treatments, and we actually have 8 currently FDA-approved treatments in the market. That said, having there's always this goal, right? Get the research, get treatments. Having the FDA make treatments available and approved does not actually mean we have access to them. So I can speak personally, I take 2 medications. I take one, which is called a prophylactic. The goal is to prevent the attacks from happening in the first place. And the second one is an acute treatment that I take when I do have an attack to treat the immediate symptoms. My drugs are extremely expensive. So the first drug, the prophylactic, is a medication called Takhzyro. It is on the list of 20 most expensive medications in the country, according to GoodRx. So for a month, which is 2 doses, the retail cost is a little bit above $42,000. My health insurance plan has a co-insurance for these medications. They pass along $14,000 to me per month. Additionally, with the rare disease, a lot of the specialty medications, and I don't know exactly what the mechanism, but there's a exception in the Affordable Care Act where the pharmacies and the prescription benefit managers can determine that these medicines are considered non-essential. And what that means is that they can collect copay and co-insurance, and none of it gets to count towards out-of-pocket maximums. Now, in my case, my other medication, my prescription is the acute medicine. I'm supplied roughly 10 doses a month at a retail cost of about $138,000. My copay for that is $2,800. But that would make the out-of-pocket expense for me alone over $700,000 a year. Now, in my position, I'm actually fortunate. I don't pay any of it. I have a combination of copay assistance from the pharmaceuticals, and my company actually provides a benefit where anything the copay assistance doesn't pick up, my company has a service in place that they pick up the tab. It's a kind of a copay maximizer. So my company self-insures, so they can increase the copays as much as they can, offset the cost of the company, and still make sure I don't pay any. But my company offers, I work for a Fortune 500 company, so we're big, and they offer excellent health benefits. The majority of our patients likely are not in that boat, and there are certainly going to be patients in Connecticut with hereditary angioedema and other needs who are relying for their children on Husky or other state exchanges, and getting access to the medications, making sure they're on formularies and ways to afford them. If my company did not offer the benefit to cover the costs, I would not get the medicine. There's no way to afford that.
I would love to follow up with some sort of comment, but I'm too busy picking my jaw off of the floor after hearing those numbers. So thank you very, very much for sharing that. I think that is a critical piece for us all as we move forward in understanding this. Thank you.
Yeah, thank you.
Thank you, Representative, and thank you so much, Mr. Leeds. I don't see any other hands raised. Thank you for your testimony and your time.
You're welcome.
Next, we will hear from number 42, Robin Fretwell Wilson.
Yes, thank you for letting me appear in support of 5278. My name is Robin Wilson. I'm a law professor at the University of Illinois, but I speak only for myself and not the system. I urge enactment of 5278, which would prohibit intimate pelvic, prostate, and rectal examinations on deeply sedated, anesthetized, or unconscious patients for medical teaching purposes, unless the patient consents in writing or electronically. 5278 will ensure that norms of autonomy for all persons are honored and no one is treated as a means to an end. It would place Connecticut squarely within the 20 states giving patients the right to decide whether medical students will perform intimate exams on them for the students' learning. My written testimony, page 2, shows 19 of these laws. I'm sorry, are you able to hear me? New Jersey became number 20.
We could hear you, you just muted.
We're coming up at the end of Hill Street.
I'm so sorry, can you hear now?
Yeah.
Better, okay. So we know exams happen in Connecticut without consent. A March 1 email shared with me from Yale's OBGYN department said that its recent policy revision was needed because, quote, this practice was done without consent. I speak to medical school student chapters all over the country, including in Connecticut. 2 women medical students told me that they had been asked during rotations in Hartford to do exams that they believed were unconsented to. Medical students are afraid to face down attendings about the need for consent. It can affect where they land for their residencies. It can affect their lives. Asking consent provides a teachable moment for the next generation of healthcare providers that respect matters. It relieves their moral angst. Now, some say that intimate exams are no different morally than suturing a wound. Many patients, like Ashley Bates, who testified earlier, are sexual assault survivors. Men and women might actually flip out too, to know that rectal exams are being taught on them without consent. Some people say that patients have impliedly consented upon admission to being practiced upon. They have not. Patients with insurance go to in-network hospitals because they have coverage. Many, quote, public patients go where they can, not because they agreed to be practiced upon. And this is on pages 8 through 11 of my testimony. Standard consent forms obscure the kind of teaching being done. Yale's general consent form, which was excerpted in the Connecticut Mirror last year, leads a reasonable reader to believe that everything being done is being done for the patient's benefit, not the student's. Requiring informed consent for intimate exams will not shut down medical education. Lucy Nolan gave stats. There's stats on page 11 of my letter. But it turns informed consent completely on its head to say, we can't ask you because you might not say yes. Now, this adds no burden to securing consent, as I show on page 3 of my letter. Hospitals facilitate doctors' consent duties now. They can simply add the clear text right from the bill into admission forms.
Excuse me, Ms. Bratwell-Wilson, your time is almost up. If you could please summarize.
Last sentence.
Thank you.
Many believe that self-regulation is enough, but community hospitals are far-flung, as I show on page 8 to 9 of the letter. And so it takes strong norms like positive law to actually change behavior. Medicine is pervasively regulated. Last point, if COVID has taught us anything, it is that trust in healthcare matters. Patients should be enlisted as respected partners in medical teaching. Thank you.
Thank you for being here and for your testimony. I don't see any hands raised. Thank you. Have a great afternoon.
Thank you.
Next, we'll hear for number 43, Dr. Nancy Stanwood.
Yes, I'm here. Can you hear me and see me?
We can hear you. We can't see you.
Okay.
There should be, where you unmute and mute, there'd be the video option.
Thank you. I'm going to find that. This is a different setup than I am used to seeing. I only have microphone control.
Does your computer have the camera?
Yes.
Well, we can hear you if you want to go ahead.
All right. I'm just going to look at one other thing.
Sure.
We're all learning about navigating technology.
Sometimes it's a little box that shows like 3 dots and you drop down on that and it'll say show video.
I have no dots. I have no dots.
And then last for me, the last thing I can think of is at the bottom of your screen would be a video. It shows like the video image.
Yeah. Well, if you'll allow, I'll join with my phone.
Sure. If you want to log back out and in, we'll go to the next person and then we'll go back to you.
Well, I'm logged in right now.
Recording in progress.
Nope, now she's muted. Dr. Stanwood, are you with us?
All right. Well, I'm sorry about the lack of camera. I can tell you that I just got done with a session with patients and I've got my N95 mask marks on my face, but thank you for trying to walk me through that, Co-Chair Gilchrist. I want to give my thanks to the committee chairs and members of the Public Health Committee. I am Dr. Nancy Stanwood and I'm the Section Chief of Family Planning at Yale School of Medicine. And I'm also the Associate Medical Director of Planned Parenthood of Southern New England. This summer, I am the incoming Chief Medical Officer of Planned Parenthood of Southern New England. I'm a board certified OBGYN with over 20 years of experience in medical practice and medical education. I come before you today to express my support for House Bill 5261. I'd like to start with some important medical and public health facts. Abortion care is time-sensitive health care. Abortion care is safe with a complication rate 10 times lower than that of childbirth. While abortion care is very safe, the risk of a complication increases with time into the pregnancy, so timely access equals safety. Access to abortion care is limited for some people in Connecticut. As the leading provider of abortion care in Connecticut, we at Planned Parenthood work hard to make care available and accessible, But we have had challenges with physician coverage of our sessions, and the wait for an abortion procedure appointment is currently 2 to 3 weeks. We can do better for our residents by modernizing our healthcare workforce. HB 5261 will remove the physician-only requirement to providing early abortion care, expanding the workforce to include advanced practice clinicians, APCs, who are nurse practitioners, certified nurse midwives, and physician associates. In Connecticut, under an attorney general's opinion, APCs already provide first trimester medication abortion, but this bill will allow them to provide first trimester aspiration procedures, the most common way that people choose to have early abortion care. In making this health policy recommendation, we are fortunate to have sound science to guide us. Before California similarly expanded their law, researchers there conducted a study of over 11,000 procedures, comparing the rate of complications for procedures done by newly trained APCs with those done by experienced physicians, and they found that both groups had equally low complication rates, under 2%. Early aspiration abortion procedures are similar to other reproductive healthcare procedures that APCs already safely provide, such as IUD insertions. And just as APCs receive training in IUD insertion, they can be trained in first trimester aspiration procedures. In the California training program, they found that APCs reached competency after 40 procedures. I'll say that for over 2 decades, I've trained newly graduated doctors in this procedure when their procedural skills are similar to those of newly graduated APCs. And I concur that new learners become competent after about 40 training procedures. As we look to a US Supreme Court decision this June that will end the protections of Roe, and will see up to 26 states criminalize abortion care, we anticipate that some people from those states will travel to Connecticut for their care. We want to be prepared in our healthcare workforce to meet the current needs of people in Connecticut.
Excuse me, Dr. Stanwood, your time is almost up. If you please summarize.
Yes, thank you. As well as those who may come to our state seeking this essential care. Passing HB 5261 with recommended changes to bill language will help us be prepared to meet this critical health need. I'm happy to take questions. Thank you.
Thank you, Dr. Stanwood. Thank you for being here. And with your expertise, I'm wondering, we've heard a lot today about safety. Can you talk about safety? How do we know that advanced practitioners will be safe for the people needing abortion care?
Thank you for the question, Representative Gilchrist. As I said, we're so fortunate that we have great science and data to look at as we look at making this policy change. And from the California experience, they looked at over 11,000 procedures. That's a very impressive number of cases to have in a study. And their careful analysis showed that the complication rates were equally low for newly trained APCs as for experienced physicians. So we can also look to the experience of 14 other states that have made this update based on this science and have done so successfully and safely. So I am very reassured by the experience of the other states and by the data that this is a safe policy change to make. And it will also ensure improved access to care, and that delays in care negatively impact safety already.
Thank you. I have 2 more questions, and then I'll get to my good colleague who's raised his hand. When you're just speaking about access, we've also heard today the number thrown out there of it's taking about 2 weeks for individuals in the state of Connecticut to be able to get an aspiration abortion. Is that your understanding as well? And then how do you see access being impacted by what is going on nationally?
Thank you. Yes, access definitely is an issue. I can speak to my experience today. I'm in our fantastic New Haven Health Center for Planned Parenthood. And before the increased difficulty we had with physician coverage for sessions, we would have 2 or 3 procedure sessions a week. But this week, we've only been able to have 1. So instead of having around 20 people booked for procedures today, we had 40. So that certainly our amazing team can rise to the need that we're seeing right now, but teams can burn out. And we know this from the pandemic, and that we really want to look at expanding the healthcare team that can meet the needs of our patients. And we know we can do that safely through this mechanism of HB 5261.
And my final question, thank you for that answer. What would you say to folks who are saying, okay, we hear you on the access issue, but why not just train more OBGYN residents to provide aspiration abortion?
Thank you for the question. I think the issue really is that training OBGYN residents is certainly important. It's something I've done for the past 20 years, but that doesn't necessarily mean that those people will become providers of abortion care. And we know that when people do get the training, they don't necessarily become providers, that there can be barriers. And that when we look for our workforce here at Planned Parenthood, we have APCs who are already excellent providers of medication abortion care, are already excellent proceduralists for other things like IUD insertions and endometrial biopsies. And they are eager to become well-trained and provide first trimester aspiration abortion procedures so that we could address the need for access very quickly by training the people who want to step into the workforce immediately. That is not met by training residents, where actually the minority of them will go on to be abortion care providers.
Thank you. That's very helpful. All right, we have 2 hands raised. Dr. Pettit, go right ahead.
Thank you, Madam Chair. Thank you, Dr. Stanwood, for your testimony. A common theme today has been clearly it's that the PAs, APRNs, nurse midwives are able to do the medication induced abortions. And the issue then becomes procedural, because what I learned coming here 6 years ago out of medicine was that we have this review of scope of practice through DPH. Have you or any of your the organization like ACOG had conversations with DPH in terms of reviewing the scope of practice for these products? Sounds like you've come up with the national number that 40 procedures gives you reasonable competency to do the procedure. Is that something that DPH agrees with and could act upon in a timely fashion?
Thank you for the question, Representative Pettit, or do I say Dr. Pettit? I'm not sure when you have 2 titles. We have had conversations with Connecticut ACOG and with DPH. And what I can say is that from our perspective, APCs already do procedures, and that this is not adding anything to their scope of practice, that this is taking away an unnecessary restriction on the skills that they are completely qualified to be trained in and to provide for the citizens and residents of Connecticut.
I practice as an endocrinologist, so my last pelvic exams were about 40 years ago, so I'm certainly not an expert. I would agree with you. It seems that given insertion of IUDs and other procedures, that the suction abortions appear to be within things that they do. Would that also include DNC or other? I don't know what other procedures are required at times during an abortion. If you could comment on that, that would be helpful to me to understand the array of services provided.
Yeah, I think that we can look to the experience of the other 14 states that have done this and have safely trained APCs to provide early first trimester low risk aspiration abortion procedures, so that we're not talking about procedures in an operating room. We're not talking about surgery. We're talking about low risk, outpatient, office-based early aspiration procedures.
So that would exclude a DNC or something that was more invasive than an aspiration abortion?
Well, the techniques are fairly related to each other, but again, we're fortunate in that ACOG does have a definition of their perspective of what is the difference between a procedure versus a surgery in reproductive health. And their definition of a procedure includes aspiration abortion procedures.
Yeah, and as I understand it, we have that issue in Connecticut statute where we don't have a clear-cut definition of surgery, which occasionally raises issues among certain subspecialties looking to do other things. But I appreciate your testimony and those answers, and I will defer to the next questioner. Thank you. Thank you, Madam Chair.
Thank you, Representative Pettit.
Thank you, Dr. Pettit. Yes, we have a question from Senator Summers. Go right ahead.
Yes, good afternoon, and thank you, Doctor, for your testimony. I think one of the things that many of us are struggling with, even though we want to be able to provide services for women, asked to allow us to do more within their scope. And usually that goes through a scope of practice through DPH, which would sign off, yes, this is okay, or no, it isn't. And in this case, I hear you saying that ACOG believes that it is within the scope of practice, which is a procedure. But I think we need to get a clear definition from DPH if they also agree to that. And unfortunately, they are not testifying today. I do have a question about, you said, so this would be APRNs or PAs that will be specially trained to do these aspiration terminations. And I'm assuming that that would be put into the regs to ensure that the people that are carrying out these procedures are qualified in that particular area. So how would you imagine the training happening for an APRN that would like to go, or a PA? I'm not sure how many PAs actually do this kind of work, but that would like to get the training. How does the training work? Do they work with a physician and work side by side with them, or can you explain how that works?
Yes, thank you for the question, Senator Summers. We are fortunate to be able to look to the experience of other states that have done this, including California, that developed a robust training program. And as a medical educator for over 2 decades, I can readily imagine the process that we will be able to implement here in Connecticut for our advanced practice clinicians at Planned Parenthood who want to have this training. It would involve being trained with the direct supervision of a physician such as myself, and with specific markers for competency in developing the procedural skills, as well as knowledge base and written exams, and that combination of hands-on training and knowledge base is what builds competency and safety to meet the needs of our patients.
So when you say on hands-on training, if a woman comes into your clinic for an abortion in the first trimester, is she given, does she sign consent that she is allowing somebody to perform the procedure on her that is in training? How does that work? Can you explain that? We've just had this big conversation about consent, so I would like to ask that question.
Yes, of course. I'm aware of the additional bill that's being considered by the committee. Well, I can say that, I mean, today I was working at Planned Parenthood and I was training a physician, a resident in OBGYN, and that when patients come to us, we let them know that part of our mission is to help train the next generation of excellent physicians who can provide this kind of care, so that we make it clear that we are a training program, and we already do that now for physicians in residency, and we would do the same clear description to our patients for training additional healthcare providers such as APCs.
Okay, and then do you think that there is, one of my concerns is that if DPH does not weigh in, if they do not give us a clear indication that this does in fact fit with the scope of practice, because it's debatable. If you read the definition of surgery, it could be debatable as to whether this is considered surgery or not. I know ACOG and others do not consider it surgery. We don't have a clear definition of surgery in our statute, so we get bounced around. But if in any way this is perceived that we are allowing a clinician to do something outside their scope of practice without going through scope, it opens up the door for us on the Public Health Committee to then be asked by other clinicians to do other things that are outside of their scope, also not going through the scope of practice. So that's why it's really important that we hear from DPH, I feel, as to, what they feel about this particular situation. I'm very cognizant that there's not many people. My husband's also a clinician, and he had said that the people that do this type of work are very needed. You know, you work under conditions that are difficult, people are sometimes protesting outside of your facilities, and it is a service that we absolutely need to provide. But there are reasons why people choose to not provide the service. So I do understand that we want to make sure that we have enough available clinicians for this. It is a little unnerving to me that a woman may have to wait 3 weeks, like you said, to have a procedure if that's what she chooses to do. I do think it's important that we allow people to work at the height of their scope of practice. But my other concern is the skirting of our system that we have here through DPH in the state. You know, regardless of what ACOG says, we have our own system here in the state of Connecticut on how we allow things to happen. So I just wanted to share that with you, and I want to thank you for your answers to the questions. It is very helpful in learning about the training, et cetera, and how long that takes. And I appreciate your time today.
Thank you, Senator Summers. I will lift up that I too find it unnerving when we have waiting times for appointments that are increasing, and that our mission of care is that we don't turn people away, and that we work hard to make access a reality for everybody who might need to come to our health centers. So I appreciate your engagement in the issue. Thank you so much.
Thank you, Senator Summers, and thank you, Dr. Stanwood. I don't see any other hands raised. Thank you for your testimony and your time today.
Thank you so much.
Next, we will hear from number 44, Nicole Elsinger. Sorry about that.
Oh, you got it. No problem. A lot of people mess it up. Hi, everyone. Good afternoon. Good afternoon specifically to the distinguished members of the CGA Public Health Committee. My name is Nicole Elsinger, and I am the Student Government Association President here at Central Connecticut State University. Today, I will be sharing the importance of supporting HB 5272. Early adolescence is a time in life that is filled with changes. Children grow taller, voices get deeper, and things like acne and facial hair become more apparent. For better or worse, these simultaneous changes are awkward to navigate for young adolescents. In some cases, these changes are embraced, but of course, not all changes are celebrated in the same capacity. An aspect of puberty that is heavily stigmatized is the menstruation process. I started menstruating when I was 12 years old, which was already very scary to navigate. If any of you have daughters, I'm sure you can relate to that. This was made worse by the shame and embarrassment that I felt in school when I was trying to discreetly slip a pad from my backpack into my pocket if I was menstruating and needed to use the bathroom. And even now as a college-aged woman, if I start menstruating unexpectedly while at school and do not have enough of my own products to accommodate, I must resort to using less sanitary methods such as toilet paper. The importance of requiring products to be kept in schools guarantee that they are in our bathrooms and relieves the stress from those who menstruate of supplying our own products. The cost of menstrual products is also a burden. The average menstruating individual spends around $100 to $300 per year on menstrual products alone, and this does not include other costs affiliated with menstruation, such as pain-relieving medications. Moreover, we mandate that young adults spend most of their time out of the day in school, so it is justified to expect that these supplies should be provided in schools as well. So please, I urge you to make a change that is worth celebrating, to support this bill, to help break the stigma, and to alleviate stress from our menstruating community. This is a much needed change for the state of Connecticut. Thank you very much for your time.
Thank you so much. Thank you for being here and for your testimony today. Next, we will hear from number 45, Liz Gustafson.
Can you hear me okay?
Yes, we can.
Okay, thank
Go
you.
right ahead.
Senator Anwar, Representative Steinberg, and distinguished members of the Public Health Committee. My name is Liz Gustafson, and I'm the State Director of Pro-Choice Connecticut, and I testify in strong support of HB 5261. It is no secret that the rights and freedoms of people who can become pregnant are under direct attack, as 2021 alone has been a record-breaking year for the number of anti-abortion restrictions raised and enacted in states across the country. This year also marks the 49th anniversary of Roe v. Wade, and the United States Supreme Court is considering a case that could overturn or undermine Roe, which established our constitutional right to abortion sometime before the end of this June. This week alone, multiple states have introduced legislation that not only seeks to ban abortion, but would also allow private citizens to sue anyone who assists those seeking abortion care, similar to what we have seen in Texas. As other states face more restrictive laws or try to ban abortion outright, we need to make sure our state is doing everything we can to protect and expand access. As a state that codified the right to abortion in 1990, Connecticut has always been a leader in the fight to protect and expand reproductive freedom. Now more than ever, it is our moral and ethical responsibility to be on the right side of history. We must act to ensure our state's laws and regulations for abortion reflect contemporary medical standards of practice by eliminating barriers to providing and accessing care. While abortion, including medication and aspiration abortion, is one of the safest medical procedures in the United States, Connecticut's physician-only restriction singles out abortion for different treatment without any medical justification, despite strong evidence that advanced practice registers nurses, nurse midwives, and physician assistants can provide safe and quality aspiration abortions on par with physicians. HB 5261 is a common sense solution that will modernize our statute and remove medically unnecessary barriers that prevent qualified advanced practice clinicians from providing aspiration abortion in our state. All people deserve access to abortion care when they need it, on the timeline they choose, and by the provider that they trust. Permitting APCs to provide aspiration abortion would allow patients in our state to obtain this care from the healthcare provider who knows them best, and will ultimately result in greater access to time-sensitive essential abortion care for communities that already face significant systemic, economic, and logistical barriers. Additionally, as someone who had an abortion in 2018, I personally know how important the patient-provider relationship is. My provider at Planned Parenthood was the first number I called when my pregnancy test came back positive. And I am so grateful that I was able to go to my trusted gynecologic provider for my abortion and for the routine care I have always and will continue to receive from them to this day. Our
Ms.
state should treat.
Gustafson, your time is almost up. If you could please summarize. Thank you.
Okay, thank you. Our state should treat abortion as healthcare, abortion providers like other healthcare professionals, and catch up to the 14 states who already permit APCs to perform procedural abortion. Abortion providers help us shape our lives and our futures. And Pro-Choice Connecticut strongly supports HB 5261 with the recommended language change included in our testimony. And I will also note we submitted testimony in support of HB 5272 and HB 5303. Thank you.
Thank you so much, Ms. Gustafson, for being here and for your work. I don't see any questions. Thank you for your testimony.
Thank you so much.
All right, number 46, Amber Vlangus.
Hi, can you hear me?
Yes, we can. Go right ahead.
Okay, very good. I would like to say hello to the distinguished members of the Public Health Committee, and thank you for allowing me to testify today. My name is Amber Vlangus, and I am a volunteer with the Restorative Action Alliance, and we are a group of anti-carceral crime survivors, individuals who've been impacted by the criminal legal system, and restorative advocates and practitioners. I am here today to testify on two bills. First, we would like to testify in support of HB 5278, an act prohibiting an unauthorized intimate examination on a patient who is under deep anesthesia or unconscious. We believe that people should have autonomy over their bodies, and that consent should be needed for such an exam. I am also here to testify on SB 254, an act requiring long-term care facility residents to undergo a criminal history and sexual offender registry search. We are strongly opposed to this bill. And to contextualize my comments, I would like to say that I am a survivor of sexual assault and also part of a system-impacted family. We believe that all people in our state deserve to have care that they need based on their healthcare needs and not based on their past criminal convictions. I also had the opportunity to serve on the council that studied collateral consequences in our state. And we do not believe that registries are a good measurement of risk. And by our state's own admission, registries are overbroad, and the state does not say that appearance on a registry actually indicates that somebody is at a risk to reoffend. I would really like to caution this committee against making policies as a knee-jerk reaction to outlier cases. I also am a person who worked for 4 years in an assisted living community, and I am aware that working in such a community, particularly with individuals who have Alzheimer's and dementia, has some inherent risks. So just by virtue of having Alzheimer's or dementia, people do tend to act out sexually. And that is no more true for someone who is on a registry than for somebody who simply has other diagnoses. In the particular situation that gave rise to this bill, the individual had been incarcerated, they had been decimated by the registry, they had been homeless, and then they came from another state. And there were a lot of missteps on the part of the facility that accepted the individual, that did not assess the care needs of this person, did not
Excuse me, Ms.
protect.
Blagus, your time is almost
I will
up.
summarize.
Thank
They did not protect their employees. There was a situation where the person locked the person in a room, and that should never be even a possibility in a nursing facility. So I just really want to have this committee really considering all of those things before enacting legislation that is difficult to tear down, particularly because these types of policies will be impacting some of the most vulnerable people in our state who already have limited access to care that they need because of the stigma that the state has given them. Thank you, and I'm happy to take any questions.
Thank you, Ms. Blangus. Yes, we have a hand raised. Senator Kushner, go right ahead.
Thank you. And as always, Amber, it's good to see you. Amber is one of my constituents and very active in this work. And, you know, I too was on the, I chaired the Council on Collateral Consequences. And so I learned a lot during that process that I had been unaware of about the number of statutes that we have, many of which have not been looked at for decades and decades. That are obstacles for reentry. And so I'm really sensitive to the subject you raise. I think what would be helpful, and hopefully you and others could help work on this with us, is to understand clearly, you mentioned in your testimony that there were measures that had not been taken to make sure that the workers in the facility were safe and secure in their work. And I think it would be helpful if you could look at alternatives rather than just a registry search. I think your points are well taken that there are two problems with the registry. One is that it is often not a good risk assessment, I think you said. And then the other is that, you know, it doesn't really indicate others who might not be on the registry, but might also, through an individual's risk assessment or assessment of their health and mental health, one would discover that they could be a risk to people they're working with. I think those are both really important comments, but it'd be helpful to us if there was a way to codify that, if there was a way you could suggest that we work on this bill to make sure that the workers are protected in every situation. So I think it's something to think about, and I hope you'll work on it with us.
I would be happy to, and I know that there are others who have testified here today that are happy to lend their assistance and expertise in terms of what the solutions actually are. And again, I would really encourage this committee to really do a deeper dive rather than enacting legislation, again, that will, based on the impacts of our criminal legal system that impact individuals from marginalized communities, from based on their socioeconomic status, based on their mental health issues. All of those people are going to be the ones who are going to be suffering, and it will become a life and death issue. This individual that committed this heinous crime that gave rise to these conversations did find himself homeless. And it was because of these exact policies. I think one of the representatives here today said, do we need to look at the registry in our state? Absolutely. Registries only destroy, they don't heal, they don't provide safety, and we need to be looking at tearing down a multitude of things that cause this situation to happen. Not the scope of this committee, but we need to be working across committees in our state to make those changes to keep everyone safe.
Thank you, Madam Chair, or Madam Vice Chair, or Chair. I'm never sure about what to call you when you're in that role, but thank you very much for allowing me the question, and thank you for being here, Amber.
Thank you, Senator. Thank you, Ms. Langus. I don't see any other hands raised. Thank you for your testimony and your time.
Thank you.
Next, we'll hear from Dr. Dan Fries, but before he speaks, I'm going to turn it over to Senator Kushner to chair the meeting. Thank you.
Thank you, Representative Gilchrist. And so, as you said, we're ready to go to the next speaker. You can go ahead, Dan.
Thank you. My name is Dan Fries. I've testified a couple times before, but most of you probably don't know me. I'm the past president of the Connecticut College of Emergency Physicians, current legislative chair. I'm an active clinical emergency physician and academic emergency physician in Hartford and a resident of West Hartford. I think Representative Gilchrist is my rep, actually. I'm here today to testify against at least portions of raised Bill 5190, which would require the offering and provision of HIV testing in emergency departments. First, I want to say I and the Connecticut College of Emergency Physicians are very sympathetic to the need for increased testing for HIV. And would probably be in favor of generalized routine testing of some sort. Unfortunately, the emergency department isn't the place for that. As important as an issue as this is, emergency departments are, unfortunately for our society and the lack of healthcare, for emergencies and not for routine testing. And it was only maybe a year ago when we had to put out public health or public service announcements, if you will, saying with the pandemic, saying, emergency departments are not for routine COVID testing because there are emergencies that need to be seen, and we're already seeing massive boarding, massive crowding, and massive wait times, which get worse when we add on sort of routine testing and sort of public health measures that aren't directed at emergency care. Secondly, there is a cost to this as well, both to the state in terms of Medicaid and to many patients who we do see both avoid emergency care and avoid primary care due to costs. I know there's some laws that say that insurance has to cover it, but unfortunately coverage doesn't mean taking the patient out of the middle, particularly with high deductible health plans, which are a whole separate issue. Finally, the issue of follow-up. One of the reasons, in addition to the lack of patient flow and a further backup in the emergency department, is that emergency departments aren't set up for the provision of necessary follow-up care and even counseling that goes along with a potential HIV diagnosis. We have, unfortunately, a critically low amount of clinics for the indigent, particularly with infectious disease and even HIV in general. That needs to change. I'm not implying that should be a barrier. That's something that needs to be enhanced prior to consideration of anything coming out of the emergency department. On the flip side, I think the primary care avenue for testing is something that needs to be addressed. I unfortunately have been unable to stay on for the whole day, but I know there was a very compelling person testified earlier on the other side about the importance and gave a great story of himself being diagnosed through a primary care setting, which had the resources to provide follow-up and to say, hey, here's your result, please come right to the clinic and we'll start everything up. That's just not what the emergency department is, unfortunately.
Excuse me, Dr. Fries, your time is almost up. If you could summarize.
Thank you very much. I would welcome questions, but I will stop there. Thank you.
Thank you. And I see Senator Anwar, the chair of this committee, has a question. So you may proceed.
Thank you so much, Madam Chair. So Dr. Fries, thank you for your testimony. I think that the rationale behind this is that a lot of people, unfortunately, are still getting their care at the emergency departments, and their entry point into healthcare is the ED. We don't want that, but that's a reality. And that may also be one of the rationale for them to follow up on the test results with a primary care, or because you're supposed to connect them with whoever primary care is available and when they have the ED visit, if they don't have an assigned person. And I think just adding a line is saying that this result, you can follow up with the result with your primary care doctor and pass it on so that that part can be taken care of. And I think the broader part on the policy on the cost, we can as legislators work on that part. So that's going to be something that we will figure out. But I think with respect to your follow-up part, I think that should be part of the primary care follow-up like many other labs every day. What are your thoughts on that?
I would say that I don't have a number, but I would estimate 40 to 50% of my patients do not have a primary care doctor. And of those, probably half honestly have no ability to get one. Based on the system we're in, that's not Connecticut. That's unfortunately just, I see a lot of people with lack of healthcare resources and don't have the ability to have a steady primary care doctor. That's something that needs to be addressed. But I think for this to work, we would have to have something along those lines, be it a clinic that's assigned for each emergency department. If this were to work, I think it would have to be, hey, we are sending this test. Your care is not going to be here, and you may or may not get the result here, but here is where you're going to follow up. Or even if the testing went to another venue that could be set up, be it a clinic or an infectious disease center, that we said, we will offer you the test, here's the test. You will, if your test is positive, you will hear from this person, which is something that's set up in conjunction with New York's program, though I don't know how that works out of the emergency department. But you would have to have something on the back end for a guaranteed follow-up for all the provision of care, which currently doesn't exist. If you could set that up, then that would be great for all sorts of public health issues.
One more thought is that historically, when we used to order the HIV test, we had to go through a 30-minute conversation, documentation, and so on, which with how the disease has changed may not be as critical as it used to be historically. And the result could also be mailed to the patient so that at least we close that part of the loop of information to the patient, and then subsequent follow-up options with a list of places that that individual could go to. That may be another way to address that. In other words, the ED doctors would be the entry point, but not necessarily the final point. I want to make sure that your loop gets closed and you're protected, but the person has the information and a way in a place or a list of places to go to.
I think that's very reasonable. I don't know that, I know the bill isn't fully written. That's not how I interpret the bill. I think the bill as written would put an impetus on the emergency department and provider to ensure follow-up and be very much an active participant in that process. If it were set up such that there was a simple if the handoff was simply providing a follow-up number, or the patient was automatically followed up by an outside provider or clinic, then that would work. I can't speak to how this is going to be interpreted on the legislative level. And I agree that we no longer have a 30-minute discussion with people, and I don't think that's necessary. My bigger concern is holding people in the emergency department an extra hour to 2 hours to get this result, which I think most medical providers would say almost is required, because yes, it might fulfill the letter of the law to send someone a letter saying your HIV test is positive. I think most doctors, be it emergency doctors and outside doctors, would not think that's acceptable. I think they would feel that has to be a diagnosis given in person, or at least over the phone with extensive resources and semi-provision of care at that time.
Yeah, I agree with you there too. And then I think I'm trying to find a way to navigate the entry point of emergency department, but also not having the emergency department become a primary care in the absence of a robust PCP system that we have.
Yeah, I think for it to work, it would have to be a entry point and not a starting point. I don't know if you can see the dichotomy there.
I agree with you. Thank you so much, Madam
No problem.
Thank you, Senator Anwar. Next up is Representative Pettit.
Thank you, Madam Chair. Thank you, Doctor, for your testimony. To follow up on that theme, the previous testimony from Mr. Walters from, I think, APNH suggested that perhaps, say, your emergency department could team with your ID department or your own HIV clinic within the hospital, send the results over there and have them deal with it. Do you see that as a possible mechanism that could work, or would it only work in certain places, or would you think that has issues as well?
I think that would work in certain scenarios. I think there are probably 3 major emergency departments. I'm guessing at this, I'm being honest. There are probably 3 or 4 major emergency departments in the state that have a active, attached, function, accessible infectious disease clinic. I think a lot of them are going to have a tough time setting something up locally. I actually had a meeting with Rep. Jeff Curry earlier and had a long discussion on many of these issues. And one thought was, if you found some regionalized system, much like we do for medically assisted therapy or some psychiatric services, whereby for a certain hospital, regional, if you split the state up into different regions and said, okay, for this region, this clinic's going to be assigned to follow up those people in this very small, because it's not going to be a lot of people, but this small amount of people that have routine testing that test positive, that would be an option. I think that would be very local. To say every hospital has that ability would probably be unrealistic, both in terms of a lot of hospitals not having that resource, and B, even I work at Hartford Hospital, and we have probably as many infectious disease doctors and clinics as anyone in the area other than maybe Yale. And even then, getting someone into one of those clinics can be a barrier. So yes, I think that's the answer, is creating those resources, but I don't know that they exist at the moment.
Yeah, I would tend to agree with you. And just not to go too far on the garden path, I think you mentioned as well insurance, and I don't know how much of an issue the high deductible insurance plans are in the ER. I guess once someone's there, the ER visit and therapy is going to be much higher than the HIV test, but certainly as for outpatients and other settings, that's an issue. Is that also an issue within the ER, or once they're there, it's sort of a moot point?
No, I like that gets brought up a lot in terms of like what's the marginal cost is very low, but it's still a cost. Yes, compared to the facility fee, that HIV test is not going to cost very much. And I'm not going to say I know the cost of an HIV test, nor could any emergency physician in the state probably tell you what their hospital charges for one, even if a patient asked. But call it $50. $50 is $50 for a lot of people. And if with high deductible health plans, that may be, we're going on a different tangent now in terms of cost benefit of that. And would some people be deterred by that? Possibly. But especially with the emergency department where there can't be any cost discussion along the way, $50 is $50 to some people with a high deductible health plan. I think that's somewhat of a peripheral issue that doesn't get to the heart of the issues with the emergency department providing this service. But it is an issue.
Agreed. Thank you. Thank you. And thank you, Madam Chair.
Thank you, Representative Pettit. And I don't see any other hands, so thank you for your testimony today, Doctor.
Thank you.
The next speaker is number 48, Lydia Bennett, followed by 49, Terry Fitzgerald. Lydia, are you here? There you are. Go ahead.
Yes, thank you. Members of the Public Health Committee, my name is Lydia Bennett, and I am here in strong opposition to HB 5261, an act increasing access to reproductive health care. I am opposed to this bill because of the expansion of access to abortion. Whether or not we realize it, we all know someone whose life has been negatively impacted by abortion. And what is often not discussed is the negative generational impact abortion has on women and families. I have a friend who many years ago had an abortion. She told me how at the time she didn't fully understand what it was she was doing. She knew it was her right, a choice. It seemed like it would fix everything for her. My friend went on to describe how after her abortion, she suffered from depression, from alcohol abuse, from nightmares which involved losing a child, and she didn't know why. These had an impact on her ability to be a good wife and mother, and no one she talked with connected her issues to her abortion experience. Then one day, my friend, in conversation with another woman, was asked if she ever had an abortion in her past. It was through this conversation that my friend found a post-abortion support group that allowed her to walk through a grieving process and come to understand how her current issues trace back to that one experience in her life. Through this group, my friend found healing, restoration, and forgiveness. Because as much as we don't like to say it, abortion ends the life of an innocent human being. And those who are involved in the ending of that life are left to grapple with that reality, whether they realize it or not. Pregnancy makes a woman a mother. Terminating the pregnancy by taking the life of the child cannot change that fact. To quote Carrie Gordon Earl, a woman who had an abortion as a teenager, "The world is not a better place because of abortion. It's created a world where you're almost expected to abort if you're pregnant at an inopportune time. And it's created a society in which it's easier to push women to have an abortion rather than accommodate them. And abortion feels like your only choice if you want to keep your place in school or the workforce. That's not empowerment for women, that's bondage." Increasing access to abortion only increases an already existing tragedy. So many women make this decision under pressure and high stress, and then are left to try to pick up the broken pieces of their heart, some for the rest of their lives. Let's not expand the harm that abortion creates. Let's help men and women find hope and healing from their pain and spare that pain from others. Please oppose this bill. Thank you.
Thank you for your testimony. I do not see any hands, so we will go to the next speaker. I believe Terry Fitzgerald is in the room. Go ahead, Terry.
Thank you, Senator Kushner. And thank you, Senator Anwar, Representative Steinberg, and the members of the Public Health Committee. My name is Terry Fitzgerald. I am the Manager in Advocacy and Outreach for YWCA Hartford Region, and I am a resident of Enfield. I stand in support of HB 5303, an act concerning continuing medical education requirements concerning endometriosis. Statistics show that endometriosis impacts 1 in 10 born with a uterus in the US, and yet it can take 7 to 10 years for a diagnosis. This length of time seems to be due largely to a lack of knowledge of the disease by medical providers and under-researching for women's health conditions. Women are often faced with being told that the pain and other symptoms that they're experiencing are normal, and these symptoms can include pain, bloating, fatigue, pain with bowel movements, pain with intercourse, excessive bleeding, and infertility, and some others. This intersection of sexism and racism creates additional barriers for Black women, including medical provider implicit bias and discriminatory beliefs. I experienced endometriosis in my 30s, and it was quite a number of years before I received a diagnosis, and I experienced many of the symptoms I described above. I felt a bit crazy when nothing could be found wrong with me at the time. I was offered medication for depression, which I know can be a symptom that comes with this, but I just felt very frustrated at the time. Imaging reveals that I did have cysts, and yet I was also told that that could not be the cause of any of the symptoms I was experiencing. I finally found an OBGYN who understood endometriosis, and I felt fortunate for that, and fortunate that she recognized it and was able to offer a solution. The diagnosis could not come until I actually had surgery, being there is no current test or imaging that shows that you have endometriosis. Once I had the surgery, I felt a lot better. I felt fortunate that I had insurance that covered it. But as there's no cure for it, and it does often reoccur, the length of time for this diagnosis decreases the quality of life for women, and it can cause infertility. There needs to be more research on women health conditions and education and training for healthcare providers. Healthcare providers need more training on identifying symptoms, diagnosis, care, and treatment of patients, including racial disparities, implicit and implicit bias, cultural competency, and gender diverse experiences. In closing, I urge you to support HB 5303. And we have also submitted support for HB 5272 and HB 5261. I thank you for your consideration.
Thank you, Terry. And before I call on Representative Gilchrist to ask her question, I do want to say that as someone of my age, I'm going to be 70 this year, and I've known women, friends, since I was very young, that experienced endometriosis and didn't have a clue about what was going on. So your story is something really familiar to me. What I find astounding is that now, almost 50 years later, it's still an issue, it's still a problem that we're not dealing with. And I do want to thank Representative Gilchrist for her work in this area and the working group. I attended as often as I could, and I found it amazing to hear the stories of the women who experience endometriosis, but also to find the lack of resources that still exist and the lack of education. And so I really applaud you all for the work you're doing in this area. It's been eye-opening for me, and I think that it's way past time that we address these issues. So thank you very much. That's my own personal comment and opportunity to publicly thank you and Representative Gilchrist. So with that, I will call on Representative Gilchrist.
Thank you so much. And not a question, a comment. Thank you, Ms. Fitzgerald, for being here and for sharing your experience. I would just, call attention to the piece of your testimony where you said you just happened upon then a doctor who understood endometriosis, and that shouldn't be the way it is. And so I thank you for testifying in support of this legislation.
Yes, thank you. And thank you for championing this issue.
Next, we have Representative Cook.
Thank you, Senator. And Terry, I want to thank you for your testimony. So I was an 18-year-old girl with endometriosis that often brought me to my knees and had no understanding as to why. And when you are going through all sorts of other things as you grow up, that is one of the things that you don't understand. And I mean, going back so many years where the information was not out there, my heart, when you were talking, my heart was breaking for you, given the fact that I understood my own personal experiences and I heard them coming out through your testimony. So I want to thank you for having the courage to come and speak to something that's so vitally important. We're pulled in so many different directions in this world that we live in here, called the legislative world. And I haven't been able to be as a part of the working group as I would love to have been. And it's so vitally important, the work that Representative Gilchrist has done for all of the folks that are in positions like we are in, to be able to keep our sanity, I guess, if you will, and talk about it. And for those that have not been able to understand what's going on with their own personal world, to know that there's other people out there like that will be able to be support for them and that we have their back. So I just wanted to say thank you again for your testimony and not being afraid to tell your story. So be well.
Yeah.
Thank you.
Yeah, and I think it's important, like with that length of time for some women, they're giving up those years of their childbearing years, not knowing why they cannot get, conceive. And it would be nice if there was a way to determine a diagnosis quicker and without surgery.
Yeah, I so agree with you. And I have to say, my very dearest friend, never was able to conceive and did not know until probably in her 50s. And then it was too late. It was almost impossible for them to adopt. And so that story is very touching to me and so many women I know. I don't see any other hands at this time. So thank you so much for your testimony here today. And we will move on to the next speaker, number 50, and that's Mark Zetrika.
Yeah, hi, I'm Mark Zetrika. Thank you for having me here today. Thanks to the Public Health Committee and the opportunity to testify in favor of House Bill 5260, establishing a rare disease council. I live in West Suffield, Connecticut with my wife and 2 8-year-old daughters. I also own a My Life specialty pharmacy here in Connecticut, and I'm a founder of the Connecticut Hemophilia Society and work closely with the New England Hemophilia Association. I was born with severe hemophilia, which is a rare genetic bleeding disorder. And while we've made great advances in medication and treatment since I was a child in the early 80s, hemophilia still impacts my life in countless ways. I have severe chronic pain, decreased range of motion in almost all my joints, difficulties with mental and emotional issues as well. And so I'm here today not only to advocate on my behalf, but on behalf of my daughters who are both carriers of the hemophilia gene as well. And so I was hoping to bring up a couple other impacts that this council could have. Within the healthcare system, even small changes can have major impacts on families like mine. For example, some previous changes that have created stress and harm to families and children living with rare chronic illnesses include the introduction of copay accumulator adjusters, new restricted formularies, access to health insurance, and mandatory step therapy. This council would give us a voice when debating such issues. This council will also help protect us from discrimination, usually inadvertent discrimination, and help ensure that we will continue to have access to specialists, in my case, hemophilia treatment centers, regardless of our insurance's network. As a community of people with rare disorders, our voices typically are not heard. The council will provide an excellent vehicle to not only look out for those of us with rare conditions, but help amplify our voices for those who typically don't have the time, energy, or means to advocate for themselves. This is especially necessary if you think about the loud voices of other stakeholders in the healthcare landscape, such as big pharma and health insurers in the state. It's incredibly important that our lawmakers and agencies hear from all stakeholders, which include the patients and the families that are usually impacted the most by the many changes we experience in today's world of healthcare. Lastly, I'd like to point out why having a council that acts as similar to a watchdog is so important. In the early 80s, myself, along with about 90% of other severe hemophiliacs, contracted HIV from our medication. It was one of the most tragic events in modern medicine, in my opinion. And at that time, our voices as patients living with a rare disorder were non-existent. So by the time we were given the information, it was too late. And these are all reasons why we need a seat at the table. We need to know about issues and help advise on issues before it's too late. And so by supporting HB 5260, you'll make a huge impact for so many of us simply by inviting us to the table. The council is looking forward to also supporting your efforts just as much as you'll be able to support us. So thank you for allowing me to submit this testimony today.
Thank you, Mark. And I don't see any questions at this time, but thank you so much for being with us and sharing your information, your perspective on this important bill.
Thank you.
Next up, we have Heather Wedone.
See and hear me?
Yes, we can. Go ahead.
Good afternoon, Madam Administrator, esteemed Chair, and all committee members. I want to say thank you for this opportunity. My name is Heather Wedone, and I am the Program Director of the Center for Endometriosis Care, a disease educator, a board-certified professional advocate, a Hudson Valley native, and importantly, an endometriosis patient. I was personally diagnosed over 35 years ago, and I have worked professionally within the disease space on an international level for 3 decades. I'm honored to be an active member of Representative Gilchrist's endometriosis working group, and I come here before you today in support of Ray's Bill HB 5303. I thank you in advance for the consideration you will give this critical precedent-setting matter on behalf of the 1 in 10 people living with endometriosis, as well as those as yet undiagnosed. This disease has impacted the majority of my own life in profound ways that only those with endometriosis can understand. But it is not my intention to use this opportunity to center myself here today. As the World Health Organization estimates, there are approximately 190 million others living with the disease in every corner of the globe, all of whom deserve to have the critical narrative of this disease conveyed. In just the United States alone, current research indicates that nearly 9 million Americans are living with endometriosis at a societal cost burden of almost $70 billion annually. Correctly defined by the International Endometriosis Working Group as a systemic inflammatory disease characterized at surgery by the presence of endometrium-like tissue found outside the uterus, with an emphasis on like, as this is an important distinction. Endometriosis is a spectrum disease with a variety of subtypes and clinical presentations. Pain, inflammation, fibrosis, infertility, adhesions, painful sex, organ dysfunction, and much more are very common. Although often located in the pelvic cavity, this disease can also be found in distant areas like the lungs or diaphragm. Unfortunately, misinformation and a sustained lack of awareness about endometriosis echoes in perpetuity across all sources. As a result, underdiagnosis and poor management are common, with many suffering through repetitive non-excisional surgeries that are ineffective and inadequate drug therapies, which bring significant side effects on their own and do not actually treat the disease itself. As well, while public doctrine often mistakenly portrays endometriosis as merely a condition of painful periods affecting only reproductive age cis females, this inaccuracy leaves adolescents, those who are postmenopausal or post-hysterectomy, and other non-menstruators without adequate intervention. Care access and utilization is also fraught with significant disparities, leaving many unable to access high-quality multidisciplinary care. In the course of my own lived and professional experiences, it became well evident early on that research on disease biology, its relationship to health-related quality of life or lack thereof, its ties to comorbidities, including certain malignancies, and elucidation of its origins has been sorely lacking. Today,
Excuse me, Ms. Gadone, your time is almost up. Thank you.
The dearth of answers persist, and I would encourage everyone to please act now to implement programs and policies that address disparities, treatment inequality, access for all, associated costs, and to eradicate the incessant misinformation surrounding this disease. I respectfully thank you for my time here today and for joining me in support of Representative Gilchrist on this most critical matter. Thank you.
Thank you so much for your work and for your advocacy and for your testimony here today. Representative Gilchrist.
Thank you, Madam Chair. Thank you so much for being here and for participating on the working group. Just wanted maybe you to expand on what your center does and what you've experienced in the patients who have been fortunate enough to find your center, and what have they gone through in their search to relieve the pain that they're experiencing?
Absolutely. So we are one of the original centers of expertise in endometriosis. We were founded in 1991. We treat patients from all over the globe. We've had patients come in from about 70 countries to date, thousands of patients. The reason that patients are traveling to centers like ours, much as I myself had to do, I had to leave the metropolitan New York area to get care for myself years and years ago after failing treatments locally. Patients are traveling to centers of expertise because they're not getting quality care or quality answers at the local tertiary level. Unfortunately, we know that Black, Indigenous, Latinx, other persons of colors, transgender, gender diverse patients, people with disabilities, their outcomes are diminished because of the disparities surrounding this disease. Not to mention, not everybody has access to the high quality multidisciplinary care that's needed. So while centers like ours exist, and that's a wonderful thing, and we need certainly more of them, what we need to do is address the disparities that prevent every patient from getting the same equity of care and being able to live a full and fulfilling life in spite of endometriosis.
Great. Thank you so much. Thank you for your work and for being here.
Thank you all so very much. I appreciate it.
Thank you. And I don't see any other hands at this moment. So thank you for being here and testifying. Next up, I believe we have number 50. I don't know if 52 is in the room. I know there was some issue with number 52, but I don't see her at this moment. So we will go to number 53, Kayla Glynn.
Hi, Senator Kushner and distinguished members of the Public Health Committee. Student activism organizations in Stamford and Norwalk have come together to support HB 5272, which is about period products in schools, colleges, and shelters. We are grateful for your attention to the role that period equity plays in supporting students' physical and mental health. My name is Kayla Glynn. I represent the Mayor's Youth Leadership Council at Stamford High School, which is one of the 2 student activism groups from Fairfield County you will hear from. While our members support the period products on college campuses and shelters, I will focus on Section 2, which is about products in restrooms in middle schools and high schools. I have 2 suggestions to strengthen the bill. Number 1, we recommend that lines 17 to 19 be revised as follows. Local and regional boards of education shall place dispensers with free menstrual products in restrooms. The dispensers we have researched are not that expensive and are easily installed and maintained. Number 2, while we would like period products to be in every restroom in every middle school and high school, we do not think that is necessary. This recommendation is a follow-up to the testimony delivered a couple of years ago before this committee and the Children's Committee. We suggest that each school put together a student-faculty team to determine the number of restrooms with tampon or pad dispensers based on the number of students in the school, the physical layout of the building, and easy access to restrooms by the greatest number of students to cut down on missed instruction time. This analysis is important for schools that are similar to Stamford High School. Tampons and pads are made available to students at my school, but we have to walk a mile to get to the nurse's office, which is where the products are stored. This instruction time that is lost is unacceptable, but it can be corrected by dispersing the products to restrooms via dispensers. My friend from the Center for Youth Leadership will testify about charter schools, boys' restrooms, and health issues related to period equity. Thank you.
Thank you for testifying here today, and thank you for your youthful activism. I don't see any hands at this time. Again, we appreciate you being here. Kayla, keep up the good work.
Thank you.
Next, we should have in the room, I believe, Melissa Mannion. Is Melissa here? There you are. Go right ahead. You need to unmute.
Yep, sorry about that. Okay. Members of the Public Health Committee, thank you for having me. I am here to strongly oppose the Raise Bill 5261. As both a mother who has birthed 4 children and also suffered the pain of 1 abortion, I believe I have a unique perspective on this. My abortion was surgical and performed at the hands of a doctor working with Planned Parenthood. Even under what I would have to assume were his skilled hands, it was both physically painful and traumatic. I cannot imagine, as this bill proposes, having a medical practitioner who is not carefully trained within the scope of surgery performing a surgical procedure. And as I mentioned a number of times, I'd like to add that the ACOG and the DOH have not defined this very specifically, and that is concerning to me. As for the midwife in particular, also being proposed as a viable practitioner, again, I'm in opposition. I had amazing midwives for 3 out of the 4 pregnancies I saw through full to term. Having said that, in the middle of one of my pregnancies, I was told by my midwife that I needed to be transferred to OBGYN to see one of the doctors to be sure that a simple issue that had arisen wasn't more serious. I was made to understand that this could be out of the scope of their practice and that they were not able to take what are considered high risk. So my question is, if they couldn't have helped me deliver if I became what was considered a high risk pregnancy, how are we to assume that it would be safe for them to be able to remove a fetus from the womb via abortion safely? And if something goes wrong and they could be liable, will the help be available at the cost potentially of their career? Finally, there is no clear understanding addressed in this proposed bill as to what the gestational age of a viable pregnancy would be. This to me, again, is a dangerous slope to the mother who now could be 20 plus weeks pregnant and having an unqualified medical professional perform a surgical procedure to remove an exceptionally formed fetus under no direction from a surgical team. Setting aside any personal stances on the justification or lack thereof of abortion itself, this bill proposed is putting women in danger and I believe should not be approved. I am concerned, especially based on a number of the testimonies, that it is based more on the politics of abortion. And I pray that that won't be what is considered. I wanted to also note that it's been noted a number of times that 14 states are already doing this. However, there are 52 in the US, which means that 38 of them are not. And I think that that should be noted. And I do commend the representatives that have seemed to want to have more information. And in particular, what concerns me is at the cost of allowing more access, we could be opening up for more trouble. And another thing that I wanted to note too was that IUDs and the placement of IUDs have been mentioned a number of times. And anyone with a television at this point knows that there are mass class action lawsuits over perforated uterus from this procedure. So I am concerned over the clarity of how the procedure will be performed by people who technically are not allowed, simply to try to make wait times less.
Excuse me, Miss Mannion, your time is almost up. If you could summarize.
The one last thing that
Thank
I would say is my mother was just diagnosed with cancer for the second time and had to wait 2 months to have a lump removed and have her mastectomy. So, I think that should be taken into consideration, that within the time sphere, we could get them to a doctor to do what it is that they feel that they need to do, but they need a doctor. They need a doctor. So at least it can be safe, as some would call it. Thank you so much for your time.
Thank you for your testimony. I don't see any hands at this time, so we will move to the next speaker, and that would be Hunter Pagot. Hunter, are you here? There you are, Hunter. Go ahead.
Thank you. Chair Steinberg and Abrams, ranking members Pettit, Wang, and Somers, and esteemed members of the Public Health Committee, my sincere gratitude for the opportunity to testify in support of House Bill number 5260, an act establishing a rare disease advisory council. My name is Hunter Pagot. I am a North Haven resident, and I have an extremely rare disease, SMART1, short for spinal muscular atrophy with respiratory distress. To give some perspective, out of a population of 8 billion, there are approximately 70 people in the world with this ultra-rare respiratory neuromuscular disease. Due to the fact that virtually no one on the planet, except for a handful of researchers and physicians, had heard of SMART1, I began a campaign when I was 7 years old to initiate legislation for a Connecticut state law for a SMART Awareness Day. 7 years ago, I testified in a public hearing and am proud to share House Bill number 6100 was advanced successfully through all chambers, establishing every February 10th as SMART Awareness Day. While a significant advancement, I knew then when I was 9 years old that there was a lot more work to be done in our state with raising awareness and increasing education, not only of my very rare disease, but for the rare disease community. Ironically, I was unable to celebrate this year on February the 10th, as I was ill due to significant visual difficulties experienced from poor access to school. Upon being asked to testify regarding a considerable certainty that advocating to obtain a battle for myself and my families in a school. Despite having a detailed IEP with outlined accommodations in place, inclusive of customized school healthcare plans created by my medical team, I've faced and sadly continue to face difficulties in ascertaining access to my public education, such as legible materials and appropriate remote access, to name a few. This has deeply negatively impacted me in a myriad of ways it never should have, notably limiting my access to my education. Those with rare diseases should not have to endure such great and lengthy hardships at high cost simply to receive their education and to have opportunity to achieve their goals. Having a rare disease is more than enough to manage as a person and as a student. This is one of the reasons why being here today is so very important to me, to shed light on one of the outstanding challenges faced by those with rare disease. I am hopeful for House Bill number 5062 and firmly believe a Connecticut Rare Disease Advisory Council would mitigate hardships for our rare disease community in numerous and so very much needed ways. While I promise to remain a passionate advocate in continued dedication to raising awareness, increasing education, and hopefully inspiring others to transcend beyond stereotypes, labels, and discrimination, that is not enough. Myself and all other rare disease patients here in Connecticut need your committed help and support in establishing an RDAC. Everyone requires and deserves access to meet their medical needs, to their education, for opportunities to thrive and self-actualize, and to live their lives minus undue strain, hardship, and disadvantage. Our state has the capability of leading the way in rare disease. Establishing an RDAC is a necessary step en route to fulfilling this vision and becoming the national leader I know and trust that we can be. Thank you very much.
Thank you so much for your testimony, but also for your advocacy and your leadership on this issue. And you've been at it for a very long time. Well, I don't know how old you are, but it sounds like you've been at it for quite a while. And, you know, I think your voice is very important here. So thank you. And I do see Representative Kennedy has her hand up.
Thank you, Madam Chair. I just needed to say thank you, Hunter, for your very passionate testimony. We really appreciate hearing from you. Thank you so much. Thank you, Madam Chair.
Thank you very much, Representative. It means a lot to me.
Thank you, Hunter. I see Representative Pettit is giving you a thumbs up. I know that people are very happy to have heard from you today. So thank you for being with us. Next up, we have the next person on the speakers list is number 59. And I believe, I hope I'm saying this correctly, but Asija Keteza?
Hi, it's Asya Kiteza.
Go ahead. I'm sorry, I mispronounced your name.
It's okay. Thank you for having me here today and giving me the opportunity to testify. My name is Asya Kiteza, and I'm a menstrual equity advocate for Live Girl, which is a nonprofit organization fighting for gender equity, as well as I'm also the UConn Waterbury Associated Student Government President. I am testifying here before you today to exhibit strong support for HB 5272 and that concerning menstrual products. I think it is crucial for this bill to be passed in order to address the concerns of every menstruator in Connecticut who does not have access to menstrual products. As a Live Girl menstrual equity advocate, I have had the privilege to work with Representative Kate Farrar and other legislators and advocates to raise awareness on the necessity of a menstrual equity bill. As many of the committee members know, 1 in 4 women and girls in the United States reports struggling to afford menstrual products. Working closely on this issue, I have met some of those girls that cannot afford menstrual products, and I understand the negative impact it can have on their health. To highlight the necessity of this bill, I want to tell you the story of one of my peers, and I think this story addresses some of the questions that were asked earlier on in the day towards Representative Farrar. I have a friend who moved to the United States from the Dominican Republic when she was 7 years old. She came from a household with a single mother, and she had a younger brother that she had to take care of. Although the average age that a girl gets her period is 12 years old, she got her period at 9 years old, and this made her feel ashamed and isolated from other girls her age. She was scared to talk to her mom about her period because she felt embarrassed, and she would not always have access to pads in her house. This was further exacerbated by the fact that her mom was already struggling financially, and getting her period early meant having to buy more menstrual products, a burden that her family could not afford. For a full-time menstruator making minimum wage who earns approximately $2,000 a month, affording menstrual products can be burdensome. For 2 menstruators in a household, menstrual products can cost $168 a year, and organic menstrual products, which are deemed as a healthier choice, cost even more. Although this may seem like nothing for some people, for lower income families, this can really impact them in a negative way. I believe that free menstrual products in public institutions, as proposed in the bill, is a step in the right direction to achieve menstrual equity. Passing this bill will not only give menstruators access to products, but it is also essential to reducing and eliminating shame, empowering women and girls in our state, as well as creating a more open and understanding society. It is time for our society to move forward, past the stigma, and the best way to do that is through legal change. The issue of period poverty is extremely urgent, and the provisions of this bill, I believe, are necessary for this problem to be legally addressed. Thank you for your time and consideration.
Thank you for your testimony here today on this important subject. And I don't see any hands, but I'm glad that you hung in here and were with us today. Thank you so much. Next up, we have Stacy Taylor, number 61.
I'm trying to unmute there. Hi.
Hi, we have you now.
Thank you so much. Senator Anwar, Representative Steinberg, and distinguished members of the Public Health Committee, on behalf of the physicians and physicians in training of the Connecticut State Medical Society, thank you for this opportunity to provide testimony on House Bill 5190. CSMS recognizes the public health goals of increased testing for HIV. However, we have concerns with the specifics of the bill. This bill is an example of legislating the practice of medicine. Medical care decisions are best left to physicians and their patients. This bill appears to require physicians practicing in both emergency departments and primary care to offer their patients 13 years and over a yearly HIV test. In primary care, physicians are allotted 15 minutes or less by health insurers per visit. While the act of inquiring about an HIV test is quick, the discussion that may follow as to why the patient is being asked will be more time-consuming. There is not enough time allowed by insurers to add another element into a visit, particularly when it may not be applicable to the majority of patients. Physicians in the ED are quickly treating many patients with a multitude of conditions. The logistics of how this would work in the ED are unclear. Is the physician supposed to ask a patient screaming in pain with a compound fracture if they would like an HIV test? This proposed requirement does not consider the realities of medical practice in primary care or the ED. There is no requirement in this bill for health insurers to cover HIV screening. Therefore, patients with high deductible health plans will have to pay out of pocket for this testing until they reach their deductible and may not realize that this will be at their own expense. We are also concerned about the potential for overlap. If during the year, a patient visits one ED, 2 urgent care centers, and their primary care physician, will they be asked 4 times if they want an HIV test? At some point, patients may become frustrated, if not insulted, by the repetitive questions. If this bill were to pass, what comes next? Hepatitis C, TB? This legislation has the potential to open the door to numerous testing requirements, which will become unmanageable. We do have some suggestions for how to accomplish the public health intent of this bill in a more pragmatic way. This bill can include mechanisms that would satisfy its intent, including but not limited to presenting a document on patient check-in explaining the law and potential costs that presents the patient with a checkbox option for an HIV test, posters encouraging HIV testing. We believe adding these options into the bill will be easier for the patient as well. Paper documents or posters are non-confrontational, reduce the often emotional component of HIV testing, and may encourage reluctant patients to accept an HIV test. CSMS stands
Dr.
ready.
Taylor, your time is almost up. If you would please summarize.
I will.
Thank you.
CSMS stands ready to work with this committee to develop mechanisms for increasing HIV testing that does not place undue burdens on the patient and medical community. Thank you very much.
Thank you for your testimony, Dr. Taylor. I see Representative Cook has a question.
Hi, Senator, thank you. No question. I just wanted to give a huge shout out to Dr. Taylor and all the great work that she does out here in the Northwest corner and her continued advocacy. We've seen her in front of our committee before the pandemic hit and locked us out numerous times. And I just wanted to thank her for her dedication and her continuous advocacy for all of the people that she does look out for. Thank you, Dr. Taylor. It's great to see you.
You're welcome. And thank you to the committee for all the work that you guys do.
Thank you, Representative Cook. I will call on Representative Pettit.
Thank you, Madam Chair. Thank you, Dr. Taylor. Dr. Taylor, I want to give you a chance to respond. Mr. Walters, who testified in favor of this bill, I had read the CSMS testimony, suggested that and reviewed that you had suggested offering a checkoff sheet in the office, and I know your practice was a very busy practice with a lot of people in and out of there every day. Do you think, from a clinical point of view, that would be a reasonable alternative to having to ask every person in the room in the middle of a visit?
I think that would be a very reasonable alternative, a little faster. And a medical assistant, for instance, could present it before the provider goes in, and we could certainly and put it into the medical record system as an order that we co-sign. So that would be extremely reasonable.
And in your area, Charlotte Hungerford, do you have access to an HIV clinic if more tests were done and there were referrals? If you have to refer people, can you refer them locally, or do they have to go out of the local area for HIV care per se?
They would have to go outside the local area. And that raises some of the concerns that the prior ER physician mentioned as well. We have one ID infectious disease physician in the area, and that is it.
Thank you, Dr. Taylor. Thank you, Madam Chair.
Thank you. Next up, Senator Anwar.
Thank you, Madam Chair. Thank you, Dr. Taylor, for your testimony and the work that you do. I wanted to brainstorm with you and maybe clarify a couple of thoughts. There's a public health argument and there's a logistical argument. Do you agree with the public health argument at least?
I agree that, for instance, the CDC says we should all be testing HIV at least one time in a lifetime. I think knowing your patient is very important. There are people who are high risk and people who are not. I think an 85-year-old that you've known throughout her lifetime or his lifetime necessarily doesn't need repeated HIV testing if they've been happily married for 50 some odd years. However, there are certainly people who miss the opportunity to get tested, and you want to capture those people. So I think that is a correct concern. How do you pick up those people that might be positive that are not picked up either by their primary care provider for whatever reason, or don't have a primary care provider? So I think that is a valid concern. However, how you logistically do that in such a simple way that it is fast and there's follow-up that is quick and appropriate, and that's worked into the system needs to be spelled out a little bit more. Perhaps we just need to work on payment, work on procedures a little bit more just to get this tightened up.
So the way I'm seeing various testimonies is that the public health argument is a reasonably strong argument. The logistical argument has some challenges, and the challenges are because of the weak primary care system that we have. And it's glaring now that, okay, if we don't have a primary care setup, then that's where these things should have been. But recognizing that a significant proportion of a population are getting their care in emergency departments, and those are the rubs that we have right now. And then the payment system, which you and others have alluded to in other testimonies about how messed up that is part of the challenge as well. So we will have to tighten some of these areas and maybe use this as a test case to figure out a navigation mechanism, because this is a surrogate of a need for fixing this with a broken system at various levels. And then we can try to see how we can build things around. I know there are initiatives to build up the primary care too, but I hear your concerns, and I also feel that for something that's treatable, preventable, and block the spread of it, we have a responsibility to come up with a strategy, and we have to try to start that work from what resources we have, and then start to figure out a way to build on them. That's how I'm seeing this, at least at this point.
Right, but and by the way, it is about $70 on the low end for an HIV test, just to let you know. Someone raised that question earlier.
Yeah. Good, this is very helpful. Thank you so much for your testimony. Thank you.
You're welcome.
Thank you, Senator Anwar. I don't see any other hands. Thank you for your testimony today, Dr. Taylor, and we will move to the next speaker. That is Roja Yusuf. And after Roja, we will have Sabrina Yuva. Roja, sorry, your time is, you can go ahead and begin.
Hi, Senator Abrams, Representative Steinberg, and distinguished members of the Public Health Committee. You heard earlier today from my fellow student activists in support of HB 5272, which is about period products in schools, colleges, and shelters. Kayla is from the Mayor's Youth Leadership Council at Stanford High School. My name is Roja Yusuf, and I represent the Student Center of Youth Leadership at Brian McMahon High School in Norwalk. While our members support the period products on college campuses and shelters, I will focus on Section 2, which is about the products in restrooms in middle schools and high schools. I have several suggestions to strengthen the bill. Number one, we agree that with the suggestion to install tampon and pad dispensers in restrooms. Number two, we agree that a student-teacher team at each school should determine the number of bathrooms to get dispensers. Number three, we suggest you follow a bill in Utah that requires charter schools to provide period products to students as well. Number four, we suggest you follow a bill in Illinois that period products are needed in girls' and boys' restrooms in order to address the health needs of transgender and cisgender students. As one legislator said, if you are biologically a female by identifying as a male, you're going to menstruate and you're going to need these products. If you are identifying as a male and that's where the bathroom you want to go to because you feel most comfortable, you may need these products. And number five, we strongly suggest that the availability of tampon and pad dispensers in restrooms be accompanied by an education piece that describes the impact of period equity on families and the connection between periods and other health issues, such as endometriosis. On behalf of our members, I'm grateful for your attention to the role that period equity plays in supporting students' physical and mental health. Thank you.
Thank you, Roja. I see Senator Anwar has a question.
Thank you, Madam Chair. I just had a quick comment, and I'll be very short. Roja, I'm very impressed by you because you kept a very concise presentation, and you actually not only did your groundwork on the background of some of the other bills, you actually had a concern about the bill and you made a suggestion rather than just saying that there's a problem with it. You actually looked at how to strengthen it. So very impressive. Keep up the good work. Proud of you. Thank you, Madam Chair.
Thank you.
Of course. Thank you for being here. And I see that we have another speaker here, number 63, Sabrina Yuva.
Hello, my name is Sabrina Yuva. I am from Stamford, Connecticut, and the president of the Student Government Association at the UConn Stanford campus. I have a background in research within the Human Development and Family Sciences field, where I study the effects of protest activities on college students' mental health. My research with my passion for civic engagement bolstered my ability to lead various community initiatives and provide students with necessities, including menstrual products. I would like to thank all the members of the Public Health Committee for holding this hearing today and allowing me to share my efforts surrounding menstrual equity. I stand in support of the bill HB number 5272, an act concerning menstrual products, as it is crucial to aid in reducing inequities among individuals who menstruate in Connecticut. Menstrual equity is a necessity and not a luxury. Periods are too often stigmatized, and menstrual products are a basic hygiene need, similar to soap and toilet paper. The burden for menstruators to carry products with them at all times and the stigma around periods needs to be broken. I could personally attest to experiencing the burden of not having access to menstrual products at school. The dispensers that are currently in the bathrooms require coins for payment, and they're consistently empty. Students should not have to face a financial burden or stress when they need menstrual products. The lack of product is more than just a barrier at school. It's a public health issue. Toxic shock syndrome and reproductive tract infections could occur when individuals are unable to find products during the day, and they end up waiting longer than the recommended time to change their products. Breaking the stigma around menstrual maintenance is needed to protect the health of menstruators. To address the stigma and inequities among menstruators, I've been part of the statewide coalition with state representatives, nonprofit organizations, and other community leaders advocating for greater access to period supplies in Connecticut. I have led a menstrual equity initiative on campus that provided hundreds of products to students free of charge. Advocating for menstrual equity legislation, along with creating a pilot program at my university, are the next steps towards ensuring equitable future for menstruating individuals. Menstrual equity advocacy is crucial to amplify the need to provide greater access to menstrual products in public schools and universities, and providing free access to these resources allows for menstruators to fully engage in the public sphere without placing financial burdens or fear of stigmatization. Menstrual equity is a necessity. Thank you so much. I'm really happy to be here.
Well, we're very happy that you're here also. It is really quite amazing to see this movement and all of the young people young activists and young people who have spoken today. For a woman of my age, it's really great. It's encouraging to see this next wave of this next generation of activists. So thank you for being here. I don't see any hands at this time, so we will move to the next speaker. And that would be number 67, Jim Williams.
Good afternoon. I'm Jim Williams with the American Heart Association. I would like to thank you for House Bill 5273, an act establishing a statewide stroke registry, and the opportunity to speak in favor of it.
Jim, I don't know if you can hear me, but we cannot see you. I didn't know if you intended to be off camera. There you go.
Sorry. Okay, I'm sorry. In the interest of your time and recognizing that you have my written testimony, which largely deals with the requested strike all amendment that we and the state of Connecticut Stroke Advisory Committee proposed, I will just highlight a few key areas with the reasoning behind the strike all amendment. Section 1A deals with the data platform that is being used. 22 out of 24 certified stroke centers now use the American Heart Association data platform, Get With The Guidelines Stroke. However, we agree that hospitals should not be limited in choice, and we offer a specific language change to clarify this section. Section 1B has to do with the data that is collected. This is it's very critical to get this language in this section correct. At a minimum, the data collected must include stroke achievement measures by the American Heart Association, American Stroke Association, and Joint Commission. The need for this minimum requirement is strongly supported by every national organization that is involved in stroke care. There's also a minimum requirement for all 21 states that have statewide stroke registries. Our amendment makes a specific language change to this section as well. Together, we agree with the Hospital Association that punitive language is an unnecessary stick and should be deleted. Finally, we wholeheartedly support the Department of Public Health's funding for the necessary 1.5 FTEs that I believe they will request, and that will be required to manage the stroke registry. In closing, we believe that should this bill pass with the proper language, the end result will be an improvement in overall stroke care for the residents of Connecticut, evidenced by reduced deaths attributed to stroke, increased prevention of stroke-related disability, and reduction of recurrent strokes. I'm more than happy to answer any questions you have now, or would be more than happy to follow up with anybody interested.
I do see a couple of hands, so we'll start with Representative Pettit.
Thank you, Madam Chair. Thank you, Mr. Williams, for your hard work on this over a number of years. It's a complex question. I don't know if you have the answer. In other states where this has been instituted, do any of them have a 3-year, 5 or 10-year track record that made an estimate for money saved or quality life years saved or improved based on creating a stroke registry and implementing new protocols to improve stroke care?
Representative Pettit, I'm not prepared to answer that question at the moment, but I do know the right person to go to and can follow up with the answer to that. And I'd be happy to share that with you and your colleagues.
Thank you so much. Thank you, Madam Chair.
Thank you. And next is Representative Parker.
Thank you, Madam Chair. Nice to see you, Jim. Just a few questions about cost, which I know has been a thing certainly of important concern. First of all, can you, and I appreciate that in the bill you suggested that the American Heart Association's data registry is not the one that must be used, but is an example. Could you let us know for, as an example, how much that costs per year?
Yeah, that's actually an important question, Representative, because last year, if I remember correctly, the fiscal note said that it could cost up to $500,000 for the data platform and maintenance of. And I can only speak to Get With the Guidelines Stroke, which is the platform that's utilized by, I believe, 22 out of 24 stroke hospitals in Connecticut. It actually costs $6,018 annually for that platform. As far as the rest of the fiscal note from last year had to do, I believe, with personnel that the department may have needed to manage the program. In our language, we're suggesting 1.5 FTEs. And if I remember correctly, an epidemiologist was quoted at approximately $75,000 a year per last year's note.
Thank you. You read my mind on the second part of that. So again, to clarify, roughly $6,000 would be the cost of a statewide license to be able to use that if that were to be selected. And then from a capacity standpoint inside the department, which of course we've been talking to them about, your sense is 1.5 FTEs for probably one full-time epidemiologist. And then I understand the 0.5 would be for someone more focused on the data side of it. Is that correct? Or anything else we should know about your sense of the staff capacity?
Well, that's correct. And just to get back to the $6,018, what that would actually allow you to do, as we know, the vast majority of stroke hospitals right now are collecting this data. This would allow them to transfer that data to the Department of Public Health so that it could then be evaluated and shared throughout the state with the other hospitals. As far as what the department may or may not want, it was my recollection that they most recently suggested 1.5 FTEs, but I don't want to put words in their mouths. We are more than happy to sit down again with the department or the hospital association or anybody else involved in this bill to make sure that it comes out with the best language possible before moving forward in the process.
That's great, Jim. Thank you for your time and coordination on this. And thank you, Madam Chair. And we'd really love to have that answer to Dr. Pettit's question. So looking forward to that too.
Thank you, Representative Parker and Chairman Steinberg. You're next.
Thank you, Madam Chair, Vice Chair, or whatever. Jim, good to see you. You can understand why DPH bristles somewhat at the magnitude of the task. If we're talking, arguably 1.5 FTEs. Why is it so labor intensive? And could these FTEs also be doing other work?
Well, I can use Rhode Island as an example. And admittedly, Rhode Island is smaller than Connecticut. When they passed their stroke registry legislation, their department was able to manage the program with existing staff. What they did was just allocated X amount of additional hours to that particular task. And in their case, they use an epidemiologist for that. Again, Connecticut is different as is every single state, but that's one example of how a state was able to manage that. Really, all it is the collection of data and then sorting through it and sharing it.
But it sounds like it's a fair bit of data if you need that much manpower to take care of it. In other words, we're talking about relatively voluminous data that has to be sifted through.
Well, that's why we believe that the department's request of 1.5 FTEs would be appropriate.
Yeah, this is the stumbling block that I hope we can overcome this year, but it remains a significant one. Thank you, Madam.
Thank you. And I don't see any other hands. So thank you, Jim, for being with us today.
Very welcome.
Next up, we have number 68. That's Jake Mazidis.
Mazidis, hi all. Thank you so much to the committee. New Haven. Oh, can you hear me?
Now we lost you for a second, but you're back.
Oh no. Well, let's pray that doesn't continue.
You might want to close off your camera because that might improve your sound. Thank you.
Okay, is that better?
Yes.
My sincere apologies. Anyway, my name's Jake. I use he, him as pronouns. I'm a resident of New Haven, also a student at Yale Law School and a member of the school's Reproductive Rights and Justice Project. The views I express today are my own and don't represent the institutional views of Yale law. I'm here today to testify in support of raised House Bill 5261, an act increasing access to reproductive health care. This bill expands abortion access in our state, eliminates barriers to care, and ensures that abortion regulations are in line with modern medical practice. In June of this year, the US Supreme Court will decide a case that could undermine the critical protections of Roe v. Wade. For residents of Connecticut, there seems to be little doubt that pregnant persons will still have access to abortion, regardless of the whims of the conservative supermajority. But if these critical federal protections are stripped away, several states will move immediately, as some have already done, to criminalize reproductive autonomy. If and when this happens, it will be critical that Connecticut and other progressive states across the US provide a venue for non-residents to access safe, expedient, and reliable care within state borders. Connecticut has frequently held itself out as a leader in gender equity and the equal treatment of its citizens, but it might also be time to consider how Connecticut's policies benefit our entire nation. Indeed, an anti-abortion law passed just last year in New Hampshire shows that assaults on reproductive autonomy are not an exclusive feature of the South or the Midwest. One of the ways in which Connecticut can hold itself out as a leader in reproductive autonomy in a country in which Roe may no longer stand is to pass House Bill 5261. This common sense legislation allows advanced practice clinicians to perform aspiration abortions, a practice which already occurs in 14 states, some with abortion laws more restrictive than Connecticut. This sensible policy ensures that the medical infrastructure exists if and when individuals from this region and elsewhere in the US seek reproductive care in Connecticut. APCs are eminently qualified and, assisted by spectacular advances in medical technology, more than up to the task this legislation entrusts them with. In closing, I strongly support this bill with the recommended language changes provided by medical professionals that best reflect modern medical practices. Though access to abortion may not long be a federal constitutional right, it is a human right that this legislature ought to protect to the fullest extent possible. The decision to seek an abortion is time-sensitive and personal. Expanding the number of medical professionals qualified to perform such a procedure not only offers a more expedient timeline for pregnant persons, it also allows them greater flexibility in choosing a provider that meets their needs. This bill is a step in this direction, and I hope you pass it. Thank you for your time.
Thank you, Jake, for your testimony today. I don't see any hands, so we will move to the next speaker, and that would be Alana Butler, number 69.
Thank you so much. I'm Alana Butler, the Jewish Community Relations Council Director at the Jewish Federation of Greater Hartford, and I'm a resident of Hartford. We would like to go on record in support of House Bill 572, an act concerning menstrual products. We've submitted written testimony as well, so I will just very briefly reiterate our points. We've been working with the organization Dignity Grows for several years on menstrual equity. We provide tote bags of menstrual products and hygiene products to women and girls across the state and nationally. We have heard from so many women and girls that they are unable to go to work or school once a month because they are unable to afford menstrual products. These women should not have to worry about their periods in order to go about their daily lives. Menstrual hygiene necessities are not covered by SNAP or other government programs and are rarely available at food pantries. 30% of women suffer from period poverty. Providing menstrual products at no cost at schools, correctional facilities, and institutions of higher ed would change the lives of countless women across the state. Thanks for your consideration.
Thank you for your testimony today. We've had a number of people speak on this issue, and I don't see any hands right now. Thank you. Next up, we are going to number 71, and that's Ashley Starr Frechette.
Thanks so much, Senator. Good afternoon, Senator Anwar, Representative Steinberg, and distinguished members of the Public Health Committee. My name is Ashley Starr Frechette, and I'm here today from the Connecticut Coalition Against Domestic Violence. We're the state's leading voice for victims of intimate partner violence and the agencies that serve them. And we have 18 member organizations across the state that serve nearly 40,000 individuals each year. I'm here today to ask for your support of two bills. The first is House Bill 5261, an act that would expand access to reproductive health care by allowing advanced practice clinicians to perform procedural abortions. On behalf of CCADV, I want to emphasize the importance of this bill for survivors of intimate partner violence who are directly affected. Nationally, 1 in 4 women have been physically abused by an intimate partner, and ACOG reports that 1 in 6 women are first abused during pregnancy. Victims and survivors of intimate partner violence face coercive control, birth control, sabotage, sexual abuse, and rape. These forms of abuse increase the need for safe, convenient, and trusted health supports. The trauma of abuse is significant, and it's important to support victims and survivors in any way that we can. By passing this bill to permit APCs to provide aspiration abortions, survivors would be able to obtain care from their local health providers that they know and trust. Currently in Connecticut, there are only 4 Planned Parenthood sites and 1 independent site, leaving patients having to travel over 40 miles if one does not have an availability. This is important to note because many victims and survivors have their transportation and finances taken or limited by their abuser. By passing this bill, we will increase equal access to abortion resources for survivors who will be able to seek supports in their own community with providers that they know and trust. I encourage you as a committee to support birthing people and work towards destigmatizing pregnancy and everything that goes along with it. On behalf of CCADV, I would also like to voice our support of House Bill 5272, which seeks to require the provision of free menstrual products in various settings. The lack of access to menstrual supplies and period stigma results in physical and mental health risks, including reproductive issues and depression. CCADV's 18-member organizations always provide free menstrual products to survivors, either residing in our shelters or receiving community services. We believe that the proponents of this bill intended to include domestic violence shelters in the bill. So we've provided suggested substitute language in the testimony that would capture our shelters as they are not included in the existing bill language, but we would love to be added. CCADV supports raised bill House Bill 5261 and 5272 with recommended language changes, and we urge your support of these two bills. Access to feminine products is extremely important, and abortion is healthcare and a human right that victims and survivors need to be able to access safely and easily. Thank you very much for your time and consideration.
Thank you for your testimony, and thank you for the work you do in our state and our communities. I don't see any hands at this time, so we will move to the next speaker. And I am sorry, I passed up number 70 unintentionally, Dawn Beeland.
Thank you. Thank you, Representative Steinberg, Senator Anwar, and members of the Public Health Committee. Thank you for the opportunity today to testify in support of the Bill 5273 regarding Connecticut Stroke Registry. My name is Dawn Beeland. I live in Burlington. I'm a nurse, and I've been the Comprehensive Stroke Center Coordinator at Hartford Hospital since 2001. I'm also co-chair of the Connecticut Stroke Coordinators Group and SOCSAC, which is our State of Connecticut Stroke Advisory Council. And my intention today is to promote the development of a statewide stroke registry to enhance the stroke systems of care that are already being built to better manage the burden of stroke. And this work is a continuation of what was started in 2017 with the successful passage of House Bill 7222. And at that time, we advocated for the creation of a continuous quality improvement program using a registry. I'd like to thank the committee for raising this bill and support it. But as my other colleagues have mentioned, we don't support it as it's currently worded. As you've heard, punitive and penalty language was added that was beyond our intention. And I believe you've gotten a revised version from other members of our group. As far as some background information, stroke centers that are certified, which the majority of hospitals in Connecticut already are, are required to create comprehensive multidisciplinary performance improvement plans. And this ensures that each hospital stroke care is monitored and that the teams work to continually improve it. As a condition for certification, which was our previous bill, certified centers also now need to keep that data in a registry. So on behalf of the coordinators and SOCSAC, what we're advocating now is just an establishment of a centralized statewide repository to put this already collected data together. From that, we hope to monitor and identify statewide trends, identify potential disparities and any inequities in the delivery of care. As we pull this data together and analyze it, hopefully that'll help us create some statewide performance improvement plans rather than hospital-based, which can lead to some practice strategies so that everybody gets the same level of evidence-based standards of care. Most simply, stroke registries already exist across the state, and we're asking to aggregate the data in one registry in a de-identified, HIPAA-compliant fashion that allows for some analysis and help us direct support from our groups and resources wherever it's needed most. So I look forward to continuing to work on the language, and I can answer some of the prior questions about burden of data and how all that is collected if that's still requested.
Thank you for your testimony. I don't see any hands. I know your last comment about providing information for questions that were asked previously. I don't know if you want to take a minute to do that.
Since the data is already collected by each hospital, it's placed into fields. You have to imagine that the program, it's employed in 3,500 hospitals across the nation, has to be easy to use, very user-friendly. And so there are many reports that can be run automatically by just clicking a few buttons, setting a date range, and that data has to come in within certain barriers to meet the criteria for that field. So it's already very clean, and the program, as you're adding it, tells you if you have some internal errors. So the manipulation of the data by the Department of Public Health should be minimal, shouldn't require much effort. It's more the analysis. And in our conversations with them, without having a content expert on staff, at least in our conversations, that's what they were said that they would require. A content expert in stroke to know what to do with some of this analysis and how to direct care better. But our groups, the SOCSAC is really standing by and wants to be more than a partner, but really, in front seat to help manage some of that data to make that analysis, but we can't be super users ourselves. So we're asking the state or the DPH to be the super user so that other activity can happen.
Thank you. Thank you, Dawn. I don't see any other hands at this time. So we will move to the next speaker, and that is number 73, Dr. Mark Alberts.
Good afternoon, Representative Steinberg, Senator Anwar, and distinguished members of the Public Health Committee. Thank you for the opportunity to testify in support of HB 5273, an act establishing a statewide stroke registry. My qualifications are in the written testimony, but briefly, I'm Chief of Neurology at Hartford Hospital and Professor of Neurology at the University of Connecticut. As you've heard from my colleagues over the past few hours, stroke is a serious and common disease. Indeed, I suspect that many of you have been personally touched by stroke in some way. In many cases, strokes occur suddenly and without warning. Indeed, the term stroke comes from ancient times when people thought that a stroke was an act of God or came from the heavens because it struck down people without warning. My colleagues and I want to intervene to prevent strokes from occurring and better treat patients who have a stroke. A well-known business icon and management guru named Peter Drucker once said that you have to be able to measure something if you want to change it. The same is true for stroke care. We have to be able to measure who's having a stroke, where they receive care, why they're having a stroke, and how they're being treated if we seek to improve care and the outcomes for these patients. Furthermore, we know that stroke impacts disadvantaged populations, minority groups, people of color, and underserved groups in a disparate way, leading to higher death and disability among these people. Hence, there's a pressing need to better understand these basic facts about stroke in our state. The registry will do all of these things for us. But now I have some good news to share with you. As my colleague Dawn was saying a few minutes ago, we already have some of this needed information about the citizens of Connecticut. In fact, the vast majority of hospitals in Connecticut are already collecting the vast majority of needed information in the majority of stroke patients. That's the good news. The challenge is that these data points are all in different buckets, in different hospitals, in different cities, in different regions. No one has a statewide perspective that's needed to do a thoughtful, insightful analysis, identify trends, and then synthesize approaches to better treat these patients. Our proposal for a statewide stroke registry is one important step towards overcoming some of these limitations and providing us with a statewide perspective on the distribution and impact of stroke and identify approaches to improve treatment and track outcomes. It will provide us with the needed data and insights to make sure that all of our fellow citizens receive equitable care in a timely and compassionate manner. I believe the proposed amendments, as reviewed prior, as submitted and in the written documents, are reasonable and appropriate. The new FTEs that we are asking for will ensure that the DPH has the necessary resources to manage the data and perform thoughtful analyses. As I said, we have a lot of good news. The amendments should address any remaining concerns. Thank you all for your attention and commitment to the health of our fellow citizens, and I'm happy to answer any questions.
Thank you, Dr. Albert. I do see a question from Representative Pettit.
Thank you, Madam Chair. Thank you, Doctor. Just a quick question, similar to what I asked Mr. Williams, but not the money part. In other states that have instituted this, have your neuro colleagues in other states seen improved algorithms, treatment pathways, or outcomes based on the stroke registries they've created?
Thank you, Representative, for asking that question. The answer is yes, absolutely. There are large nationwide databases that have millions, with an M, millions of patients in them. And they have clearly shown that by having this sort of tracking combined with quality improvement, we can absolutely improve the treatment, the care, and the outcomes of these patients. Simple example is using TPA, tissue plasminogen activator, as an acute treatment. Collecting these data and instituting quality improvement so that patients get to the hospital sooner and they're treated more rapidly can dramatically improve the outcome of these patients. And in fact, TPA actually, if used appropriately, reduces the cost of care. So you have a brand new medicine that's expensive, but overall it reduces the overall cost of care and improves outcomes. It's like Hannah Montana. It's the best of both worlds.
Thank you, Doctor. Back to you, Madam Chair.
I think that last comment was to make sure we were all listening, and you could tell who was listening by the people that were laughing. So thank you for your testimony, and I don't see any other questions at this time. So thank you for being here. We'll move on to the next speaker, and that would be Lauren Fields.
Hi, thank you. Dear Senator Anwar, Representative Steinberg, and distinguished members of the Public Health Committee, my name is Lauren Fields. I'm a resident of New Haven, Connecticut. I'm a nurse and a nurse practitioner. My main work is as a faculty at Yale's School of Nursing, where I educate nurse practitioner and midwifery students in training. But I've also been a healthcare provider at Planned Parenthood of Southern New England for 13 years. I'm here today to testify in support of House Bill 5261, an act increasing access to reproductive health care, and specifically the piece of the bill that supports advanced practice clinicians, nurse practitioners, midwives, and physician assistants to provide aspiration abortion. I choose the work I do because I know it's essential for people to receive comprehensive health care from a provider they trust. I have seen it again and again in my career that when I have to refer my patients to someone else for a service they need, they face increased barriers to care. When I have to refer a patient for an abortion, they face higher emotional and financial costs, more stigma, and are less likely to receive the treatment they need in a timely way, sometimes facing several weeks of wait time for an appointment or logistical barriers like transportation and childcare to visit a health center that's farther from their home. The best care for patients occurs most often when they can get as much of the care they need from one person that is highly skilled and that they trust. For many patients in the state of Connecticut, that is a nurse practitioner, midwife, or physician assistant. When I was still in training as a provider, I was passionate about getting trained to provide aspiration abortion. I knew it was possible for nurse practitioners to provide safe and high quality abortion care because I had colleagues in states across the United States who already were. And I was also aware of a very well-designed research study conducted in California that proved advanced practice clinicians had just as good safety outcomes as physicians providing first trimester abortion. I sought out this training myself. I sought training opportunities working with a physician who had decades of experience, and I was able to participate in over 50 procedures and become competent in the care. However, because I have built and created my practice in Connecticut, I've been unable to incorporate the service into my practice. Unfortunately, this often means that I have to send patients away to another provider, including the people I take care of who are experiencing miscarriages, because aspiration procedures are not only for women seeking abortions, but are sometimes necessary and life-changing for people experiencing miscarriages. I hope that our state representatives will support this bill that addresses a critical public health need and that will bring Connecticut to match the other states in the US who already support advanced practice clinicians to provide aspiration abortion. Connecticut can do its part in increasing the number of abortion providers in a time where more and more patients around the nation are facing barriers to care, especially under the stresses of the pandemic, and with the legality of abortion in peril in many states due to the expected reversal of Roe v. Wade later this year. Most importantly, our patients deserve—
Ms. Fields, your time is almost up. If you would please summarize. Thank you.
I had one more sentence, but I think I've already said everything I really need to say. So I thank you for—
You can read your one more sentence. We will allow that.
Most importantly, our patients deserve to obtain abortion care from the healthcare provider they trust in their community and who already knows and care for them, the same provider they see for their routine wellness exams and their other primary care or gynecologic problems. Thank you for your time.
Thank you. And I'm glad that wasn't a terribly long sentence or someone might have gotten mad at me. But thank you for your testimony. I see Chairman Steinberg has his hand up.
Thank you. Thank you for your testimony today. You made mention of the fact that you did an extra study in order to be prepared to handle these kind of procedures. Did you spend time during that training contemplating all the potential bad outcomes and what one must do under those circumstances?
Yes, absolutely. That as a healthcare provider, that's always on my mind. And I already provide some procedures that others have mentioned earlier in the day that carry some risk. I insert IUDs. I was trained to do colposcopies and biopsies of the uterus. And so certainly there are some complications, and that is always on the forefront of my mind when I'm responsible for taking care of somebody. That was part of my training, was being prepared for emergencies, knowing how to respond to them, as well as having systems in place to get backup support when it's needed.
So would you agree that it would be a good thing for any nurse practitioner to have that additional training before they could perform such abortions?
Yes, I think, and the way we think about it in most healthcare settings is you get education and then you get training, and there's a process, we often call it privileging, where you do a certain amount of a skill under supervision, where others who are competent in the skill give their opinion and their assessment that you have done enough to be able to safely provide the care yourself. And so I think, like most other skills, it would be appropriate for folks to have training and supervision and support before they did the procedure independently.
And you've heard testimony that we are contemplating adding additional practitioners to the list. How would you feel about PAs having those privileges as well?
I'm absolutely in support of that. The study that I briefly mentioned from California did include a population that included nurse practitioners, midwives, and physician assistants. And again, all of them had equivalent safety outcomes to physicians. So I've also worked with all kinds of providers in my career, and I think this is well within the appropriate scope of practice of physician assistants as well.
Thank you for that. Obviously, we're giving a lot of thought to not only the consequences of broadening privileges, but also who ought to have that. So thank you for your testimony. Thank you, Madam Chair.
Thank you, Chairman Steinberg. And I don't see any other hands at this time. So thank you, Lauren. And we will move on to the next person on the list. And that would be number 75. And 75 is Livia Fry.
Thank you, Representative Kushner, and good afternoon, everybody, and especially to all the members of the Public Health Committee. I'm here testifying today in support of HB 5278, an act prohibiting an unauthorized intimate examination on a patient who is under deep sedation or anesthesia or unconscious. I give you this testimony today as a survivor of non-consensual teaching practices in a Connecticut teaching hospital. When I was a young child, my family was referred to a physician who practiced out of Connecticut Teaching Hospital to get me treatment for an uncommon skin condition. We were given the impression we needed somebody who specialized in treating the condition in children, and we were told this teaching hospital was the only option. Whether we wanted a teaching institution or not, this was where we had to go. And when students entered with the attending physician, my family was under the impression we had to let them stay. The language allowing them to be there was vague and buried in the middle of consent forms, much the same way language allowing intimate exams under anesthesia or sedation or while unconscious often is currently. We didn't understand what we were signing up for, much the same way many of today's victims of unconscious intimate examinations do not. That was the first time I was forced to show my naked body to strangers for the purpose of furthering their education. The first time I was reduced from a human being to a teaching tool, an object, or an exhibition. The first time I learned what it felt like to be violated. It wouldn't be the last. It continued roughly from age 8, 9 through age 14, several times a year, every year. At every appointment, the doctor would walk in with whatever doctors in training would be viewing my naked body that day. Sometimes they also photographed me. At each examination, the doctor examined my full body. By itself, an examination is innocuous, a necessary part of healthcare. But during these examinations, he put my naked body on display for his students like an exhibit or a sideshow. I was forced to lie on a table while he pulled back the flimsy paper gown I was wearing to expose my chest, my back, and my belly. The part I hated the most was when he would pull down my underwear to expose my buttocks and genitals. To this day, I can feel his hands on me on my stomach, pulling down the thin piece of cloth that protected me from the strange eyes standing behind him, staring at me. I was so acutely aware of those eyes gaping at me, like someone usually gawks at an animal in a zoo, that I could physically feel them on my skin. They had no regard for my dignity, my privacy, my well-being, or my feelings. They only cared about how they could use me, how the use of my body was furthering their education like a practice dummy or a textbook. I was made to feel lower than an animal every time I stepped into that institution's exam rooms, and I have been left with a lifetime of pain and anxiety, along with post-traumatic stress disorder because of what was done to me. I have flashbacks, panic attacks, and nightmares, along with an intense fear of doctors and healthcare in general. Earlier today, Dr. Amy Brown of Hartford Healthcare shared spoken testimony, and she also submitted written testimony that stated, in part, the ability of patients to exclude trainees from even observing seems illogical. Her testimony, along with the written testimony of Dr. Anthony Tarantino, also of Hartford Healthcare, urges the committee to amend the language in the bill so that patients cannot mandate the trainee be excluded from observing the exam.
Excuse me, Ms. Fry, your time is almost up if you would.
I'm wrapping up. Thank you.
Thank you.
I hope that by sharing my story, I have shown how wrong Dr. Brown and Dr. Tarantino's assertions are and just how much harm even non-consensual observation can do. Patients should and must have the right to refuse any portion of student or trainee involvement they wish. We do not go to the hospital to train the next generation of doctors. We go for medical treatment. And some of us only have access to a teaching hospital and simply cannot choose a private option without students present. I submitted along with my written testimony a list of over 107,000 petition signatures from individuals who are urging the passage of this bill with the language prohibiting student observation included. We are depending on you to pass this critical legislation and protect us when we can't protect ourselves at our most vulnerable moments and prevent us from being violated when we are sick and need care. Thank you for hearing me today. I'll stop there and leave it at that.
Thank you, Livia. I see that Representative Gilchrist would like to speak.
Thank you, Madam Chair. Ms. Fry, I just want to thank you for being here today and for sharing what I would imagine is a difficult testimony. I'm sorry for what you've experienced, but I really appreciate you sharing your experience to help others. Thank you.
Thank you, Representative Gilchrist, and I want to thank you for your work on this important bill as well. It's been noticed and appreciated by an entire community of survivors.
Thank you, Representative Gilchrist. And now Senator Saud Anwar.
Thank you, Madam Chair. Thank you, Ms. Fry, for your testimony, and I'm so sorry about your experience, and I'm so sorry about the trauma that you have experienced. I wanted to just share with you that this bill is also talking about getting the permission and getting a consent in advance. And if a person is going to have an illness in the private areas and have that permission to be able to examine, so that in future, the next generation, once they have the permission, should be able to get the skills to be able to manage them. Now, we just heard that APRNs are also trying to learn some of the skills. It's not only the doctors who are learning the skills, everybody in the pipeline, whether they're medical students or PAs or APRNs or midwives, they're trying to get the skills, and there are multiple different individuals. But I think there's obviously in your experience, you truly had somebody who, from what your description is, a highly unprofessional way of managing this, is probably truly outside the realm of acceptable way of managing things. But if the individual is given the opportunity to say yes or no, is a very critical part to existing criteria. That's a known thing, but I think this bill may be able to help clarify that further, so that people don't have this experience that what you entailed.
If I may respond, Senator Anwar, I don't object to medical education provided it is done with consent. I understand that students need to learn. However, I would argue, as would many people, I believe a survivor of one of these exams gave testimony earlier today, as did several other people, that the consent practices in our state are not sufficient. Consent language, as I mentioned, is often buried in consent forms, and people don't know they have the right to refuse. They think that if they're at a teaching hospital, even if it is the only one available, then they are required to let students and trainees participate. And I would argue that is simply not the case, and that hospitals are taking advantage of the way the laws are currently written that allows them to get by with vague language and burying it in the middle of the consent form. I celebrate that this bill wants to make that consent very explicit, and that is what I am advocating for: explicit, direct, and informed consent. And if somebody consents to an intimate exam by a student, then thank you to them and God bless them. But I take exception to the notion that has been expressed in testimony and has been expressed by teaching institutions in past testimony against previous iterations of the bill, that patients are inherently resources. We're not. We're living, breathing human beings who have a right to health care, whether we want our bodies used that way or not. My experience is not uncommon. I agree with you, it was unprofessional. In fact, I think it was abuse. But there is an entire community of survivors who have lived through similar things. One of them testified here earlier today. So that is why I'm advocating for this bill as it is, without language added in or revised that would allow, that would prohibit a patient from sending a medical student out of the room even for an observation, because we should be able to refuse an observation as well.
Thank you so much. I truly appreciate your thoughts. It really helps me quite a bit. I appreciate your testimony. Thank you, Madam Chair.
Thank you, Senator Anwar, and thank you, Ms. Fry. I don't see any other hands at this time, so thank you for being here and sharing your story. Next up, we have Logan George. There you are.
Hello and good afternoon. My name is Logan George and I'm a resident of New Haven and undergraduate at Yale University. Thank you so much for having me. I'm honored to be here today to testify in support of House Bill 5261, an act increasing access to reproductive health care. 2021 saw the highest number of anti-choice restrictions enacted in a single year across the US. Now more than ever, the importance of access to reproductive health care cannot be understated. This bill will improve the lives of menstruators in Connecticut in 3 meaningful ways. It will increase access to safe abortion services by allowing more medical professionals to perform them. It will modify Connecticut's language around abortion to be inclusive to all people who can get pregnant. And it will reaffirm the rights of menstruating people in Connecticut in a time where the right to choose is being eroded. As a young woman who grew up in Texas before coming to Connecticut, this issue is close to my heart. Safe, accessible abortions are a constitutional right with dire consequences for my fellow menstruators and me if limited. What happens to my body is my decision alone, and life-changing healthcare like abortion should be easily accessible to all who might want. Connecticut is a strong supporter of reproductive healthcare access, unlike my home state, but we should not allow this to blind us to criticism around Connecticut's reproductive healthcare system. Unnecessary barriers to treatment persist and do not reflect new medical technologies and safety standards. As it stands, Section 19 of the Public Health Code states that no abortion shall be performed at any stage of pregnancy except by a person licensed to practice medicine and surgery in the state of Connecticut. However, such certification is not necessary for all abortion procedures. The FDA includes advanced practice clinicians as eligible providers of these services, and the World Health Organization recommends general practice physicians, nurses, midwives, and other advanced practice clinicians should be allowed to provide such services. This indicates that Connecticut's laws need an update as outlined in this bill. Economically disadvantaged people and people of color already face unequal access to abortion services, and this bill could take important steps to solving this problem. The average cost of abortions in the US during the first trimester of pregnancy is about $500, while later term abortions cost up to $3,000. Allowing more medical professionals to perform abortions will allow people to get earlier, cheaper services, limiting the economic barrier to access and allowing people to receive services from individuals they trust. With the countrywide increase in anti-choice legislation, ensuring reproductive health care is accessible, both to Connecticut residents and those to travel to our state for these services, is vital. This bill not only provides safe, sensible solutions that will increase access to crucial medical service, but it will also assert that abortion is and will remain a right in Connecticut, despite our country's current trends, providing comfort and support to people across our state. For all these reasons, I urge you to vote favorably on this bill. The health and safety of people like me depend on it. Thank you for your time.
Thank you, Ms. George. It's very good to have you here, especially coming from Texas. Welcome to Connecticut. I do recognize Representative Parker with the question.
Thank you, Madam Chair. Just wanted to thank you for joining us, Logan. And similarly to what Senator Kushner said, we really appreciate the perspective you offer as someone that is from Texas and has an experience there, and then in Connecticut for at least a couple of years in college is also experiencing some of these impacts on your life here. So your really unique perspective is valued, and we appreciate your time. Thanks for being here.
Thank you. And thank you so much for your work on this piece of legislation.
Thank you. So next up, we have Dr. Thomas Farquhar. I'm not sure I said that correctly, but.
Thomas Farquhar, yes. So Senator Anwar, Representative Steinberg, Senator Wong, Senator Summers, Representative Pettit, and members of the committee. My name is Dr. Thomas Farquhar. I'm the legislative co-chair of the Radiological Society of Connecticut, which is the state chapter of the American College of Radiology. And I'm a practicing physician in Hartford and a number of other different central Connecticut. I wanted to offer brief comments on Senate Bill 249, an act implementing the recommendations of the Breast Health and Breast Cancer Awareness Working Group. I know that my colleague, Dr. James, spoke what must seem like yesterday, but it was just this morning on this, but to follow up with some of the answers to the questions that have been asked. So the working group was created last session as a result of Section 14 of the Public Act 2135, comprised of stakeholders and experts on the issues of breast cancer and breast cancer screening, and met multiple times, led ably by Representative Jillian Gilchrist with substantial participation by Representative Kathy Kennedy. So one of the focus of the group's discussion was the breast and cervical cancer early detection treatment referral program. So that's administered by the Department of Public Health. It serves approximately 4,100 women is what we've been told, with a budget of $2.1 million a year. And the eligibility guidelines focus on women who either do not have health insurance or they may not be able to afford their deductible, which could be thousands of dollars. So Senate Bill 249 suggested 3 enhancements, giving priority to women in minority communities, which, as we know, have higher, greater degree of impact. So lower rates of screening, but greater morbidity and mortality. And so we believe this will be an important step towards addressing this known healthcare inequity in breast cancer screening. It'll encourage the use of breast tomosynthesis, also known as 3D mammography when possible. In most hospitals and imaging centers in Connecticut, it has become the standard of care for screening mammography, and it can detect cancers earlier with fewer callbacks than a traditional 2D mammogram. And then lastly, the bill would encourage the use of co-testing for both PAPG and human papillomavirus at the same time. So the working group also agreed that the budget should hopefully be adjusted for fiscal year 2023 to increase reimbursement for imaging examinations used for breast cancer detection and to increase the funding for the breast and cervical cancer early detection and treatment referral program. So one of the questions that was asked was, what is the gap? I think it was Senator Moore who asked. So the Department of Public Health had estimated that perhaps as many as 38,000 women worldwide, or excuse me, statewide, would qualify for help. And again, it's an excellent program. It reaches 4,100 women, much to their benefit, but that's a gap of nearly 4,000 women across the state that we believe could be improved with increased funding. So while the bill itself doesn't address the funding, it does include the changes that would allow this program to reach more women in need. And we have had conversations with the Appropriations Committee about trying to get that funding. We all know that early detection of cancer saves lives. That was the focus of the working group, and it's the focus of this bill, and we encourage your support for it. Thank you.
Thank you. And I do see Senator Moore has her hand raised. You are muted.
Thank you. Representative Gilchrist had hers up first.
Oh, I'm sorry. I didn't see her hand up. I think she took it down.
She took it down.
Yeah, my question was the gap, and the doctor responded. Thank you.
You're welcome.
Thank you. Hi, Dr. Carr. How are you? Thank you for
I'm fine, thanks. So nice to see you.
You know, this is such an important subject to me. I've spent more than 20 years of my life, and I'm not a breast cancer survivor, and I don't even have, I'm not, other than being a Black woman, we don't even have a high risk in our family, but I've watched so much stuff in the way of disparities happen across the state, from access to screening to lack of insurance. I'm one of the first persons that worked for the Connecticut Breast and Cervical Cancer Program under Planned Parenthood in 1996, and that's when I learned so much about the disparity in breast cancer and what was available. And I still stand on, and this is based on what I know, I still stand on the lack of access to care and the information that comes out to women in low-income communities, that who should be screened, when you should be screened, when you should go back. You know, one of the things is we find that a lot of times women get screened the first time, they get an abnormal, they get that letter, they freak out, and they don't want to go back because for some reason they think by not going back, nothing's going to happen. But then it turns into later stage breast cancer when they could have learned very early on when it was treatable on what to do. And you know, when I say I've had hundreds of women, and now that I'm not actively doing outreach, there's not a woman that I don't meet that tells me that she had breast cancer and she's under 40. Mm-hmm. When I began this trek, it was 40 and older, get a mammogram, and then it got pushed up to 50, get a mammogram, get a clinical breast exam, get a Pap test. And I don't think there's enough education anymore. I think people are taking it for granted, like it's a common cold, and breast cancer is not a common cold. And it can be treated so early on, as you know. We have to do more in the way of education. And I know at one time, the Breast and Cervical Cancer Program paid for education as a part of the grant that they were giving out to some of the providers that they had to do a certain amount of education. They had to do bring in a certain amount of people for screening. So in your recommendations, I heard you increase imaging. I wanted to ask you about what are you reimbursed for a mammogram through the state?
So I don't have the exact number top of mind, but I will tell you that back several years ago, things had been based off of the 2007 Medicare, the federal government rates, and they had been reimbursed at 100%, and they were cut almost in half to 57.5% of the federal government Medicare rates. So we had data that we shared with the committee that showed that the rates that we get are reimbursed for mammography are lower than neighboring states like New York and Massachusetts. All this in the state that usually, if it doesn't have the highest, it's the second highest incidence of breast cancer in the country. Much like other professions, we are seeing in radiology, everyone is overwhelmed with the amount of work to do. We don't have techs, we don't have enough mammographers, we don't have enough doctors to do everything. And we've actually now seen groups stop taking Medicaid patients, and we're very worried about that access as well. And again, whether or not someone takes Medicaid or not is kind of a debate. You could see one Medicaid patient a week and take Medicaid, a true statement, but you're not scheduling patients irrespective of their insurance. And like you said, there are so many barriers to women getting screened, from lack of education, lack of access, transportation difficulties, anxiety, fear. The pandemic showed a lot of the issues that we would have with women delaying their mammograms. We just don't need any more obstacles. So we need I would argue that we even need to incentivize radiology practices to be able to provide this as an option, because we are starting to see providers no longer take Medicaid.
So at one point, I mentioned this earlier when someone was speaking, that there was a time when you could go from Stamford to Bridgeport to New Haven and Hartford and find a mobile unit. Now there's just a mobile unit at Yale, I believe, and at Hartford Hospital, but there's nothing in Lower Fairfield County. I found that I had great response from women in the community who would never go get a mammogram if I could bring it to the community. As a matter of fact, I was just thinking about, I took the mammogram machine from Stamford Hospital into a housing complex in Greenwich that no one knew existed. And for the first time ever, women got screened. So access is really a huge part of this. And I'd like to see the mobile units come back and be on the road. I know that the state, in my first year as a senator, funded Stamford Hospital to get that van. I don't remember the amount, but I know we did fund it. So I know we can fund and support those type of initiatives. And then you mentioned HPV, and I was wondering how that plays into this.
So human papillomavirus, there are certain subtypes of that, and this is almost well beyond my pay grade, but it carries with, certain subtypes carry with it an increased risk of cervical cancer. So the literature has suggested at the same time pelvic exam for a pap smear to get the cells to look at, you could also test that for HPV, and that information as an increased risk of future cervical cancer would be just as useful.
Well, how does it fit in with this legislation? What are you trying to do with that?
That part of again, it's wrapped in with the fact that it's a breast and cervical cancer early detection program. So the two parts of that came out of that from a gynecology perspective were to go ahead and do that co-testing and recommend that be done more commonly. But I had an opportunity to check. It's around $9 that we get reimbursed for reading a mammogram. And again, so that's for the expertise of someone like my colleague, Dr. James, who's going to look at the mammogram and make a life-altering decision about whether or not there's cancer there. So we really do think it's critical to increase the Medicaid rates for those exams specifically, so that there is you don't see further erosion in access. Things like the mobile vans are one, but we also see that we want private offices across the state to be able to see it. With the pandemic, we found women most of us don't want to go into a hospital these days to get something as simple or straightforward as a mammogram. So you need to have outpatient venues. A mobile van is a good idea if there are transportation issues. But what woman wants to go into an acute care hospital during a pandemic to have a mammogram done? We want to have lots of options in the community, including radiology offices. And crucial to that, we think, is keeping the reimbursement fair and on par with other neighboring states. Often the argument is, well, we haven't noticed a lack of access, which means we don't get complaints by women calling to say, I'm trying to get a mammogram and I can't get that. But I think that sets a really high bar. I think, unfortunately, the inertia is to simply not get the exam done, and no one's going to look up the number to complain to the state government that you can't find it getting done. It just doesn't happen, like you said, with these women who live in Greenwich and haven't had a mammogram their whole lives. And how far away might they be from a hospital? The answer is it's just too far, and that access issue was an obstacle for them being treated once.
In the education piece, I screened a woman who was in her 70s, close to 80, for the first time in her life, got a mammogram.
Yeah.
Took a picture of it because I couldn't even believe what I was seeing, and I wanted to be able to document it. And when you think about $9 for a doctor to look at a mammogram, that number is really way off. So I hope that you're talking to APROPS, and my APROPS chair for human services is here, Senator Kushner. So I hope she's listening, that we need to be able to support this. So thank you so much. And I'm telling you from the bottom of my heart, I so much appreciate you all speaking out on this subject, because I am so tired of hearing the same thing over and over. I think of Fannie Lou Hammer saying, I'm sick and tired of being sick and tired. Well, I'm not going to be tired. We just have to do something about it, and we need to do it right now. So thank you so much for your testimony.
Thank you. My pleasure. Thank you.
Thank you, Senator Moore. I was listening, and we'll talk. Next, I see a hand, Representative Gilchrist.
Thank you, Madam Chair. I'll be quick, but just wanted to let Senator Moore know that another recommendation from the working group was to include 2 additional mobile vans. So I'd love to speak with you about that. Thank you.
Thank you, Dr. Fakuhar. I don't see any other hands. And so at this time, we will be calling next David Reynolds, and I will be turning over the chairing to Chairman Steinberg. Thank you.
Chairs and members of the committee, my name is David Reynolds. I am Associate Director of Public Policy with the Connecticut Catholic Public Affairs Conference, which represents the Catholic bishops in Connecticut. The conference stands in opposition to HB 5261, an act increasing access to reproductive health care. This opposition is not solely based on its longstanding moral opposition to abortion, which I will not even refer to in this testimony, but on significant shortcomings surrounding the language of the bill and additional underlying facts which question the wisdom and need of this bill. First, the designation of which medical providers can perform an abortion is not defined anywhere in state statute. That responsibility has always been left to the State Department of Public Health, as they created the regulations for abortion procedures in our state. In the current regulations, as many of you are already aware, it only allows a licensed person that has license to practice medicine and surgery in the state to perform an abortion. The legislature left this responsibility to the DPH, since they are the experts in the scope of practice and training requirements medical providers operate under. If this committee desires to specifically define which medical providers can perform abortion in the state, then it should also include a reference to the level of training in abortion procedures that these providers receive. HB 5261 overrides the surgery requirement in state regulations. So this committee must consider what will it be replaced with. Second, the language in this bill would not only allow any general physician or advanced practice clinician to perform an abortion without specific training, but there is also no limit on number of trimesters in this bill that provider can do. So under the current language in the bill, those advanced practice clinicians could actually go out to the 3rd trimester. This could be dangerous to women being served. In fact, the American College of Obstetricians and Gynecologists, which supports advanced practice training for abortion, has 2 caveats. One is that general physicians and APCs should have at least limited training in abortion practices, and that these physicians and APCs should be limited to the first trimester abortion. This bill makes no reference to those requirements. Third, I would ask, is there actually a need for this legislation in Connecticut? Abortion advocates in Connecticut and nationally are taking advantage of the national debate about abortion rights, driven by a potential Supreme Court decision, to request numerous pieces of legislation being considered by the General Assembly this session. The conference has no record of this issue being raised in past legislative sessions, and I've been here for 18 years, so that's a long time. And I think we need to ask several questions. Are additional providers needed in a declining market? In Connecticut and nationally, the number of abortions performed, both surgical and medical, have been on the decline. As of 2019, compared to 2007, there's been a 30% decline in the number of abortions performed in the state. So it clearly appears the demand for abortions has declined, along with the finances they generate.
Excuse me, Mr. Reynolds, your time is almost up if you'd summarize. Thank you.
Then I will continue on. And I think we have to, a passage of this legislation actually fix the perceived problems of access that it was meant to address. We've heard from about 14 states having this. What we haven't heard is in those 14 states, when they authorized advanced practice clinicians to do this, did it actually increase access and wait times for abortion services? Also, it's important to know how this will affect low-income women, because 75% in 2018, 75% of abortions were performed on Husky recipients, costing taxpayers $4.2 million. Okay, and most of our abortion clinics are located in low-income minority areas. The conference, despite its strong underlying opposition to any efforts to expand abortion services, believes that the secular facts have not proven that there is an access problem for any women in Connecticut who are seeking an abortion, nor that this proposed law would actually increase abortion access. This legislation attempts to address an access and provider problem that has not been proven. I'd like to just wrap up with saying that there are hundreds of doctors in Connecticut that meet the current requirement defined in the existing state regulation, and hundreds of APCs who can provide medical abortion drugs. Yet few choose to perform abortions. Why? Most common reasons are moral and religious objections, lower financial compensation, and personal professional aspirations. These reasons also exist with the general physicians and ACPs referenced in the proposed legislation. So the conference feels that this bill is actually unnecessary and will not increase access to abortion for most women in Connecticut. Thank you.
Thank you for your testimony. Next up is Mark Thompson.
No questions. Interesting.
Good afternoon, Senator Anwar, Representative Steinberg, and members of the Public Health Committee. My name is Mark Thompson, and I'm the Executive Director of the Fairfield County Medical Association. I appreciate the opportunity to speak on Raise Bill number 5303, an act concerning continuing medical education requirements concerning endometriosis and cultural competency, and the creation of a plan for an endometriosis data and biorepository program. Connecticut first adopted the mandatory continuing medical education requirement for physicians in the mid-2000s. At that time, the statute required physicians to complete 50 hours of CME every 2 years. That included mandatory CME in infectious disease, risk management, sexual assault, and domestic violence. Since that time, the legislature has added the topics of cultural competency and behavioral health. The legislature then expanded the definition of risk management to include not only prescribing controlled substances and pain management, but also the screening for inflammatory breast cancer and gastrointestinal cancers, including colon, gastric, pancreatic, and neuroendocrine cancers, and other rare gastrointestinal tumors. The legislature also expanded the definition of behavioral health screening to include at least 2 hours of training on diagnosing and treating cognitive conditions, including but not limited to Alzheimer's disease, dementia, delirium, related cognitive impairments, and geriatric depression, or mental health conditions common to veterans and family members of veterans. The Public Health Committee is now considering the inclusion of screening for endometriosis and systematic effects of racism, explicit or implicit biases, racial disparities, and experiences of transgender and gender diverse persons on patient diagnosis, care, and treatment. While all of these issues are important, the question is, when will the legislature stop adding topics to the mandatory list of required courses? The addition of topics over time can be endless. Physicians have the requirement to take 50 hours of CME every 2 years, and they should be allowed to select the topics that are relevant to their practice of medicine. While many of the topics that have been added over the years are characterized as may include, end quote, then why is it necessary to list them? Not everyone needs to take a course in rare gastric cancers, geriatric depression, or endometriosis. Instead of adding new topics, we would welcome the opportunity to work with you on the creation of an appropriate mandatory CME program for the state of Connecticut. Thank you.
Thank you, Mark. Good to see you. Yes, you're not the first to raise the issue that we do seem to pile on year after year, and the accretion becomes an impediment, perhaps, to the for physicians to keep up with practice because of all the different things they have to be aware of. On the other hand, medicine has advanced so significantly. There are just so many more things to be aware of and to be sensitive to in order to be able to meet the need of whatever a patient presents. I, for one, would be glad to work with you to look with fresh eyes at what we require for CME, and perhaps rather than throw out a bunch that we've had in the past, perhaps we can tailor the requirements to certain professional qualifications, typical practice, things of that nature. Maybe there's a middle path here which we can achieve, because we do feel strongly when we bring these education topics forward that they are important to us. I see that Senator Anwar has a question.
Thank you, Mr. Chair. Thank you, Dr. Thompson, for your testimony. And in 2019, when I started to serve over here, I did speak on the Senate floor, and I explained to everybody that the CMEs are meant for learning in your areas of expertise what new has happened. In their new lung diseases, their new respiratory problems, area diseases. But what's happened right now is that every advocate in the last few years, and they're rightful in their passion and understanding, are saying that everybody, and especially physicians, have to learn it. Now, we know already that the physicians are leaving, and then I can talk about why we don't have enough doctors in our state anymore. But that's part of the challenge, is that many of the psychiatrists can no longer learn as much about psychiatry because the state is requiring them to learn about a lot of other things that is probably not in their area of expertise to begin with. And in the same way, many specialists, not necessarily in this bill as much, but they're required to learn about some of the things that they may actually never see in their life, but they will stop putting those extra hours because, frankly, the doctors are struggling, and that's why this one group of occupation, the people are hurting themselves. The suicide is increasing significantly because of how the state wants us to practice, and then the insurance industry is trying to control us, and some of the others may not have to go through any stringent criteria of work. So I hear you. Do you think there's a solution to this? How do you go about making sure that we have the people learn about their own specialties as well?
Sure. Thank you. A couple of things that I didn't mention in my testimony. Most physicians today are board certified. It's required by the insurance companies and many hospitals. In board certifications, the boards have their own requirements for the physicians to keep that certification. It's very stringent, very labor intensive on the part of the physician to keep their boards current and up to date. The other thing is the way that we're doing it now in Connecticut, and I'll just give a couple of examples. All of the mandated courses that they're required to take, the physicians are required to take, it's not by specialty. So if you just have an MD degree and you have a medical license, then you have to take all of these different topics. And I hear frequently from the pathologists saying, I don't even see patients, yet I've got to take all these courses. You know, I look at, you know, lab specimens and organs and things of that kind. I'm a psychiatrist. Why do I have to take something in infectious disease or some of these cancers? I'm treating the mental health of patients. So to answer your question, I think the one things that we could possibly do is take a look at the different things that the different specialties should be taking and consider their specialty in the courses that we may require them to take. The other is, you know, physicians are you know, they're very bright, like most people are, and they remember what they learned. So the requirement that we make them take these different mandated topics every 6 years doesn't make necessarily a lot of sense. I think there's a number of things that we could do to streamline and to make the requirement process much more appropriate and meaningful for the residents of Connecticut. And we would like to work with you on that.
I too look forward to working with you because there's almost like two different paths. One path for the physicians is that once you become a doctor after whatever years you go through medical school, you are required to do a formalized residency program. And today we heard that there's no formalized program, and APRNs and PAs would be able to have their program of some training which is not well defined, and they would have the privilege to be able to perform procedures going forward. And did the physicians bring it upon themselves, and that is why the industry or the healthcare, the physicians in the state of Connecticut are either leaving or stopping the practice? How can we change it internally?
Yeah, no, that's another very good observation, and I think there's no single silver bullet. I think it has to be a number of things that we need to do to make Connecticut an attractive place to work, and this is just one little tiny cog in that whole process.
Well, thank you, Mr. Chair. Thank you so much for your testimony.
Thank you.
Mark, we have a few more questions for you, starting with Representative Pettit, followed by Representative Terziak.
Hey, Mark, a couple of questions. I wonder if you could add anything to the discussion on, I think it's 5190, the HIV testing bill in terms of in the office, whether you think that's reasonable or if your position's consistent with CSMS has submitted in testimony, first of all.
Yeah, Bill, that's something that we would need to take a look at specifically, but generally our position is similar to that with the Connecticut State Medical Society. I would have to get back to you on that.
And secondly, on the reproductive rights bill, if you're OBGYNs or if you've had meetings with ACOG in terms of the issue of making a regulatory change versus a scope review for the PAs, APRNs, and nurse midwives to perform other procedures.
We have discussed that particular bill, and the biggest concern that we have is that the final language, as this bill is flushed out and expanded, that there's at a minimum adequate protections in the bill to assure that the safety and the health of the patients is protected. So we've been holding back on opining on that particular piece of legislation because we wanted to see what the Public Health Committee is going to come up with in terms of advancing a bill in that particular area.
Thank you. Thank you, Mark. Thank you, Mr. Chairman.
Thank you, Representative Terziak.
Thank you very much, Mr. Chairman. Sorry for the mix-up there. My question is more general about medical doctors' CEUs, required CEUs. So it's okay with me whether it's answered by Dr. Anwar, Dr. Thompson, or Dr. Pettit. Are there two kinds of CEUs? One is that this is required, you have to study it, and the other is you have to choose X number of CEUs from this menu of different topics. That's been my understanding.
Sure. There's an overall general requirement that physicians have to receive at least 50 hours of CME every 2 years. Layered on top of that, Connecticut also has a requirement that physicians have to take 6 hours of CME in very specific areas, and those were the items that I was talking about primarily here this afternoon. And those 6 topics, those particular courses have to be taken every 6 years. So we have a fairly complicated, convoluted CME requirement here in the state of Connecticut. And we believe that it could be improved upon.
Thank you. So my impression that the CEUs required for, say, learning more about inflammatory breast cancer, that is on the list, that is on menu B, where you can choose these topics or those, and you as a psychiatrist might choose not to learn about the early indications of inflammatory breast cancer. But is that correct? That's the way I understood it. You have 30 to take over however many years, but only 6 hours where it says this has to be done. The rest is choose from this menu. Is that
that is
so,
correct? But that menu is getting significantly longer over time. And but there are 6 broad topics, which I did mention. I'd be happy to do that again. There is 6 broad topics that everybody has to take every 6 years.
Great. Thank you very much, Doctor. Thank you, Mr. Chair.
Thank you.
Thank you, Representative. I do not see any further questions for you. So next up is Jill Brown, followed by Jennifer Love.
Good afternoon. Thank you to the Public Health Committee for the opportunity to present testimony supporting House Bill 5272, an act concerning menstrual products. My name is Jill Brown, and I'm currently serving as Director of Finance and Operations for the Bristol Public School District. Last month, at their meeting on February 9th, the issue of period poverty was brought to our Board of Education Operations Subcommittee at the request of one of our board commissioners. As a result of the discussion and approval of the item, the topic was forwarded to the full board for its consideration. At its regular Board of Ed meeting this past March 2nd, the Bristol Board of Education unanimously voted to support the availability of free menstrual products in its schools serving grades 6 through 12. The board's decision followed considerable research, robust discussion, and public participation from 3 of our Bristol Central High School young scholars who spoke about the need for free menstrual products in their school. They spoke of anxiety and worry coupled with the lack of available products during the school day. Each spoke of not being able to access feminine hygiene products, having to ask the nurse or classmates for a product due to various reasons, and each advocated for readily available products to help with reducing the need to leave school while menstruating. Their words echoed the study conducted by Harris Insights and Analytics, which states that 20% of teenage girls surveyed, 1 in 5, can't afford to purchase menstrual hygiene products. 25% have missed class because they didn't have access to menstrual products, and 83% think the lack of access is not talked about enough. Prior to the board's discussion, I had reached out to the Bristol Burlington Health District, which staffs the nurses' offices within the Bristol Public Schools, and they supply feminine napkins to students who need them during the course of the school day, and in some cases beyond. My questions were around the types of products, the annual consumption, and the approximate cost associated with products that are currently offered through our nurses' offices. I learned that the only products offered are napkins, and that our students utilize approximately 1,800 to 2,000 units per year. Undoubtedly, our collective research, the advice and partnership with the Bristol Burlington Health District, and the testimony of 3 very brave young scholars have influenced our board to support free menstrual products in our schools. And I'm proud to be associated with a community that recognizes this need and is among the first to address it proactively in our state. In Bristol, we've identified 60 bathrooms that are designated as women's or gender neutral bathrooms in the school district, serving grades 6 through 12. We've estimated the startup costs for dispenser units and products to range between $10,000 and $12,000. A mandate with no funding attached will prove very difficult for school districts across the state, and I would highly recommend that the bill includes startup funding at minimum. Or
Excuse
better
me,
yet,
Ms. Brown, your time is almost up. If you would please.
almost
summarize.
done. Thank you so much.
Thank you.
Or better yet, full funding considering menstruating as a basic human function. Thank you for allowing me time to share how period poverty is affecting the community of Bristol and our school leadership's response to this issue. And thank you for your thoughtful consideration of this bill.
Thank you for your testimony. And from your testimony, it's clear that your school district was very deliberate and thoughtful about the entire prospect of providing such products in the schools. I would guess that Bristol is not the wealthiest of school districts, yet you apparently have made the decision to budget for these products on an annual basis.
Yes, we'll be adding the cost of the products to our custodial budget, and in reaching out with to the Bristol Burlington Health District, they have agreed to partner with us to share the cost.
Thank you. That does respond to one of the questions we heard earlier, whether or not this would potentially be a significant impediment on a school district. Your testimony suggests that in some cases, districts have stepped up in that fashion. I see that Representative Kennedy has a question.
Thank you, Chairman Steinberg. Good afternoon, Ms. Brown. I just wanted to ask you, and thank you for your very passionate testimony. Do you happen to know a cost to your custodial budget that you're adding to it? Do you have an idea of the cost?
We'll be adding between $2,000 and $2,500 per year just for products.
Okay, and what about like dispenser or that type? Is that factored in there as well?
Yep, we've estimated the cost of dispensers, a single type, to be about $150 per. So times 60 bathrooms in Bristol. Bristol has about 8,000 students. I think we're the 8th largest district in the state. So it's a considerable expense. That would be about $9,000 or $10,000 for the installation. Our maintenance crew will be able to install them, so we won't have to, pay additional funding for that. Some of the smaller school districts would consider this a tremendous expense.
I appreciate your responses. Thank you, Mr. Chairman.
Thank you, and thank you, Ms. Brown, for your testimony today. Very on topic, and we appreciate your patience in sticking with us this far up. I see Representative Betts has a question.
Yes, thank you very much, Mr. Chairman, and thank you, Jill. In your planning of this for the capital cost, that's one thing, but the maintenance now, the cost you said it's going to be per year to be able to, after the bathrooms have been upgraded, is what?
After partnering with the Bristol Burlington Health District, we expect to add about $2,000 or $2,500 to our custodial supply budget, just to keep the products in the laboratories.
Okay, and I should know maybe, but has this been an ongoing problem at Bristol schools, or have people found other ways to deal with the shortage or not the availability of these products?
So currently, our students can go to the nurse's office, and we do have products available there. And so asking them about their consumption, they've indicated about 1,800 or 2,000 units in that range per year. We would expect that to increase if products are readily available in the bathrooms. After listening to the 3 girls who spoke so bravely at our board meeting last week, you know, your question was, is this an ongoing problem? I think it's a silent problem. They all 3 talked about products not being available, having to leave school. The embarrassment of one girl talked about having a friend check her as she walked down the hall to the nurse's office, having to be excused from class. You know, when you're a teenager, you feel a spotlight. And so has it been a problem? I would say yes. After listening to those 3 girls, absolutely.
And I take my hat off to those 3 girls for doing it. But I think it's a very good move. I think it's necessary. And I appreciate your putting in the testimony. And I'm sorry my dog is barking to the phone here. It's a pug. Thank you, Mr. Chairman.
Thank you, Representative Benson, for identifying your dog's breed. Next up is Senator Summers.
Yes, and thank you for your testimony. It was very great to hear the detail that you could provide. And my question for you is, if you didn't partner with your local health district, or what, do you have an idea what your cost would be, or what is your local health district contributing? Because maybe not every health district would be able to do the same thing. I'm trying to get my hands wrapped around what the true cost would be for a school district. And like you said, a larger school district maybe could absorb the costs. And I'm a little concerned about some of our really small school districts in smaller towns, that it may be a burden of a cost for them. So I'm trying to figure out how we can move forward with legislation so that we're not putting too much of a burden on a smaller district, et cetera. So do you have an idea what the cost would be if your health district was not helping you or not partnering with you?
So right now, the health district supplies 100% of the products that are offered to students, because right now it's exclusively been through the nurses' offices. And they have indicated to me that 1,800 or 2,000 units, so pads per year, they buy by the case, and the cost is under $1 a piece. Okay. So conservatively, I would say that the health department is furnishing $2,000 a year, expecting the consumption to, you know, likely grow, perhaps double. That's where we're saying, all right, we're going to each do $2,000 per year. We're going to be between $4,000 and $5,000 in total. We'll have to see what happens over the next, 22-23 school year to see what that consumption is. And I know that there are some girls that the availability is not there at home. In talking to the nurses at the health district, they have indicated that there are some girls that will take extra home for the night. So we'll probably see some of that here as well.
So then if I could just follow up, do you happen to know if this is unique for your health district, or is that something that most health districts supply to schools free of charge right now?
So the health district here in the Bristol School District, they furnish our nurses. In smaller school districts, the nurses are in the general fund budget within the school district. So you're going to see a difference there.
Okay. And then do you know, can you just, I don't know if you know this, is if somebody does not have the availability of these products at home, can they stop by a local health district and get them for free, or do they have to go to the, does it have to get?
I couldn't tell you if that's the service of the health district.
I'm going to ask that. Okay. Yeah. Thank you so much. That was really
of course
informative. I appreciate it. Thank you.
Thank you, Senator. Seeing no further questions, again, thank you for your testimony today. And we will next move on to Jennifer Love, followed by Karen Nystrom.
Hi there. Thank you all so much for your time and your support. I know it's been a really long day, so I will try to keep this brief for you. My name is Jennifer Love. I am a certified nurse midwife. I work for Planned Parenthood of Southern New England. I do full gynecologic care, including medication abortions. I don't currently provide obstetrics, but that was my past. I'm here today to testify in support of House Bill 5261, an act increasing access to reproductive health care. As a midwife, I am licensed to independently manage prenatal care, conduct deliveries, and manage major obstetrical complications. This requires a much higher degree of expertise than procedural first trimester termination. I also routinely perform colposcopies, endometrial biopsies, IUD insertions, and other procedures that are similar or higher in complexity to procedural abortions. Interestingly, my license also allows me to provide vacuum aspirations to manage incomplete miscarriages. That's a time when the pregnancy isn't viable, but the body hasn't naturally passed it. This is the exact same procedure used to perform a first trimester procedural abortion. There is no medical difference between those two procedures. The only difference is the viability of the embryo. So, there's no medical justification for restricting my ability as a midwife to perform procedural abortions. It is clearly well within my scope of practice. And it is a skill that any advanced practice clinician could be safely trained to do with the correct training. This is something that is just near and dear to my heart. I pride myself on my close relationship with my patients. They come to me for everything from their pap smears, breast lumps, when they get a positive pregnancy test, they come to me for help. And it's not a good feeling for me to tell them that they have to go see somebody else to get this procedural termination, for no medical reason. I love my patients. I love my job, and I want to be able to help my patients. I want to be able to practice, to the full extent of my training. So, that's really what I have to say about this. Thank you for your attention.
Thank you, and for the passion of your testimony. Representative Gilchrist has a question.
Thank you, Mr. Chair. Thank you, Ms. Love, for being here and for the work you do. You're one of there's been a few people who've talked about this continuity of care, and I appreciate folks raising that because I think far too often when we're talking about abortion, there's just this acceptance that it would be kind of this additional or add-on or separate from healthcare. And so to hear that, of course, a patient would want to get that healthcare from the provider they're most comfortable with makes sense. So I appreciate that. My question, I'd love you to dive a little deeper. You're the first person, I believe, to raise the fact that you were mentioning with miscarriage, you provide a procedure that's very similar to aspiration abortion. Can you speak more to that?
Yeah, absolutely. So as part of my current work at Planned Parenthood, that's not something that I do. But as a midwife, my license includes the management of miscarriage. And the way you manage a first trimester miscarriage where the pregnancy has not passed is through what we call a manual vacuum aspiration. And so that is literally the procedure that is used to perform a first trimester procedural abortion. Exact same procedure, exact same, potential risks. So clearly, if that's something that I am qualified to do, there's no difference except for the viability of the pregnancy.
Sorry, my dog is bopping my arm. Thank you so much for your answer. Thank you, Mr. Chair.
Thank you. I see Senator Summers has a question as well.
Yes, and thank you, Jennifer, for your testimony. I would like to know, so you're a nurse midwife, is that correct?
That is correct, yes.
Okay, so is a nurse midwife license and training slightly different than an APRN?
So and that's a really good question, and I feel like that's a really important point. A nurse midwife is a kind of a specific specialization of APRN. So we do specialize in women's health and obstetric care. So, honestly, that does give me, I have been lucky that my training has really been focused in this area of expertise. So that being said, the first trimester procedural abortions are a very straightforward skill. They are considered a basic entry-level skill that any nurse midwife right out of school should be able to perform. Mm-hmm. So that the fact that I am lucky enough to specialize in this does not mean that only midwives are qualified to provide this service by any stretch of the imagination. it is a skill that, just like we teach our physician assistants and APRNs to do IUDs, other similar procedures with the appropriate training, this is something that any advanced practice clinician would be able to safely perform.
Okay, but currently it's within the nurse midwife scope of practice.
Mm-hmm.
And we haven't gotten a clear answer if it is in an APRN's current scope of practice. That's where I think some of the issues are. So, and I understand the need for clinicians, and I understand, as I said before, I'm just concerned about the scope of practice portion of it, that we don't want to skirt what we have in process or in the way that we normally handle these things, and allow an expansion of a scope of practice without it going through the scope, or something that we're going to do in the regs to ensure that that APRN has the additional training that they would need to be able to perform this. So I just wanted to clarify, a nurse midwife has different training than a standard APRN. So I just wanted to understand that. And I don't know if you heard the speaker before, and I apologize, I can't remember her name. She was a clinician who talked about 40 procedures within training under supervision would be what she considered to be sufficient then to allow an APRN to move forward and be able to provide this procedure on their own. Do you agree with that type of training?
Yeah, and I think I'm just so glad that this is what you're focusing on, because it really, the most important thing is patient safety and patient access.
Mm-hmm.
So the first thing I would say is that this is a skill that's at a level that it does come down to training, but the baseline education and skill set of any advanced practice clinician is sufficient to allow them to achieve the training necessary, if that makes sense. Right. It is first trimester procedural abortions are a very straightforward skill. I think for a long time, first trimester abortions were called surgical abortions. And I think that word surgery kind of gets people a little bit nervous and kind of makes you think that the procedure is more complex than it actually is. Currently, APRNs, PAs routinely perform colposcopies, IUD insertions, biopsies, things that again are at or exceed the same level of complexity with adequate training. So I don't want in any way from my testimony to be construed to say that I don't think my APRN and PA colleagues aren't qualified. And in terms of scope, my scope, it is a tricky area because I specialize in women's health, but abortion access or first trimester abortion is something that is well within the procedural scope of the education of APRNs and PAs in general. In terms of what I think adequate training it's a big question for me when I think about it. I think about the past training I have done for my deliveries, colposcopies, things like that. And I would say 50 supervised procedures for a first trimester vacuum aspiration.
Okay, thank you. One of the reasons why I wanted to ask you that question on your scope is because I didn't want it to be convoluted that because you're a nurse midwife, that your scope was exactly the same as an APRN scope. And I just wanted to clarify that because you do have this extra training. But I'm hearing you say what we've heard before, that an APRN with the proper training should be able to safely perform these procedures. So we just have to figure out, is that within their scope of practice? And, DPH needs to weigh in. And if so, how do we proceed with updating our regulations so that we can ensure the proper training of these individuals to provide a service for women for a variety of reasons, for continuity of care, for access, etc. So I just wanted to ask you that so we could be clear. I don't want people mixing them together saying you can do it and we're talking APRNs and other things. And I just wanted to be clear. So the APRNs and the midwife, the nurse midwife, you are allowed to perform these aspiration terminations for up to 12 weeks. Is that correct?
So currently we don't, in Connecticut, no non-physicians perform first trimester abortions, but the same procedure can be used to manage miscarriages, and that
Right,
is something
but I guess I should have rephrased my question. If that is allowed and you were allowed to do that, it would be up to 12 weeks for the aspiration.
Yeah. First trimester abortion is a different situation than second trimester abortion. Yes.
Right. So
Different
that's
skill
all I
sets are
was that was asking. So thank you very much. Your testimony was really helpful.
Thank you so much.
Thanks.
Seeing no further questions, again, thank you for your testimony. Really appreciate it. Next up is Karen Nystrom, followed by, well, we'll get to that in a minute. Karen?
Hi, good afternoon. My name is Karen Nystrom. I'm a nurse practitioner and the program manager for the Comprehensive Stroke Center at Yale New Haven Hospital. I want to thank the distinguished members of the Public Health Committee for the opportunity to provide testimony this afternoon to advocate for support of Senate Bill 5273. As was mentioned in our earlier testimonies, almost all Connecticut hospitals are certified stroke centers. And as such, these programs comply with national standards for delivering evidence-based stroke care to patients suffering from stroke. Certified hospitals must demonstrate compliance with these standards using validated measures and collecting data to evaluate both processes of care as well as patient-related and system-related outcomes. The proposed statewide stroke registry would allow the state to gather selected data from all stroke programs in Connecticut. And this database would aggregate those measures and would provide critical insight into both clinical practice as well as identifying potential disparities in healthcare delivery. The registry would also allow for the surveillance of trends in treatment and quality of care. Many states across the country have established registries, and in follow-up to one of the very astute questions this afternoon, our team will provide some follow-up references that show improved access to stroke care as well as improved outcomes. The State of Connecticut Stroke Advisory Council, otherwise known as SOCSAC, is a voluntary team of stroke stakeholders representing stroke programs across the state. And SOCSAC supports a collaborative partnership with the Department of Public Health to oversee data and best practices which will support and strengthen hospital systems of care across the stroke care continuum. This will translate data into better outcomes, lives saved, and have a substantial impact to reduce the burden of stroke. As my colleagues previously commented during their testimonies, the proposed bill has several revisions to the original draft that we feel best expresses the intent of our mission, which is to promote resources to oversee the database and to encourage hospitals to see the downstream benefit of a rich database to improve care. I thank you for your time. I think my colleagues did an excellent job of describing in some detail some of the efforts put into the Senate bill, and I'm happy to answer any questions that you might have.
Thank you. You're correct. Your colleagues have done a great job, but it's still good to hear it one more time. We're
very good.
I don't see any further questions. So thank you for your testimony and for your patience waiting. What is it? We're approaching now 9 hours. So thank you.
Not a problem. Thank you.
Next up is Anthony Santella, followed by Tina Yates.
Good evening, Public Health Committee. I respectfully submit the following testimony in support of House Bill 5190, an act concerning testing for HIV. By way of introduction, my name is Dr. Anthony Santella. I'm a professor of health administration and policy at the University of New Haven. I also sit on the American Public Health Association's HIV/AIDS section, the New Haven Fairfield County's Ryan White HIV Planning Council, the New Haven Mayor's Task Force on AIDS, and the Connecticut HIV Planning Consortium. I've worked in public health, specifically HIV and sexual health, for the past 20 years. And so I am here to tell you loud and clear that expanding, routinizing, normalizing HIV screening is what's needed to end the epidemic. Clearly, more work is needed to normalize this part of healthcare. I believe the proposed bill is important because it will provide us a tool to significantly lower the number of Connecticut residents who remain undiagnosed. The HIV care continuum, which is the public health model that outlines the process someone goes through from diagnosis to achieving viral suppression, the ultimate goal, starts with the HIV test. And so we need to do everything possible to expand HIV testing. Moreover, national policy efforts also support this legislation. For example, it's the first goal in the National HIV Strategic Plan. It's also been widely endorsed by the U.S. Preventative Services Task Force, the independent volunteer panel of national experts who grade evidence-based medicine. They gave the HIV screening a grade of A, their highest grade. Finally, it is critical that this bill include funding for a rigorous evaluation. Program evaluations collect, analyze, and use data to examine the effectiveness and efficiency of policies and programs such as this one to contribute toward continuous program and policy improvement. It'll be important to conduct a rigorous evaluation to examine the quantity and quality of what was actually implemented in practice and why, and this may facilitate interpretation of program outcomes. Additionally, an outcomes evaluation would establish indicators and collect data at baseline now, prior to the start of the legislation, and continue throughout the implementation phase to see the impact that this bill can have on the health of Connecticut residents. Again, I strongly support 5190, and I urge you to favorably pass this important bill. Connecticut wants to be known as a forward-thinking, public health-friendly state, and I think this will do that. Thank you.
Thank you, Doctor. Yes, we do want to be known as that. We have some work to do to honor that expectation. As you said, you've worked in this field for 20 years, and you referred to the problem as an ongoing epidemic. And, we unfortunately are all too familiar with epidemics and pandemics these days, but many people would have thought that we would have been past this by now. You made reference to the fact that there are undiagnosed out there, and the order of magnitude of the actual epidemic is not well known. How do we get any sense about how many people are undiagnosed?
Well, we've had reliable and valid HIV tests approved by the FDA for many, many, many years now, decades now, and we still are talking about the problem of undiagnosed persons with HIV. So it tells you that relying on what's been historically won't move the needle as far as it should. Nationally, the CDC estimates about 14% of people living with HIV remain undiagnosed and may be unknowingly spreading it to other individuals. And we know that because, as I think a few folks mentioned earlier throughout the day, that there are a number of people who are concurrently diagnosed with HIV and AIDS at the same time, meaning they've been living with their virus for a long period of time. We also know that people, will present to emergency rooms and other forms of tertiary care because they're just experiencing symptoms that a provider would kind of get a clue that maybe an HIV test is required as part of that. And so I can tell you that, most providers out there, unless they suspect someone is quote unquote high risk or marginalized or vulnerable, are not offering a test. And so this is something that can easily be done. It's the offering of the test. And when this happens, I'm hoping it's not if, but when it happens, the next conversation will be talking about other chairside screenings. Hepatitis C is just as prevalent, more prevalent. And there are other, issues of public health significance that can benefit from, retooling how we offer healthcare.
Thank you for that, Doctor. Really appreciate your testimony today. I don't see any further questions, so have a good evening.
Thank you.
You'll be done before we will. Next up is Tina Yates, followed by Samantha McCoy.
Good afternoon, Representative Steinberg and members of the committee. Thank you for the opportunity to provide testimony on Senate Bill number 254, an act requiring long-term care facility residents to undergo criminal history and sex offender registry search. My name is Tina Yates, and I am the president of the Connecticut Association of Residential Care Homes, also known as CARCH. I am also the administrator at the Eliza Huntington Home in Norwich. I am testifying today in strong opposition to Senate Bill 254. We have submitted detailed written testimony covering all of our concerns. However, today I'd like to focus on some of the key concerns, such as the list of 81 disqualifying offenses and the fact that it is an overly expansive list and unclear what rationale there is for including some offenses over others. Perhaps our biggest issue with the bill is the complications and cost that this will add to the resident admissions process. As a reminder, residential care homes care for some of the most vulnerable residents in the state. The vast majority of our residents have a behavioral health or mental health or substance abuse diagnosis. In fact, many of our residents, they've lived in those residential care homes for multiple decades, 20 to 30, 25 years. So it becomes their home and their extended community. This legislation would require the Department of Public Health to be actively involved in the admissions process. They would create a registry and they would set up the entire waiver process. DPH would also be the sole decider of which residents receive waivers. Under the bill, a home could conditionally admit the resident before the background check is complete, but most homes will be very unlikely to do so due to the potential complications. For instance, if the resident is admitted into the home and a criminal record comes back after the admission, how would the home go about discharging the resident? If the resident objects to the discharge, despite the criminal offense, the home would then need to go through the involuntary discharge process, creating additional delays and costs. Even with such conditional admission, the resident would then be required to have constant supervision by the staff of the facility during the course of such conditional residency period. This would be an added unfunded mandate on an industry that simply cannot support it. Finally, we would be remiss not to point out our concern that this is very likely to result in discrimination against many of our residents that we already serve. Our residents, again, often have mental illness or substance abuse diagnosis, and with that can come years of past trauma and other history. The likely result of this legislation is that there will be less choices available for long-term care and limited options for some of our clients that we already serve. For instance, we know some homes do have residents that have criminal histories. Those residents who eventually may need a higher level of care would be prohibited from a nursing home admission without a waiver.
Excuse me, Ms. Yates, your time is almost up. If you reset, please summarize.
The legislation will only make it harder for those residents to find a future housing placement and will add additional cost to the time to the admission process to get them in. We appreciate the opportunity to offer testimony and would urge the committee not to move forward with this legislation as is. Thank you.
Thank you for your testimony. We appreciate it. I do not see any questions, so thank you again. Next up is Samantha McCoy, followed by Sarah Fox. Samantha.
Good evening, and thank you to the respected members of the Public Health Committee. My name is Samantha McCoy, and I am testifying today in favor of House Bill 5278 on behalf of Warriors Care. Warriors Care is a national nonprofit organization dedicated to ending sexual, physical, and emotional abuse. House Bill 5278 prohibits the practice of non-consensual intimate examinations on unconscious patients. This bill ensures autonomy and dignity to the patient while still permitting students to practice their clinical skills through a standard of explicit and informed consent. This bill poses no threat to the quality of education that medical students receive and ensures a minimum level of respect and care towards patients. If asked and informed ahead of time, there are patients who will consent. This is the proper and only permissible route in which a physician should perform intimate examinations. Clinicians travel to Connecticut to practice from throughout the United States with a variety of educational and professional backgrounds. And there is certainly evidence that this practice goes on throughout the United States. For example, Dr. Silver Eisenstadt, who submitted written testimony in support of this bill, co-authored a study called Don't Ask, Don't Tell, where he surveyed 401 students at 5 Pennsylvania schools. He found that 90% of medical students had performed pelvic exams on anesthetized patients, and that there was a reduced appreciation for the importance of consent in these patients. That is simply frightening and flies in the face of the consent culture we are trying to foster. It raises the question, why is there so much resistance on simply requiring explicit consent? It is a simple ask to a patient that will not only maintain respect and trust for the medical professionals, but will also ensure a standard of consent throughout the entire medical community. Approximately 19 states have now outlawed this practice, including but not limited to Texas, New York, Virginia, Iowa, Hawaii, Utah, and Delaware. With all due respect, I want to briefly address Dr. Amy Brown's testimony from earlier today, which argued that the bold font in the bill explaining what procedures to come should be removed because it will draw undue attention to that section. To me, that is a concerning proposition. The bold font states, and I quote, "Consent for examination of pelvic, prostate, or rectal region." That language assists in explicitly informing the patient what will happen. Why would attention being drawn to the explanation be unneeded or undue? In fact, that is the very definition of explicit and informed consent. To try and hide such information is neither informed nor explicit. We are not the only voices in support of this bill. An overwhelming 107,000 individuals have signed our petition in favor of this bill's passage. Each signature signifies a human being who is frankly horrified of the idea that such a practice continues today. Each signature is further calling on the respected members of the Connecticut legislature to protect its constituents and ensure medical staff are respecting their patients' rights to say no. Thank you for your time and consideration, and I look forward to your favorable votes on House Bill 5278.
Thank you, Samantha. Just to follow up, you mentioned 107,000 signatures. Those are all Connecticut residents?
It is not. Because we are a national organization, it does include other states.
Would you have a sense of what percentage are Connecticut?
I can look that up and get back to you, and I can send that in an email to you.
Not critical, it's just curious, but it suggests a very well-organized effort. Thank you for your testimony. I don't see any further questions, but we appreciate your taking the time to join us today and for hanging in for 9 hours, and we wish you a good evening.
Thank you, you as well.
Thank you. Sarah Fox, followed by Michael Barata.
Senator Anwar, Representative Steinberg, and distinguished members of the Public Health Committee. My name is Sarah Fox. I'm here today as a resident of North Haven, as someone, and also as someone who lives with stage 4 endometriosis. I'm really grateful to be a participant on the endometriosis working group. And to be able to raise my voice in support of HB 5303, an act concerning continuing medical education requirements concerning endometriosis and cultural competency, and the creation of a plan for endometriosis data and sorry, I can't pronounce this word, but you get the gist. I'm also here in support in my role at the Connecticut Coalition to End Homelessness of an act concerning menstrual products. I would say, as someone who's lived with endometriosis, my whole life, and I say my whole life because it started at a very early age. My upbringing, I grew up in poverty, and as a teenager, I get emotional, and I'm sorry, but as a teenager, I didn't have a lot of agency, and I went to doctors, many doctors, and no one was able to identify what was wrong with me. I thought I was lazy. I thought there was something, I thought I had a mental illness. And this continued into my young adulthood and then into my adulthood, where ultimately at 35, I saw a doctor. I went in for fertility treatments. I had an operation. I was found, and the doctors found what they said, a lifetime of endometriosis within my body cavity. I had an extensive surgery. The endometriosis was cauterized. They put me on birth control. I again went to doctor after doctor where they said that there was not much they could do for me. They wanted to put me on opioids, on muscle relaxers. I worked at CCH. My boss was then talking about me going and working part-time, reducing my hours. But then I finally found one physician, Dr. Tamar Sekin. He's one of the top doctors in the nation. He actually co-founds the Endometriosis Association of America. I sent him an email. He had me in within minutes. Within 2 weeks, literally, I was in, and I was having a procedure that saved my life, changed the quality of my life. And I had agency I am an advocate. I could advocate for myself, and I speak before you today as someone who's really dealt with the worst that this disease has to offer. I understand that we need good quality care for people, that this is an issue that also disproportionately impacts women of color who face real problems getting the treatment that they need. And for me and for so many others, this is a real matter of importance. It affects almost everyone. You speak to women and, it's almost everyone within your circle. You have a conversation. It's someone you know. It's someone in your family. It's one of your friends. And
Excuse
it
me,
is
Ms.
devastating.
Fox, your time is almost up. If you would
So I will
summarize,
just say, this bill's not perfect. We definitely need more training. We need specialists in our own state who understand this disease, because there are gynecological professionals who have no idea about how to actually adequately treat and care for endometriosis. I still have a real difficulties finding practitioners who can care for my continued endometriosis within this state. So I shouldn't have to leave the state to find care. I have that luxury and I'm fortunate to be able to do that, but so many others don't. And this disease is debilitating. It's costly. It keeps women out of the work, keeps people out of the workforce. And it's just something that we really need to lean in and pay attention to. So thank you for hearing my testimony, and thanks for, and I'm very passionate about Connecticut doing better by women and by all individuals who live with endometriosis.
Thank you for your testimony. Yes, you were indeed quite passionate. I would suggest that perhaps you were lucky to run into a physician who could actually help you, but you had to put up with an undiagnosed problem for decades before that even happened. So your point with regard to having an adequate number of professionals who are in a position to help people like you is indeed our goal. We have some questions for you. Representative Gilchrist, followed by Senator Anwar.
Thank you, Mr. Chair. I do have a question, but I want to start with just a few comments. I want to thank Sarah Fox publicly because she came to me soon after I was elected back in 2018 to discuss endometriosis with me, and I'd never heard of it before. And she explained what she had gone through. And then in doing research and now having held the endometriosis working group, unfortunately, I have heard from many, many, many women who have a very similar experience to Ms. Fox, and women of all ages, as we heard earlier from our colleagues who feel as though this wasn't discussed 50 years ago, 30 years ago. Well, it's still unfortunately the same today. So I also appreciate that Ms. Fox could recognize that she is an advocate. And in having that conversation, we discussed how for those who don't don't have that ability to go advocate or reach out or go to another state, what kind of care are they receiving and how are they suffering through endometriosis? So thank you, Sarah. The question I do have is, you mentioned stage 4. And the working group has taught me so much, but one of the things is that there are stages. So could you just speak to the stages of endometriosis to educate folks on the committee?
Well, I could just say this is just like every other disease. A lot of people think about the uterus as where endometriosis actually exists, but it exists within and can be found all over women's bodies. In your eye, you could have endometriosis. For me, I have endometriosis within my bladder, within my bowels, I have a severe case of adenosis as well, which led to my uterus being removed, but it was mainly in my body cavity. And when your hormones sort of act up, stage 4 means like basically you're living in pain, excruciating, glass shattering pain within your body every single day. And it starts off where it could be weekly, and all of a sudden you are just bent over trying to function the best you possibly can. And so my level of endometriosis is one of the highest, and it ultimately led to like my organs being bound together because of ablations within my body cavity due to the endometriosis. And so it's a severe case that I live with. And even though I've had the best care after 7 years of having a surgery, having excision surgery, you can expect a reoccurrence. And so I deal with that. And sometimes I'm the level of exhaustion that comes with this disease, having to really carefully monitor this disease. Many liken this to a form of cancer. It's deep, for me, it's deep infiltrating, and has just caused huge issues with my bowels and with my bladder.
Thank you so much, Sarah. Thank you, Mr. Chair.
Thank you. Senator Anwar.
Thank you so much, Mr. Chair. Thank you, Sarah, for your testimony. Good to see you again, and good to see you with your advocacy work. I know Sarah because of her work for ending homelessness, and she's one of the most effective advocates to help people fight homelessness in our state. One of the most important. I'll have some other people get upset if I say the most, but I just wanted to ask you, did you, in your journey for diagnosis, were you able to interact with the OBGYN doctors as well, and even they had missed the diagnosis?
Yes, and I guess that's why, I was listening and I wrote this, when Mark Thompson was speaking, one of the things that I noted was, I honestly, I don't need every single doctor to be trained in endometriosis. I need specialists. I need people who are practicing women's healthcare, from pediatrics all the way up to women's health, to understand this disease, to understand the symptomology, and be able to say, okay, so all of this constellation of symptoms makes sense, because I have countless, every single person who comes to me because they hear of this disease, they tell me the same symptoms. And I'm like, oh, well, you know what? You should speak to your doctor about endometriosis. There's simple screening tools that could be put in place in our schools. There's different levels and mechanisms that could be put in place to ensure that our OBGYNs understand. I mean, I won't call out my most recent doctor, but, I was just at the doctor's, and I said, I have a severe case of endometriosis, and I got, a blank stare back at me. And it's harmful to a patient to feel as though they're so misunderstood by the medical community. And but it's those who are treating women's health issues primarily that I would like to have understand the nature of the disease, and to have some form of standardization across the medical community of what the best practices are, and standards of care are in treating, so that we can move forward and women and I'm sorry to say women, so all individuals who experience endometriosis can really have the care that they need to survive and thrive.
I agree with you, because I think I'll just expand it further, because the presentation initially could be somewhat non-specific, and even the primary cares are the ones who will probably hear about this before the OBGYN would. And then I think it's worthy for having some level of understanding about the pattern of symptom profile and how it can manifest, and how sometimes the manifestation can be outside of the organ of source, if you will. And that's part of the challenge that it can present in some of those stages. And I think that's why primary care, but also OBGYN are the area where having some of the latest information and techniques, and maybe offline, I would love to learn about the treatment that you were able to get outside of Connecticut that you were not able to get in Connecticut. So we'll talk about that probably later, unless you're willing to share less than 30 seconds.
Well, so I saw Dr. Tamar Sekin. He is a world-renowned specialist in this, but under his tutelage, Dr. Luciano, who I believe testified and is a member of this working group. So she's someone who is not in my care network, but who provides this level of service in Connecticut, but is one of the only ones that I've heard of. And she works for UConn Health.
Perfect. This is very helpful. Thank you again, and good to see you. Thank you, Mr. Chair.
Thank you. And again, I'm not sure there's anyone in the state of Connecticut who could testify with as much experience as you have brought to us today. So thank you so much. I don't see any further questions. Have a good evening. Next up is Michael Verada, followed by Linda Alderman.
Good evening. And I would like to thank Chairperson Steinberg, Senator Anwar, and the Public Health Committee members for for giving me this opportunity to provide testimony and to express my full support for HB 5190, an act concerning testing for HIV. My name is Michael Verada. I'm a licensed practicing physician in Connecticut, specializing in infectious diseases and an advocate for health equity. To provide the setting, I would like to make everyone understand that we've been fighting this specific battle for over 40 years and just have started to get a better handle on the situation. HIV has affected close to 80 million people worldwide, including adults and children with no racial or ethnic predilection, from all gender identities and sexual orientation, high income or resource challenged individuals. No longer is it an illness of marginalized populations. In time and with solid science behind the efforts, HIV has thankfully been turned into a chronic illness. Currently, close to 40 million people worldwide and about 1.2 million in the US are living with HIV, with life expectancies approaching those of uninfected individuals. This was made possible because we developed an arsenal of highly effective therapy that stops the virus from multiplying and spreading to others. The US Department of Health and Human Services launched the Ending the HIV Epidemic initiative in 2019, a collaborative initiative that aims to reduce new HIV infections in the US by 90% by 2030 through scaling up of HIV prevention and treatment strategies. The foundation for EHE consists of 4 key evidence-based strategies, and these include diagnosing people with HIV, providing HIV prevention services, treating those who are diagnosed, and facilitating a rapid response to special situations. Back in 2006, recommendations were put forward by the CDC that would make HIV testing part of routine medical care, encouraging anyone 13 years or older to get tested at least once. In 2012, the first combination therapy for HIV prevention was approved by the FDA, highly effective in interrupting transmission between individuals. And around 2018, there was a call to action to provide HIV treatment as soon as the diagnosis was made. With the introduction of the EHE effort and now additional recommendations from the CDC, the focus has shifted to raising awareness of HIV testing that encourages individuals to learn about their own serostatus. This first step must also be aided by trained professionals who can offer education and a simple test. It will also provide the linkage for thousands to be engaged and retained in the healthcare system who otherwise would remain isolated and without access to new options to keep them healthy and to help protect themselves. When engaged early, they are more likely to be retained in care and achieve good outcomes. The annual health statistics that are reported by the DPH have shown a decreasing trend in the number of new HIV infections within the state, and even in individual cities such as Bridgeport and New Haven.
Excuse me, Mr. Verratti, your time is almost up. If you please summarize. Thank you.
Okay, thank you. So in summary, it's been shown that one of the most effective ways of accomplishing a screening procedure is when a clinical recommendation is presented to a patient by a trained healthcare worker. Patients come to the healthcare systems through many touch points, and access to testing should not be limited just to a doctor's office. So one of the most successful screening programs in the state has been the requirement to offer women HIV testing during pregnancy. And so I think and believe that we can win this war. We can get infections down to 0, but we just need to commit to acting on it. We can work out the kinks, but I do ask the committee to proceed favorably on doing the right thing and be a strong advocate for your constituents. Thank you for your time today and here to answer any questions.
Thank you. Yes, I do hope we can work out the kinks. I see that Senator Anwar has a question.
Thank you so much, Mr. Chair. Thank you, Dr. Verada, for your testimony. Dr. Verada, in my mind, the why is very clear. The how is where some of the people have raised some anxiety. And the anxiety is because they want all the loops to be closed. And in an imperfect healthcare system, which we are living in right now, closing those loopholes, we will have to wait for 10 years. And there will be too many people lost. So can you help convince me and others how, in the absence of an imperfect system, we can make this work?
That's Senator Anwar. That's an excellent point and an excellent question, and I think that's what we all struggle with. And I've heard testimony from earlier today as to why it isn't a perfect system. And I think we tried to address some of that by engaging our colleagues. And I heard Dr. Freese speak, on behalf of the Connecticut Emergency Society. And really, I think there has to be a partnership, and we can find innovative ways to approach that. We have tried several things that, have shown a little success. And I like the idea of having things sort of centralized in terms of connecting people, let's say from emergency rooms, and getting them into primary care. I think there need to be resources in order to provide the navigation that is necessary. But it will all begin with being able to diagnose individuals, trying to figure out, the 8% or 8 to 10% of people in Connecticut who are undiagnosed, but then also offering all of these people who are eligible for protection. And I think that is the other avenue, and we call it a status neutral approach. So people who are HIV negative can keep themselves negative and can access options for protection. So there are a few major components, but I think we just need to sort of come together and sort of create a system that is not broken.
Thank you. This is very helpful. I think after this testimony, I'll probably see if I can coordinate. Representative Curry is very passionate about this, and other people are as well. So I would love to maybe work with you and others to see if we can find a way to make this happen and not necessarily wait for system to get better, because we can't lose people while we're waiting for things to be perfect. Thank you, Mr. Chair, for your testimony. Thank you, Dr. Virata, for yours. Thank you. Oh, Mr. Chair, thank you for allowing me to speak, not your testimony.
Not allowed to testify. Okay, we'll move along now. Linda Alderman, followed by Mary Wagner.
Good evening, esteemed members of the Public Health Committee. Thank you for the opportunity to testify in support of House Bill 5260, an act establishing a Rare Disease Advisory Council. My name is Linda Alderman, and I've lived in West Hartford for 35 years. Many of you know me through my work as state lead for the American Cancer Society Cancer Action Network, or for my work with Are You Dense to advocate for public policy changes to benefit women with dense breast tissue. From prior testimony, you may know that I'm a 2-time breast cancer survivor. But until today, I've never publicly spoken about the rare disease that changed my life and took my career before I was diagnosed with breast cancer. I'm a survivor of adrenal Cushing syndrome, a disease that affects only 1 in 3 million people. In 1997, I was a healthy 34-year-old environmental attorney juggling a thriving legal practice, a young family, and community service. But for the ensuing 8 years, I knew that something was terribly wrong with me. I had a list of significant and strange medical symptoms typical for women decades older than me. I was a trained advocate who did everything I could to get doctors to test for a systemic problem, but none would. And not one of the myriad of specialists I saw over that 8-year period thought to test for Cushing's, even though I was presenting with almost every symptom of that disease. I was only diagnosed with Cushing's in 2005 because at the age of 42, my heart rate became uncontrollable. I had an emergency full body MRI, and a 3-centimeter adrenal tumor was discovered and then surgically removed. Because Cushing's was allowed to progress untreated for 8 years, it not only almost killed me, but caused permanent brain damage and cost me my legal career. I've been on full disability since 2006 because of memory loss and slow processing that will never fully recover. But even worse than the physical insults of the disease was the fact that no one I knew had ever heard of Cushing syndrome, and there was no one who could relate to or understand my experience. I felt completely alone. Just as I was getting through the worst of the fallout from Cushing's, I was diagnosed with breast cancer. My breast cancer experience was completely different from my rare disease experience. I felt heard and supported, and I didn't have to be an advocate or almost die to get the care I needed. Cancer treatment was incredibly frightening, but I felt so supported, cared for, and understood by doctors, friends, extended family, and society at large. I welcomed that support, but it came in stark contrast to the loneliness, isolation, and hopelessness I suffered because of a rare disease that not even most of my doctors understood. House Bill 5260 will provide those suffering from a rare disease with a resource to get information and support. It will give rare disease patients and survivors a way to communicate with and educate legislators, state administrators, and physicians about the needs of rare disease patients.
Excuse me, Ms. Alderman, go ahead. Your time is almost up.
Okay, I'm almost done. I strongly support this bill, but would ask, however, that it be amended to include one additional adult who has personally experienced a rare disease. Right now, there's a maximum of 2 allowed on the council, and there could be only 1 at any given time. And that's just not enough representation. Thank you for this opportunity, and I'm happy to answer any questions you may have.
Thank you so much for your testimony. Truly appreciate your insight, and I'm glad it was diagnosed in a timely fashion, because undiagnosed Cushing's and God forbid an emergency would result in a disaster. So I'm glad you're well, and thank you for your advocacy. I see Representative Gilchrist has a question.
Thank you, Senator Anwar. Not a question, just wanted to say thank you to Ms. Alderman, not only for your testimony on this bill, but all your work on preventing and addressing breast cancer. Thank you so much.
Thank you. And Senator Anwar, I appreciate your comment, but I do need to say that it took 8 years to diagnose my disease. And had it been diagnosed in years 1 through 5 or 6, I wouldn't have had brain damage, and I wouldn't have lost my legal career, and I wouldn't have almost died. So I thank you, but to me, it wasn't timely at all. And my hope is that information will be provided by this council that might allow for doctors to become more educated about rare diseases. And so people will not have to wait 8 years for a diagnosis of a rare disease.
So true. Thank you so much.
Thank you.
Seeing no other comments or questions, we'll move on to the next person on our list, which is Emma Hines. Ms. Hines.
Hello.
Hi.
Good evening. My name is Emma Hines. I'm a current graduate student at UConn, and I have of social work. And I also have a bachelor's in women and gender studies. Today I'm speaking on behalf of HB 5303. While I have focused my passion to promote feminist objectives, my sister has dedicated her passion to science and is currently researching endometriosis at Boston's Children's Hospital in the Rogers Lab. It's not surprising that we often share lengthy conversations on the subject of endometriosis, even more so now that we are both under the process of being diagnosed with it. My sister and I have talked about how endometriosis as a disease has been overlooked by the medical community and by society as a whole due to its association with the female sex. We have even talked about how this experience is worse for women of color, as well as how difficult it is to get research funding. My sister has seen firsthand how male-centric the male-centric medical research is. I have confided in her my experience with doctors, gynecologists, my menstrual cycle, dysmenorrhea, and dyspareunia throughout my life, and now I will share some of that experience with you. When I started menstruating in middle school, it was unpredictable and painful. However, it started to feel like every time I got my period, it got worse and worse. One morning in my freshman year of high school, I woke up with such bad menstrual cramps that I vomited from the pain. For what felt like the rest of high school, I would miss school at least once during my menstrual cycle. When I finally talked to my pediatrician, her solution was to prescribe me pain medication. Then when I was 16, my pediatrician recommended I go on the pill. I didn't know much about birth control at 16, except for that it prevented pregnancy. What I didn't know was that the pill she gave me was an estrogen-based form of birth control. My sister and many other scientists and doctors who have studied endometriosis will say that it is an estrogen-dependent disease, meaning that estrogen-only birth control wasn't going to alleviate my suffering. There were so many things I missed out on due to my extreme menstrual pain, but mostly it impacted my education. When I finally went to see a gynecologist, she refused to give me a pelvic exam because she thought I was too young. She refilled my estrogen-only birth control and I went on to suffer, coping with the pain. When I saw a new gynecologist, she switched my birth control to a progesterone pill with the hopes that it would alleviate my extremely painful menstrual cycle.
While this change did help, I continue to suffer from chronic pelvic pain, back pain, and dyspareunia, which are all signs of endometriosis. In 2020, my gynecologist finally suggested that I may have a touch of endo, and I was supposed to have a pelvic laparoscopy done, but the COVID-19 pandemic prevented it. My sister and I have talked about how I'm not alone in my experience, but many people with uteri have been medically misunderstood. Therefore, it's not surprising that it can take up to 10 years to receive an endometriosis diagnosis, and that many individuals are misdiagnosed. Supporting this bill will help change dynamics of how this painful disease is handled so that individuals like me are not medically misunderstood for years and receive proper diagnosis and treatment at a younger age. Thank you.
Thank you so much for your testimony. Thank you for your advocacy. And I'll share with you this in initial part of your testimony, what you suggested, there's data to show that the male doctors do not provide female patients the same level of pain medicine that the female doctors may, especially for some women's health related issues and women's health related pain. So there's data that shows that as well, that the male physicians have to have a better understanding in this aspect. So thank you for raising that awareness as well. I have Representative Gilchrist who has a comment or a question.
Thank you, Mr. Chair. Thank you so much, Ms. Hines, for being here as a fellow policy practice UConn social worker. It's nice to hear your testimony. We'd love you and your sister to participate on the working group, so it'd be great to connect with you after today's hearing. Thank you for your testimony.
Yes, thank you. That would be lovely.
Excellent. All right, seeing no other comments or questions, thank you again. And we will move on to the next person on our list, which is Mag Morelli. Ms. Morelli.
Thank you, Senator Anwar. Representative Steinberg, my name is Mag Morelli, and I am the president of Leading Age Connecticut, a statewide membership association representing not-for-profit provider organizations serving older adults across the continuum of aging services, including not-for-profit skilled nursing facilities, residential care homes, and assisted living communities. I'm here tonight to testify on Senate Bill 254, an act requiring long-term care facility residents to undergo a criminal history and sexual offender registry search. Leading Age Connecticut recognizes that this proposal is attempting to address a concern regarding the safety of staff, residents, and visitors of nursing homes, residential care homes, and assisted living communities. We begin our testimony by saying that we are willing to work with all interested parties on the issues of health and safety in these settings. We do, however, believe that more attention needs to be given to this specific proposal before it is moved forward. There are many, many federal and state laws, rules, and regulations surrounding the nursing home, residential care home, and assisted living community settings. And we need to consider them in such a proposal as this. We also, from an implementation perspective, a number of issues arise when you look at the requirements and the timelines included in this bill. So based on this, we would ask then and recommend that the committee convene a work group to evaluate and address the concerns that precipitated this proposal and seek solutions that take into consideration the intervening statutes and regulations that control these settings. Also, as we're talking about background checks, the nursing homes and assisted livings currently are required to do extensive criminal background checks on their employees. We've been doing this for several years, but we have an issue and we would like to ask your assistance in it. The current fingerprint scanning process for this background check process can be a logistical nightmare for job applicants during this current workforce crisis time. And it's an issue that can hamper or delay the hiring of aging services staff. The problem is that you can only get your fingerprint scanned at the police barracks, which are only in 12 locations. And we just ask for some consideration to be given to opening up the opportunity to have your fingerprint scanned at more locations to assist people who are applying for these jobs in the healthcare field. So thank you very much for this opportunity to testify. I'd be happy to answer any questions.
Thank you so much, Ms. Morelli. Thank you for coming to testify in front of this committee again. I do have a few questions. With this particular case, the Sentinel case, if you will, that resulted in our conversation that we're having right now, we were informed that there is no regulation that requires in the state of Connecticut or federally for somebody coming from Massachusetts or any other state to Connecticut to a nursing home to have a background check done. So, and that is why, unfortunately, a lot of patients who from within their own states who are being rejected come to Connecticut because there's a loophole that is allowing many of these patients to come into our nursing homes. That is part of the reason that we have to have that check now. That's what we were informed when we started to look into analysis of what's going on. And the idea is not to restrict the patients, but idea is also to make sure that the staff that is working in that environment, we need to protect. And I'm very sure that you are on board with me on that, to protect every single worker in your company and in all the nursing homes as well. So then we find out, is there a risk analysis that can be performed to make sure that we have a risk assessment, and that would allow individuals to be assessed and then decisions be made based on their potential risk of harming someone?
A risk assessment. I think there probably can be a lot of things that can be done. Things are, when someone's aware that there is a history, that someone does have a background like this, is on the sex offender registry, say in Connecticut, because you'd have to disclose that if it was in Connecticut and you were moving within Connecticut. You have to make sure you take the precautions, make sure you're able to provide the appropriate care to that resident to meet the resident's needs. And very often that can be, if you receive a resident like this and you realize that that there is a threat, you'd have to put a one-on-one person on that resident. This has happened in several settings. I'm not sure. I don't know the exact details. I know the published details of what happened with someone coming in from another state. And if the people were aware of that and did not notice the nursing home that this was the case, then that is a true issue. And I think that there can be precautions taken. If someone does do a background check, you can take the necessary precautions as they're living in the building. But some of the provisions that are in this particular proposal are not taking into consideration, for instance, the involuntary transfer discharge laws that we have, the waiting list laws that we have, and other things and procedures that would need to be considered. In the assisted living setting, it's a landlord-tenant obligation, so you'd have to go according to housing and fair housing law if you're asking someone to be discharged from the assisted living community or not accepting them into the assisted living community. All things that can be addressed, but I think they need to be addressed. I think maybe the working group needs to be expanded so we can talk a little bit about the regulations and the statutes that currently are restricting what can be done in these three settings.
Again, like you stated, if it was somebody from within Connecticut and they're already on the list, that's easy because then you already know about it. Right. The loophole is that if theoretically somebody moves from, I keep saying Massachusetts because that individual was from Massachusetts, that if an individual comes from Massachusetts and lives in our neighborhood, in any one of our neighborhoods, there would be a process at that point. Except if that person comes from Massachusetts and goes into a nursing home, there's zero process in the state of Connecticut. That's the issue.
The nursing home, so if they were, and excuse me for not knowing this, but if they were to come into living in the neighborhood, they would have to notice the police that they're living in that neighborhood as if they were like in Connecticut. But wouldn't the nursing home is their address, so they wouldn't have to notice the police in that town?
As of right now, as we speak right now, they're not required to. And that's the problem. And it is just only fair to the patients next to that individual, and also fair to the staff that's taking care of that person to be able to say, yes, it's important for us to know that. Just because if they were from Connecticut, they would know it. But if they're from out of state, they don't even know it.
So it's a matter of getting the person onto the state's registry.
And right now, there's no law that allows that. And some people knowingly may not report that.
Well, I'd be happy to talk offline about how we might be able to address that then. We just see some real problems with the way it's put into this statute and on the way it would be implemented and be able to be achieved. And it would hold up quite a few admissions and, the process you're prohibited from involuntary discharges for certain things. And so it would need to have to be incorporated into the existing regulations.
Yeah, we'll clean it up. We'll work with after this conversation today with the public hearing, we'll try to make sure that we become laser focused on the issue at hand.
Okay.
So
that sounds,
I see.
and we'd be happy to be part of that discussion.
Would love that. Representative Cook has a question or comment.
Thank you, Senator. Hi, Meg. It's great to see you. I just want to make a comment regarding what the good senator was trying to get his point across to. Although we do have a law that you are supposed to register as a sex offender when you move into point A, point B, wherever you go, that does not happen all the time at all. And I think that that's really where the concern lies. For folks that don't have the ability to defend themselves or do some of the searching and the researching, and the folks that don't follow the law, I believe is really what the intent of this is. So I'm really hoping that we can find a manner in which we can make it move forward, because it is, although it might be complicated policy, it is good policy to ensure that we can protect folks. So I'm happy to help work on it as well. But I just think it needs to be noted that not everybody follows the law and tries to get away with all sorts of things and we have to take that into consideration as well. So thank you, and thanks, Senator.
Thank you so much. Thank you, Ms. Morelli, for your testimony, and thank you for the work that you do.
Thank
Seeing
you.
all the questions or comments, we will move on to the next person on our list, which is Myrna Watanabe. I could have messed up your last name. I'm sorry in advance, followed by Philip Morella. So. Hi. Myrna.
Hi, Senator Anwar. Okay, I thank the members of the Public Health Committee, chairs Representative Steinberg and Senator Anwar, and ranking members Dr. Pettit and actually it's Dr. Huang also, yes, and Senator Summers. I'd like to explain my support of HB 5260, an act establishing a rare disease advisory council. My name is Myrna Watanabe. I've lived in Harwinton for 24 years, and for the past 2 years, I've been a full-time caregiver for my husband, Peter Brizaitis, who has sporadic inclusion body myositis. SIBM, as they call it. It's a rare muscle wasting disease with prevalence ranging from 1 to 70 cases per 1 million population. That is not a very clear number, I can say, but it's different apparently in different parts of the world. It mostly affects older males, although the members of his support group are mainly females that we don't understand, and leads to loss of muscles in the extremities, leaving patients unable to walk or use their hands. Some, such as my husband, also have difficulty swallowing, dysphagia. Others have muscle loss in the heart, diaphragm, lungs, or abdominal muscles. My husband is missing his abdominal muscles and looks like he drinks beer a lot, but he does not. My family's concern, like that of many other rare disease families, is medical professionals' lack of knowledge and education about rare diseases. And, I'm going to say, first of all, most of this was covered by Dom Cotton, and David Leeds, and it will be by Mark Zatirka. This is pretty well known at this point. Rare disease patients take years to be diagnosed. My husband's first symptom, dysphagia, began about 13 years ago. 6 years and 4 doctors later led to a correct diagnosis, referral to a team at Hospital for Special Care in New Britain. And by then, he was falling. He was falling everywhere. He was falling at home. He was falling in public. We were dragging him off to the ER to treat bleeding wounds on his face, bleeding wounds on his arms. It was pretty messy. Most medical professionals have never heard of the disease, don't know how to treat them, misdiagnose them. And as David Leeds says, going to the emergency department is terrifying. And it's terrifying for him. And in the time of COVID, it was terrifying for me because they weren't letting me into the hospital, weren't letting me communicate with the people who are treating him. And there was no way to explain what was wrong with him or to actually get them to understand how to figure out what was wrong with him and whom to speak with. So for example, he had a CVA. We knew what it was before he went to the hospital. We spoke to two neurologists that treat him. So we knew exactly what it was. We didn't know where it was in his brain. Unfortunately, it was in his thalamus. The PA who treated him decided that it was an exacerbation of his disease.
Excuse me, Ms.
And-
Watanabe, your time is
Okay, I'm going to
almost up.
finish.
Thank you.
Yeah, I'm going to finish. So what we need is we need something that the Public Health Committee does not want to do, and we need to have a database. It's easy enough to go put in links. You can put in links to NIH's Genetics and Rare Diseases Information Center. You can put in links to NORD. People need to know where to look because unfortunately, Wiki is not a reliable source for information. And I'm afraid that's where many people go. Thank you very much for your time. If you have any questions, I'm happy to answer them.
Thank you, Mrs. Watanabe, for your testimony, and thank you for sharing your husband's disease. And as of reading about it, looks like if we identified it in a timely fashion, we could have prevented a lot of progression. So I appreciate your comments and your testimony. I have Representative Cook who has a question or a comment.
Thank you, Senator. And I promise I won't say another word for the whole rest of this public hearing. Well, maybe one more word, but first I want to thank Myrna, and in full disclosure, Myrna and her family are dear friends of mine. And I love her husband to pieces, and it breaks my heart to see what has happened to him over the last several years. And going through a lot of their frustrations over the years with them, and her calls to say, I don't know what to do. People don't understand. I can't get this. I can't get that. We as a state are doing a disservice, or as a medical society are doing a disservice to folks that are having such a rare disease that people don't try to understand. Senator, that is not a shot to you by no means. But what I'm saying, or Doc Pettit, but what I'm saying is that when you have a family member that has lived through this and has seen this and has done the research, we as legislators and policymakers and the medical professional have to take a step back and listen to those family members. And I really think that what this legislation is calling for is exactly that. It is a group of experts, and you don't have to be a diagnosed expert with a title, but you can live something and be an expert in it. And I promise you, Myrna and her family are an expert in this disease. And that is not anything that they want to hold their head and say that they're proud of, but that's what they've had to live with. And I think it warrants the conversation that she and I were having as she was waiting. If Myrna, if you could share as well. So right now, they're in a second type of a phase of Peter's care as his disease has progressed. And you talk about the home care situation and the hospice nurses. Could you please briefly explain what you're dealing with? And I know it's sensitive, but I know that you're okay with being honest about this. What you're dealing with now with home care and the nurses that are coming in to try to take care of your husband?
Yes, I can. I think I should explain that the last time he went to the emergency room with aspiration pneumonia, he was so distressed at how poorly he was being treated. The doctors did not talk to him. Nobody talked to me. Finally, a PA did, but the doctors treated him. All right, he's an 85-year-old man. He's hard of hearing. He's got to be dumb as shit. Excuse my language. But no, he's brilliant. All right, a little, And he said, I don't want to go to the emergency room ever again. And his doctors at the VA had been urging him to sign up for hospice. And he said, all right, I'll do it. Because he is considered to be terminal. So they signed us up for hospice. They signed him up for hospice. The VA did that. And the place nearest to us that they thought looked good on paper was Bristol Hospital. Bristol Hospital, people are warm, they're caring. But I'll just give you two examples of what happened recently. One of the nurses who's seen him a couple of times said to me, I don't understand. He's not dying. And I said to her, yes, he is. Let me explain to you how patients with inclusion body myositis die. They mainly die from pneumonia. It's fast. This doesn't get dragged out. It will just happen. He's had 3 bouts of pneumonia in the last 15 months. He's going to have another bout, or perhaps another. He's not going to live long. Another nurse came in and said, "Oh, are you doing your leg exercises?" He has muscle wasting disease. His skin is just sitting right on top of his legs, and one of his legs is completely paralyzed. I don't think there's any exercise that he's going to be doing. She said, "Oh, well, are you doing your swallowing exercises?" Well, he has severe dysphagia. I've seen it scoped. He can't do any swallowing exercises. He couldn't do them 3 years ago, and he certainly can't do them now. "Oh, are you doing breathing exercises?" Well, his blood oxygen is 98%. Does he have to do breathing exercises now? Then she asked, did we want a machine that would remove anything that he had aspirated? And we looked at each other and we said, no, he aspirates and chokes, he dies, it's okay. It's fine. And I mentioned this to the VA palliative care doctor yesterday, and she said, "This is ghastly." And she then said, "Don't you get tired of explaining the disease to everybody?" And that's exactly where we are. I am tired of explaining this disease to everybody. It's rare, but it's not that rare.
And I think,
Thank you so
Myrna,
much. Go ahead.
and I'm sorry, Senator. I was just going to say thank you for that. And I know that it's been a long and difficult path. And that's why I think that the Rare Disease Council is so vitally important. We might not be able to solve all of the problems for all of the people, but if we can at least start to educate most of the people that are actually, taking care of folks. It breaks my heart. It breaks my heart for not only Myrna and her family, but for all of the other families that have been going through this for so many years. So I just want to thank them for their spirit and understanding and patience with us. I want to thank you, Senator, for your patience with me. And Myrna, give him a kiss for me, please.
I gave one from you yesterday, but I'll give him another one. It's right on top of his very bald head. Thank you.
Thank you so much, Representative Cook, and thank you, Myrna, for your testimony, and thank you for sharing your story. I think your story and that of others is the reason why we are, as a public health committee, doing what we are doing. Seeing no other comments or questions, we will move on to the next person on our list, which is number 100, Philip Marella. We are finally at 3 digits and followed by Janet Alfano. So.
Well, thank you. I'd first like to thank the co-sponsors of HB 5260, establishing a Connecticut RDAC, and of course the members of the Public Health Committee for the opportunity to testify in favor of this bill. I'm Phil Marella. My wife Andrea and I live in Greenwich and have 4 children, 2 of whom were born with Niemann-Pick type C, often called childhood Alzheimer's. It's an ultra-rare neurodegenerative and fatal disease that primarily afflicts children. Like many couples, we started our family life with expectations of unending joy, but then NPC changed not only our priorities, but every minute of every day. Our second oldest, Dana, was a beautiful and caring little girl. But at the age of 5, we were stunned to hear that Dana was falling well behind the other children in school. After a 3-year journey of specialists, we learned that Dana had NPC, and we were told that we had only another 5 to 6 years with her. It was 2002, right after Dana was diagnosed, that we founded a public charity, Dana's Angels Research Trust, to help better understand NPC and hopefully find a cure. With our first drug trial, Dana lived another 12 years, but they were not easy years. Seizures, a special walker by 9, a wheelchair and feeding tube by 12. At 14, Dana couldn't walk or talk, got all of her nutrition and medicines through her feeding tube, and required 24/7 care. The last 5 years were tougher, with multiple pneumonias and eventually needing a trach and a ventilator. Then just before her 20th birthday, suddenly Dana was gone. Our youngest child, Andrew, was also diagnosed with NPC just before his 5th birthday. But with the help of 2 experimental medications, Andrew has done far better than Dana, though Andrew too has always had a progressive learning disability and memory issues. But then 3 weeks after Dana passed, Andrew, a 14-year-old boy who could walk home from the school bus, started having multiple seizures per day. Andrew now has gait, balance, seizures, and his memory issues. His seizures average about 1 every other day, and he cannot be left alone. And now that he's graduated from the high school curriculum, at 22 years old, we're still searching for programs for Andrew because our Department of Developmental Services doesn't care to recognize a young person with a neurodegenerative disease whose IQ is about 55 as someone with an intellectual disability. Over these years, we've gotten to know 5 other families in Connecticut with NPC, a total of 8 patients, 5 of whom we've lost. It's been almost 9 years since we lost Dana, and we think of her every day. In closing, I'd like you to know that NPC is a relentless disease taking children piece by piece. Something a child could do today, suddenly they cannot do tomorrow. Unless you've lived this nightmare that consumes your life, caring for a person with a rare disease, you cannot possibly understand what it takes to get through every day. It's my family's hope that a Connecticut RDAC will help our legislators better understand the needs of this community so that families living with rare disease can live somewhat more normal lives. Thank you for your consideration of this important legislation.
Thank you so much, Mr. Morella, for your testimony. Thank you for sharing your loved one's story and with all of us. Sending you our love. There's no question or comment from anybody, and I will move on to the next person on our list, which is Janet Alfano, followed by Terry Sang. Mr. Alfano, hi.
Hi, good evening. Good evening, Senator Anwar, Senator Abrams, Representative Steinberg, and distinguished members of the Public Health Committee. I'm Janet Stolfi-Alfano, Executive Director of the Diaper Bank of Connecticut. I'm here to urge your support of two bills. First, HB 5303, an act concerning continuing medical education requirements concerning endometriosis and cultural competency and the creation of a plan for an endometriosis data and biorepository program. As part of the endometriosis working group, I've had the privilege of serving alongside advocates who are working to ensure that medical professionals get the training they need to properly and equitably screen, diagnose, and treat those who may be suffering from endometriosis. And as someone who has suffered from endometriosis, I know firsthand the difficulty experienced in getting the appropriate diagnosis and treatment. And my story is not so different. It took 7 years to get properly diagnosed. Please support this bill to take these first necessary steps for better diagnosis and treatment for those who suffer. Secondly, I urge your support of HB 5272, an act concerning menstrual products. Over the past 18 years, the Diaper Bank of Connecticut has been distributing, we're mostly known for diapers. We also distribute period supplies and incontinence products to Connecticut residents. And we are increasingly seeing the need and the impacts of period poverty throughout our state. Imagine being unable to afford period supplies, having to skip work, school, or social opportunities because of it. No one should have to miss out on their activities of daily life because they can't access these basic necessities. However, too many do. Pads and tampons are basic health needs, yet many go without because they must spend their limited income on other necessities. Every day, people in our community are forced to choose between buying period supplies or affording other necessities like rent, groceries, or transportation. We've been distributing supplies to our partners with products that are donated. And last year, we distributed over 146,000 products through our network of community partners. And we've worked hard to raise awareness about this issue and to advocate to make period supplies more accessible. And we have made some progress, but there's more work that needs to be done. We know that this need can't be met by charitable donations alone, and it is important that this bill is passed and fully funded in order to be equitably implemented across the state of Connecticut. Students from every district deserve access to their basic health and hygiene essentials, as well as folks living in homeless shelters, domestic violence shelters, and those who are in prisons. And we've heard from so many young people, and I know you've heard from some amazing advocates and young folks today across our state, including one young woman, Joy Wren, who she completed 8th grade when I met her at the Legislative Office building. And she presented to the Governor's Council on Women and Girls in the summer of 2019, and is still such a strong advocate today. It is young leaders like her and many of those that you heard who are really at the forefront of this effort and are making us do our jobs better and in being here and advocating for this bill. And I urge you to support it so that everyone has access to the period supplies they need, where and when they need them. Thank you so much.
Thank you so much for your testimony. Truly appreciated. May I ask you a quick question about the period supplies? Have you seen any patterns of areas that you're asking, you're getting more requests from?
You mean geographically within the state, do you mean, or?
Yeah, any specific patterns? Is it based on the network that you have, or is it based on inner cities, or is it based on, like there's a concern that minority communities have a higher need in our state? Can you say something about that?
Sure. So the data does tell us that certainly folks, our Black and Brown folks are experiencing period poverty at a more rapid rate than us, but we actually hear across the state in every community that this issue exists. And so we've heard from students from all over Connecticut. But that's actually a great question. I would love to, learn more about it. There is some level of research nationwide, but we know that this exists throughout the state.
Thank you so much. And I have Representative Gilchrist who has a comment or a question.
Thank you so much, Mr. Chair, and I'm sorry my dog might bark. Thank you so much, Ms. Alfano, for serving on the endometriosis working group and your support of that legislation. But actually, to build off what was just said in terms of national data, have there been national studies or data to back up the information about students missing school as a result of period poverty?
Yes, yep, there have been. The most recent one was actually, I believe, in the time of COVID, but there have been national studies. I can certainly share the research on that, but there have been national studies on that, both pre and post pandemic, and that the impact that COVID has had even on access for many folks. If you can imagine, if for the limited amount who were receiving some products in schools, if they did not have access to schools because of COVID or they were remote, that also impacted folks' ability to access supplies.
Thank you so much. I think that would be great to share with the committee clerk, because no one should have to, no one should miss school because they can't access period supplies. Thank you.
You're welcome.
Thank you so much, Representative Gilchrist. Seeing no other question or comment, we will move on to the next person on our list, which is Terry Sang, followed by Jennifer Cole.
Oh, hi, can you hear me okay?
We can hear you very well, Mr. Sang, but we cannot see you.
Oh, okay. That's because I'm kind of messy after my 90 minutes of on and off exercise. So
no worries.
Please pardon me.
You're exercising more than the entire Public Health Committee combined. So
yeah, sorry about that.
You can speak.
Okay, yep. So first, I'd like to thank the leadership and members of the Public Health Committee for giving HB 5278 an opportunity for a public hearing. Really, really appreciate it. My name is Terry Sang. I live in Groton, Connecticut. I'm here to testify in support of HB 5278. Clinical trials and informed consent were parts of my job for more than 30 years. For those of us working in the drug development world, we do everything possible to protect the well-being and safety of patients. There is no compromise, and it starts with informed consent. The foundation for consent is full disclosure. The guiding principle is total transparency. When I read about the unconsented intimate exam by medical students, I was beyond horrified. Medical schools rely on patients to teach the next generation of physicians. For that reason, I thought teaching hospitals would treat patients with the utmost respect and safeguard their well-being, safety, dignity, and autonomy. I was shocked to learn from a 2019 public hearing transcript for a similar bill, SB-16, that if a pelvic exam is part of a routine procedure, consent for a pelvic exam under anesthesia is implied. Apparently, implied consent is a common practice for medical schools, including the ones in Connecticut. In addition, consent forms for medical student intimate exams are vague, with statements like patients are choosing to seek care in a training institution, and trainees should be involved in their care, without any specifics. These consent forms also do not make it clear that there are aspects of the procedure to which patients can say no. Sadly, medical schools prioritize education at the cost of ethics and patient dignity. Two injustices are committed, one against the patient by the very act, and the other in imparting to the student that such transgressions are normal and acceptable. It's unconscionable that medical students are legally allowed to practice intimate exams on anesthetized patients without consent. An educator raised the question earlier today that the ability of patients to exclude trainees from even observing the exam seemed illogical and detrimental to education. The thought to disrespect patients' Bill of Rights and bodily autonomy in the name of education, to me, it's unacceptable. I would like to remind.
Excuse me, Mr. Sang, your time is almost up. If you
Okay,
please
I just got
summarize.
2 more sentences.
Okay, thank you.
I would like to remind the committee that when asked, most patients will consent. If a patient says no, it means no. Let's make Connecticut the 21st state to require explicit consent for intimate exams. It's time to respect and treat patients like human beings. Please support this bill. Thank you so much.
Thank you so much, Mr. Sang, for your testimony and very, very clear, well thought of words. I truly appreciate them. I have my colleague, Senator Heather Summers, who has a question or a comment.
Yeah, she's my senator.
Mr. Sang, how are you?
Good, yourself?
I'm doing well. I wanted to, first of all, thank you for your testimony. I know that you and I have had in-depth conversations about this, which is one of the reasons why I wrote to have this bill raised as a intimate exam, not just for pelvic, as we spoke about. And I have been bouncing between different meetings. So I was hoping everyone had heard your credentials, because that really makes a difference about in your research at Pfizer, how you had to have consent from everyone during your clinical trials. And I wanted to thank you for testifying, and thank you for all the time that you spent talking to me about your philosophy on making sure that patients have the right to consent to certain things. And I know that I heard that testimony you spoke of earlier also. And I think sometimes many of us, especially for women, if you're having an exam in a OB or gynecological office, sometimes the doctor will say, oh, I have this resident with me. It's okay if they come in, and you feel uncomfortable saying, no, it's not, and some people may not want that resident to come in to observe during whatever procedure that you're having. So I think this is a good conversation, and I thank you for your advocacy.
And thank you so much, Heather. Thank you so much for being supportive. I really appreciate it. On behalf of all the patients, thank you so much.
Good. Thank you, Ms. Senator Summers, and thank you, Mr. Sang. Seeing no other questions or comments, I hope you can hydrate yourself now.
Okay,
And,
I'll disappear.
And the next person on our list is Jennifer Cole, followed by Paul Pescatello. Ms. Cole.
Thank you so much, Senator Anwar. Thank you, Representative Steinberg, and honorable members of the Public Health Committee. My name is Jenny Cole, and I'm the Community Outreach Coordinator at the Diaper Bank of Connecticut, located in North Haven. Thank you all for the opportunity to testify in favor of House Bill 5272, an act concerning menstrual products. I would like you all to take a moment and imagine being back in middle school. Unexpectedly, you get your period. Unprepared and unsure who to ask, you're forced to substitute rolled up toilet paper for a pad. While for many menstruators, including myself, this would simply be an inconvenience, for many others, this is a monthly reality. As a community outreach coordinator at DBCT, I have had the opportunity to work alongside student advocates throughout the state on the Humans with Periods project. This project's mission is to raise awareness about period stigma and period poverty in Connecticut. Through a Google form, we've been collecting and sharing stories about people's experience with their menstrual cycle. A common theme that we found is that the stigmatization and collective inability to talk about our menstrual cycle is not only a barrier for young people to feel comfortable with this process, but also limits our ability to address access. Lack of access to these products affects far too many students' ability to attend and fully participate in school. To sort of summarize what has already been said, we do know that prior to the pandemic, in the United States, 1 in 4 teenage menstruators reported that lack of access to these products has caused them to miss class. It's unacceptable that any student here in Connecticut should have to miss class and fall behind in their learning because they can't afford pads, tampons, and other menstrual products. And while I encourage the members of this committee to vote yes on this bill, I also encourage you all to support funding this initiative. If this bill were to pass as an unfunded mandate, school districts would be responsible for budgeting for these products, potentially taking funding away from other essential programs. This legislation, along with proper funding, would be a critical step in addressing access to these products. I hope you'll all prioritize the health of menstruators across our state and vote in favor of this bill. Thank you all so much for your time and consideration.
Thank you so much for your testimony. And I see Representative Gilchrist has a comment or a question.
Thank you, Chair Anwar. Sorry, it's getting late. So good to see you, Ms. Cole. And thank you for your testimony. And when you said imagine middle school, I went right there. And I'm also thinking of high school. I was a student athlete. And so it's making me also just really reflect on, we're talking about period poverty or not having access and not being able to participate in school, but there's so many other extracurriculars or sports that would also really impact for our students. But what I wanted to ask you with the survey tool, do you have 1 or 2 things that stick out to you that you've read so far that have really, surprised you or really just stuck with you?
I think the biggest piece that's really stuck out is it's sort of this universal thing for all menstruators, that we all experience the same sort of stigmatization, but I'd never really thought about it until I saw a collective list of over 65 plus people saying that this is what they're experiencing. And then on top of that, imagine not having access to the products for your health, and not being able to talk about not having access for the products for your health. I think that was really the huge thing that stuck out to me. But thank you so much for your question, Representative Gilchrist. It's great to see you.
Thank you. Thank you for your work. Thank you, Mr. Chair.
Thank you. Seeing no other question or comments, we will move on to the next person on our list, which is Mr. Paul Pescatello, followed by Dr. Tariq Gardistunsar.
Good evening. Thank you so much for this opportunity to speak before you. Again, I'm Paul Pescatello, Senior Counsel of the CBIA and also Executive Director of its Bioscience Growth Council. I'm here tonight to speak in support of HB 5260, an act establishing a rare disease advisory council. A greater focus on rare diseases through the establishment of a rare disease advisory council is important, I think, at least for 3 reasons. First, rare diseases are not rare. While each individual rare disease affects fewer than 200,000 people, there are over 7,000 rare diseases. All of us are touched in some way by a rare disease: a child, a spouse, a parent, a brother, a sister, a friend, a work colleague. Second, as it develops policy affecting the rare disease community, The General Assembly would benefit from the more formal structure of a legislatively established Rare Disease Advisory Council. Rare disease patients and caregivers face a myriad of unique challenges as they seek accurate and timely diagnosis and appropriate quality care. A Rare Disease Advisory Council would provide a forum to better understand these challenges and, more importantly, serve as a mechanism to bring focus to the most effective solutions. Third, studying and researching and developing cures and therapies for rare diseases benefits rare disease patients, of course, but rare disease R&D generates rich dividends for broader disease populations. Insights into the genetic causes of rare diseases, for example, helps build knowledge about the human genome generally and the genetic connections and misconnections that cause disease. Many rare cancers cluster around various forms of blood cancer, and insights into these diseases have helped build a pathway for understanding the causes and mechanisms of cancer generally. Now, the Bioscience Growth Council understands that the road to cures and effective treatments lies in biopharma R&D. The more R&D, the greater the likelihood of finding treatments and cures. Given how rare it is for a quote unquote promising new medicine candidate to proceed through early to late stage research and then clinical trials to become an FDA approved drug available to patients, that's only 1 in 10,000 medicines that meet that finish line. We constantly advocate for more R&D. Because we believe R&D is paramount, we asked the committee to reconsider the membership of the proposed Rare Disease Advisory Council to include a greater proportion of research scientists whose career focus is rare disease research. As the bill is now drafted, it consists of 3 Connecticut State Agency commissioners, 2 representatives of industry, hospitals, and biopharma, 1 physician with expertise in medical genetics, 1 representative of a patient advocacy group, 1 physician who treats persons living with a rare disease, 4 rare disease patients or caregivers, and only 1 member of the scientific community who is engaged in rare disease research. We believe it would be a missed opportunity for the Rare Disease Advisory Council not to focus on research and clinical development and to take greater advantage of the deep well of rare disease R&D expertise in the life sciences, academic, and biopharma industry communities. We also know that
Mr. Pescatello, your time is almost up. If you could please summarize.
Sure.
Thank you.
We also would just like to say that it would make sense not to limit the advisory council just to Connecticut residents and to allow out-of-state participation. There's a lot of expertise out there, and if we could get somebody a Nobel laureate from out of state on rare disease, it would make sense. And finally, an IT person to add to the committee's membership would be, I think, very valuable given some of the work the council intends to do, websites and connecting patients and scientists. So with that, I'll conclude and I'll be happy to answer any questions you have.
Thank you so much for your testimony. Truly appreciate it. I see Dr. Pettit has a question or a comment.
Sure.
Paul, thank you. You're going to have to get someone else to sign you up in the future. You seem to only draw numbers in the 100s or 200s. So don't go to the casino. I asked this question earlier, wondering the same thing, whether we needed a little different expertise. And certainly Leslie Bennett said, this has been knocked around a lot. So I think it's something we need to talk to with the people that have been involved in our chairs on the committee and see if any adjustments are appropriate. And I also hadn't thought, I think the idea of someone out of state, since they are rare diseases, we heard from someone with endometriosis that they had to go out of state to find someone, and that's not a rare disease. So rare diseases, there may be only the expert may be in Texas or maybe elsewhere, and they may have to zoom in. So I think that's a great suggestion. So thank you.
Thank you.
Seeing no other comment or question, we thank you again for your testimony, and we move on to the next person, that is Dr. Tariq Kardis Tunser, followed by Sarah Moran Gentley.
Thank you very much. Representative Steinberg, Senator Anwar, and distinguished members of the Committee on Public Health, on behalf of the more than 200 orthopedic surgeons of the Connecticut Orthopedic Society, thank you for the opportunity to submit our testimony on HB 5261, an act increasing access to reproductive health care. I am Dr. Tariq Kardis Tunser. I'm the president of the Connecticut Orthopedic Society. I'm an orthopedic hand surgeon in Norwich, Connecticut. I work at Orthopedic Partners. I'm born and raised in Eastern Connecticut, and what I've witnessed in the last several hours waiting my turn is truly remarkable. I thank all of you for your dedication to all the citizens of Connecticut. It truly is remarkable. You'll wonder why an orthopedic surgeon has any interest in reproductive health care. It's simple. It's patient safety. The society, and I have to be clear about this, is not opining on reproductive health care in Connecticut, and our comments and concerns are focused on surgical procedures and the scope of practice related to physician assistants, APRNs, and nurse midwives, and most important, about patient safety. As you know, the procedures known as aspiration and dilation and evacuation are surgical procedures, and for the safety of patients should be performed by those trained in surgical procedures and within their scope of practice statute. The society contends that the healthcare professionals listed in this bill that will be allowed to perform surgical procedures are not adequately trained, educated, or licensed to perform surgical procedures. About an hour ago, Jennifer Love, a midwife with extensive training, opined, quote, with the correct training, end quote, some people may be able to perform first trimester abortions. Prior to any further consideration of this bill, we respectfully request the Department of Public Health to conduct scope of practice reviews for each of the professions identified in this bill to determine if their education and training supports a surgical procedure scope change. It has and will continue to be the position of the society that patients have surgical services provided by only the most qualified and highly trained healthcare providers. Patient safety is truly a priority for all of us. And I've noticed, and thank you for seeking clarity from members of this committee on direction from the DPH and scope review. And I thank you for your consideration. I'll be brief. Thank you.
Thank you so much, Dr. Kardas Tunser, for your testimony. I see Dr. Pettit has a question.
Well, no, thank you for your testimony. It's it's been the one issue that we've brought up. I mean, in your own field, we've had the issue of orthopedic ankle surgeons versus podiatric surgeons and what the particular scope is, and that's been the issue. Not to try to prevent people from practicing to the top of their scope, but since the policy in Connecticut has been to assess, have DPH assess and make determinations on what is required for commentary, I would agree with you in terms of patient safety. So thank you for those comments.
Thank you.
Dr. Kardas Tunser, what we've seen in Public Health Committee is every year there are about 25 to 30 requests for scope of practice. And it's almost scary for the fact that politicians shouldn't be deciding who operates on who or who does not operate on what. It's a skill-based training institutional system that is in place. And I think that's why prior to even me serving in my current capacity, I think it was decided that DPH would be overseeing some of this work. I think the only issue is that DPH may not necessarily mandate it. And I think it's probably a good idea to have that mandate that the scope of review should be through them, rather than have three advocates just say that they can go ahead and make a decision. We see very fascinating requests. I mean, this request has a very reasonable rationale, but we have seen requests where there was a request that a psychologist after 40 hours online training will become a psychiatrist, which is like the psychiatrist goes through 23,000 hours of training, and then 40 hours will make them a psychiatrist. And so we are seeing these kind of bills come in, which result in the entire Public Health Committee having to listen to some of the conversations, but it's probably a good idea to have a channel through or formalized way through Department of Public Health. And I think that's what you're suggesting as well.
Correct. Thank you.
I see Representative Gilchrist has a question or a comment.
Thank you, Mr. Chair. I'm so sorry, is it Carter?
Dr. K.
Dr. K, thank you, Dr. K. Yeah. To your knowledge, are there any other medical procedures that are written into state statute?
In fact, there's no definition of surgery in the state of Connecticut. I'm not aware of any other that are written into state statute. No, I'm not aware. Okay. But I do know there's no actual definition of surgery in the state of Connecticut. We lobbied for that several years ago, and we didn't make any headway on that either. We're concerned about these invasive procedures. In fact, we believe that if you're performing a surgical procedure, you should be able to fix the immediate complication that comes from it. So in this case, and again, I'm not a specialist, but hemorrhage, uterine perforation, bowel perforation, sepsis, if they have to be managed immediately, we would want the person performing the procedure to be able to fix the complication. That's kind of, we are trained as surgeons. You don't actually operate on somebody if you can't fix the complication, the immediate complication. So, we're very concerned about patient safety. And that's, I mean, again, I don't know anything about reproductive health. I'm not an expert on that.
Well, according to the American College of Obstetrics and Gynecology, aspiration abortion is actually defined as a procedure and not a surgery.
That's possible. Again, in Connecticut, we don't have that definition. And the several obstetricians I spoke to in the last week or two couldn't believe this bill was even being entertained. But again, there's individuals I spoke to in my health system.
Thank you, Mr. Chair.
Thank you for your testimony. Thank you, Representative Gilchrist. And so one of the highlights from my day today is I pronounced your name right first time around. So
thank you.
And so late in this. So
thank you.
Okay, and next person on the list is Sarah Moran Gantley, followed by Taylor Binyars. So Ms. Gantley.
Yes, hi. Good evening, Senator Anwar, Representative Steinberg, and honorable members of the Public Health Committee. My name is Sarah Gantley, and I'm speaking tonight to give my support to House Bill 5261, Enact Increasing Access to Reproductive Health Care. I'm from Wethersfield, and I've worked as an APRN for Planned Parenthood of Southern New England for the past 5 years. I've worked in healthcare in many capacities over the last 14 years, as a nurse in the hospital, taking care of the critically ill and intensive care, to working in an outpatient not-for-profit clinic setting. I feel both medically qualified and personally passionate about increasing abortion access, and am a proud abortion provider. Abortion access in our country is under attack. Now more than ever, we need to be expanding abortion access in our state. 14 other states allow advanced practice providers to perform aspiration abortion. Connecticut needs to allow for improved access to safe abortions for our residents, as well as for those who will inevitably be seeking care here from other states. Advanced practice providers have a very important role in providing healthcare. Our services go beyond simply filling the gap of not having enough physicians. Advanced practice providers are able to perform many procedural tasks, including uterine biopsies and the placing of intrauterine devices, just to name a few. We form unique interpersonal relationships with our patients, and we earn their trust. Allowing advanced practice providers to perform first trimester aspiration abortion is not only completely safe, but would improve the quality of life for patients and would decrease an already overwhelming healthcare burden caused by lack of access. Patient safety, as always, is our #1 priority. And just to briefly touch on the points that were made by Dr. K, oftentimes in surgery, the anesthetic is being provided by an advanced practice nurse, a nurse anesthetist. Oftentimes in surgical procedures, the person assisting is a physician's assistant. So mid-level providers are often participating in, if not conducting, several procedures that are far more dangerous than first trimester aspiration abortions. Allowing advanced practice providers to perform first trimester aspiration abortion would also ease the economic burden for patients, insurance companies, and ultimately the state of Connecticut. Advanced practice providers can perform procedures for less than the reimbursement rate for physicians. In closing, abortion is a very polarizing topic, but I urge you all not to think of this as simply abortion, but to think of this as an important public health issue. Passing House Bill 5261 allows qualified providers to give medically necessary care. Thank you all for your time.
Thank you so much, Ms. Gantley, for your testimony. Thank you for waiting till the late part of the afternoon or evening now. Yes, thank you.
My pleasure.
I don't see any questions or comments, and we'll move on to the next person on the list, which is Taylor Binyars, my
Hello.
friend as well. Hey, Taylor, good to see you.
Good to
Thank
see
you
you.
for coming.
Thank you.
Go ahead.
Co-chair Senator Abrams, Representative Steinberg, and the other members of the Public Health Committee. Today, I'm going to attempt to testify for 3 bills in 3 minutes. This includes HB 5303, which, being honest, is my priority as someone with endometriosis. Any added focus and training on it will literally save lives and also improve them. I have submitted written testimony furthering my support for each bill. And in the one for this bill, I document my 8-year struggle with it. The extreme pain, throwing up due to the pain, and that pain not being believed even by medical family members. I urge you to read it to truly understand why we need to shine a light on it. I also need to point out that when it comes to believing pain, diagnosing, and treating endometriosis, like everything else, Black women are far less likely to be believed and treated properly. To share a few facts here, the only way to confirm a diagnosis of endometriosis is through surgery, which seems odd, right? Like that's usually a step taken after diagnosing someone for treatments. Also, speaking of treatments, there's no one size fits all. There are various treatments that may help to some degree, and if asked, I can elaborate on some of them. And one of the treatments I would choose if mine got worse, a hysterectomy, is extremely tough to get for sexist reasons, such as what if you want kids, or what if a man that you haven't even met yet wants kids? He has more say over my body than I do. Next, HB 5272, an act concerning menstrual products. I am to some a pretty radical person, and I think that anything needed to survive and sometimes even thrive should be free. This includes period products like pads, tampons, and in my mind, even menstrual cups, whether reusable or one-time only. When we are talking about those in school, especially if their parents cannot afford tampons or pads, or if we are talking about those in prison, often forced to split a low amount of pads between a larger group of people, this bill has the real ability to change and better lives. That barely scratches the surface on what it can do to help the homeless population, where there's a real risk to their lives if they leave a tampon in too long because of lack of new ones or a place to change them in. And lastly, HB 5261, an act increasing access to reproductive health care. Abortions of both types are one of the safest medical procedures available. So it makes sense that medical professionals who are able to perform abortions be allowed to perform them. I also support the inclusive change that this would make to the language, given that men and those who are non-binary become pregnant and get abortions as well. With other states continuing to restrict our right to our own autonomy, it is imperative that our state not only protects, but expands access to abortions. For me, I do not want kids, I never have. So I want to live in a state with multiple safe avenues of abortion access should I need one. I urge the committee to support all of these bills as they will all better lives and even save them. Thank you, and I welcome any questions, including on my personal experience with endometriosis.
Thank you so much, Taylor, for your testimony. And Taylor, how long did you have to suffer before it was you were diagnosed with endometriosis?
So for me, I will say that I was lucky and privileged in some sense, because while I did struggle for roughly, I would say probably 3 to 4 years before receiving help, once I reached that breaking point where my mother thought I may have endometriosis, she, given her past work here in Connecticut, had connections and asked her connections for a good doctor for people who have endometriosis. And my doctor was actually previously mentioned on the stream. My doctor is Dr. Luciano at UConn, and she has been a godsend for me because she believed my pain. We figured out a treatment that is working for me right now, as I do have a lower level of endometriosis. And so for me, it was probably roughly 3 to 4 years after first experiencing symptoms. And then after that, I did actually have a very quick moving treatment and plan for that, because I did have the privilege of knowing somebody who had connections.
Thank you. I have Representative Gilchrist who has a question or a comment.
Thank you, Mr. Chair. It's 2 quick comments, just nicely done. 3 bills in the 3 minutes. Thank you for testifying in all 3, but in particular, sharing your experience of endometriosis. And then just want to flag for the committee that while Dr. Luciano could not be here, she did submit testimony and it's up on the website. Thank you.
Thank you, Taylor. We will move on to the next person, but before we move on to the next person, there's a sort of a unwritten rule in the Public Health Committee that we look at these longer public hearings as you need a captain to take on and start, and you need a captain to complete the public hearing. So I will ask the captain to join and continue on. That's Chairman Steinberg. Captain?
I'm a great believer we need more female captains. How many of the airlines are working on that right now? I always fashioned myself more of a flight attendant. Moving along, we have Christina Bennett, followed by Catherine John.
Can everyone see me?
Yes,
Okay,
please go ahead.
Thank you. I want to thank the members of the Public Health Committee for enduring all of these hours. And I also would like to thank everyone who spoke up about endometriosis, as I'm not testifying on that, but I have suffered for years and was diagnosed through surgery. So if my testimony in the future would be helpful, I'm willing to offer that to anyone who might need that. But I am here this evening to talk about opposition to Bill 5261. And I want to discuss the issue of safety. Throughout the day, I've heard many times that abortion is a safe procedure, and therefore we need more access in regards to midwives and APRNs. I'd like to bring to the attention of the Public Health Committee 3 pending lawsuits that you can find online, and I can submit the information. And they are all against Planned Parenthood of Southern New England. One in particular is against a midwife who tragically, when a pregnant woman came to Planned Parenthood, she told her that she was 6 weeks pregnant and that the fetus had died. And she presented her the option of taking chemical abortion pills. This woman did take those chemical abortion pills, and tragically, when she went home and she later had a abortion at home and she delivered this baby into the toilet, it was found to be a child that was 22 weeks gestation. And tragically, her partner had to cut the umbilical cord and she had to go to the emergency room. And as you can imagine, thinking that you have a deceased 6-week child and then finding out through delivering a child into the toilet that it actually was a viable child is very traumatic. And there's another pending lawsuit against Planned Parenthood of Southern New England that is against an APRN who had a botched IUD situation with a particular patient, and that caused her to have a pregnancy that she did not want to have. And so she is suing Planned Parenthood. These are cases that you can read about online, but there are more safety cases that I have personally talked to patients and women who have suffered botched abortions and perforated uteruses, infertility when it comes to surgical abortions, but also chemical abortions. And unfortunately, in some of their situations, they have not been able to tell their story. The women that I've met with, many of them are women of color, Black women like myself, and they haven't all had the means to be able to, or even the time to be able to have a lawsuit. And I want to speak on their behalf because we're talking about allowing midwives and allowing APRNs to perform surgical abortions, which I believe would lead to an increase in situations like this, where women are being harmed and their safety is brought into question. And so that is why I oppose this legislation, because I think that it has to do with politics, and it's putting politics above the health and the safety of women. And I ask the committee to please consider what I said. And if there's any questions, I'm here to answer them.
Thank you for your testimony. Representative Dauphiné has a question.
Thank you, Mr. Chair, and thank you, Christina, for your testimony. Do you think this bill has any harmful implications in the fight for maternal mortality in the Black community?
Yes, I do. Yes, I do, actually. So I think now this is something that people may not fully understand, but I'll explain the best that I can. When women have had traumatic experiences with abortion providers, those that have had traumatic experiences with abortion providers, sometimes because of that trauma, they are triggered by even seeing the building, perhaps if they had an abortion at a Planned Parenthood and it was traumatic for them. Even driving by that Planned Parenthood building could be something that is triggering to them. Now, if the provider only provides abortions and the woman has had a traumatic experience, then if she does not want to have an abortion again for the rest of her life, she can avoid that provider and therefore avoid some of that trauma as she's working towards being healed, which is the case for some women that I've worked with who are in therapy and seeking healing. But when you bring midwives into the conversation, if women are having traumatic experiences because midwives have performed an abortion, then they could be less likely to want to see a midwife after that, even if it's a different midwife. If they had a traumatic experience with one midwife, in the future, they may be a little bit less willing to see another midwife. And so therefore, that can be problematic when African-American women especially, we have the highest rates of maternal mortality, and midwives and doulas are so important for us in helping reduce maternal mortality. So for midwives to take on abortion and then add that to what they do, that could lead even some women who have never had an abortion, they might not feel comfortable going to a midwife who they know performs abortion. So I, as someone who is a person that's very careful with the doctors and the nurses and the OBGYNs that I see, I don't feel comfortable seeing someone who performs abortion. And unfortunately, I had an experience where I did not know that a doctor did, and that was information was held when I was on the pursuit of getting help with my endometriosis. That was before it was diagnosed. But when I found out that she did abortions, I was upset that that information was withheld from me because I would have liked to go to a different provider. And so again, in the Black community, our maternal mortality and infant mortality rates are so high. And midwives and doulas are so important to what they do. It could be detrimental to those that hear my toddler screaming in the background, but it's his bedtime.
Thank you, Christina. Do you think there's a lack of access in Connecticut?
A lack of access to abortion. I travel all across the country, and Connecticut has some of the strongest abortion laws in the entire nation. We've codified, Roe versus Wade into state law. We don't have any parental notification laws. We don't require parental consent for minors. We don't have any mandatory ultrasound laws. We don't have any waiting period laws. Our pregnancy centers have unfortunately been regulated, I guess you could say, by legislation that I think is unfair, but we obviously have a very pro-abortion state, and I do not believe that there is a lack of access. In my prior years, I served as a pregnancy resource center leader, and I met many women who've had abortions, and they did not have any delay in getting an abortion. There's abortion clinics all throughout our state, and even during the pandemic, they've remained open, and especially now with chemical abortion and the fact that the FDA has allowed abortion pills to be given out through the mail. I'm constantly seeing advertisements online about abortion pills, even in Connecticut, that can be delivered to someone's home. And so the idea that we have a lack of access, it doesn't add up. I think that that is a political argument. There are states, as we know, that are restricting abortion, and there's states that are looking at bans, 15-week abortion bans. Mississippi, obviously Texas has a ban on abortion after a heartbeat, but Connecticut is a very different state. And when we talk about abortion and we talk about the possibility of legislation in other states impacting us, I highly doubt that women from Texas or Mississippi are going to come to Connecticut to get an abortion. That was mentioned before, that the possibility of this legislation across the country could cause women to come to Connecticut, and therefore we would see a need for greater access. And I don't see how that's possible just based on what I've observed over 17 years of working with pregnant women and families.
Thank you for that. And just one last question. You spoke about the political aspect of this. Can you speak a little bit more to that? Because I wasn't sure what you were talking about. And that would be my last question. So thank you.
You're welcome. What I was trying to describe when I said that is that abortion is obviously, as we know, it's a procedure, but there are politics involved, from Roe v. Wade, Doe v. Bolton, all the way until now. And tragically, across the country, there are movements that are really designed to advance abortion access regardless of safety and regardless of how it can impact women's health. I think part of that is seen when you look at what's happening with the FDA. At one point, the FDA was taking data when it comes to the chemical abortion pill and complications, and they were collecting that data. But now they're only collecting data if a woman dies from the abortion pill. And that's really dangerous because there are women who have almost died, some of them who I know, and that information isn't being seen. And so therefore you can have people say things like abortion is the safest Tylenol, and a woman who doesn't understand all of the research and history might think, okay, abortion is as safe as a Tylenol, the abortion pill, and takes that, and then God forbid she hemorrhages, or God forbid she's left with infertility or something like that. It isn't always the case, of course, but it does happen. And in the same way, we see that there is a fear that people have, and I have empathy for that. There's a fear that people have that abortion access could be restricted because they see it happening across the country. And so because of that fear, they want to advance abortion laws and strengthen abortion laws. And as I said, advocate for abortion on demand with no apologies, so to speak. And I think that this legislation plays into that because we're not thinking primarily about women's health and women's safety and how this can impact them. And I am particularly burdened by this, being a woman of color, being someone who was born to a low-income woman who was coerced into having an abortion, but thankfully at the last minute, it took a janitor who talked to my mom at that last moment when she was in Mount Sinai Hospital in Hartford, Connecticut, and she paid for the abortion. It took a janitor to offer her the care that she needed, which was just basically a question of, do you want to have your baby? And my mom said yes, and she walked out, but that was after she left the counselor's room, and that was after the doctor yelled at her. So I know that there is abuse, and I know that there are so many women who are already vulnerable, so many women who are already scared and afraid, and I don't want to see them go to people who are not trained and are not as skilled and could really hurt them and could injure them. I know what that feels like to have infertility and deal with that. And it's painful to meet young women in Connecticut who have infertility because of a botched abortion, don't feel like they have any way to get justice for what they suffered, like the women that I mentioned in these pending lawsuits against Planned Parenthood of Southern New England.
Thank you, Christina. Thank you so much for testifying, and thank you for your answers. I appreciate it.
You're welcome.
Yes, thank you, Christina, for your testimony today. Thanks for hanging with us as we approach the end of our 11th hour. I don't see any further questions, so have a good evening.
Thank you.
Next up is Catherine John, followed by Beck Sir.
Good afternoon, co-chairs Abrams, Steinberg, and members of the Public Health Committee. I am Catherine John, Program Coordinator of the Diaper Bank of Connecticut, located in North Haven, Connecticut, and testifying in support of HB 5272 and HB 5303. Black and brown people are normally impacted by the lack of access and affordability to basic essential needs, and historically, we know that the medical establishment has mistreated Black and brown people. What does the lack of access to basic essential needs look like to you? Historically, women have accounted for almost 50% of immigrants, most of whom are Black or brown, and have been critical to establishing and maintaining the social fabric of America. Systemically, many Black and brown people in Connecticut are essential workers, such as domestic workers, restaurant employees, bus drivers, security guards, paraprofessionals, retail employees, home health aides, and like many other unspoken frontline heroes who carried the economy through the pandemic, work long hours on their feet with little time in between for a break or to check themselves while on their period, working through their cramps and other menstrual cycle effects with little to no support. What about our incarcerated people who have limited resources and funds to afford period products, which they have to request or may receive from male corrections officers? What about the schools where there's only one place in the entire building which has period supplies that is usually tucked away somewhere very few know of or will go to? What about the homeless, the sex workers, or those seeking emergency shelters? Who do they get their period products from? Also, mental health issues like depression and anxiety can hit Black women especially hard. It can be difficult to find culturally competent care, to deal with the stigma of mental illness, and to carry the stereotype of being the strong Black woman along the way. What makes this all worse is when individuals do not have access to the products needed to manage their periods. They are forced to go without, preventing them from carrying out daily activities, or they will use makeshift pads made of old rags and other objects found, adding another potentially dangerous health risk to their already high-risk situation. It is very expensive to be poor in Connecticut, especially when the recovery turns out to be for some and not all. And in a tale as old as slavery, Black and brown people in the state continually bear the brunt of financial hardship. The prospect of ending period poverty is not at all far-fetched, given that Connecticut has taken steps in that direction by removing tampon taxes. Period products are a necessary expense, which are required to be met at least once a month. Let's enforce actions which address the longest standing, yet lesser discussed and acted upon pandemic, so people can enjoy a comfortable standard of living and contribute their best selves to building a great society by changing the narrative, challenging racial stereotypes, and improving access to period supplies and efficient medical treatment. I support bills HB 5272 and HB 5303 and look forward to your support in empowering people, providing free period products in various settings, as well as improving their access to efficient, equitable healthcare. Thank you.
Thank you so much for your testimony and for your patience waiting to deliver it. We really appreciate it. Thank you for your insights. Seeing no questions, we'll wish you good night and move on next to Beck Sir, followed by Troy Moore.
Thank you, Representative Steinberg. Can folks hear me okay? All right. Good evening, members of the Public Health Committee. My name is Beck Sear, and I am a graduate student at the University of Connecticut School of Social Work. I have been in the work of preventing and combating domestic and sexual violence in Connecticut for the past 3 years, and I implore you to support House Bill 5278, as it has been long overdue to discuss and pass this legislation. Although this is a bill that will benefit all patients, I want to bring special attention to how it will impact specific patients. While I no longer identify as a woman, I was raised as a woman, so this is what I will say. It is already difficult for women to trust healthcare professionals and feel safe on the exam table. The same goes for lesbian, gay, bisexual, and transgender patients, as well as patients of color. I can name at least 10 women in my life who have not gone to the OBGYN in the past year for a checkup, and at least half of those women have simply never seen one. Intimate examinations, while necessary for our health, are already uncomfortable and sometimes painful and traumatic when the provider is not focused on providing a caring and trauma-informed environment. Most importantly, this is when patients are consciously aware of what is happening to them and visit the doctor with the expectation of receiving an intimate exam. I do not believe that any level of education or credentials put anyone above consent and bodily autonomy. The practice of allowing medical students to perform intimate exams on patients under general anesthesia without explicit consent is unethical in every way. It is hypocritical to expect patients to seek healthcare with a certain level of trust and confidence while simultaneously allowing a practice like this. While the opposition suggests that passing this bill would lead to less opportunities for students to practice these exams, that is simply false. Studies actually reveal the opposite, that patients are likely to say yes to these procedures if asked. To think otherwise speaks volumes for how, in many ways, the concept of do no harm needs to return to the forefront of patient care. The bottom line is that if we want patients, all patients, to feel safe and comfortable going to the doctor when they're sick, healthcare professionals are performing their duties with integrity, it starts with this. It starts with consent, it starts with honesty and transparency. If we don't have that, we do not have ethical healthcare for all. Thank you to the committee for your time and the opportunity to speak today.
Thank you very much for your testimony today, Beck. Extremely emphatic and pointed. We appreciate your personal insights and your strong belief. Seeing no questions, which is more a reflection of the fact that we're kind of played out. So that's the case. Next up is Troy Moore, followed by Mary Valdovinos.
Thank you, Representative Steinberg and members of the Public Health Committee. Thanks for sticking around this late at night. I do appreciate that. I want to express my support for HB 5272, an act concerning menstrual products. My name is Troy Moore, and I'm the Chief of External Affairs of the National Diaper Bank Network and the Alliance for Period Supplies. I have the pleasure of working with a committed network of more than 300 basic needs banks throughout the country, including the Diaper Bank of Connecticut, which you've heard several people from their organization. Collectively, we distribute tens of millions of free diapers and menstrual products to individuals, children, and families each year. I live here in West Hartford, and I'm a constituent of Representative Farrar. I want to thank her for her leadership on addressing period poverty here in Connecticut. I'm also a father of a terrific daughter whose public elementary, middle, and high school restrooms provided supplies of toilet paper and paper towels to all its students, but did not provide period products, which are material basic necessities that should be readily available to all students who menstruate. This needs to change. We perpetuate a system of inequity when we ignore the basic necessities of those who menstruate. Period products belong in restrooms of all public schools. In my home, we've had open and quite candid conversations about menstruation. Periods are, as we all know, a normal bodily function, yet too often our society deems periods as gross, taboo, or they carry significant social stigma. This too needs to change. Through my work with the Alliance for Period Supplies, I've learned that students here in Connecticut and across the country miss school because their parents struggle to afford basic necessities. They don't have the period supplies they need, and research bears this out. Here we see the intersection of poverty and inequity, and that's a bad combination that harms our students. As we know, some students or some schools provide menstrual products to students, but it's with a caveat. They have to go to the school nurse's office and ask for products before going to the restroom. Why? Students who menstruate aren't sick. They don't need medicine. They simply need menstrual supplies that should be freely and readily available in public school restrooms, as well as those at our universities and shelters, prisons throughout Connecticut. This bill offers a way forward, a way to address an inequity that exists between those who menstruate and those who do not. It also helps to address the inequity created by poverty. It's not good enough to pass legislation that mandates that schools provide period products. We must also include the funding to make it so. If we do not, then some school districts in our state will be left behind. They will lack the resources to ensure that all students have equitable access to the hygiene products they need to thrive. States throughout the country are introducing and passing bipartisan legislation that will ensure menstrual products are freely available in restrooms of public schools, colleges, shelters, and prisons. It's time for Connecticut to do the same. So I thank you and I ask you for your support of HB 5272. Good evening.
Thank you for your testimony. We appreciate it. No questions. Have a good night. Next up is Mary Valdovinos, followed by Janae Woods-Weber.
Good evening, Chairman Steinberg, Co-Chair Senator Anwar, and distinguished members of the Public Health Committee. My name is Mary Valdovinos. I am a resident of Norwalk and the operations manager at Women Against Mass Incarceration, a nonprofit dedicated to empowering women and girls in efforts to end mass incarceration while bringing injustices in the criminal legal system to light. I am also a formerly incarcerated woman. Tonight, I am providing testimony in support of House Bill 5272, an act concerning menstrual products. Currently, there is a lack of accessibility to essential menstrual products across the state, which we refer to as period poverty. As human beings unable to control functions such as menstruation, having this access is not only a necessity, but a human right. Across our nation, 1 out of 2 menstruate and 1 in 4 are unable to afford menstrual products due to the burdening expense. As the cost of living rises, so does the unaffordability of hygiene products. However, some do not have much choice or say in such an issue, including students, those suffering from homelessness, and those who are incarcerated. As a formerly incarcerated woman myself, I experienced, witnessed, and still hear of the perils of the lack of access and affordability of menstrual products when needed. Hygiene products in prisons still come at a financial cost as they do out here. Although prisons are supposed to offer such products, the needs of those incarcerated are commonly pushed aside or disregarded. I have witnessed women create makeshift menstrual products, thus subjecting themselves to unsafe and unsanitary measures during their cycles. Acts such as creating homemade products out of cotton, book, or magazine paper, sheets, or clothing can lead to infection, illness, and even death, which I too have witnessed. No person should feel so dehumanized. Furthermore, the age of menstruation can start as early as 8. Many of these children's families cannot afford these products, and often young children are not willing to come forward to ask for help out of fear of being harassed or taunted. Period poverty makes an already uncomfortable thing all the more unpleasant. I urge you tonight to support HB 5272 to make menstrual products accessible to those who cannot afford them and so desperately need them. Thank you for your time and have a wonderful evening.
Thank you, Mary, for that. Hopefully it will begin relatively soon. I don't see any questions for you. Thank you for your patience sticking with us. We really appreciate your testimony. Next is Janae Woods-Weber, followed by Amy Johnson.
Good evening. I'm Janae Woods-Weber, Executive Director of Connecticut Women's Education and Legal Fund, a nonprofit that advocates for women and girls. I'm testifying on House Bills 5272 concerning menstrual products and 5261 increasing access to reproductive health care. We have a problem in Connecticut. Too many residents with low income or who experience homelessness can't afford or access menstrual products, which are necessary and can cost up to $1,000 for a lifetime supply. Menstrual inequity also disproportionately affects Black and Latinx individuals, with more than 20% struggling to afford products. When people can't afford products, they often turn to unhygienic practices, which can endanger their health, or they go without, which means they miss work or school, which endangers their future. We can help alleviate this problem by passing House Bill 5272. Connecticut should provide free menstrual products in correctional facilities, all publicly funded schools, and shelters to ensure fewer individuals suffer from menstrual inequity. We also have another problem. Too many of our residents lack access to abortion care and therefore control over their own reproductive freedom. I urge this committee to support House Bill 5261, which modernizes our existing law to reflect current medical standards of practice and removes medically unnecessary barriers that prevent qualified advanced practice clinicians from providing abortion in our state. Reproductive freedom is at the core of women's economic security. Women who are denied access to abortion often face economic hardship. Women who are already struggling to support their families are the most impacted by restrictions. Research shows almost 60% of women seeking abortion care already have a child, and that 75% have low income. The inability to choose whether or when to have children also undermines women's ability to finish high school or college. Educational attainment and earnings are linked, so the decision of whether or not to have children affects lifetime economic stability and security. That decision can also impact a woman's choice regarding whether she's able to pursue, remain, or advance in a job. Being forced to continue an unwanted pregnancy is particularly cruel considering that women continue to shoulder the majority of caregiving responsibilities without needed support, such as access to affordable childcare, predictable work schedules, and a living wage, especially during the pandemic. We will never achieve gender equity without full reproductive freedom. Expanding access to abortion care will address a critical public health need and help eliminate barriers to time-sensitive health care. House Bills 5261 and 5272 are crucial for women's economic security and personal well-being. I urge lawmakers to advance both pieces of legislation this session. Thank you.
Thank you so much, Janae, for your testimony. Very direct and very helpful to us in our deliberations. We have much to think about. I don't see any questions, so have a good evening. I believe Amy Johnson is next, but I just want to caution the members of the committee to hang on for another minute after she testifies, because we want to talk just for a couple minutes about the process for Friday's committee meeting. So hang on, don't go anywhere. Amy, you have the last word, it looks like.
Good evening, Chairman Steinberg, Chairman Anwar, and members of the Public Health Committee. My name is Amy Johnson, and I'm a practicing obstetrician and gynecologist. I thank you for the opportunity to speak in support of two separate bills. First, HB 5278. And I would like to say without any equivocation that Hartford Healthcare wholeheartedly supports this bill and that patients should always be given the opportunity to consent to or decline any medical procedure or examination. Informed consent and open communication with our patients is essential to the practice of obstetrics and gynecology. In addition, patients should be counseled about the involvement of learners with their care, regardless of the setting. Our national organization, the American College of Obstetricians and Gynecologists, or ACOG, fully supports informed consent for pelvic examinations. As an academic physician and residency director, I'm acutely aware of the importance of training providers of the future to deliver outstanding care to our community. There are a significant number of teaching hospitals and facilities throughout the state that include learners across all specialties and areas of medical care. Patients should be counseled on the role of learners in each of these settings. Patients should be aware of when and how students will be involved in their care and should have the opportunity to decline student involvement. Intimate exams under anesthesia should only be performed when clinically relevant, under direct supervision, and after explicit consent of the patient. Intimate examinations must be performed in a manner to preserve patient dignity and privacy, and we agree that procedural consent forms should include an area to indicate that the patient has agreed to a pelvic exam under anesthesia and is aware that a learner may participate in the examination and care of the patient. ACOG recommends that this process should include a checkbox or area on the consent form where the patient can initial to indicate their consent. In addition, this area of consent should be reviewed at the procedural timeouts. However, requiring that the text be of a certain font or bolded may potentially be distressing to the patient and seems unnecessary as long as consent is required. It is important to note that when a patient is undergoing an intimate exam under deep sedation or anesthesia or is unconscious, there are various other providers that may be present depending on the situation. These can include, but are not limited to, members of the anesthesia team, surgical team, and nursing staff. To prohibit a learner of any level from being in the room in all situations when the authorized provider is performing an intimate examination could result in a potential safety concern or increase the time the patient is under anesthesia. In obstetrics and gynecology, many of the procedures include the need for assistance from learners such as residents with medical instruments that can involve the pelvic structures. Under the current wording, this would preclude any learner from being in the procedural room even without performing an exam.
Excuse me, Dr. Johnson, your time is almost up. If you please summarize. Thank you.
Thank you. In regards to the endometriosis bill, I had the pleasure of working with Representative Gilchrist on this and fully support this, as endometriosis is unfortunately a very common condition, and unfortunately many patients have a delay in diagnosis and a lack of treatment options, which certainly disproportionately affects women of color and low socioeconomic status. So increased and ongoing education is certainly a key element to minimize this. And while healthcare providers should participate in ongoing continued medical education to increase their knowledge in systemic racism, implicit bias, microaggressions, and as well as experiences of transgender and gender diverse patients, it does not seem necessary for all healthcare providers to complete continuous medical education, but perhaps should be more appropriately based for those individuals who provide care to reproductive age women, such as primary care physicians, women's healthcare providers, and pediatricians, to make this a more applicable requirement. Thank you very much.
Thank you, Dr. Johnson. Getting back to the intimate exams for a moment, you mentioned that an unintended consequence is that somebody couldn't even be in the room while a procedure was going on. Do you have a remedy for that? Is there any language you might supply us that would help us understand how, the real life of an intern or somebody and what their needs are, so that we don't inhibit the kind of training they require?
Yes, so I believe the Connecticut Hospital Association put forward some newer language earlier today as well, that was a little bit more in line with the practical standpoints of what occurs either in the emergency room or in a trauma bay, or in an operating room. And so certainly we want to make sure that we obtain consent from the patient. And of course, we want to follow the patient's wishes. And if they do not want to have a student or a resident involved in their care, certainly, we want to comply with that. And include that as part of the discussion. But there are, some situations where you may have an anesthesiology resident or a surgical tech who is in a training process, or a highly trained, senior OBGYN resident that needs to come in for an emergency situation if there's a complication of a gynecologic procedure. So the current language of the bill would preclude those situations from occurring.
Thank you for that. We appreciate your insights, and we will look again at the CHA testimony to make sure we've got it covered. I don't see any further questions. Congratulations for being the final person to testify today, particularly given, I'm sure, what is a very busy schedule for you. We really appreciate your taking the time. And without further ado, unless somebody else has popped up, which happens sometimes, we are done, ladies and gentlemen. But before we head off into the night, I want to talk about Friday's committee meeting at 12:30. Chairs and rankings will be meeting in the morning to do a screening, and we will have the agenda finalized for you. But what's important about Friday is our first swing at what we call a hybrid meeting. We discussed it a little bit recently. This is a meeting in which you have a choice. You can join us in person, and we will be in hearing room 1A on Friday, and we will debate as we typically do about bills and pass them out if we so agree. But there's also the option to continue to participate virtually if that is your preference. So here, fully remote participation, we'll use the exact same process we've been using up to this point. You will raise your hand as you did before, and you'll be recognized. You will vote when asked by the administrator or clerk, as before, with your face visible. And there really isn't any difference. The difference is really for those of us who will attend in person, in which case we will not use our computer microphones or visuals. We will be seen via CTN, and we will vote at the testifier's desk one at a time when we reach that point. You will not be able to participate even in the meeting room without your laptop. So you're going to need your laptop in any instance. And also remember to bring your charger so that you don't run out of juice before you get to do everything you want to do. I think that's pretty much it. When you're using the hearing room, you use the microphone you're sitting in. You should not unmute yourself on Zoom. So you stay mute on Zoom and you use the hearing room microphone. And your camera should be off as well. Okay? Yes, Senator Wong.
Just a question logistically. Does it need to be the CGA laptop? Or can you use your own laptop?
Wow, you stumped me there, Senator. I would strongly recommend that you use your CGA laptop, but we will get back to you to confirm that. I imagine you might be able to use another one, but I don't know if there are any extra complications. Maybe somebody will bail me out here. Either that or they're asking more questions.
Just wanted to raise the question. Thank you.
Now, hang on. Maybe somebody else has an answer. Here's Representative Gilchrist.
No, sorry, it's to build on that question. Yeah, what is the laptop being used for when voting in person?
Well then.
The rule requires you to be remote. You cannot operate in the hearing room as if you're in a regular meeting. So you have to be on your laptop. That's what I was told.
Like on Zoom on the laptop?
Yes, you have to log in using Zoom because the 2021-22 rule is remote public hearing and committee meeting. So if we're following the rules, we have to use a device to log into the meeting using the Zoom link that was distributed to members.
So then to Senator Huang's point, I would assume we can use whatever computer we've been using for Zoom.
I think we can, but I will make sure I find that out and I'll send the information, the confirmation to you guys tomorrow.
Rules don't always make sense through you. Senator Moore.
I'm assuming it's, thank you for a very long meeting, but you all, I just think, did a fabulous job today. I assume even though some may be at the Capitol, I could do this remotely from my Capitol office?
Yes, you can.
Thank you.
The change in the process is only for legislators who are going to be sitting in the room, where you cannot have your microphone on, you cannot have your camera on, because all that will be done by CTN. And if you leave your microphone on, we'll have a lot of echo in the room.
We got enough of a problem with that already. Okay, we answered you. We got more questions. Senator Kushner.
I'm just assuming that the reason we need to have our computers and Zoom if we're in the room is so that we can watch our colleagues who are not in the room. I would assume that's a
good insight, Julie. Very good.
Once in a while.
I think much more often than that. Representative Carpino.
Thank you, sir. Since we will not be in the chamber, we will not be in a public hallway, but we will be in a designated hearing room. What is the mask protocol for those of us who are in the room? Just so that everybody is on the same page.
Wow, yeah, that's a good one. I imagine that some people will be wearing masks.
Some people will be wearing masks, and I don't believe we are authorized to ask people to leave the room based on a meeting we had, I think it was yesterday or the day before. Legislative management and Capitol Police are the only people that would be making sure that the rooms are not overcrowded like they do in any regular session or public hearing or committee meeting. I don't know how, there's no way to enforce that. And there was a public, I think it was a public safety meeting yesterday, and there were folks in the room without masks. So just to let you guys know that.
I guess the fallback would be if you become uncomfortable, you can always go back to your office.
May I ask a follow-up?
Please.
If you don't wear a mask, are you breaking a rule?
I don't know.
Okay.
The only
clarification on that.
I will check with legislative management tomorrow.
Thank
we
you.
will send around an email to all committee members when we ascertain the answers to these really good questions.
Masks are still required on the first floor of the LOB. Masks are required in any public spaces in the LOB on the first floor. So I will check with Jim Tambora in the morning to make sure I'm giving you the correct information, because things changes pretty often in that building.
I do apologize for bringing it up. So I know it's been a long day.
No, that's okay. That's okay. We need to know.
Yeah, we thought we had this locked down. I guess we're going to find out as we go, but we'll have more answers for you tomorrow. Stay tuned. Take the evening off. We'll talk to you tomorrow. We'll meet on Friday. Over and out.
9 a.m. See you there.
Chairs, ranking members, and vice chairs, we have screening at 9 a.m. in the morning.
Yeah. Beverly, all the masks are at the gas stations now. The guys charging you for your gas have them on, so that's where they are.
Okay, thank you. Bye.
Thank you, Beverly.
You're welcome. Bye. Have a good night.
And that's a beautiful purple suit. I love it. Or is it blue? Looks purple on my screen.
It's a shade of purple.
There you go.